हाँ सर, कर दो लाइव, कर दो लाइव, चैट लाइव कर देना। ओके, ठीक है सर, मैं अभी लाइव स्टार्ट
Hello friends, a very good evening. We are just 2 weeks, less than 2 weeks away from your exam, from your D-Day. I'm sure you must be putting in lots of effort to finish, cross the finish line. So without wasting a single second of yours, let us start with the question discussion on questions which had come from pediatrics. I am Dr. Dipali Gupta, your pediatrics faculty at Allen Next. So let us start with the first question. A 3-year-old child presents with periorbital puffiness, especially noticed in the morning. Urine examination reveals grade 3 proteinuria and no hematuria. Which of the following statements about her probable diagnosis is true? See, you will be able to get this question correct. I'm sure most of you would have got it correct only if you know what is the diagnosis they are wanting from you, giving you such statements, right? So, क्या है बच्चे को periorbital puffiness है, right? Morning puffiness है, so we know usually this occurs when there is kidney problem, right? And urine examination में massive proteinuria है, anything grade 3, grade 4 proteinuria is considered as massive proteinuria. Very importantly, no hematuria. So when you have this, and especially the age, less than 7 years of age, you should know if a child presents to you like this, there's a high possibility that the child is suffering from nephrotic syndrome, and that also which variety? The MCD variety, or the minimal change disease, or sometimes this is also referred to as minimal change nephrotic syndrome. और हमको ये पता है, we know this, that in nephrotic syndrome the C3 levels are supposed to be normal. That is one investigation, you always get it done to rule out other causes which can have a similar kind of presentation, notably in this context SLE. SLE में C3 can be low and can have such kind of presentation. Another very important differential diagnosis जहाँ पे आपका C3 low आएगा, आपको याद रखना है, that is PSGN, post streptococcal glomerulonephritis, sometimes also referred to as AGN, acute glomerulonephritis, right? So very importantly, as we know that C3 levels are normal in nephrotic syndrome, while low C3, I will again write it down, are a feature of notably SLE and post streptococcal glomerulonephritis and also MPGN, membranoproliferative glomerulonephritis. But important thing is, in children less than 7 years of age, 80% of children, they usually present with MCD, that is minimal change disease type of nephrotic syndrome, where C3 level is going to be normal, right? So C3 levels are low, तो नहीं है true statement. No IgG C3 deposits on renal biopsy. Of course, the name itself tells you minimal change disease का मतलब ही ये है that on histopath you get hardly any features. Of course, always remember, on electron microscopy you get effacement of podocytes. This is all asked in your exams, and I hope by now this should be very clear to you. So that is only on electron microscopy. But if you see immunofluorescence, or you do light microscopy of the kidney specimens, then what you get to see is absolutely nothing, and hence the name minimal change disease. So no IgG or C3 deposits on renal biopsy. This is the correct statement. और देख लेते हैं, Malignant hypertension is a common occurrence. Always remember बच्चों, hypertension is common in nephrotic syndrome, ठीक है, but not malignant hypertension. Malignant hypertension at your level is nothing but severe kind of hypertension. This can be seen in post-streptococcal glomerulonephritis. In fact, you should know one of the presenting features of post-streptococcal glomerulonephritis, apart from cola-colored urine, can be severe headache in children. You know, and that severe headache is because of malignant hypertension, right? Sometimes we have to, treat it as hypertensive emergency or urgency in post-streptococcal glomerulonephritis. But malignant hypertension, remember, is not a feature of nephrotic syndrome. So again, this is a wrong statement. The first episode of this condition is best treated with levamisole and steroids. Of course, you must be knowing this. In nephrotic syndrome, the first episode is very, very, important to treat and very nicely treated. Aggressive treatment is required in form of 6 weeks of daily steroids, very importantly, and 6 weeks of alternate day steroids. This is how a complete 12-week therapy is done, and it is said if you treat vigorously or aggressively the first episode of nephrotic syndrome, minimal change disease, then chances of relapse are very, very low. So never at all you have to use other than steroids anything else. Levamisole nahi indicated hai. Levamisole is a steroid sparing agent that comes later on when the child develops, frequent recurrences and steroid dependence. Then its role comes. But the first episode, always remember, is treated with 12 weeks of steroids, 6 weeks of daily and 6 weeks of alternate day steroids, right? So Dr. Ali Zulfikar has, correctly written the answer B. Of course, our answer is going to be B in this case. Any other comments? I'm waiting for your comments to occur. If you have any other thoughts regarding this question, we'll take it up later on also, right? So let us move forward. The straight away question, I hope you got it right. Let us come to the next thing. So this was minimal change disease. We have already discussed, immunofluorescence do not demonstrate anything. As I told you, except occasional mesangial IgM, nobody is going to ask you that. Just remember this, do not demonstrate it. Does not show anything on light microscopy. Only what is important is electron microscopy showing you obliteration or effacement of either you call it podocytes, you call it, or the foot processes of the epithelial cells, which is there in the glomerular basement membrane, right? Okay. Now let us move forward. Next question. All of the following statements are true about cephalhematoma except. We know cephalhematoma is a, injury, kind of injury which occurs during birth. So let us see. Notice shortly after birth can be a cause of neonatal jaundice, can persist up to 10 to 12 weeks, often develops after forceps delivery. So they are asking which is a false statement, right? True except करके लिखा है, तो we are going to go for the false statement. See, often develops after forceps delivery. Yes, this is a correct. So basically any kind of traumatic delivery occurring, that can result in the child developing cephalhematoma, where there's rupture of the bridging veins in the subperiosteal layer, right? And because the veins rupture in the subperiosteal layer, that is why there's accumulation of the blood in the subperiosteum. Along with there can be fracture of the underlying bone, skull bone also, right? Okay, so again I am getting questions over here. So Dr. Sahib says C option. I think you are talking about the second question, Dr. Sahib, which we are discussing. Rest all are giving me A option. So Kapil Dev Chaudhary, Dr. Kapil Dev Chaudhary is there. Dr. Ali is again A. Dr. Tapazzum is A. Dr. Rahul is also going for A. So see, of course, you all are right. The A option is correct over here. So if we see it, yes, it develops after forceps delivery, can persist up to 10 to 12 weeks. So Dr. Sahib, if you were talking about this being a false statement, this is not a false statement, this is true statement. It can take 10 to 12 weeks for the resorption of the blood that is collected in the subperiosteal layer. Please remember this came in your 2023 NEET PG exam also. They had given an X-ray of the skull where they had shown the swelling, and they had said that this X-ray is taken at 10 to 12 weeks of age. What do you think? And this has been persisting since birth. What do you think is your diagnosis? You should know that they were talking about cephalhematoma. hematoma, right? Then can be a cause of neonatal jaundice. Of course, if there's so much extravasation of blood, that blood will be resorbed, will be, tackled by the reticuloendothelial system, and then what happens, what is the fate? The RBC lies, the hemoglobin is released, hemoglobin, gets split into heme moiety and the globin. Globin is the protein part which goes for recycling again to make hemoglobin, while the heme undergoes various changes which occurs in the reticuloendothelial system, including spleen, and gets converted to bilirubin, which is a highly toxic pigment, and then this goes to the liver for detoxification. And of course, liver is already swamped by so much bilirubin because the RBC count is high. So therefore, there's a increased load of bilirubin on the liver, if there is cephal hematoma or any extravasation of blood, and hence you have a exaggeration of physiological jaundice. So that also always you have to alert the parents that come back soon, your child might have excess of jaundice, right? So that can be a cause of neonatal jaundice. That's a correct statement. Then notice shortly after birth, of course, you should remember the accumulation of blood does not occur straight away at the time of birth. At the time of the birth, you will be amazed to know this cephal hematoma swelling is hardly noticeable. Only when you go for your, rounds, let us say at 6 hours or maybe 12 hours. More appropriately is this swelling is usually noticed 12 to 24 hours after birth. So at birth, this swelling is hardly noticeable, in fact, not noticeable at all. While vis-a-vis, we have a very close differential diagnosis, that is caput succedaneum, that is noticed straight away at birth. In fact, while the child is, trying to come out of the introitus, while we are getting the delivery done, at that time only you can feel the boggy swelling of the scalp, which indicates that the child has developed caput succedaneum, right? So that is present at birth right away. But cephal hematoma, the swelling becomes visible 12 to 24 hours after birth. This was a very vague statement. I agree with everyone, but remember, most of the times you don't get a very halwa question, straight away question, and then you have to use your discretion that out of the 4 statements, which is more appropriately fitting whatever they are asking. So this is a false statement. This is not noticed shortly after birth. Although you can argue with me that 12 to 24 hours bhi to shortly hai, shortly ki koi limit nahi hai. But please remember, always see which is not fitting the scenario, and then you go for the correct option. So many people have given me the correct answer. Good. Dr. Shiva, Dr. Kanchan, good going. So I think you are all set as far as pediatrics is concerned, and I'm sure for the other subjects also. So let us move forward. So this is again the swelling. You can see the different layers where the collection of the blood takes place. So cephal hematoma, you can see this is the periosteum, right? This is the periosteum. So below the periosteum is cephal hematoma, and then you can see, below the gallia aponeurotica, there is subgaleal hemorrhage. This is again another very close differential diagnosis of cephal hematoma. You should know few lines about it. Remember, this is again very similar to cephal hematoma. This is noticed again sometime 6 hours after birth, not at birth itself, and the subgaleal space or the space beneath the gallia aponeurotica is a huge potential space and can house at least 260 ml of blood. So if that much blood accumulates, then there's a great tendency the child goes into shock, or as you call it in simple words, hemodynamic instability, and what is required is resuscitation in this child. That means fluid resuscitation. You also have to transfuse blood if the child has lost so much blood in the gallia aponeurotica. Otherwise, this child is sure to collapse in front of you. So that is what is subgaleal hemorrhage, requires immediate attention. Remember, for cephal hematoma, no treatment is required. It is masterly inactivity, as we call it. The two wonderful words what we always, we were very happy during our PG days or during our MBBS days when we were told treatment of any condition is masterly inactivity. That means don't do anything. So at least we don't have an extra burden to remember ki iska treatment bhi remember karna hota hai. So there's no treatment is required. You will be enticed saying that IND kar dein kya, incision and drainage, no, nothing. This will get resolved on its own. And then you can see in the subcutaneous tissue of the scalp you have the edema, which is the caput succedaneum, right? Okay, so that sums it up. Let us move forward. Quick revision has been done for you. Which of these is not a component of KMC, kangaroo mother care? So let me tell you one thing, guys and girls. See, in your exam, usually what the pattern, at least pertaining to the questions of pediatrics, is they ask you very simple, down-to-earth questions, but with a twist. The simple topics like breastfeeding, simple topics like KMC and vitamin deficiencies, but then you must know everything about it. That's what the exam is always conducted like. So let us see what is the correct answer to this question. So which of these is not a component of kangaroo mother care? KMC or kangaroo mother care as you call it can be provided while the baby is being fed orogastric tube. So is this correct? Let us see. Covering the newborn with woolens, particularly the child's head. Is this correct? Let us see. KMC can be initiated immediately after birth in stable babies weighing more than 1800 grams. And of course, KMC can be provided even when the baby is on oxygen therapy. So I'm waiting for your answer. Yes, so people have started giving me the answer. Most of you, Dr. Sahib, Dr. Ali Zulfikar, Kapil Dev Chaudhary, Dr. Tabassum, Dr. Kanchan, they are, Dr. Kapil Dev has given me C option, while all others, Dr. Sahib, Dr. Shiva, all are giving me the B option. So the B option is the correct answer. Of course, yes, the answer correct is the B option. Remember, if we see the other things, somebody said C. So first let us see the C option. KMC can be initiated immediately after birth in stable babies weighing more than 1800 grams. This is a correct statement, Dr. Kapil Dev. Okay, this is how KMC was actually devised by Dr. Edgar Ray. This man, he was a resident of Bogota, Colombia, and initially the KMC was taken as an alternative to the radiant warmer care. So in developing countries you might not be having so many radiant warmers in the nursery, and then they devised that why not go for the KMC and provide a heat to the baby in such a manner. And now amazingly this has become a standard of care because they got very good results with KMC. Now KMC, always remember, this was derived for both low birth weight babies and preterm babies, and usually low birth weight means anyone measuring more than 1800 grams, right? And it is usually terminated when the child reaches a weight of 2500 grams or a gestation of 37 weeks. Number one, that is one indication where you stop KMC. And of course the second indication that is valid every time, when the child is not comfortable in the KMC position, he's trying to wriggle out, so then of course, or he's excessively sweating, then it is better that you stop KMC. So that is indications of starting and stopping KMC. And very importantly, you will be amazed to know that here I have given on oxygen therapy, and even if the baby is being fed by orogastric tube, yes, KMC can be given in such a situation. Yes, Dr. Shiva Tripathi, I am not getting why have you written 35 weeks. It is 37 weeks at what you stop, and you can start at whatever weeks you want to. But very importantly, always remember one thing, bachcho, that the child has to be hemodynamically stable. That is very, very important. If any child at any gestation is hemodynamically unstable, then you cannot start KMC. And very importantly, if tomorrow, if I would have given you a question, let us say if the child is on IV fluids, will you start KMC if the child is on IV fluids? I am waiting for this answer. Tell me yes with IV fluids or no with IV fluids. I want you to type your answers, and then we will come to this again. So is KMC indicated when the child is on IV fluids? That is my question for you right now. So here let us see the other options. So KMC can be provided while the baby is being fed by orogastric tube. This is the correct option. KMC can be initiated immediately after birth in stable babies weighing more than 1800 grams. This is also correct. And KMC can be provided even when the baby is on oxygen therapy. So that is also correct. Very importantly, what is not correct over here is the false statement, which is our answer over here, covering the newborn with woolens, particularly the child's head. See, in this case, again, I would tell you this is again a very vague option. Always remember, you can give KMC when the child is wearing the cap, wearing the nappy, and also wearing the socks. So with this, you can give KMC with cap, nappy and socks, but of course, and you can also clothe the child, but the sleeve, whatever light clothes you are making the child wear, that should be open from his chest, so that there is skin to skin contact between the caregiver, the chest of the caregiver. That caregiver can be mother, can be father, can be anyone in the family. Please understand that KMC is only not for the mother to do it, but any caregiver of the family can engage himself in giving KMC to the little one. And the anterior part of the cloth, the anterior part of the chest, and of course that of the caregiver, that should be totally bare, so there is skin to skin contact. That is most important thing. So tomorrow if they tell you that the child is covered with woolens from the back, but the front part is open and the skin to skin contact is being given, is this correct? Please understand, this is a correct. What is important is the anterior portion of the body, the chest and the abdomen should be bare, should be without any clothes, so that is in skin to skin contact with the caregiver, very importantly, right? So many people have responded good. Dr. Sahab, Medico's lifesaver, says yes, with IV fluids KMC can be given, but very importantly, the only thing important is hemodynamically stable baby. So tomorrow if they ask you hemodynamically unstable baby on IV fluids, do we give KMC? You will say no. KMC is cannot be given in a hemodynamically unstable baby. So that should be very clear, right? So let us move on to the other. So okay, the correct answer or the false statement is covering the newborn with woolens, that we have already discussed. Of course, there would be a better false statement over here, then we would have gone for that. But here the most inappropriate statement over here is covering the newborn with woolens while giving KMC. That is not indicated as compared to the other statement. So that's why the correct answer is going to be B, right? Okay, now next is a newborn is assessed at 5 minutes after birth. She is found to have heart rate of 120 per minute with vigorous cry. Also, the newborn is found to have blue extremities and active movement of all limbs and minimal response to stimulation. Calculate the Apgar score. So this is a very, very, often repeated question. Every time they ask you, I'm sure by now, just few days for the examination, you must have already cramped up the Apgar score, right? So let us calculate it over here. Heart rate of 120 per minute. So that will give you a score of 2 over here, because anything more than 100 per minute has a score of 2 as per the Apgar score. Vigorous cry is again 2 over here. Also the newborn is found to have blue extremities. So blue extremities means the rest of the body is pink. So maybe they are talking about acrocyanosis, and only blue extremities, that gives you an score of 1 as per the Apgar score, right? Then active movement of all limbs, this is again 2 over here, and minimal response to stimulation is as good as no response to stimulation. So that we go for the Apgar score of let us say 0. So if we add up all this, yes. So Dr. Sahib is added up. Yes, this is 7, Apgar score of 7, and the correct answer over here is the B option, that is 7, right? So B option, yes. So Dr. Shahid has also said B option, yes. Dr. Kapil Dev is correct. Dr. Tabassum is correct. Dr. Ali is correct. Good going. Dr. Kanchan Jadhav is also correct with the B option, that is 7. So I hope you got it right. Quick remembrance of the Apgar score, it stands for a mnemonic: appearance, pulse, grimace, activity and respiration. Appearance is pink, overall is 2, then extremities blue is gives you a score of 1, and overall blue child gives you a score of 0. Pulse more than 100 is 2, less than 100 but present is score of 1, but absent pulse gives you a score of 0. Grimace, that means when you give a nasogastric stimulation, if the child cries and pulls away, that is score of 2. Grimaces or weak cry, that is score of 1, and no response or maybe minimal response to stimulation gives you a score of 0. Then activity, active movement is score of 2, and arms, legs flexion is there, then that is a score of 1, and if absolutely no movement, that is score of 0. Then respiration, if there is a strong cry, that is score of 2, and slow irregular breathing or cry, that is score of 1. No breathing is score of 0, right? So let us move forward. Let us come to the next question. All of the following are features of cyanotic heart disease except. So cyanotic heart disease given in your X-ray, if you can guess, yes, you guessed it right. What is the cyanotic heart disease? Waiting for your answer. What is the cyanotic heart disease we are talking about? So I am waiting for your answer. What is the cyanotic heart disease we are talking about? very clear from the X-ray, right? Yes, so this is, you can see, everybody can see, this is a boot shaped heart, and a boot shaped heart with almost pulmonary oligemia in both the lung fields. This is nothing but tetralogy of Fallot we are talking about, right? So everybody is giving me the correct option over here. What is the correct option over here? So let us see with respect to our diagnosis of TOF. So infundibulous stenosis is the basic abnormality in this congenital heart defect. Are we clear on this? Yes, we are clear that infundibulous stenosis is common. That is the basic problem in TOF. Congestive cardiac failure is common in early infancy. Yes, it is common in, is it common in early infancy in TOF? Remember, TOF children, they do not go into congestive cardiac failure, right? So this is not common in early infancy. Of course, sometimes if you have written, there's an exception if there is pink TOF. I will not go into details, but pink TOF wale jo bacche hote hain, they can go into congestive cardiac failure. But as a rule, TOF per se, they do not go into congestive cardiac failure. Sometimes if you encounter this pink TOF written, then you have to consider congestive cardiac failure. Otherwise, TOF, tetralogy of Fallot, may the hemodynamics are such that the child does not go into congestive cardiac failure. So everybody is giving me correct answer. Very good. Dr. Sahib tells me this is boot-shaped heart. TOF. Dr. Kapil Dev says TOF. Dr. Shiva, Dr. Kanchan, Dr. Anda, and Dr. Kapil Dev again says this is TOF, right? So we are talking about TOF. Then congestive cardiac failure is common in early infancy. So this is a wrong option. Probably this is going to be our answer, but let us see the other options also. It is the commonest congenital heart defect in which squatting is noted. Of course, yes, because you know squatting means what? Squatting means the child is trying to increase the systemic vascular resistance. Always remember that. Systemic vascular resistance, if the child is trying to increase, the TOF may, you know, because of a VSD, the infundibulous stenosis, if I have to draw it over here, let me draw it and show it to you. So this is the child with TOF having the 4 chambers, right, of the heart, and right. So this is the right atrium, this is the left atrium, this is the right ventricle, this is the left ventricle, and over here if I have to, you know, show a VSD over here, and then I have to show you a pulmonic stenosis. Let us say this is a pulmonic stenosis or infundibulous stenosis over here, and this is the aorta over here. So because of the infundibulous stenosis, most of the blood would cross over and come over here, and this is the deoxygenated blood resulting in cyanosis in the child. We are not happy, you know, giving deoxygenated blood to the systemic circulation. So what do we do is we try to plug this. How do we try to plug this? Is by squatting. What happens when the child squats? What is squatting? For people who don't know, it is sitting in the Indian toilet position. That is known as squatting. So during squatting, what happens? These gates, that is the aortic, the systemic vascular resistance, it greatly increases. And if the systemic vascular resistance greatly increases, then what will happen? This flow of blood will be hampered. I will just put a cut over here, and then we will be forced to push the blood into the pulmonary circulation, and this blood in the lungs will get oxygenated and then will come to the left side of the heart, and then you know, the child will be benefited by getting oxygenated blood in the systemic circulation. So in anyhow, we have to, you know, the child finds some relief when he is squatting, because by that position he tries to increase the systemic vascular resistance, and that is why squatting is observed, right? Okay, so let us come back. Iron supplementation is recommended for all infants and young children with congenital heart defect. Yes, with this congenital heart defect, you should know there are 2 things we start in all children with TOF. Remember, those 2 things are, anybody can tell me what are these 2 things? One is your iron supplementation, which is already mentioned over here, and the other thing I am waiting. So I am waiting for your responses, then I will tell you that which is the other thing we start in children with TOF, right? Okay, so Dr. Shiva is saying yes, there is overriding of aorta also, but Dr. Shiva, let me tell you, of all the 4 components of TOF, as the name suggests, tetralogy, that means there's going to be 4 defects. Overriding of aorta does not have that much clinical significance, while all the other 3 abnormalities or the defects are contributing to the hemodynamics of TOF, right? Okay, so I'm waiting for your answer. What is the other thing we start in children with TOF, right? So Dr. Sahib says O2. No, O2 will not have any, you know, during cyanotic spell, of course, O2 will help in again decreasing the systemic vascular resistance, but and the pulmonary vascular resistance. But the important is For long-term prophylaxis, one, we start iron as a long-term prophylaxis. When a child with TOF comes to us, he's a totally stable child, and still I start two medications on him. One is iron. What is the other medication? That is my question to you. So I'm waiting for your responses, and then in the meantime, let me move forward. I'll come back to it, right? So anyways, as far as this question goes, the correct answer is congestive cardiac failure is common in early infancy. This is a wrong statement, and hence this is the answer for this question. Let us move forward. A mentally retarded 14-year-old boy has a long face, large ears, micropenis and large testes. Chromosomal analysis is likely to demonstrate which of the following. So please remember, every time in every exam of yours, there are one or two questions pertaining to the syndromes. Last time in the FMGE exam, which happened, you know, in the last time, that is on in July, 30th July, questions came on Down syndrome, which is very easy for you. So that's why, you know, in every CBoT we are trying to put one or two questions of a syndrome so that you are able to answer. So let us come to this mentally retarded. So what is it? Everybody is giving me the answer. Yes, Dr. Sahab says D, Dr. Kapil Dev D, Dr. Mansukh says B, trisomy 18, and Dr. Anda says Fragile X syndrome. Of course, yes. So the correct answer over here, without much ado, we are going to talk about Fragile X syndrome. This is Fragile X syndrome. Remember, somebody has also giving me the answer of trisomy 18. Remember, Edwards syndrome has, you know, polydactyly and VSD as a congenital heart defect, and usually these children do not survive beyond 12 to 18 months. In fact, the mortality is to the rate of 80% by the age of 12 months, right? So you will not get such a big child of Edwards syndrome, let me tell you. And other features of Edwards syndrome is that you will also, as I was telling you, you will have overlapping of fingers. Very importantly, you will have microcephaly, you will have retrognathia, you will have micrognathia. So that is all is there in Edwards syndrome. And the overlapping of digits is not only in the upper limbs, that is in the hands, that is seen in the lower limbs also. So whenever you get a, you know, figure where there's overlapping of digits seen, then always think about Edwards over there. Of course, there would be other features, as I told you. So this is not Edwards, beta. Whoever is saying Edwards, this is not Edwards. This is Fragile X syndrome. Typical, that this is the morphology or the phenotype the Fragile X children have. They have a broad forehead, elongated face, large prominent ears that you can see, and then you have strabismus, highly arched palate is there. There's hyperextensible joint. There is also hand flapping. That is very important. Hand flapping that is seen with the Fragile X syndrome. Then there is hypotonia, and very important feature of Fragile X, as everybody should remember, is macroorchidism. That means large testicles. That is very important feature of Fragile X syndrome. Of course, there can be pectus excavatum and mitral valve prolapse, and flat feet can be there, and seizures can be seen in 10%, because you know this is because of the mutation in the FMR1 gene, and when this gene is there, it messes up with your brain, and therefore these children have a higher incidence of autism. Very important. Autism is very common, commonly associated with Fragile X syndrome. So remember all these features: hand flapping, macroorchidism, and this typical phenotype. So very good. Yes, all big. Dr. Sahib says all big. Good for you. Chalo, आगे चलते हैं. Let us come to the next. So I was waiting for the answer. You know this TOF. What do you give for long-term prophylaxis? One is iron, and the other thing, nobody gave me the answer. The other thing is propranolol. Always remember, propranolol, oral propranolol is started as a long-term prophylaxis because this prevents the frequent occurrence of cyanotic spells or the TET spells, as we know. So before you can, you know, till the time the child is waiting for the surgery to occur, for the corrective definitive surgery to occur, then you can start the child on these two things. One is iron prophylaxis and other is propranolol, that they are very much helpful in maintaining the stability of this disease, right? So that is it, right? Okay, so Dr. Sahib is saying 20% male affected in Fragile X. Always I would like to tell you the incidence, it is seen, Fragile X is seen both in girls as well in boys, but amazingly it is seen more in boys. In fact, in boys the occurrence is 1 in 4,000 to 7,000 or 8,000 boys, right? In girls it is seen the frequency is much low, the incidence is much low. So it is seen from 7,000 to 11,000 girls. So that you can see it is more common in boys. So that you have to remember with Fragile X syndrome, right? Okay, so let us move forward. Arrange these milestones in chronological order of their attainment. By age, handedness gets established. So when does handedness gets established? Let us see. So this established usually by 3 years of age. See, some book says it starts getting established by 2 years, but the final statement is usually gets established by 3 years of age. So we will go by 3 years of age. Makes towers of 6 to 7 cubes. When does this occur? So this occurs by, let us say by 2 years of age. That is it. So tower, if you remember, 15 months, 2 cubes tower, 18 months, 1 more cube added, so that means 3 cube tower, then 2 years and 3 years. I told you just multiply by 3. So 2 into 3, that means 6 cubes tower, and 3 into 3, that means 9 cubes tower, right? So here is 6 to 7 cubes, so we will say 2 years, right? Walk with one hand held, that is typically, I have made you, remember this. On his first birthday, the child goes for cake cutting near the table, which is placed on a table. So he holds the hand of his mother on his first birthday and walks up to the cake cutting table. That's how you have to remember that. Walks with one hand held at 1 year of age. And then waves bye-bye, that comes as early as 9 months of age. And how do we remember this milestone? I've always emphasized on this. 9 months pe when the child will come for MMR vaccination or for MR vaccination as per the national immunization schedule, then the child waves bye-bye. So, when the children come to my clinic and, parents say, chalo, bye-bye karo, doctor ko. So, I always tell them 9 months, you come for the MMR vaccination or the MR vaccination, then the child waves bye-bye. So, this is how you remember this milestone, right? So, of course, so everybody is giving me the answer. This is 4, 3, 2, 1. Very, very correct. That is the B option. Everybody's got it right. Yes. So, Dr. Mansukh, Dr. Kanchan, Dr. Abhishek, Dr. Anil Taran, Dr. Sahab, everybody is giving me the correct answer of B option. So, that is it. 4, 3, 2, 1. So, that means first 9 months, then 1 year, then 2 years, and then 3 years of age. So, that is the correct answer over here. Okay, now let us move on to the next question. All of the following statements about breast milk are true except the colostrum is rich in IgA. I think this is a true statement. T डाल देते हैं यहाँ पे. CMV can be transmitted easily through breast milk. Do you think this is a true statement? Of course, this is a true statement. So, very importantly, CMV infection in mother is a contraindication to breastfeeding. What do you think? Of course, this is a false statement. CMV gets transmitted through breast milk. This is a fact which you all should remember. In fact, this also goes and results in CMV pneumonitis. And typically in which babies? In preterm babies. In preterm babies, if the mother is infected with CMV, there's a high likelihood that the delivery will be premature, will be that of a premature baby. And then when these preterm babies drink the CMV infected milk, then breast milk, then they are liable to land up with CMV pneumonitis. Do we stop breastfeeding? The answer is a big no. In spite of this, the benefits of breastfeeding outweigh the risk involved with the transmission of CMV. So therefore, CMV is not a contraindication for breastfeeding. This should be very clear to you, although it gets transmitted. This should be very clear. So again, this is a wrong statement over here. So let us put it. Let us see the other statements. Expressed breast milk can be stored in refrigerator for 24 hours. We know this. In refrigerator for 24 hours, in a deep freezer at minus 20 degrees centigrades for 3 to 6 months. Nelson says 6 months, or Ghai says 3 months. So remember, 3 to 6 months in a deep freezer at 4 degrees centigrade for 24 hours, and at room temperature usually recommended is 6 to 8 hours. So that you have to remember every time asked in your exam. This is how you store expressed breast milk, right? Okay, so this is a correct statement. Then human milk has less protein as compared to cow's milk. Of course, we know that the protein load in the human milk is good. This is in fact beneficial for the baby. Remember, more protein load more more load on the immature kidneys of the newborn. So we are not very happy giving cow's milk. You should never ever prescribe cow's milk. What we prescribe is human milk, because many advantages are there, but of course one of the advantages is it has less protein, and it has that much protein which is required by the baby. And you should know the content also. It is 1.1 gram per 100 ml. So you should know this protein content of the human milk is definitely less than the cow's milk, right, where the content is around 3 to 4 gram per 100 ml, right? Okay, so what is the incorrect statement over here? It is the B option, that is the incorrect statement. Okay, so Dr. Anda has asks me, HIV में continue रखते हैं breastfeeding? बेटा HIV में again there is a whole new, this is a controversial this thing, but of course still we say in a developing country like ours, the benefits of breastfeeding outweigh the benefit of the risk for HIV transmission. So we do continue HIV में भी breastfeeding. Remember that thing, right? So chemotherapy में करते या नहीं मैम? Of course yes, I'm just coming to that. ये जो आपको याद रखना है किसमें breastfeeding नहीं देते हैं. I am getting the questions, so I hope this slide will solve your queries. So when the mother is taking any substance, is involved in any substance abuse, or is having severe neurosis or psychosis, that is a contraindication for the breastfeeding. Of course we are talking about the mother being involved in all this. If the mother is having breast abscess, it's a relative contraindication because it's a very painful procedure, so therefore we will tell her to temporarily stop breastfeeding. Infants with galactosemia, straight away we stop breastfeeding. Lactose intolerance, we stop in the baby we stop breastfeeding. So galactosemia and lactose intolerance, we stop breastfeeding. Now if the mother is on anti-thyroid drugs except propylthiouracil, we have to stop breastfeeding. Radiopharmaceuticals, stop breastfeeding. And of course जैसे कि किसी ने पूछा मुझसे, मैम chemotherapy में when the mother is undergoing chemotherapy, do we continue breastfeeding? Of course the answer is no. So in all these it is contraindicated. One more thing over here is, if the mother is an active case of tuberculosis, remember that, and is not on therapy, very importantly, then also that is a contraindication for breastfeeding. Remember this. Of course, if the mother is a case of active tuberculosis but is on therapy for at least 2 months, then you can always continue with breastfeeding safely. Remember that. Usually 2 months कहते हैं, but anyways if she is on therapy, if अगर आपके question में mentioned नहीं है that she has been on therapy since when, but if she is on therapy means ATT, anti-tuberculosis drug, then you can safely go for breastfeeding. I hope that solves your query very clearly, right? So these are all the contraindications for breastfeeding which you have to remember. Straight questions आते हैं. I don't want you to get this wrong in your main exam. Okay, then a newborn that is suctioned and given tactile stimulation, flicks on stool, does not cry at the time of birth. The child is still hyporesponsive with a heart rate of 80 beats per minute. Important is 80 beats per minute and intermittent apnea. After 30 seconds, so that means what do we start now? We have to start positive pressure ventilation. So that has been started as per the question. After 30 seconds of positive pressure ventilation with a bag and mask, her heart rate is 55 per minute. What is the next intervention to be done? Waiting for your responses. Let me read out the options for you. Increase the pressure of the positive pressure ventilation, intubate the baby, take ventilation corrective steps, yeah, start chest compression. So what do we do? Waiting for your answer. Okay, so Dr. Shahid says B, intubate the baby. Dr. Mansukh says C. Dr. Kapil Dev also says C. Dr. Sahib again says B. Dr. Anda says D. Okay, so I'm getting lots of different options over here. Everybody is not on the right page over here, and every time I notice this, when neonatal resuscitation, कुछ ना कुछ गच्चा जरूर रह जाता है. There is some or the other doubt which is prevailing in the mind of students. So let me just dispel those doubts for once and for all, and that is why I always put a question of neonatal resuscitation in your CBoT. So that is again I'm giving you a question leak over here. Next time also you will definitely get a question. So now what is it all about? क्या करें हम इसके बारे में? So Dr. Anil says less than 60 है तो chest compression चालू करो, काम खत्म, right? So everybody is saying, many of you are saying start chest compression. देखो बच्चों, one thing should be very clear. If this would have been 30 seconds of effective positive pressure ventilation, then I would have definitely gone with the D option. Remember, positive pressure ventilation does not, अगर आपको बताया गया है that with positive pressure ventilation there is, adequate chest rise is occurring and it is an effective positive pressure ventilation we are delivering, and still the heart rate is less than 60, definitely then my answer would have been chest compressions. But what is wrong over here is that the child has been given PPV, but there's no mention whether the effective ventilation was there or not, in form of या तो word effective use करते हैं या फिर they would have told that there is chest rise occurring. If that is not been mentioned, then the next step is go for ventilation corrective steps. Always remember, I tell this to all children many times and I'm repeating once again, the indication of chest compression, everybody in this world thinks, students, they think a heart rate less than 60. Don't remember this. This is not the way you remember indication of chest compression. The indication of chest compression is if the heart rate is less than 60 per minute, despite this, the what follows after despite is the most important part, which most of you forget. Despite 30 seconds of effective positive pressure ventilation. Now that positive pressure ventilation can be through bag and mask, then positive pressure ventilation can be through bag and tube. Bag and tube means you have already intubated the baby. We are not concerned with that. What I want over here is effective positive pressure ventilation despite 30 seconds. After 30 seconds, have we given 30 seconds of effective? Was the word effective mentioned here, or was it mentioned that there was adequate chest rise occurring? If it would have been mentioned that adequate chest rise had been occurring and still the heart rate is less than 55 per minute, then definitely the D option would have been clear, right? So ma'am, so learn with Dr. Learn with Sky, it is not less than 60. Less than 60, don't fall in this trap. Tomorrow I give you a question, a newborn is born at the time of delivery, the newborn's heart rate is 40 per minute. What do I do? Will you start chest compressions? You will not. You will again start with, first is your initial steps and then positive pressure ventilation. Usually they will not give initial steps as option. They will give you an option of positive pressure ventilation and chest compression, and because you have seen a heart rate of 40, you will fall in the trap and you will start with chest compression, which is a wrong answer. Remember that the correct answer over here is you start chest compression when the heart rate is less than 60. Agree with you. Despite is very important. Everybody forgets that. Despite 30 seconds of effective positive pressure ventilation. So here very clearly somebody is saying MR SOFA. It is not MR SOFA, it is MR SOPA. So MR SOPA, that means the ventilation corrective steps have to be done. So you can see over here, bacha, so we have, heart rate is less than 100 per minute. We have started ventilation over here. See, and heart rate is again less than 60 over here. Then first is again you go for ventilation corrective steps. That is, here we have to go for ventilation corrective steps. Okay, now that ventilation corrective steps can be putting a endotracheal tube or putting in a laryngeal mask or ensuring a proper seal. So how do you remember these ventilation corrective steps is by going for this. So these are MR SOPA. This is the mnemonic for ventilation corrective steps. So this what you have to done, and after this, if still after 30 seconds of ventilation corrective steps the heart rate is 40, the heart rate is 58, the heart rate is 55, then you go for chest compressions. I hope this is very clear to you. Every time so learn hands. Yes, I hope. Yeah, I'm happy. So Dr. Learn with Sky is happy that at least things are clear at this end, because this is one trap every student falls into. So that you have to be very clear that ventilation corrective steps have been done, effective positive pressure ventilation has been done, and after that you add on chest compression. You never start with chest compression whenever you see heart rate less than 60. Remember this. Again and again I'm telling you. So let us come back to our question. So the question was, what do we do? Yes, the correct answer over here would be take ventilation corrective steps. Now here what I was expecting is you will say, ma'am, increase the pressure of positive pressure ventilation bhi to ventilation corrective steps hai. Of course this was a googly question for you. So anybody who has gone for the C option is correct. A option is not wrong. That is a part and parcel of the ventilation corrective steps. But of course you have to see the broader picture. A broader picture would be the correct option would be take ventilation corrective steps. I was expecting a war between A and C, but you just took me off guard. आपने मेरे पे गूगली डाल दी. ठीक है, चलो आगे चलते हैं. So all of the given statement about growth in infants are true except. So let us see the growth. This is again very important, part and parcel of your syllabus for the exam, anthropometry. You should know that very clearly. So increase in length in the first year of life is by 50%. Is that clear? Of course, yes. This is a correct statement. How do we know that? आपको पता है at birth the length of the child is 50 centimeter. At 1 year of age it becomes 75 centimeter. That means there is a gain of 25 centimeters. And what is 25 centimeters? Is 50% of the birth length. So yes, the increase is 50%. Then head circumference becomes equal to chest circumference by 2 years of age. Okay, so let us see if this is true or false. I am just leaving it right now. Birth weight quadruples by 2 years of age. We know that birth weight, let us assume the average birth weight is 3 kg. You know it doubles by what time? 5 months, right? Then it triples by what time? 1 year, right? And then it quadruples by, that is 4 times, right? Quadruples by what time? This is 2 years, 2 years of age, right? Not 12 years, it is 2 years of age. So yes, this is a correct statement. Birth weight quadruples by 2 years of age. And the rate of increase of head circumference between 4 to 6 months of life is 1 centimeter per month. So you should be knowing this. In the 0 to 3 months, the increase is 2 centimeter per month of the head circumference. We know this. 3 to 6 is 1 centimeter per month, right? And then 6 to 12 months or 7 to 12 months, it is what? 0.5 centimeter per month, right? So we should know these rate of head circumference increase. Let us revisit the second option. Yes, I am getting it clear. Yes, doctor. So Dr. Sahib has given me the D option. No, bacha, D option is a true statement. ठीक है, we are looking for a false statement. Dr. Adarsh says B statement. Yes, of course, the B is the answer over here. Remember that head circumference becomes equal to the chest circumference by 1 year of age. Remember that, right? So that is the B option. Yes, so everybody is giving me the correct option. Yes, Learn with Sky also tells me that the option is B, and he's written many number of times. I have got your this response. So it is B option over here, which is the incorrect, because everybody knows head circumference becomes equal to chest circumference at 1 year of age, and thereafter the chest circumference slightly surpasses the head circumference, right? So that is it. So I think that brings us to the end of this session over here as far as the pediatrics questions are concerned. So all the best, study hard, keep MCQing, sky is the limit for you. I'm sure you will do very nicely in your exams, and my all the very best wishes and good wishes with you, right? Okay, so that is it. So signing off, this is Dr. Dipali Gupta, your pediatrics faculty at Allen Next, and the next faculty will follow and will discuss the other subject questions with you. Thank you.
Good evening, friends. Welcome to the session of psychiatry. Question number 1. A patient is on haloperidol 5 milligram. Okay, 5 milligram haloperidol twice a day. You know haloperidol is first generation antipsychotic, first generation or typical antipsychotic, and you know typical antipsychotic is associated with extrapyramidal side effects. Okay, although atypical antipsychotic also have extrapyramidal side effect, question has been asked that extrapyramidal side effect are more commonly associated with first generation, okay, than second generation. So in EPS, earliest EPS is acute muscle dystonia. Acute muscle dystonia. Muscle dystonia means tone is changed, contraction of extraocular muscle. There would be oculogyric crisis, uprolling of eyeball. That is acute muscle dystonia. In this question, the patient developed prolonged uprolling of eyeball after haloperidol. This is acute muscle dystonia. Earliest EPS, more common with first generation antipsychotic. Okay, and the treatment for this is injection benstropin, not given the option, or injection promethazine. So in this, injection promethazine. Okay, it's not normal side effect. Propanol is used in EPS akathisia. This is not convergent disorder, directly related to the haloperidol. Very good, correct answer, Shiva. Answer is C. So EPS, acute muscle dystonia, I just told you. Akathisia, yes, I told you the treatment, beta blocker. This is subjective and objective restlessness. Tardive dyskinesia, that is perioral movement. Okay. Now, 25-year-old female was brought to casualty after she attempted suicide. Wrist are slashed, multiple linear scar mark. I have told many times, multiple line borderline. Okay, so borderline personality disorder, in this impulsivity is there. On small issue, they cut their wrist, they injure themselves. Means brother did not give her biscuit, in anger, wrist cut. So borderline, multiple line personality disorder. They have difficulty in maintaining interpersonal relationship. Recurrent mood fluctuations are there. This is borderline. Let me discuss little bit about other. Schizoid. Mnemonic is shy. SHY. Okay, they prefer solitary activity. Means a person is sitting since morning to evening in library without girlfriend. Okay, not interacting to anybody. That is schizoid personality, and he is happy. All personality disorder are egosyntonic. This question has been asked. Egosyntonic. Okay. Histrionic personality, you will remember Rakhi Sawant. Okay. Yes. Histrionic personality, they want to be center of attention. Yes, they are dramatic, exaggerated emotions are there. They behave in sexually seductive way, use physical appearance. This is histrionic personality. Okay. Schizotypal personality disorder, they have magical thinking. What is magical thinking? The person say 1, 2, 3, I tapped it, there would be rain in Bombay. This is magical thinking. Okay. Now, good prognostic factors of schizophrenia are all except. So previous question, the answer was yes, borderline personality disorder. Now, good prognostic factor are all except. This is very important topic for FMGE exam. So schizophrenia type 1, type 2. You will remember type 1, type 2. Type 1 is having good prognosis and type 2 is having poor prognosis. So you will remember what is type 1 if onset is acute. If acute onset, then it is type 1. Precipitating factor present. symptoms are positive symptoms. Positive symptom means hallucination and delusion. Family history of mood disorder. Emotions are present. CT MRI normal. So if type 1 is there, prognosis is good. Acute onset, prognosis is good. Emotions are present, prognosis is good. A question was asked, there is a schizophrenic patient is taking treatment. Now patient started crying. Prognosis is yes, good. Prognosis is good. So if crying means emotions are present, prognosis is good. Now you can solve question. Acute onset, good prognosis. Female, yes, good prognosis. Depression or family history of depression. Family history of depression, both are good prognostic factor. Onset in early adolescence, yes, this is poor prognostic factor. So other than these, you will write here good prognostic factor. One is late onset. This is not. There is some technical issue. Hi, dear friends. Let me check it. Okay, friends. So good prognostic factor. Other good prognostic factors are late onset. One. Second is female. Third is married. In most of the psychiatric disorder, whenever person is single, prognosis may be poor, and whenever married, prognosis may be better because support is there. Other than yes, mood disorder is present, then it is good prognostic factor. So early onset is poor prognostic factor. Okay, friends. So now type 2 you can easily remember. Insidious onset, poor prognostic factor. Precipitating factor absent, poor prognostic factor. Negative symptoms are there. Anhedonia is there. Yes, negative symptoms, poor prognostic factor. Family history of schizophrenia, you will remember this. This is very important table. Most of time you will find family history present, absent. But in both of type 1 and type 2, family history is present. If family history of mood disorder is there, prognosis is good. If family history of schizophrenia is there, prognosis is poor. Emotions are absent, prognosis is poor. CT MRI finding is present, then prognosis is poor. What is the finding? Question has been asked. Bilateral temporal lobe atrophy. Temporal lobe atrophy. So these are poor prognostic factor. Okay. The fourth question, depression, you know the symptoms. EMI, gaps cause depression. Okay. Energy, mood, interest, guilt, appetite, yes, psychomotor activity, sleep, suicidal, concentration. in the out of these symptoms, according to DSM-5, if 5 symptoms are there for 2 weeks, the diagnosis is depression. The diagnosis is depression. Now, in this question, whenever clinical questions are asked on depression, always count the number of symptom. Yes, 26-year-old girl presenting psychiatric OPD with depressed mood. First symptom, anhedonia, decreased interest, not getting pleasure in previously pleasurable activity, decreased energy. Third symptom, having difficulty sleep. Fourth symptom, not eating properly. Fifth symptom, 5 symptoms for more than 2 weeks. Diagnosis is depression. But they have said that this patient has been experiencing mild feeling, means mild symptom of depression for many years. And you know, if depressive symptoms are there for 2 years, but they don't fulfill the criteria, that is dysthymia. So I draw here, if a patient is having depressive symptom for 2 years, but don't fulfill the criteria, dysthymia. Okay, and if these dysthymic patient develop few more symptoms and develop depression, then it is double depression. Just like in this question, they have said the patient was having mild depressive symptoms for many years, means patient was having dysthymia. But for 3 weeks, now the all 5 symptoms are there. Now the diagnosis is depression, means this is depression in dysthymic patient, double depression. So this question has been asked in FMG. They ask simple question that is double depression is depression in dysthymic patient. तो ये मैंने deliberately क्वेश्चन को फ्रेम किया है, which has been asked in a single liner form. They can make clinical question. Okay, dear friends? Yes, catatonic is good prognostic factor. Yes, let me write here because you have mentioned this. This is very important question for FMG. Catatonic, then paranoid, then hebephrenic or disorganized, and fourth is simple. So yes, catatonic is best prognosis, paranoid good prognosis, hebephrenic poor prognosis, simple worst prognosis. Okay, this is controversial, so don't get confused. Simple is having worst, simple schizophrenia, worst prognosis is there. Okay, negative symptoms are very difficult to be treated. Now paranoid, a clinical question has been asked. I will mention here paranoid. P4 paranoid, P4 positive symptom. In paranoid, positive symptoms are there, means delusion and hallucination are there. Okay, and this is having good prognosis. They gave clinical question that the patient is having hallucination, patient is suspicious of family member or neighbor. What is the type of schizophrenia? That is paranoid schizophrenia. Got the point? Now, in this double depression, major depression, I told you major depression or major unipolar depression is same. In this question, depression criteria is fulfilled, depression is there, but previously patient is having dysthymia, so it is double depression. Okay. Seasonal affective disorder, every time depression is occurring in a particular season, just like winters, and the treatment is bright light therapy or phototherapy. Sometimes question has been asked. Phototherapy. Atypical depression, in depression sleep and appetite usually decreases. Atypical depression, sleep appetite increases. Atypical है, जो typically नहीं होता वो है ये reactivity of mood present. What does it mean? A question has been asked previously in FMG. They mentioned that the patient की mood की reactivity है, means patient would go outside with his friend, will enjoy, when he will come back again he is sad. Means कुछ stimulus आया, कुछ positive stimulus आया, patient better हो गया. Okay, atypical depression, yes. And one question long time back, they have leaden paralysis. Means patient would say, Doctor साहब, my limbs are too heavy, बहुत heavy है, मैं move नहीं कर सकता. Actually paralysis is not there, but patient feel his limb as heavy as lead and can't move, latent paralysis. इसका टिपिकल निमोनिक बनाता हूं मैं. एक पेरेंट आया, बूढ़े बाबा आए बच्चे के साथ, कहने लगे डॉक्टर साहब परेशान कर रखा है, पूरे दिन खाता है, पूरे दिन सोता है, और कोई अच्छी बात हो, गर्लफ्रेंड का फोन आ जाए अटेंड करता है, बड़े मजे लेता है और कहता है मुझे डिप्रेशन है. इसे काम करने को कहो तो कहता है मेरे तो पैरालिसिस हो गई. तो हम उसे समझाएंगे बाबा ऐसा कुछ नहीं है, झूठ नहीं बोल रहा, हो सकता है इसको क्या हो, एटिपिकल डिप्रेशन. तो याद रहेगा एटिपिकल डिप्रेशन. यस, नाउ वी कम टू, यस, 30-year-old मेल इज ब्रॉट टू ओपीडी बाय हिज फैमिली मेंबर. मैं बार बार कह रहा हूं कि एफएमजी में क्लिनिकल क्वेश्चंस आ रहे हैं, बट मैनी टाइम्स दे गिव यूजलेस हिस्ट्री और डिटेल. समटाइम इट इज यूजलेस बट इतनी इंपॉर्टेंट नहीं होती. ओके, जस्ट लाइक इन दिस क्वेश्चन इंपॉर्टेंट नहीं है. उसका इंपॉर्टेंट कहां है कि पेशेंट टॉक्स वेरी कॉन्फिडेंटली हाई ऑफ हिम, ही सेज दैट ही फील एज किंग ऑफ वर्ल्ड, ही कैन डू एनीथिंग. दिस इज डिल्यूजन ऑफ ग्रैंडियोसिटी, डिल्यूजन ऑफ ग्रैंडियोसिटी. उसने मेनिया के सिम्टम बताए इन दिस क्वेश्चन. दे हैव गिवन द सिम्टम्स ऑफ मेनिया. यस, कंसंट्रेशन ऑफ एनी वर्क, unable to concentrate, hyperactive, okay, sleepless, very talkative, impulsive. Okay, so this is manic symptoms, bipolar type symptom. Okay, now in this question they have asked correct regarding this case. This is disorder of content of thought. Delusion is disorder of content of thought. This is very very important topic. Disorder of perception, illusion, hallucination. Illusion means misinterpretation of stimuli, misinterpretation of stimuli. Recently asked question. Illusion is first, yes. Hallucination, yes. Perception without stimulus, perception without stimulus. Recently asked question, difference between hallucination and pseudo hallucination. Hallucination occur in objective space. Pseudo hallucination, S for pseudo, S for subjective space. Subjective space. Disorder of form or possession. तो आंसर तो A है. Disorder of possession, mnemonic, obsession, possession. Okay. Obsession are disorder of possession. If possession is not given in the option, then you can mark content. Okay, but obsession, possession. मैंने याद रखा possession के disorder PK मूवी से. PK was alien, so thought alienation, alien. Then thought broadcasting. Yes, thought alienation include thought broadcasting. If you remember this alien, he was having radio. Radio मतलब broadcasting. So that is PK movie broadcasting. Thought broadcasting is disorder of possession. Thought insertion, thought withdrawal. If you remember this movie, yes, she was thinking something to be inserted, but he was withdrawing the thought. Thought withdrawal, thought insertion. तो PK मूवी का निमोनिक बन गया हमारा, और याद रहेगा हमें कि these are disorder of possession of thought. Form of thought, again mnemonic. Yes, form as platform of train. जहां पे भी ट्रेन से रिलेटेड हो, wherever you find anything related to train, then it is disorder of form of thought. Derailment, rail. Yes, पटरी से उतर गई रेल. Derailment. Loosening of association means association between two thought is lost. बग्गी के बीच में association lose हो गया. Incoherence, complete loss of organization, accident हो गया. Yes. टेंजेंशियलिटी, जैसे कि तुमने टॉय ट्रेन देखी होगी, उसमें टेंजेंट पाथवे होता है, टेंजेंशियलिटी. नियोलोगिज्म, नई लोगी नई बोगी, एक नई बोगी जोड़ देते हैं. ये टॉय है, ट्रेन टॉय, इसमें पाथवे इज सर्कुलर, तो सर्कमस्टेंशियलिटी. एक ही पाथवे अगेन एंड अगेन, परसिवरेशन, वन पाथवे इज बीइंग प्रिजर्व्ड, निमोनिक. थॉट ब्लॉक, ये सब क्या है, टॉय ब्लॉक हैं. यस, थॉट ब्लॉक. सो यू विल रिमेंबर ऑल दीज आर डिसऑर्डर ऑफ फॉर्म ऑफ थॉट. दिस इज पोटेंशियल क्वेश्चन. Person, recently asked question, controversial. If question is asked obsession or disorder of, better answer would be possession. Answer is A. Yes, in this double depression, depression is very important. You must have an idea about the symptoms, 5 symptoms for 2 weeks. Schizophrenia, yes, types of schizophrenia. Now these types has been removed according to ICD-11 and DSM-5. This can be a question. Update. Histrionic personality, yes, different type of personality. All personality disorder are egosyntonic except avoidant personality disorder, which is ego dystonic. Okay, and extrapyramidal side effect, recently asked question. Akathisia, yes, treatment is beta blocker, subjective and objective restlessness. Okay, thank you friends for delusion of, yes, grandiosity. कभी कभी अपन को लगता है अपन ही भगवान है, यस। और दोस्तों कल हम आ रहे हैं मन की बात लेके, इसमें हम कुछ टॉपिक डिस्कस करेंगे। अश्विनी भाई और मैं कल 6:30 बजे आपसे कनेक्ट होंगे, और कोई भी तुम्हारे डाउट हो, तुम्हें लगता है कि यार ये चीज़ परेशान कर रही है, इमोशनली डिस्टर्ब कर रही है या टेंशन दे रही है, तो यू कैन डिस्कस विद अस ऑन दैट प्लेटफॉर्म, और या क्वेश्चन यहाँ पे भी डाल सकते हैं आप। आई विल टेक दोज क्वेश्चंस, और कल हम लाइव डिस्कस करेंगे वो सभी पॉइंट्स और कुछ इंपॉर्टेंट टॉपिक्स जस्ट लाइक प्रोग्राम्स इन पीएसएम, और कुछ टॉपिक्स हम डिस्कस करेंगे। ओके, कुछ निमोनिक्स डिस्कस करेंगे। थैंक यू। Circumstantiality, okay dear, circumstantiality is again controversial. That's why these three are controversial. Few books says that these three are disorder of stream of thought. Okay, but yes, fish psychopathology says that it is disorder of stream of thought, but Kaplan says these are disorder of form of thought. So depending on the question, Shiva, depending on the question, according to me, better answer is form of thought, disorder of form of thought. Okay, thank you. Any other question?
Hi la bedu log. Hello bhai log. A very warm welcome to all my friends in this CBoT PSM discussion session. You can ask your doubt questions in the chat box. मजा आएगा अगर आप कुछ सवाल पूछेंगे तो. I would really love that. चलो, coming to the first question, they are asking ICTC centers and sentinel surveillance are done in which program? So if you know, please do reply. Thank you, Dr. Cheetah, Dr. Siva Tripathi, Dr. Anil Tanan, Anda Huzaifa for joining the session and asking your doubt questions here. So it is done in which program? ICTS means it is Integrated Counseling and Testing Center. So integrated counseling and testing, these are needed in case of HIV. Okay, and this HIV sentinel surveillance is done to know trend of HIV in different states of India. So these both are part of NACO. Now there are three questions which come from this part. First question, this counseling and testing is which level of prevention? So whenever there is testing means early detection and treatment. Do you know which level it will go? Early detection and treatment, all are example of secondary. So ICTC are example of secondary level of prevention. Second point, in this HIV sentinel surveillance, what are the various group which are included on which we do it? किन लोगों पे करते हैं? So in the HIV sentinel surveillance, there are high risk group. बताओ क्या डॉक्टर हाई रिस्क ग्रुप हैं HIV के लिए? Then there are bridge population. Tell me, are doctor belong to high risk group? And then there is ANC mother. So what happen is कि high risk group and bridge population, they do not come to hospital. We go to them and we search for hidden case. That's why it is active surveillance. Active surveillance आप सबको पता होगा, हम लोग मलेरिया में भी करते हैं. In malaria, when we do active surveillance, MPW visit home to home and make 2 blood film from every case of fever. So that is there. Tell me, does doctor come in high risk group? My Cheetah student is writing that truck driver come in high risk. Truck driver are there in sentinel surveillance. You are right, Cheetah. Long distance truck driver are in bridge population. Not long distance relationship people, but truck driver are in bridge population. So tell me, does doctor come in high risk group? Because in bridge population there are 2 people. One is long distance truck driver, second are single migratory worker. वो यहां से सवाल ऐसे पूछते हैं, they will ask कि which of the following is not included in HIV sentinel surveillance. So you should know which are included, only then you can say which are not included. Single migratory worker are also in the bridge population. Now, Dr. Siva Tripathi, Cheetah Anda and Dr. Huzaifa all are saying that doctors are coming in high risk group. No, my dear friend, you have not performed that well. Doctor don't come in high risk group. Sex worker come in that group. So you need to increase your performance to come in this group. You are still underperforming. Sex worker, not sex group, sex worker. Second people who come are transgender. Third group of people who come are MSM. MSM means male having sex with male. And fourth group which come under it is intravenous drug user. So total there are 7 people included in HIV sentinel surveillance. 4 high risk group, 2 bridge population, 1 ANC mother. ANC mother come to hospital by themselves. So whoever come to hospital by themselves, इनको कहते हैं passive, क्योंकि ये खुद से आ रहे हैं. They are passive surveillance. And passive surveillance will tell about notified case. Active surveillance will tell about hidden case. छुपे हुए केस को पता लगाने के लिए हमें उनके पास जाके पता लगाना होता है. पैसिव खुद से आते हैं तो हॉस्पिटल में नोटिफाइड हो जाते हैं. And when you mix active and passive, then it becomes sentinel surveillance. So remember, sentinel surveillance is for all cases. And these are the 7 people which come under it. And STD patient do not come under it. Don't come under it. So where do STD patient go? STD patient go to Suraksha Clinic. This is a common question being asked multiple times. Suraksha Clinic have this logo in which it will be similar to Red Cross, but only difference is there will be a central this thing. This is Red Cross. This is the logo of Suraksha Clinic. अगर अंदर में खाली है तो सुरक्षा क्लिनिक है, भरा है तो रेड क्रॉस है. और सुरक्षा क्लिनिक इज फॉर एसटीडी पेशेंट. रिमेंबर, सुरक्षा क्लिनिक एंड मोबाइल मेडिकल यूनिट both are example of public private partnership, and in both of them medicine come from government. Okay, all this has been asked in previous exam. Medicine is given by government in Suraksha Clinic and mobile medical unit both. So I think you understand the thing, why they are bridge population, truck driver and single migratory worker, because they go to sex worker. Sometime, not all of them, but some of them. And from sex worker, they transmit HIV infection to their innocent wife back at home. So they are acting like a bridge. Okay? And tell me one thing, I also go to different states to take 4-day, 5-day class. Someday I go to other countries, Philippines, Kyrgyzstan, 10-day, 15-day, 20-day class. So am I a migratory worker? Yes or no? What do you think? Okay. So do remember, they are part of HIV sentinel surveillance. One more question come here is, तो क्वेश्चन क्लियर है, कौन लोग नहीं है सेंटिनल सर्वेलेंस? ये 7 हैं, बाकी नहीं. सेकंड थिंग दे आस्क, व्हाट डू यू मीन बाय मॉडरेट प्रिवलेंस स्टेट? मॉडरेट प्रिवलेंस स्टेट उनको कहेंगे जहां HIV इन हाई रिस्क ग्रुप इज मोर देन 5% एंड HIV in ANC is less than 1%. Because अगर ANC मदर में HIV है तो वो ज्यादा डेंजरस बात है. दिस इज मोर डेंजरस. इफ ANC mother has more than ANC mother have HIV, it means HIV has spread in the general population. So we want to keep it less than 1%. And high risk group, if it is more than 5%, it's okay, no problem. It's a problem, but it's not a bigger problem than ANC. ANC more than 1 is more bigger problem. So we first try to reduce ANC HIV, then we focus on high risk group. Okay. So my friend Dr. Josefa is saying, hope not as migratory worker. Thank you, dear. Yes, I am not a migratory worker because for being a single migratory worker, the duration of stay should be longer. And my duration of stay is 20-day, 15-day maximum. So it's not that big duration of stay. Okay. Now, coming on to the next question. There is a lot of questions which came from it. I hope you will remember them all. The antibody for varicella were negative in pregnant women. If antibody is present, that means the mother is immune. क्योंकि रोग प्रतिरोधक क्षमता आ चुकी है, तो इसका मतलब लड़ने की ताकत आ गई है, इम्यूनिटी आ गई है. But when antibody are not there, it means now the mother can acquire infection. She is susceptible to chickenpox. Do remember 3 points about chickenpox. First of all, chickenpox isolation is done for 6 days. Second thing, if chickenpox occur, we give varicella zoster immunoglobulin, and the first preference is given to pregnant lady. And this varicella zoster immunoglobulin is given within 72 hours. But if they write in the question that there is an adult male hostel or boy hostel, in the hostel condition, varicella means of course adult hostel, varicella zoster immunoglobulin not needed. Because chickenpox has 2 complications. The most common complication is superficial secondary skin infection by streptococcus. And second is pneumonia, and then. So serious complication do not occur in adult. That's why it is not given in adult. Okay, this was a question in NEET exam recently asked, so do remember. Chalo, very good. So now I hope this question is clear to you. Which of the following vaccine is given in post-splenectomy patient? Remember, post-splenectomy, whenever they ask, they want to tell you about immunocompromised patient. And sometimes they can also write as old age patient, HIV positive patient. And in all of them, what is the most common cause of death in old age? हमारे प्यारे प्यारे बुढ़ऊ लोग क्यों टपक जाते हैं बुढ़ापे में? क्या रीजन हो सकता है? Most common reason, of course, BP, sugar are non-communicable reason, so non-communicable disease, so vaccine are not needed there. Other than that, most common reason is of course pneumonia. So their death is due to pneumonia. That's why which vaccine will you give? Pneumococcal conjugate vaccine is given to all such patient. Okay. Capsulated organism, C is the answer. Very good. Tabassum, Josefa, M. Rahman, Sultan Ali. All of you are right. And in hepatitis B, they have asked that which will be used. In hepatitis B vaccine, what do we use? HBCAG, HBsAg, HBeAg, or HBV DNA? So of course we use DNA. DNA is definitely used because hepatitis B is a recombinant vaccine. Along with DNA, which is used out of the three? Along with DNA, we also use HBsAg. Surface antigen is used. So that is a recombinant vaccine with these two components. Hepatitis B. Remember? AsAg. And I like my name. As1E. Similarly. Chalo, coming to next question. In Saharanpur, UP, there is a Japanese encephalitis outbreak. Boom. Which route should be preferably used to administer the vaccine for most likely infection? So we will use live and subcutaneous. This was the question in NEET also. Remember, MR and JE both are given live and subcutaneous. In JE, the name of the strain is SA1414 2 bar, 1414 2 times. Killed and intramuscular was Nakayama strain, and Nakayama is nakamyab. We don't use it anymore. So it is not in use anymore. We don't use it. And don't you think that JE is only endemic in UP. It is endemic in 21 states of India. So it's a common thing to be for endemicity. Now, let's come to the next question. To find the risk factor for obesity, a cohort study was carried out. Which group won't be accepted? Yes, it's a challenge for all of you. Let's see whether you are right or wrong here. Please, if you can answer, do answer. Sultan Ali was right. Tabassum Rasid was right in last time. Ishu Yadav is laughing. Thank you so much. You are laughing on my ass. Very good. Come here. What is the answer? First of all, it's a cohort study. And cohort studies start with risk factor present, risk factor absent. In place of risk factor, we can also write exposure present and exposure absent. If it is a case control study, this is the way to find out which study they are talking about. If this is case control, case are case hai be. We say it normally also to our friend. Ke bhai case hai be. It means he is having something abnormal. Outcome is there or disease is there. And control means outcome or disease absent. Outcome absent, disease absent. So here, what is the disease? Out of the 4 options, which one have the disease in it? बीमारी क्या है? क्या smoking बीमारी है? No, smoking are risk factor. क्या eat online food ordering बीमारी है? Eat online food or not? नहीं, online food ordering is also just risk which can lead to obesity. क्या exercise बीमारी है? नहीं, ये तो बीमारी से बचाव है. So what is the illness? Illness is obesity out of these four. And in case control, we will have two group, obese, non-obese. So obese, non-obese will be in case control. Rest all have risk factor. So rest of them will be example of cohort. But obese, non-obese will be example of case control. तो इस बात को आप बड़ी आसानी से समझ सकते हैं कि जहां भी बीमारी है, बीमारी नहीं है बोल रहा है, वो केस कंट्रोल हो जाएगा, और जहां भी खतरा प्रेजेंट, खतरा एब्सेंट है, वो कोहॉर्ट हो जाएगा. So in all such study, you have to look what are the two group they are talking about. Like I hope you have done such questions, but still let me repeat one example which can make you further better. Eating paratha, especially varma paratha in night, है ना, can lead to gastritis. मुझे अभी भी याद है, when we were preparing in Gotham city, Gotham Nagar, we were there. If we used to eat varma paratha in the night, then whole night our jet used to take off again and again, take off again and again, bloom blam. माहौल गर्म हो जाता था एकदम. So eating paratha in night can lead to gastritis. In a study, participant with gastritis are compared with participant without gastritis in terms of their paratha intake. In terms of intake of paratha. So this is which study? It represents which study? Can you answer me which study is here? In this question, which study is done? Option A, it's an example of cross-sectional study. Option B, it's an example of case control study. C, cohort. Or D, ecological. You can also have E as randomized control trial. So, I am waiting for your answer. Please do reply. And this is a common type of confusing question which they ask in MCI exams. So, and of course in NEET also. So, you should be sure how to use it. Sultan Ali is saying कि सर मूली के पराठे से ज़्यादा गर्म होता है. वाह सुल्तान, है ना, रे सुल्तान कर दे चढ़ाई, क्या बात है. वेरी गुड सुल्तान, वेरी गुड. चलो, सो हाउ टू आइडेंटिफाई सच स्टडीज. देखो, इन द बिगिनिंग फेज यू हैव टू मार्क कि कहानी शुरू कहां से हुई है, कारण क्या है, व्हाट इज द रिस्क फैक्टर, व्हाट इज द एक्सपोजर. सो रिस्क फैक्टर इज पराठा, एंड देन यू हैव टू थिंक व्हाट इज द डिजीज और आउटकम. सो डिजीज इज गैस्ट्राइटिस. Now, remember, case control is when there is disease present, disease absent. We talked about it last time. Case control means disease present, disease absent. What is the disease? Gastritis. So, if the two group is with gastritis, without gastritis, it means they are talking about disease present, disease absent. And if it is disease present, absent, it is a case control study, which Dr. Anuradha and Dr. Huzaifa answered earlier, but then Dr. Huzaifa changed his answer from case control to cohort and you became wrong. So that's why even Saswat Ray sir requested, I also requested, always go with your first answer because most of the time they are correct. Your gut feeling is more correct. Here, already there are people with disease, without disease. With and without disease means case control. If it is a cohort study, then the two group will be paratha eating present, paratha eating absent. अगर कारण present absent है, paratha present absent है, cohort होगा. Reason present absent, exposure present absent, that is cohort. Disease present absent is case control. I hope you all agree. Chalo, very good. Now let's move ahead. In the program of Anemia Mukt Bharat, who is the target age group for the blue tablet and what is the dose for them? So मैंने बोला रे सुल्तान कर दे चढ़ाई, भाई ने लिखा फॉरवर्ड. Very good. So it is a backward study in the last time. केस कंट्रोल इज ए बैकवर्ड स्टडी. हम लोग बीमार ऑलरेडी हो चुका है, लोग गैस है गैस नहीं है. हम पूछ रहे हैं कि आप में से किसने पास्ट में मूली के पराठे खाए थे वर्मा पराठे से. इन द पास्ट हु ऑफ यू हैव ईटन द पराठा. वी आर आस्किंग फ्रॉम द टू ग्रुप, one with gastritis, one without gastritis. So this is retrospective study, not retrospective cohort, retrospective study. है ना? In retrospective cohort, remember there will be this line that written record is available or work record is available. Then it will be retrospective cohort. Okay. Chalo, very good. So this is Anemia Mukt Bharat, correct? Dr. Huzaifa, it is 6 into 6 into 6 strategy. बड़ा ही छक्का program है. First 6 are the benefit which will be given. Second 6 are the beneficiary which will be there. And last 6 are the institutional mechanism, method by which it is given. And remember, the target of Anemia Mukt Bharat is 3% reduction of anemia each year. But I have this intuition that they will ask about Poshan Abhiyan this time in your exam. The target of Poshan Abhiyan is reduce malnutrition by 2% each year. Malnutrition, stunting, wasting, each should be reduced by 2%. So Poshan is 2%, Anemia Mukt Bharat is 3%. Now, this blue tablet is for adolescent boys and girls. But dose is not 45-400. What is the correct dose? Some are writing C, some are writing A. Correct dose is C, 60 and 500. This dose, 45 and 400, this is for 5 to 10 year boys and girls, 5 to 10 year, and pink tablet will be there. So this is pink, this one is blue, and then 60 and 50 adult female, this one is red. And all these three, pink, blue, red, in adult female, in children, in adolescent, all of them are given once a week. So the mnemonic to remember them is PBR. PBR is similar to PVR. हम लोग, we go to PVR to watch movie na. Of course, some naughty people like you, they go to PVR to do other thing also, है ना? So, in a week, how many movies are released in PVR? In 1 week, one movie is released. Like, movies are released once a week, na? Thursday, movies are released. So, just like that, once a week, we take these 3 tablets, pink, blue, red. But, if it is 6 month to 5 year children, in them we have to go give low dose, and because we have to give low dose, we divide weekly dose into 2 and we give twice a week 1 ml IFA, and this 1 ml IFA is given with 20 milligram iron and 100 microgram folic acid. So it's so easy to remember. 20 into 5, 100. And because it is children, we have to give low dose, so twice a week. Last group is pregnant and lactating mothers like me. So in pregnancy and lactation, we give the same tablet 60 and 500. This is the same tablet which we give in pregnancy and lactation. But of course, in pregnancy and lactation, if you give 1 tablet per week, mother will throw the tablet on your face. Or, and you understand. So you cannot give once a week. In pregnancy lactation, we give it 180 day before and after delivery. In the first 3 months, iron tablet are not started. They are started after first trimester. So from 4th month to 9th month, total 6 months, 180 day. And then 6 months after delivery also, we give this IFA tablet with 60 milligram iron, 500 microgram folic acid. Okay. So I hope you will remember the mnemonic PBR, pediatric and lactating adult, lactating and pregnant female, they get it, lactating pregnant, they get it once a day, pediatric, they get twice a week. So please do remember the dose and all the questions which are here, very important slide for your exam. Next question. Pregnant female, not bi-weekly. Pregnant female once a day. Okay. Now, which is this image shown here? And what is your answer? No, they are not doing orgy. What is the thing they are doing here? Can you tell? It is a focus group discussion. Because in a focus group discussion, there will be no audience. You can see there is no audience. They are talking with each other in a round table. This is 6 to 12 group. They have asked this question in FMGE exam previously. 6 to 12 group of people who talk among each other. That is focus group discussion. It can tell us about the superstition which they have, the cultural barrier which they have, that can be told. Now, what is the difference between panel discussion and symposium? In panel discussion, 4 to 6 experts speak on a topic, but there is no fixed sequence of talking, and audience can ask question in between. Okay, but symposium is more of a boring thing where there is a fixed sequence in which all the experts speak. So fixed sequence is in symposium. Second thing, in symposium, question will be asked by audience at end of discussion, not in between. Okay, so do remember they are asking question from this part, symposium panel discussion. Now, if they ask, what is the best way to tell ORS preparation? Can you tell me best way to teach ORS preparation? Or best way to teach use of condom? Both of them, the best way is demonstration. Or suppose you want to teach the people how to use pulse oximeter and all. Demonstration is best way. Okay. I still remember our professor used to tell that during their PG time in 70s, one time they went into village and told the villager that imagine this finger as your penis, condom you have to wear like this and then go for sex, children will not be born. So after some 5-6 months, when the professor went back to the village, and villagers complained that, sir, we are using condom but still children are being born. So sir asked that, how is it possible? Show me how you do it. Maybe you are not wearing condom properly. So this demonstrated, they wear condom on finger and started doing, like said, now I am ready for sex. So demonstration should be accurately told, not like that. Okay. Yes, very good, Dr. Aswa. You are right. Demonstration. Sahab is also right. Shivangi Sinha, Anuradha, all of you are right. Dr. Huzaifa and Sahib are also right. Very good. Coming to the next question. A woman went to family planning clinic to get advice on contraception. It was discovered during the gathering of her medical history that her mother has undergone breast cancer surgery within the previous year. What kind of contraception does this woman should prefer? Because there is breast cancer surgeries. See, there is a bit of controversy on this thing, but OCP increases some cancer and decreases some cancer, which can be really confusing under exam pressure. So how we used to think, OCP is from O and OCP increases outside cancer. O for OCP, O for outside. Outside cancer are breast and cervix, which are in a female body, they are comparatively outside. Of course, I know vagina is outside, not cervix, but compared to uterus, cervix is outside. So these two cancer is increased by OCP. And OCP decreases two cancers, which are endometrial or uterine cancers, because it is inside, and ovarian cancer. These two cancer are decreased by OCP. Plus do remember, OCP also decrease ectopic pregnancy, very commonly asked, and OCP also decrease PID. These two, ectopic is very commonly asked. OCP decreases ectopic and PID. So because breast cancer surgery has been done, we cannot give hormone to the mother, especially estrogen and all, which can lead to further breast cancer thing. Mirena is third generation IUCD. And third generation IUCD are hormonal IUCD. And Mirena protect for 7 to 10 year maximum. average 5 to 7 years. So we cannot give Mirena because it has hormone. Mala N is of course normal dose OCP. Mala N has 30 microgram ethanyl estradiol plus 150 microgram of levonorgestrel. Okay. So this is Mala N, which is free of cost. Mala D is also the same thing as Mala N. Only difference is Mala D costs 3 to 5 rupees per strip, but Mala N is normal free. Okay. And remember, this is normal dose OCP. If we have low dose OCP have a dose of 20 microgram ethanyl estradiol and same 150 microgram levonorgestrel. So only difference is dose is 10 less. So we cannot give Mala N. Dampa is depot medroxyprogesterone acetate with 150 milligram of levonorgestrel, and it protect for 3 months. It is given intramuscularly, protect for 3 months, and Dampa is being promoted by Government of India by the name of Antara, not Santara. Antara. So Antara and Chaya, these are the two things which is promoted by Government of India in Mission Parivar Vikas, which is our family planning program. And Chaya stand for Centchroman tablet. C for Chaya, C for Centchroman. Okay. So do remember this thing. And Centchroman tablet is again non-hormonal and all. So that can be given here. But other than Chaya, what else can we do? We can give multi-load 375 because multi-load 375 is a second generation IUCD, and second generation IUCD is non-hormonal IUCD. So it do not pose any risk of breast cancer. Okay. Very good mnemonic. Dr. Sahab and Dr. Huzaifa has given good mnemonic. When it is Mala D, it is costing money, so it will be given in Dukan. When it is Mala N, it is not Nirod, it is Nisulk, without cost. Nisulk. Nirod is the old word for condom. Okay. So very good mnemonic, both of you. I will use it in another class with your name. Chalo, now tell me one thing. In I-pill, what is the dose of levonorgestrel? Is it 150 milligram or is it 1.5 milligram or is it 0.15 milligram or is it 0.75 milligram? This 1.5 milligram, one tablet in 72 hours, and 0.75 is one tablet in 72 hours and second tablet in next 12 hours. So I-pill is actually of two type. This and this both are correct for emergency contraceptive pill. In India, we give 1.5 milligram. 0.15 milligram is same as 150 microgram. This is the dose in normal dose OCP and low dose OCP. So OCP has this dose, any kind of OCP, normal dose and low dose. Both have same 0.15 milligram levonorgestrel, 10 times is there in I-pill. This question has already been asked in, of course, FMGE exam, so do remember it. If they ask, what is the ideal or best emergency contraceptive? What is the answer? Best emergency contraceptive. Can you answer it? My dear friend, answer is IUCD because it protect for 5 days. Rest all protect for 3 days, IUCD for 5 days. Now, next question. In which of the following bags Ryle's tube is associated? Ryle's tube is made up of plastic and all plastic goes in red. So answer will be red. Along with Ryle's tube, PPE kit will go in red. Urine bag will go in red. Then, of course, all kind of gloves like acrylic gloves, even blood stains gloves will go in red. because it is just blood stained. And we cannot burn the plastic. If we will throw all this plastic in yellow category went through incineration, it will be a lot of pollutant which will be there. So we cannot burn them. That's why we do not throw the plastic in yellow category. Okay. Yes, red, correct. Now, what is this condition that they are showing here? They are showing blue color lining on upper gum. This is known as, can you name the situation? Burtonian line. So Burtonian line is something which occur in lead poisoning. Lead poisonings, they ask what is the most common route of lead poisoning. So most common route is inhalation. We inhale it. And then in lead poisoning, the symptoms can be remembered by the simple mnemonic A, B, C, D, E. A for anemia, there will be pallor. B is not just for Burtonian line, but also for basophilic stippling. Basophilic stippling means inside RBC, there will be granules of basophil. So that is basophilic stippling. C is of course for tutty tight, constipation. D is for wrist drop. And E is for encephalopathy. So all of these can occur, and ethylene diamine tetraacetate is drug of choice for lead poisoning. Okay. Now, next question. Very good, you are right, Dr. Anuradha. Inhalation is the most common route. And Sivangi, Siva Tripathi, Sahab, all of you are right. It is plumbism. Which of the following transmit Quintaniac fever? Can you answer it? If I ask which of the following transmit Q fever? For Q fever, answer will be air. But Quintaniac fever is the other name of trench fever. And can you tell me who transmit trench fever? Why? Because trench fever is transmitted by Bartonella quintana is the causative organism. Quintana. So that's why we call trench fever as Quintaniac fever. Who transmit Quintaniac fever? Trench fever or is Quintaniac fever, who transmit it? Answer is louse, head lice, our childhood friend. Louse transmit 4 disease which can be remembered by the mnemonic pediculosis, epidemic typhus, relapsing fever, and trench fever. 4 disease transmitted by louse. How to remember it? The mnemonic to remember louse is PUT. Why? Remember your childhood days. When you used to take out a louse and kill it, it used to produce the sound of PUT. So the mnemonic is also PUT. Okay, that is the mnemonic, and I hope you will remember it. Now, next question. What is true about Montreal Protocol is to decrease chlorofluorocarbon protection to protect ozone layer. International Summit to decrease greenhouse gas production is known as Kyoto Protocol. I used to remember it like this, कि क्यों छोड़ी हरी हरी gas? क्यों छोड़ी हरी gas, greenhouse gas? Q means why. Why you emit green gas? That was my mnemonic to remember it. So if you remember Kyoto, you can easily tell Montreal. And when CFC will be decreased, then ozone layer will be protected. So that is there. Now, the next question is that there is a multi-purpose worker who was examining a woman who has developed gestational diabetes during her prenatal visit at 36. This question has came, what is the ideal time of gestational diabetes mellitus diagnosis in ANC? What is the ideal time to do random blood sugar? Because for gestational diabetes mellitus in ANC, because we only do random blood sugar at subcenter level, not fasting. Because in rural area, people do not maintain fast, so we do random. What is the ideal time to do it? Please answer. It was a PYQ of FMGE exam already. So, observe that there was no fetal heart sound. So the child is died at 36 week. Do remember this flow chart. If there is 28 week of pregnancy and any child is dying before this 28 week, we call it stillbirth. Now, if the child died between 28 week to birth or till first 7 day, this whole period is known as perinatal. Try to understand the meaning. Natal means delivery. Peri means around, periphery. So perinatal means around delivery. So around delivery, between 28 week till delivery and in the first 7 day, if any death occur, it is perinatal. If any death occur in first 7 day, we call it early neonatal death. In any death occur between 7 day to 28 day, we call this period as late neonatal. And if you add both the period between birth till 28 day, we call it neonatal death. And do remember, in sustainable development goal, the target to reduce neonatal death is less than 12 per 1,000. Similarly, the target for MMR, maternal mortality ratio, is less than 70 per lakh. The target for under 5 mortality rate is less than 25 per 1,000. MMR target has already been asked. So how to remember? 3 number बस याद रखना है, 12, 25, 70, 70, 25, 12. Now, if death occur between 28 day till 1 year, we call it post-neonatal. And if you add early neonatal, late neonatal, post-neonatal, this period will become infant mortality rate, IMR, infant death. So sometimes they ask, in IMR, which of the following is not included? In IMR, perinatal not included. You can see it yourself. Perinatal has some part in which death are occurring before birth also. So perinatal is not in IMR. Okay? Do remember, in IMR, perinatal not included. Perinatal not included. Okay? Chalo, very good. So do remember this duration and SDG targets. Recently, 2 methods, CPAP and bubble CPAP, were compared. In conventional method, 90 out of following show extubation failure, while 40 out of 160 showed extubation failure. So, in all such question, you have to see the outcome is quantitative or qualitative. Now, qualitative is also known as categorical. What is the answer of this question? If you know, please answer. Okay. Categorical means which can only be divided into category. Like my obesity. You cannot measure it. You can just say that, sir, you are mild obese, moderate, severe. You cannot say that, sir, you are 6.9 obese. So obesity is a category. Similarly, extubation failure and extubation not failure, these are also category, na? And whenever the data are just category or qualitative, in this case, if there is more than or equal to 2 group, we apply chi-square test. So the answer is chi-square, because data is qualitative categorical. Second way of finding it out is, in qualitative or categorical, data will be in percentage or proportion. And here you can see 90 out of 160. So this is proportion. Again, 40 out of 160, that is also proportion. So data is in proportion, that's why also qualitative. One more question in recent INICT from this part. If data is in mode and median, that is also qualitative. So in any question, if you found percentage, proportion, mode, median, qualitative data is there. And if there is any disease data like hypertension, diabetes mellitus, anemia, obesity, all of these are just category. You cannot say person is 2.2 hypertensive. You can only say person is mild, moderate, severe hypertensive. So categorical data always apply qualitative, always apply chi-square. That's why the answer is chi-square. Now, if the data is quantitative, that means we can measure it. Quantitative is also known as continuous. Example of it will be weight, height, BP, HB, sugar, all of these are quantitative. And we can take average weight of the class. So in quantitative, data is in mean. Qualitative, median, mode. Now in quantitative data, if in the question you found the word pre and post test data, before and after giving drug, or you find match data, in this case you will apply paired t-test. If you found that there are two groups, then you will apply unpaired t-test. And unpaired t-test is also known as student t-test. If you found 3 or more than 3 group, you will apply ANOVA, whose full form is analysis of variance. So let's do a question on this thing. Suppose they ask this thing, BP of 3 group of participant are measured. What is the answer? 3 group participant, answer will be ANOVA. If they change 3 into 2 group and they are measuring BP, answer will be unpaired t-test. If they say BP of 2 group before and after exercise, before and after drug, so before and after they have used, answer will be paired t-test. And if they ask percentage of hypertensive patient, so percentage of hypertensive patient, hypertension is a category and data is in percentage of 2 group, answer will be chi-square. Did you understand this concept? If they say percentage or proportion, chi-square. If they say BP, pre-post paired, BP 2 group unpaired, BP 3 group ANOVA. So first you have to decide data is qualitative or quantitative. Qualitative chi-square, quantitative, out of these 3 anything can be the answer. Does it sorted your problem or do you need one more example to understand it? Please let me know. Okay. Chalo, very good. So you were not right in that question. That was chi-square. Whenever you see number, you think number are there, so it's quantitative. No dear. Number can also represent percentage or proportion. And when it is percentage proportion, it is qualitative and answer will be chi-square. Okay. What is the maximum number of vaccine vial that can be carried in this? What is this? This is vaccine carrier. Vaccine carrier is square shaped. Because it has 4 ice pack. And each ice pack can carry maximum 5 ampule. So total they can carry is 16 to 20. 5 into 4. There is one more thing, day carrier, which are rectangular. Why they are rectangular? Because day carrier has only 2 ice pack. And because each ice pack can carry maximum 5, so it can carry 10 vial maximum. Okay. So do remember it. Correct. Dr. Adnan Rasid and Dr. Huzaifa, you both are right. Next question is about this curve. This curve is positive skewed or negative skewed? See, if the curve is towards right hand side skewed is also known as positive skewed. And if this part is, let's say, 20, 30, 40, 50, 60, this topmost point is always mode. And we all know, if there is a big number, mean is mean minded and mean get deviated towards big number. जहां बड़ा number देखता है ना, mean उधर ही खिसक जाता है. और याद रखना मीडियन बीच का है. So median will always be in the center. Median will never be the greatest. So you can see here, mean is at 50, median is at 30, and mode is at 20. And 50 is bigger than 30 is bigger than 20. So mean is bigger than median is bigger than mode. So mean is larger than median will be right. But why I teach it like this? Because sometimes they ask you to label it. They will write A, B, C and you have to label it. But whenever they ask about positive negative skewed curve, it's very simple to remember. Just remember one line summary that in positive skewed curve, mean is greatest. Just remember this line. Because in positive skewed, mean is greatest. Sequence will be simple. Mean, median, beech ka hai. So mean, then median, then mode. You will remember the sequence. And if in positive skewed, mean is greatest, it means in negative skewed, which will be greatest? Mode. Because median can never be the greatest. So mean is greatest in positive. In negative skewed, mode will be greatest and sequence will be mode, then median, then mean. So you can easily remember it if you remember this mnemonic. Mean is greatest in positive skewed curve. Okay. Now, next question. A tile factory worker presented hospital with respiratory distress and pneumoconiosis. The patient X-ray shows snowstorm appearance. Snowstorm appearance occur in silicosis, which I hope you all know it occur in cement factory worker, tiles factory worker, and glass factory worker. And this question has been asked in MCI exam that because silicosis damage the lung parenchyma, so now TB bacteria can easily grow. That's why silicosis patient should be annually screened for TB. हर साल इनको टीबी के लिए एक्सरे करके देखना चाहिए. एनुअली स्क्रीन्ड फॉर टीबी. ओके, याद रखना अगर एस्बेस्टोसिस होता तो वो मेसोथेलियोमा कैंसर देते. मेसोथेलियोमा कैंसर ऑफ लंग प्लूरा. विच प्लूरा? लंग प्लूरा. ओके, इज देयर. देन इन बैगासोसिस दे आस्क who is the causative organism of bagasosis. So causative organism of bagasosis, can you tell me? Thermoactinomycetes. Thermoactinomycetes saccharide is for bagasosis. And do remember, bagasosis not only occur in sugarcane mill worker, it also occur in cardboard factory worker and sugarcane mill worker, both. Sometimes they ask what is the causative organism for farmer lung. Farmer lung. Answer is, for farmer lung, it is Micropolyspora fani. Do remember this causative organism, they ask it again and again. Okay. Now, in this child, where you can see a protruded abdomen. दिख रहा है क्या? पेट निकला हुआ है ना? So abdomen is protruded. What is the answer of this question? Can you reply the answer? Here, A, B, C, D. What is the answer? Is it protein, energy, both energy and protein, or essential fatty acid? Plus vitamin A, D, E, K. Remember, if it is essential fatty acid and vitamin A, D, E, K deficiency, that is known as phrynoderma. Phrynoderma has rough, dotted black skin. They can give an image-based question here. And phrynoderma is known as toad skin. You know toad, na, brother of frog with rough skin, that is there. So phrynoderma is for this deficiency. What is the answer here? Is it A, C, A or C? What is the answer? One of my friend has answered C. Two of my friend has answered A. Correct answer is A, dear. Because it is Kwashiorkor, which is only protein deficiency. If it is both A and C, it will become marasmus. So it is not marasmus, it is Kwashiorkor. And do remember from Kawasi-Yorker they ask 3.3 question. First thing, Kawasi-Yorker will have fatty liver. Second thing, very common, fatty liver. They will have flag signs. Some hair will be brown, somewhere will be black, looking like flag on the head. Main thing, Kawasi-Yorker child, will he be interested in eating or not? He will be not interested in eating because he is not hungry. Main thing is he is not getting protein. Okay, marasmic child will be hungry. So do remember this question, very commonly asked area. What is the recommended dose of vitamin A for a 16-month child but weight 7 kg? So whenever the weight is less than 8 kg and age is more than 6 months, in this case, we always give 1 lakh international unit. Age more than 6 months, weight less than 8 kg. But if age is less than 6 months, then we give 50 lakh international unit. Okay? And of course, first dose of vitamin A is given 1 lakh at 9 months. And after this first dose, because it has been asked in last FMGE also, so do remember it, second dose is between 16 to 24 months. Okay? So, preferably we give it at 18 months. And then, after the second dose, of course, there is first dose of vitamin A at 9 months. And after this first dose, 2 doses of 2 lakh each year till 5 years. So this is the immunization schedule for vitamin A. Total dose of vitamin A that we give is 17 lakh. And total visit for that is 9 visit. Okay. And if the child has already developed vitamin A disease symptom, if the person have gerophthalmia, then we give the dose of vitamin A on day 1, 2 and 14. Now second day and then 14. 3 doses we give if the child have vitamin A deficiency already present. Okay. Very good. Ashish Kumar is asking, sir, 50k. 50, not 50 lakh, 50k, yes. Because we are giving 1 lakh, so here it will be 50,000, not 50 lakh. Correct, Ashish. Thank you for correcting me here. 50,000 international unit for age less than 6 months. Okay. Thank you. Now, in a group of passengers, sorry for that mistake, Caribbean island, there is a new infection being found. Similar infection occur in Mediterranean Sea island people also. Both group of participants were investigated, treated, and their prognosis was recorded based on history. So, which kind of study is there? Can you answer which study is there? Because in this story, in this question, they are writing complete hospital story of one or more than one group of patient. But all these patients have common infection, having common disease. So what will you call such study? Complete hospital story of one or more than one group of patients having common disease. This is known as case series. Okay. Answer is case series here. If it is one patient hospital story, only one patient hospital story, then we call it case report. Case report is also known as care study. CA they take from here, RE they take from here, care study. Case report is sometimes also known as case study. So one patient case report, one or more than one group of patients having common illness is case series. Why it is not ecological? Because in ecological, we don't have hospital story, we just have hospital data. And hospital data is correlated with population data. So correlated with population data means we should gather some data from the population, how many people are getting infected. Like COPD cases are rising, So we are collecting data of sale of cigarette and COPD cases data from hospital. That will be ecological, because we are collecting cigarette sale data from income tax department and COPD patient data from hospital. So that will be ecological. This is not ecological because there is hospital story, not hospital data, and we are not correlating population data with it. Okay. Dr. Aswa is saying that this study are confusing us. Yes, dear. That's why we need to discuss this study part with some example. And of course, we have discussed this part here in some example, but tomorrow there will be a session of Chote Miyan Bade Miyan from 6:30 p.m. That will be Man Ki Baat on YouTube. And in that session, I will discuss ecological study in detail with some, at least 7 example I will take, and I will discuss this topic in detail from 6:30 p.m. tomorrow. There will be a session. I will be taking it and discussing it. Okay. So Dr. Ashwa, I hope I will clear your problem of ecological study there. Okay. That will be Man Ki Baat. Not like Modi. But that is, they are naming it as Man Ki Baat. Okay. Me and Ankur Jan sir will be there. We will have some fun. We will take your query, doubt, personal questions, and we will discuss some important topic like ecological study. Our health program will be my topic. So HB is measured on 5-day, and it came that 22 is wrongly written in place of 12. So if they replace 22 by 12, which is least affected? Can you answer? Which is least affected? Which is least affected? Least affected. Which is most affected? There are two things here. What is your reply, dear friend? Most affected by big number is mean, because mean is mean-minded. Mean get deviated towards big number. So big number, mean get affected. Least affected is median. So answer will be median. And I hope you know it. If it is 8, 9, 10, 11, 22, median will be 10, because 10 is the middle number. Mean will be average of all. So if you take average of this all, 9, 11 will be 20, 22 and 8 will be 30, 30, 20, 50 plus 10, 60 by 5, 12 will come. But if I am replacing 22 by 12, new sequence is 8, 9, 10, 11, 12. Here again, median is 10. So you can see median was 10 earlier, median is 10 now. So median is least affected, not affected. But now the mean will also become 10. How I know it? Because 8, 9, 10, 11, 12 is symmetrical distribution. Every number is equally away. So middle number will be the mean. So mean is 10. Here mean is 12. You can see mean is most affected. From 12, it will change to 10. Most affected will be mean. Least affected will be median. Okay. Yes. That's why I explain it in detail. Okay. I hope it is clear, Dr. Sahab. Please let me know, is it clear or not? Dr. Sahab is the name of a student who is replying. Which of the following is an example of point source epidemic? And some of the students ask me that they want to know about point source epidemic in detail. Point source epidemic simply means that all cases occur within one incubation period. And mainly when they ask about epidemic, they talk about 3 diseases. One is salmonella, food poisoning, which occur in 1 to 3 days. So if all cases are occurring in 1 to 3 days, you call it point source, or point source is also known as common source single exposure. Okay. So we call it common source single exposure or point source. If salmonella in 1 to 3 days, cholera in 5 days, and hepatitis A, all cases occur within 50 days. If cases are occurring within incubation period, one incubation period, we call it point source or common source single exposure. And a very good example of it, food poisoning. Okay, so food poisoning will be point source. Influenza outbreak, this will be example of propagated epidemic. All the respiratory infection like COVID, SARS, MERS are propagated epidemic example, and propagated epidemic will have secondary wave of case. Secondary wave will occur. Cases will first go down and then again second wave will occur. A gradual increase of cancer case in population. Gradual and constant increase. This means they are talking about secular trend. And very good example of secular trend is cardiovascular disease case which are constantly increasing in the population. So remember cardiovascular disease, hypertension, diabetes, example of secular trend, and they have asked in FMGE exam 2.5 year back that secular trend is represented by which diagram. So all the trend are represented by line diagram. So answer is line diagram will represent secular trend. This last milkman distributing contaminated milk, it came in MCI exam just last time some student told me. This will be example of common source continuous exposure. Why? Because milkman will keep on infecting villager again and again. The continuous infection will be there. Common source continuous exposure. Common source continuous exposure have some more example like typhoid Mary, sex worker transmitting gonorrhea, or cholera from a pond or well. So pond or well is infected, people will keep on getting infected continuously. That's why these are an example of common source continuous exposure. Okay dear? Again, this slide is very important for your example, for your exam. Dr. Huzaifa is asking that sir, single source multiple exposure, can you explain? My dear friend, in Park textbook of PSM, they write only about 3 type of epidemic: common source single, common source continuous, and propagated. They do not write common source multiple. And in fact, continuous is sometimes called as multiple. But this is in Park, so mostly in your exam question will come from these 3 only. But some of the international standard book, they differentiate common source continuous from common source multiple. In common source multiple exposure, the wave will start, will go down, then again start, go down, then start, go down. It will touch the baseline again and again. And there will be no secondary wave like thing. It's just cases coming and down, going like that. That is multiple exposure. And if it is common source continuous exposure, again the cases will be fluctuating, but cases will never be touching the baseline. That's all. So this is international book which they write. For Indian, you just have to know that continuous exposure will be there if cases are occurring in more than 1 incubation period. Propagated will be there if there is secondary wave, and single exposure will be there if all cases occur in less than 1 incubation period. Okay. Burden of disease in a society is best indicated by DALI. DALI stand for Disability Adjusted Life Year. And do remember a very important question. DALI have 2 components. First, year of life lost due to early death. Early death. If I replace early with premature, this will become premature year of life lost. PYLL means premature year of life lost. So there is a small difference between PYLL and this component. Plus years of life lived with disability. Okay. So this 2 component, if you will add, then it will become DALI. Do remember the definition. If we want to know burden of mental illness, hemiparesis, in which people are not dying, just suffering, DALI will be the best indicator. Okay. Now, 8th pass. ASA is 8th pass. And there is 1 ASA per 1000. In Park textbook, it is written 3 times that ASA minimum educational qualification is 8th pass. We want 10th pass, but they never ask want. They ask minimum. And minimum is 8th pass. Okay, do remember. And of course, there is 1 ASA per 1000. In urban area, we have USHA. 1 USHA is between 1000 to 2500. Average is 2000. And remember, in urban health center, urban area, sub-center are not there. That's why in Delhi, we have Mohalla Clinic. And in Tamil Nadu, they opened Amma Clinic, which was there later on closed by this current government of, after Lenin, who was there? The current government has closed those Amma Clinic, but they were sub-centers. Because sub-center are not there, so some places they open Mohalla Clinic and Amma Clinic. Okay? Chalo. Now, next question. What is home-based pregnancy test by Government of India? It is Nischay, to be sure of. So, Nischay is pregnancy kit. Nischay is application which is web enabled. So, you can apply it by WhatsApp or Gmail also. Web enabled case reporting and follow up of TB patient. TB patient. And it is not just government, private and government both. Okay. Indradhanush scheme is not for vaccination. It is 7 days, 7 different color bed set. Where? Where? In Dr. Siva Tripathi bedroom? No, in government hospital. So if they talk about a scheme, this is the scheme. But if they ask about intensified mission Indradhanush 3.0 or 5.0, intensified mission Indradhanush is for immunization for all the disease, vaccine preventable disease which are in national immunization schedule. Remember, they sometimes confuse between Ujjwala and Ujjavala. If they talk Ujjavala, Ujjavala have a jaw. And what is the function of jaw? To capture food and put it in the stomach back. So like that, Ujjavala is capturing those children who are being trafficked and saying them back to their home. So it is to prevent child trafficking. If it is jaw, it is to prevent child trafficking and help in their rehabilitation. Okay. Evaluation of birth and death, this is civil registration. DLHS and NFHS, they will tell about immunization data. They are district level health survey and national family level health survey. Immunization data, breastfeeding data, anemia data, domestic violence data. These are given by DLHS and NFHS. Census is done every 10 years. It gives us sex ratio. It gives us socio-economic status, job condition, married, unmarried and all. But census do not tell about death data. Do not tell or give mortality data. Okay, mortality is not a data coming from census. Mortality data either in civil registration or mortality data like IMR, MMR. These are given by SRS, sample registration system, in which the reporting of data collection is done twice. First, ASA or field worker collected, then a supervisor collected. So SRS, do remember, very common question. SRS is dual data reporting method. IMR, MMR by SRS, it is dual data reporting. 2-time data reporting is done. Double data reporting is done. Very common area of question. Now, if you are at a PHC in a high seismic zone, which you will not do. Of course, we will prepare for the situation. Of course, we will increase public awareness. Of course, we will conduct a simulation and assess the response. But we will not follow instruction by the community. Community will follow your instruction now. You cannot follow community instruction. Suppose community is saying that death is near, pray to Almighty Allah. You cannot start praying in place of running away. You can pray while running also. So never listen to community because they can say some of their belief. It's better that you tell community what to do. Okay, so that is wrong. In which of the following organization national TB drug? That is in SIDA. S for SIDA, S for sputum, national TB drug. Danida is for eye. How will you remember it? Netradan, eye donation. Eye program is funded by Danida. UNDP fund Sustainable Development Program and UNFPA fund Family Planning Program. Okay, so do remember it. Now, what is Ayushman Bharat? Correct. Cover after hospitalization only for private? No, private plus government. PMJ is a component of Ayushman Bharat? Correct. There are two components of Ayushman Bharat, PMJ and Health and Wellness Center. But Health and Wellness Center do not, what are Health and Wellness Center? In PMJ, first remember, they ask it again and again. In the Ayushman Bharat logo also, you will find a tree with 5 petal, indicating 5 lakh rupees, 5 lakh. So it is 5 lakh per year health insurance for economically weaker section, not for BPL, EWS category. And Health and Wellness Center means they will upgrade sub-center and some PHC and they will give ENT, dental plus mental, yani psychiatric health, plus old age, geriatric care, plus they will give yoga, क्योंकि yoga से होगा. So they will not just ENT dental health and not 2 lakh, it is 5 lakh. So correct answer is option B. Okay. Correct. Rajni is happy. You are correct. Siva Tripathi is also right. Next question. Under Suman, which are included? So Suman is having 5 program under it. Janani Suraksha Yojana, in which money is given after delivery. Janani Shishu Suraksha Yojana, in which money is given, not money is given, ambulance, food and treatment is given. So if there is a poor female patient who don't have money to go to hospital, GSSY will help her. Then there is Laksh. In Laksh, there is improvement of facility in labor room and maternity ward. Then there is Dakshata. Dakshata is a Hindi word which means highly skilled. In this, there will be training will be given to doctor and nurses to decrease neonatal death and pregnancy complication. Last is PMSMA, Pradhan Mantri Surakshit Matritva Abhiyan, in which on 9th of every month, free ANC checkup will be given in government hospital. तो बहनों और भाइयों, किस दिन ले जाओगे माओ को अस्पताल? 9 को. अगर भूल भी गए तो कोई बात नहीं, क्योंकि ये महीने में हर दिन फ्री होता है. फिर भी सरकार ने बोला 9 को ले जाओ, है ना, एक नया प्रोग्राम लॉन्च किया. So do remember these are the 5 things under Suman. So GSSY will be there, PMSMA there, but NACO will not be there. Laksh GSY, PMSMA. So C is correct. 5 things will be under it. So that's all from PSM part. If you have any question, any doubt, feel free to ask it here, or you can ask it again at 6:30 p.m. There will be this session of Man Ki Baat on YouTube, on which you can do your Man Ki Baat and ask any doubt, any question, and we will revise epidemiological study there. Anything you want to say, please ask. So that's all from today's session. We will meet again. Till then, bye bye, Khuda Hafiz, Hasta la vista, Dasvidaniya, Baka. Okay, dear, anything you want to ask? Dr. Sahab is saying, air me. How can I air you? I don't know. Dr. Sahab is saying, wow, sir, for my dancing skill. It is very good, I know. Thank you. Shukriya. Bye bye. Thank you. Bye, dear.
Okay guys, so now we are discussing like exam discussion of medicine question. Are you ready? तो शुरू करते हैं with the first MCQ. Okay, try to give your input first, then we'll come to the exact answer. So ज़्यादा time नहीं लगाएंगे हम. We will give 1 to 1.5 minute in one MCQ. So be fast. 27-year-old patient. So first hint is age. Present with complaint of arthralgia. So there is joint pain. Dirt-like sensation. So this is a classical hint. Difficulty swallowing. Laboratory result shows ANA positivity. Anti-Rho positive. Rheumatoid factor is positive. So understand this thing. Now question is confusing you by giving this term rheumatoid factor positive. Is it clear? So don't get confused with this thing. So क्या answer होगा? Just try to answer. Now you can see ANA is positive. So ANA positive means ANA is a test for screening. So this is a test that we do to screen many autoimmune diseases. Then they are telling you anti-Rho is positive. Anti-Rho is positive. So what become the diagnosis? It is a case of Sjogren syndrome. Is it clear? So rheumatoid factor can be false positive. देखो हो सकता है, it could be like sometime you will see secondary Sjogren. Secondary Sjogren is commonly seen in rheumatoid arthritis patient. But again जब mention है Sjogren syndrome, so that is the answer. So it could be a case of secondary Sjogren syndrome. So इसलिए confused नहीं होना है. If it is not given in the option, then it can be rheumatoid arthritis. So remember, most common cause of secondary Sjogren is rheumatoid arthritis. Am I clear? Anti-Rho, just remember, it's also positive in neonatal SLE. It is also positive in neonatal SLE. समझ में आ गया? Shiva, Rajneesh, am I clear? So these are some tricky questions. Sometimes examiner want to confuse you in these silly questions. So इससे confuse नहीं होना है. So it is just intentional, pure intention to confuse you so that you can make mistake here. So these mistakes should be avoided in exam. Moving to next one. Okay, so first is cluster headaches are frequent, severe and incapacitating. Patient require acute management. Which of the following? So they are asking you simple. What is treatment of choice in cluster headache? So dihydroergotamine, it is never a drug of choice. Right? So we can use this in patient like who is not responding with triptans in migraine. Verapamil we use in prophylaxis. Verapamil को कहाँ यूज करते हैं? इन prophylaxis of cluster headache. मैं लिख रहा हूँ PX. It is drug of choice for prophylaxis of cluster headache. Sumatriptan oral it is drug of choice for migraine. Means migraine attack. For migraine acute attack. In migraine prophylaxis we prefer propranolol. Okay, so understand, in cluster headache, the treatment of choice will be 100% oxygen. Now, once this question came, next better drug, this is the best drug, this is the treatment of choice in cluster headache. Next best to this will be subcutaneous 6 mg sumatriptan. So, यहाँ पर sumatriptan क्या दिया हुआ है? Oral दिया है. Here it is given oral. So, answer is 100% oxygen. Am I clear? So, it is B. Okay, moving to next one. Big question, बड़ा question है. 40-year-old male patient who is chronic alcoholic and chronic smoker, presented with 3 episode of hematemesis since morning. Patient also had complaint of epigastric pain for the last 1 week. 3 episode of hematemesis. He has been taking diclofenac, means NSAID की history almost daily for back pain for the last 1 month. Again, you can see like जैसे जैसे question में आगे बढ़ोगे, once you read the question, you will get a differential diagnosis in your brain. So whenever I read this question, like patient is taking NSAID and then with NSAID is developing hematemesis. So maybe it's a case of NSAID-induced esophagitis or NSAID-induced gastritis. Clear? On examination, vitals are normal with mild tenderness in epigastric region. CBC report is normal except for hemoglobin 10.2. Male के हिसाब से कम है. Initial basic management is done and he is taken for upper GI endoscopy. If the following is not true about his risk of rebleeding without intervention. So basically they are telling you like it probable. So I'm not telling you a concrete diagnosis. So whenever I read this question, so एक बार में मेरे को diagnose बनाना है. So my diagnosis will be, it may be a case of NSAID induced ulcers and this ulcer is bleeding. Simple. NSAID induced ulcer and this ulcer is bleeding. So I should know, maybe it's like a medicine surgery overlap MCQ. So what we call this forest classification per question है.
So the rebleeding assessment you can make with forest classification. Clear? Shiva, Anda, Asva. Am I clear? Rajneesh. So let us see what you can notice here. Adherent clots covering the ulcer base have around 30% risk of rebleeding. Flat pigment spots covering the ulcer base have about 10 to 20% risk of rebleeding. A clean based ulcer is associated with very low risk of rebleeding. Risk of bleeding is about 90% if there is oozing of blood from the ulcer base. So let us see this question, what you can notice here. अगर आप इस क्वेश्चन को देखोगे तो you can see this is forest classification. So we have 1A where there is active spotting which will have around 60 to 100% chance of bleeding. 1B there is oozing, so rebleeding chance is 50%. Then what we have like 2A which are non-bleeding visible vessels, so rebleeding risk will be 40 to 50. In 2B you will see clot 20 to 30 and 2C you will see flat spot, so risk will be 5 to 10. Whenever there is a clean base ulcer, the risk is minimal. Minimal means कितनी होती है 3 to 5%. So when you see this type of question, what will be your answer? क्या आंसर होगा? When you see this type of question, now see, risk of rebleeding is about 90% if there is oozing of blood from the ulcer base. So look at the screen. If there is oozing, risk is only 50%. So what will be the answer for this? The answer for this will be D. Adherent clot covering ulcer base have around 30% risk of bleeding, so it is true. But what they are asking you, look at the screen, which of the following is not true. तो आपको क्या पढ़ना है? To answer such type of question, we should remember forest classification. So why I have added this question? Because this is a topic which is like a medicine surgery overlap topic, and this has been asked many times in exams. So this is one of the important high yield topic for exam. Again, a medicine surgery overlap topic, that is forest classification, very very important. Moving to next one, which of the following is not a sign of upper motor neuron paralysis. So understand, upper motor neuron paralysis में क्या होगा? Tone will be more. Increased tone. When you say tone is more, then what else? You can see there will be increased tone, there is more reflex. So you can see more reflex, or we can use the term exaggerated reflex. Reflex बड़े हुए आएंगे. And in upper motor neuron you will see spastic type of paralysis. Spastic type of paralysis याद रखना. अब lower motor को इसका उल्टा कर दो, तो lower motor में क्या होगा? Tone कम हो जाएगी, tone will be decreased, reflex will be diminished, और reflexia and spastic की जगह क्या होगा? You will see flaccid type of paralysis. So Babinski sign, understand, Babinski means it's an example of exaggerated reflex. So Babinski एक exaggerated reflex है, so it is a sign, it's not the answer. Can you see spastic paralysis? Answer is yes. We can see exaggeration of tendon reflex, yes, all reflex. You will see hyperreflexia, so सारे reflex exaggerate होंगे. तो answer क्या होगा? Denervation pattern. So remember this denervation pattern. So let me write here, low tone, low reflex. Low reflex को क्या बोलेंगे? Areflexia. Then I can say flaccid paralysis. Flaccid paralysis which is having fasciculation. Fasciculation. And low pattern. So मैं denervation pattern को लिख रहा हूँ low pattern in EMG. Low pattern in EMG. So everything, if you see lower motor neuron के सारे feature में L आ रहा है. In lower motor neuron you can see low tone, low reflex, flaccid में भी L है, fasciculation में भी L है, and low pattern. So these are all the features you will see in a patient with lower motor neuron issues. Clear? तबस्सुम, अंधा, अस्वा, शिवा. Am I clear? आगे चलते हैं. एक क्वेश्चन पे 1 मिनट देना, उससे ज़्यादा नहीं. मूविंग टू नेक्स्ट वन. 60-year-old male with no known chronic medical history came to routine checkup. Routine checkup means age is the hint. So again a geriatric type of question. Routine checkup हुआ, creatinine is 2.3, slightly elevated. Urea is 45. Hemogram was unremarkable except for hemoglobin 10 gram%. Following are clue suggestive of CKD over AKI in patient. तो आपसे पूछा जा रहा है कि ये CKD है कि AKI, कैसे आप डिफरेंशिएट करोगे? जस्ट ट्राई टू अंडरस्टैंड दिस. On one side I am writing AKI, on one side I write CKD. So understand the difference is, again with duration you cannot make a difference. आपको symptom से difference करना है, कैसे differentiate करोगे symptom से? So understand AKI is something which is reversible. So AKI was previously called ARF, but now this term we don't use. अब इस टर्म को हम यूज़ नहीं करते बिकॉज ये रीनल फेलियर रिवर्स हो जाता है. बट CKD स्टिल वी कॉल दिस CRF. CRF मीन्स क्रोनिक रीनल फेलियर. सो AKI रिवर्स हो जाएगी. सो दिस इज अ रिवर्सिबल कंडीशन ओवर टाइम. ठीक हो जाएगी, रिवर्स हो जाएगी, मीन्स इट मे टेक अराउंड अ मंथ, कभी कभी महीने 1.5 महीने भी लग जाते हैं, बट इट इज रिवर्सिबल. CKD इज इरिवर्सिबल. CKD is irreversible and over the time patient will need dialysis or transplant. CKD सिर्फ प्रोग्रेस करेगी. पहला डिफरेंस हो गया. Then understand next difference if you see like AKI में you will not see some feature. क्या क्या फीचर आपको नहीं मिलेंगे? न्यूरोपैथी नहीं होगी. न्यूरोपैथी मीन्स लाइक आइसोलेटेड न्यूरोपैथी, कोई भी न्यूरोपैथी नहीं होगी यहाँ पर. कार्पल टनल सिंड्रोम. देन आई कैन से मेटाबॉलिक बोन डिसीज. मेटाबॉलिक बोन डिसीज जो हम पढ़ते थे पहले, इसका नाम होता था रीनल ऑस्टियोडिस्ट्रॉफी, बट रिमेंबर नाउ वी यूज द टर्म MBD. रीनल ऑस्टियोडिस्ट्रॉफी और मेटाबॉलिक बोन डिसीज ये नहीं होगी. क्लियर. उसके बाद आप देखोगे कि अगर पेशेंट को AKI है तो अनीमिया होगा, लेकिन माइल्ड होगा. देयर मे बी माइल्ड अनीमिया. एंड रिमेंबर मेनी पेशेंट दे विल नॉट हैव. अनीमिया हर पेशेंट को नहीं होगा. क्लियर. Then you will remember like feature of hyperparathyroidism. Feature of hyperparathyroidism, this will be also absent. ये भी नहीं होंगे. These features will be absent. These all things will be present in CKD. CKD में होंगे. Then how else we can differentiate? We can differentiate simple by doing an ultrasound. If you see very important difference is USG. जब आप USG कराओगे अल्ट्रासाउंड में, if you see a normal kidney, when you see a normal kidney, किडनी का साइज नॉर्मल है, एंड कॉर्टिकोमेडुलरी जंक्शन, इसको बोलते हैं CMJ या कॉर्टिकोमेडुलरी डिफरेंशिएशन. द CMJ इज इंटैक्ट, मीन्स आप किडनी में इजीली यू कैन इजीली डिफरेंशिएट वेयर इज कॉर्टेक्स वेयर इज मेडुला. लेकिन CKD में क्या होगा? किडनी का साइज विल बी श्रंकन. यू कैन सी श्रंकन किडनी और डिक्रीज किडनी साइज. तो यू विल सी अ श्रंकन किडनी एंड कॉर्टिकोमेडुलरी जंक्शन इज लॉस्ट. ये जंक्शन खराब हो जाएगा. क्लियर. तो समझ में आया क्वेश्चन को. अब इसको क्वेश्चन को हम पढ़ते हैं विद दिस डिफरेंस यू शुड रिमेंबर. सो लेट अस सी द क्वेश्चन नाउ. क्वेश्चन आपसे पूछ रहे हैं द फॉलोइंग आर क्लूज. अल्ट्रासाउंड शोइंग श्रंकन किडनी विद कॉर्टिकल थिनिंग, मीन्स कॉर्टिकल थिनिंग हो गई, इसका मतलब कॉर्टिकोमेडुलरी जंक्शन लॉस्ट, वो गया. तो यू कैन नॉट डिफरेंशिएट वेयर इज कॉर्टेक्स एंड मेडुला. दिस इज अ ट्रू स्टेटमेंट. राइट, सही बात. अल्ट्रासाउंड में ये कहाँ मिलेगा? दिस इज सीन इन CKD. Normostatic normochromic anemia with no history of blood loss. Again, anemia is more in CKD. Secondly, hyperparathyroidism, CKD. So answer will be all of the above. Clear? Am I clear? Dr. Sahab, Rajneesh, Aswa, Shiva. So these are the point of differences जो आपको पढ़ने हैं. देखो MCQ मेडिसिन का थोड़ा बड़ा आएगा and you need to make your answer in one go. Very very important. So AKI CKD को कैसे आगे चले? Okay, moving to next one. Easy question है, try to answer. 45-year-old man presented with shortness of breath. सांस फूल रही है. On auscultation, clubbing is there. Now clubbing you can see in many respiratory condition. Bibasilar crept. So this is the hint. Bibasilar crept. Now understand. First you see this question. जैसे आप क्वेश्चन को पढ़ोगे तो पहली हिंट आपको मिल गई, that is bibasilar crept. अगर ये obstructive lung disease होती तो V's mention होता. Am I clear? If it could be obstructive lung disease, तो V's होता. Then you can see FEV1 is 60, FEV1 FVC ratio is coming more normal और ठीक है ratio तो. So this ratio is अगर ये ratio कम होता this ratio is decrease in COPD, but this ratio is coming increase. In fact, it is more than point, means it's 0.9 means it's more. So mainly I can say this is a case because since there are no V's नहीं है. This FEV1 FVC ratio, this ratio is 0.9. So these 2 points are telling you it is not obstructive lung disease. So obstructive lung disease नहीं है means bronchitis नहीं है, bronchiectasis नहीं है. There is no history of weight loss and you can see clearly see there is a pattern. This pattern is restrictive pattern. So restrictive pattern where we can see in idiopathic pulmonary fibrosis. So this is one of the example of this. क्रेप्स मिल रही है आपको, रेस्ट्रिक्टिव पैटर्न मिल रहा है. लंग कैंसर के कोई और फीचर नहीं है. एम आई क्लियर? तो जस्ट क्लबिंग इज नॉट सफिशिएंट टू मेक अ डायग्नोसिस ऑफ लंग कैंसर. एम आई क्लियर? जस्ट क्लबिंग इज नॉट सफिशिएंट. क्लबिंग यू कैन सी इन मेनी केसेस विच कॉज डिस्पनिया, यू कैन सी क्लबिंग. आगे चले. एम आई क्लियर? तबस्सुम, शिवा, यस. आगे चलते हैं. ओके, मूविंग टू नेक्स्ट वन. मोस्ट अप्रोप्रिएट डायग्नोस्टिक टेस्ट यूज्ड इन अ 26-year-old male who arrived at emergency department with fever, nausea, vomiting. after an alumni evening party. He is experiencing dull type of epigastric pain that radiate to back. So classical hint is you have a pain which is radiating to back. So this is a ऐसा pain कहाँ होता है? This type of pain you will see in a patient with acute pancreatitis. Simple. Simple. तो पार्टी में गया, ज़्यादा दारू पी ली, taken maybe alcohol or due to overeating, so patient is developing acute pancreatitis. Now they are asking you what is the test. So gamma, GGT we do for liver disease. So again, ALP is non-specific, CPKMB is for heart. So answer क्या होगा? Lipase. Is it clear? So simple answer, it is lipase. So for pancreatitis कौन सा test करोगे? Lipase करोगे. So answer will be A. Okay, moving to next one. 54-year-old gentleman present to OPD of a medical college with complaint of, so first age is the hint, shortness of breath and cough for the last 2 years. Now see, they are telling you 2-year history. 2-year history means it's a chronic condition. Am I clear? Chronic condition. He works in a factory. Factory दे दी. So second, now see, आपके पास पेन कॉपी नहीं होगी वहाँ पर. So you need to think this in your brain. 2-year की हिस्ट्री हो गई, chronic हो गई. आपको अपना डायग्नोस ऐसा बनाना. You need to make your diagnosis like this. 2-year chronic. Factory की हिस्ट्री दे दी means pneumoconiosis, occupational lung disease. You should be thinking of occupational lung disease, which make tiles for construction. अब टाइल्स की फैक्ट्री में क्या होता है आगे देखते हैं. ही हैज़ लेफ्ट साइडेड चेस्ट पेन ऑल्सो. ही हैज़ बीन एक्टिवली स्मोकिंग बीड़ी, स्मोकर भी है फॉर द लास्ट 25 years. X-ray chest is done. So what you can see these leaf-like structure in the X-ray. So again, when you see these two conditions, even suppose if you don't know anything in exam, remember two common pneumoconiosis which are common and which are frequently tested in exam, and where you can see a lot of patient, that is asbestosis and silicosis. Asbestosis and silicosis. So since you can see first hint, there is working in tiles industry. Second hint, you can see that second hint will be this X-ray finding. इसको बोलते हैं holy leaf sign. So this X-ray finding is what we call this holy leaf sign. So holy leaf sign and tiles factory. The answer will be yes. क्या होगा आंसर? Silicosis. No शिवा. सोचो कहाँ बताया था? Think. होली लीफ साइन कहाँ बताया था? वेयर आई टोल्ड होली लीफ साइन. वेयर? ओके, लेट्स सी ऑप्शन. ओके, अच्छा देखो इसको देखो. सपोज बेरिलियोसिस तो रूल्ड आउट है, एरोस्पेस इंडस्ट्री होगी, टीबी भी रूल्ड आउट है. नाउ यू हैव टू चूज वन. तो सिलिका विल नॉट हैव दिस थिंग. होली लीफ साइन इज क्लासिकल फीचर ऑफ एस्बेस्टोसिस. क्लियर? सिलिका में क्या मिलेगा? व्हाट यू विल सी? यू विल सी देयर कैन बी हाइलर लिम्फेडेनोपैथी. और क्या मिलता है? क्रेजी पेवमेंट पैटर्न यू विल सी इन सीटी स्कैन. क्लियर? तो आंसर विल बी एस्बेस्टोसिस. कोई बात नहीं, यहाँ गलती हो गई, डोंट मेक दिस मिस्टेक इन एग्जाम. वेरी वेरी इंपॉर्टेंट. आगे चले. अब सिलिकोसिस बोल रहे हैं. इट इज नॉट सिलिकोसिस. So let us see what you can see. This is called holy leaf sign, and holy leaf sign where we have studied. It is a classical sign we see in asbestosis. Clear? Silica में क्या होगा? Crazy pavement pattern, hilar lymphadenopathy. Sometime you can see popcorn calcification. Okay, moving to next one. What type of hypersensitivity reaction is responsible for the development of skin lesion and fever shortly after starting treatment in a patient diagnosed with lepromatous leprosy? So basically they are asking you, patient को leprosy है, and leprosy will show two type of reaction. What are these two type of reaction we see in leprosy? So one is called a type 1 lepra reaction, and second is called type 2 lepra reaction. Again, dermatology overlap with medicine. Dermatology overlap with medicine. अब इसको देखो कैसे सॉल्व करना. हाउ टू सॉल्व? रिमेंबर दिस अ टाइप 1 लेप्रा रिएक्शन. दिस इज अ टाइप 4 hypersensitivity. It is a type 4 hypersensitivity. And type 2 lepra reaction, it is type 3 hypersensitivity. तो type 4, type 3. अगर इसको भूल जाओ, so always remember the total should be 5. See, 1 plus 4 is equal to 5. Similarly, 2 plus 3 is equal to 5. समझ आया? 2 plus 3 will be equal to 5. Now you need to think this is which type of reaction. Now tell me, अगर मुझे बताओ, try to answer this. अगर मैं आपसे पूछूं, patient is having lepromatous leprosy. So type 2 reaction is generally seen with both the types. So generally if you see like it's the case of borderline type of leprosy, BL type of leprosy means borderline type. This will show type 1 lepra reaction, and type 2 you will see in a patient with lepromatous leprosy, LL type of leprosy. And what we call this? We call this erythromata, means erythema nodosum. इसको क्या बोलते हैं? Erythema nodosum. So understand this thing. It's the case. So lepromatous leprosy is the hint. तो ये type 2 reaction है. तो क्या आंसर होगा? क्या आंसर होगा? It is type 3. Right? It is a type 3 hypersensitivity. LL टाइप में जो मिल रही है. Am I clear? तबस्सुम, डॉक्टर शिवा त्रिपाठी, डॉक्टर सिलिकोसिस, बताओ सही है? आगे चले, सिंपल है, इजी वन. आप गलती मत करना. दिस इज कॉल्ड टाइप 2 लेप्रा रिएक्शन, और व्हाट वी कॉल दिस इरिथेमा नोडोसम लेप्रोसम. इरिथेमा नोडोसम लेप्रोसम. सिंपल. Okay, moving to next one. अगला बताओ. 40-year-old female with AIDS. First hint in the MCQ is AIDS. Is experiencing headache and stiffness in the neck. Neck stiffness हो रही है. During a lumbar puncture, clear CSF is obtained. CSF कैसा आ रहा है? Clear. But leukocyte count is greater than 100 cc. India ink staining is positive. Now see, all hint you are giving you AIDS का patient है, India ink positive है. So see, it is not tubercular, it is not candida, it is not cryptosporidium. Cryptosporidium will cause diarrhea in it. ये AIDS में diarrhea कराएगा. So answer will be cryptococcus meningitis. So I think this is the easy one. ये सबका ही सही हुआ होगा. Clear? This is the easy one. Shiva, am I clear? Is it clear? Any doubt in this? Okay, आगे चलते. Okay, treatment में आपको क्या देना? You need to like in treatment of lepra reaction, what we give steroid. 17-year-old male patient is brought to the hospital following trauma and he is currently unconscious. देखो 17 year young boy following trauma हो गया, currently unconscious. Immediate intubation is required for further treatment and surgery. आपको intubate करना है इसको. Medical professionals have determined that cervical spine precautions are not necessary. तो सर्वाइकल स्पाइन के प्रिकॉशन नहीं चाहिए. देन व्हाट इज द कन्वेंशनल टेक्निक, मींस व्हाट इज द नॉर्मल टेक्निक. सो नॉर्मल टेक्निक क्या होती है इंटुबेशन की? व्हाट इज द नॉर्मल टेक्निक? व्हाट यू कैन सी, क्या टेक्निक होगी नॉर्मल? सिंपल है. साइड वे टंग डिस्प्लेसमेंट हम करते हैं इंटुबेशन से पहले. नो, वी डोंट यूज दिस. अगर आप टंग को साइडवर्ड डिस्प्लेस करोगे, इससे इंटुबेशन में क्या हेल्प मिलेगी? कुछ नहीं मिलेगी. देयर इज नथिंग. इज इट क्लियर? टंग शुड बी डाउन. Then jaw displacement without head movement. जॉ को डिस्प्लेस करके भी क्या करोगे? दिस टेक्निक वी फॉलो. इसको कब करते हैं? जॉ डिस्प्लेसमेंट विदाउट हेड मूवमेंट व्हेन वी डू व्हेनेवर देयर इज सर्वाइकल स्पाइन इंजरी. दिस इज डन व्हेन देयर इज सर्वाइकल स्पाइन इंजरी. तो अंडरस्टैंड दिस. क्वेश्चन में लिखा हुआ है सर्वाइकल स्पाइन प्रिकॉशन आर नॉट नेसेसरी. लिफ्टिंग द नेक फ्रॉम द बैक. गर्दन को लिफ्ट कर दो, इससे तो ऑब्स्ट्रक्शन और बढ़ जाएगा. सो इट इज नॉट नीडेड. Then that method that we use is tilting the head back and lifting the chin. So this is the method that we use in normal simple intubation without cervical spine injury. Clear? So ये भी easy था question. I think this is the easy one, easiest of all. Okay, moving to next one. 42-year-old woman has experienced 4 spontaneous abortion, all occurring before reaching 10 weeks of gestation. She also has a medical history of deep vein thrombosis and pulmonary embolism. What is the likely diagnosis? So again, straightforward question. Gynecology overlap with medicine. It's the case of Apla syndrome. It's the case of Apla syndrome because she is having any 3 or more recurrent abortion, right? So you can see यहाँ पर 4 दिए हुए हैं. Then there is also history of any arterial or venous thrombosis. तो यहाँ दोनों ही हैं. Both are there. DVT भी है, pulmonary embolism भी. So both venous as well as arterial thrombosis. So it's the case of Apla syndrome. Okay, torch infection unlikely, it will not cause that recurrent abortion. Disseminated DIC इसमें हो सकता है, but अगर DIC जब अपला दिया हो then answer will be अपला. SLE can also cause secondary अपला syndrome, but again अपला is mentioned, so that is more correct answer. Clear? Okay, moving to next one. 60-year-old male with history of type 2 diabetes. Type 2 diabetes is admitted to the hospital due to pneumonia. While hospitalized, he experienced reduced appetite and irregular oral intake. Reduced appetite means भूख कम लग रही है. Irregular oral intake. To address the high blood sugar level, physician decided to administer rapid acting insulin. Simple. This is the easy one. बताओ इसको. Easy one है. So rapid acting means Rapid acting is also called short acting. So just try to understand this. Detemer is long acting, Lente is long acting, Glargine is long acting. So answer is glulysin. Simple. Okay, so understand this thing. Insulin can be long acting insulin. It can be intermediate acting insulin, or it can be short acting insulin. अब याद रखो, just remember, short acting insulin की स्पेलिंग में एस होगा. लिस्प्रो, एस्पार्ट, ग्लूलाइसिन. नाउ यू आर सेइंग सर क्या दूसरे किसी में एस नहीं होगा? आंसर इज हाँ, नहीं होगा. बाकी किसी इंसुलिन में एस नहीं होगा. क्लियर? तो शॉर्ट में क्या होगा? लिस्प्रो, एस्पार्ट, ग्लूलाइसिन. इन इंटरमीडिएट वी हैव NPH. NPH stand for neutral protamine hagedron. एंड NPH, what else? NPH stand for regular. NPH के अलावा कौन सी होगी इसमें? रेगुलर इंसुलिन. दीज आर इंटरमीडिएट. लॉन्ग कौन सी होगी? लॉन्ग इज ग्लार्जिन, ग्लार्जिन, डिग्लूडेक, डिग्लूडेक, डेटेमर. देख लो किसी में भी एस नहीं है, बाकी किसी में देयर इज नो एस. हाउ टू रिमेंबर दिस? लॉन्ग मीन्स लार्ज, LARGE, थोड़ा दूर है, इज लिटिल फार. सो ग्लार्जिन इज हैविंग लार्ज. एंड व्हाट इज लॉन्ग? लॉन्ग इज डिस्टेंस. So long, D for distance, D for degludec, D for detemer. Simple. So simple question they can ask you in exam. All are short acting, long acting. So यहाँ पे क्या पूछा? You can see rapid acting means what is that? Glulysin. Am I clear? Okay, moving to next one. Which joint is most commonly affected in pseudo gout? Wrist joint? No. Metatarsophalangeal joint. First MTP. This is most common joint in gout patient. Gout में होगा. MCP, this is most common affected joint in rheumatoid arthritis. It will affect MCP and PIP mainly. So answer will be knee joint. So याद रखना, this knee joint is most common joint. Knee joint is most common joint affected where? In osteoarthritis. This is most common joint affected in pseudo gout. Anything else? और कहीं पे होता है? It is most common joint affected in septic arthritis. In septic arthritis also most common joint will be knee joint. Simple. Okay, moving to next one. 65-year-old patient with chronic obstructive pulmonary disease means, अब देखो lung disease की history है. Emergency department with increased shortness of breath and confusion. ABG, pH is 7.28, normal pH is 7.35. So pH, I can say that the direction of pH is lower side, कम आ रहा है. PCO2 is 65, normal PaCO2 is 35 to 45. So ये ज़्यादा आ रहा है. So when you see the direction are reversed. Reverse direction means it's a case of respiratory disorder. Respiratory, and pH is low means it's a case of respiratory acidosis. Simple. So respiratory acidosis option में. Yes, Lente is long acting. Lente, Lentus, Hemilente, these are long acting, right? So these are like some of the trade name available. Like sometimes they have Glargine as a drug. Clear? Lente is long acting. 14-year-old boy was rejected to have type 1 diabetes 2 months back. 2 महीने पहले, 2 months before he was diagnosed with type 1 diabetes. Now tell me, this child can present with all the following feature except. ये अच्छा question. I am waiting for your answer. Shiva, you will tell me this answer. Shiva, Kartika, Tabassum. इसका आंसर करो पहले. Tell me the answer for this question and why. बताओ. शिवा त्रिपाठी, कार्तिका, तबस्सुम, कम ऑन, बताओ इसका आंसर. अच्छा क्वेश्चन है ये. अगेन इट्स अ ट्विस्टेड एमसीक्यू है. तो सी, बताओ, कम ऑन, कौन बताएगा? कोई नहीं बताएगा. सी, नो, सी आंसर नहीं होगा. बताओ. आई एम वेटिंग फॉर योर आंसर. ओके, जस्ट ट्राई टू अंडरस्टैंड दिस. अब इसको देखो. Patient is having type 1 diabetes, right? Then they are mentioning you 2 months back. So any chronic complication, it will take minimum 5 to 10 years to develop. Minimum 5 to 10 years. Is it clear? 5 साल तो कम से कम है. तो अभी क्या हो सकता है? टाइप टी के हो सकता है. यस. बच्चे का वेट कम हो सकता है. यस. पॉलीयूरिया हो सकता है, yes. Diabetic retinopathy, this will occur after minimum 5 years. Is it clear? So understand this thing: retinopathy, neuropathy, dermopathy, and even you can say like nephropathy. So these are chronic complications. They will take minimum 5 years to develop. The answer is simple. It is D. Just I am writing this thing like chronic complication. Chronic complication will take, this is line of horizon, will take minimum 5 years. And in most cases they develop after 10 to 20 years. Is it clear? So chronic complication will take minimum 5 years after diagnosis. तो अभी retinopathy नहीं होगी, unlikely. Okay, choose the diagnosis based on the given image below. बताओ क्या होगा? So in this you can see like patient is having full face involvement. You can see like there is drooping of eyelid भी है, right? Then what is the diagnosis? So it is a case of right sided. Now see, since full face is involved, पूरा face involve हो रहा है तो कौन सा होगा? This is right sided LMN or UMN. अगर पूरा involve हो रहा है तो when there is full face involvement, you can see that's a case of right sided lower motor neuron palsy. Answer will be C. Okay, next one. After undergoing a thyroidectomy, thyroid की surgery हुई, 45-year-old patient experienced symptom associated with damage to parathyroid gland. Following symptom finding would be anticipated. So basically they are asking you, thyroid की surgery के बाद parathyroid भी निकल गया. Increase urine production. Understand, urine production is more whenever there is a diabetes insipidus. This will occur only whenever there is any surgery related to brain. अगर आपने कोई hypothalamus की और pituitary की surgery करी तब ये होगा. Is it clear? So diabetes insipidus will occur only whenever there is a hypothalamus or pituitary or any brain surgery, neurosurgery, right? FMG exam will be simpler than this. Don't worry. Now, can you see exaggerated reflex? Let me come to this. So suppose, just try to understand this. Question आपसे क्या पूछ रहा है उसको पहले relate करते हैं. Patient had thyroid surgery, but accidentally आपने क्या निकाल दिया? Parathyroid भी निकाल दिया. So thyroid gone, parathyroid gone. These two things gone from the body. Now when these two things gone, there is low PTH. So parathyroid hormone भी कम होगा. Am I clear? There will be less PTH. Will patient have difficulty passing stool? Constipation you can see after any surgery. Again, that is not a major issue. Excessive sleepiness you will see. Now just try to understand this thing. Whenever there is a low PTH, there is a low calcium, there will be low calcium, so patient will develop hypocalcemia and patient will develop tetany. And because of tetany, there will be Chvostek sign, or I can say Trossy sign. So that is called exaggerated reflex. So उसके reflex बढ़ जाएंगे. Simple. So it is because of this patient will develop I can say tetany. Tetany is an example of exaggerated reflex. Okay, easy one. Next one. Young woman was diagnosed with SLE nephritis, lupus nephritis, kidney biopsy suggestive of wire loop lesion. Simple है तो. Which category of lupus nephritis does this patient belong? बताओ. Kartik Atabasun, come on. Mesangial focal. So understand this thing. I told you like most common type of lupus nephritis. Most common type of lupus nephritis is type 4. It is type 4, and type 4 is called DPGN. DPGN means diffuse proliferative glomerulonephritis, right? Diffuse proliferative glomerulonephritis is the most common type. So एक बार सारे type पढ़ लेते हैं. So we have total 6 type. Type 1, type 2, type 3, type 4, type 5, type 6. So type 1 is minimal proliferative type. Type 2 is mesangio or mesangio proliferative type. Type 3 is focal. Type 4 is diffuse proliferative glomerulonephritis, इसको बोलते हैं DPGN. Type 5 is membranous, and type 6 is advanced, means here you will have CKD feature. तो देखो in type 1 to 3 patient will have minimal symptom. कम symptom होंगे तो hospital नहीं आएगा. So most common type diagnosed is type 4, and this type 4 will have classical two things. One, you can see here wire loop lesion. Second is here you can see like antigen, antibody, immune complex, anything will deposit. We call this A, B, C, D. Anybody can deposit. इसको बोलते हैं full house effect. So in pathology, what we call this full house effect. Means antigen, antibody, immune complex, everything will deposit. So we call this full house effect. Clear? So answer क्या होगा? Answer will be DPGN. मजा आ रहा है? इजी क्वेश्चन है, थोड़े से पेपर ऐसे आएगा, थोड़ा सा इससे इजी होगा, इट विल बी इजियर देन दिस, राइट? आई एम जस्ट इंटेंशनली कंफ्यूजिंग यू सो दैट यू शुड कमिट योर मिस्टेक हियर, नॉट इन द मेन एग्जाम. डन? Okay, moving to next one. 38-year-old female came to OPD with cheap complaint of dry eyes, bilateral parotid gland swelling and difficulty chewing food. What is the diagnosis? What is the diagnosis? Batao. What you can see? Is it a keratoconjunctivitis sicca? Now understand, keratoconjunctivitis sicca, it is the symptom. It is a manifestation, means symptom of Sjogren syndrome, or I can say secondary Sjogren, means rheumatoid arthritis. So यहाँ पर सिर्फ dry eyes होगी. So it will have only dry eyes, not other complaint. Dental caries में only dry mouth, parotid swelling, these features can be seen, but again dental caries will not have dry eyes. Behcet syndrome, understand this, here patient will have positive pathology test. So pathology test is positive and patient will have recurrent oral and genital ulcers. Is it clear? Recurrent oral and genital ulcers. So answer will be again Sjogren syndrome. Simple. Answer क्या होगा? Sjogren syndrome. Moving to next one. Fast. 1 minute में एक question solve करना है. 48-year-old male with hypertension present with sudden abnormal flinging movement in his left upper and lower limb. Flinging movement, एक हाथ की flinging movement हो रही है. Most likely site of hemorrhage causing these symptom is. Understand this. So we have suppose if a person is having chorea. Chorea is involuntary semi-purposeful movement. So that we see whenever there is a damage to caudate nucleus. So C for chorea, C for caudate nucleus. Simple. Simple. Understand this thing. Substantia nigra damage will cause tremors. So patient will have this type of tremor. We call this pin rolling tremor. There is pin rolling tremor. There is pin rolling tremor. And it is called a flinging movement or a ballistic type of movement. Flinging, or I can say ballistic type of movement or strong jerky movement. Or strong jerky movement. This jerky movement is called hemiballismus, and this hemiballismus will have, it will occur due to damage to subthalamic nuclei. Right? Upon के damage में क्या होगा? You can see like you can see the size of pupil will be affected in this case. One more movement here is so कैसे याद करना है इसको देख लो एक बार. Ballismus thalamus. C for chorea, C for caudate nucleus. There is one more. Sometime you can see like athetosis. Athetosis is again like it is a slow snake-like movement, again involuntary movement. So this will occur whenever there is a damage where in putamen or globus pallidus. Putamen or globus pallidus में damage होगा तो क्या मिलेगा? Athetosis. Simple. So answer is A, subthalamic nuclei. Expected question in this attempt. High chance आ सकता है. बार बार स्क्रीनशॉट ले लो, फोटो ले लो. वेरी वेरी इंपॉर्टेंट. ओके तो ये ईसीजी के ऑप्शंस नहीं दिखे. सो लेट मी सी व्हाट यू कैन सी इन द ईसीजी. ऑप्शन भूल जाओ. व्हेनेवर यू आर हैविंग अ क्वेश्चन, यस जैक स्पैरो पोंटाइन हेमरेज विल हैव मियोसिस मींस कंस्ट्रक्शन ऑफ प्यूपिल. व्हाट यू कैन सी इन द ईसीजी. ईसीजी में आपको क्या दिख रहा है? Okay, so what you can see? So first of all, you can see there is narrow complex, narrow QRS. So whenever I see this ECG, I can interpret it. It's a case of narrow QRS. Option A or B, they are missing in my notes. So can you give your input? देखो normal sinus rhythm तो नहीं है because you can see it is narrow QRS but regular RR. So narrow QRS but regular RR. Okay, option B and D are missing from my notes. So let me just see the option B and D. तो वैसे तो मेरे हिसाब से ये PSVT का केस है. इट्स अ केस ऑफ PSVT बाय जस्ट लुकिंग द ECG. बट लेट मी सी ऑल द ऑप्शन. यू कैन सी फ्लटर. इट्स नॉट फ्लटर. फ्लटर नहीं है. VT वेंट्रिकुलर टैकीकार्डिया में क्या होगा? ब्रॉड QRS. नॉर्मल रिदम भी नहीं है बिकॉज देयर इज टैकीकार्डिया. सो अगेन इट्स अ केस ऑफ PSVT. PSVT is not given, so answer will be SVTC. Why it is not ventricular tachycardia? Because ventricular tachycardia will have broad QRS. Atrial flutter will have sawtooth wave. Okay, all are of the following are primary vasculitis syndrome except. ये तो simple है. Now see, flutter will have flutter waves, right? Flutter waves. So इसको बताओ. All the following are primary vasculitis. Granulomatous with polyangiitis. Now understand this thing. If I don't know this question, अगर मुझे नहीं भी पता इसका आंसर, then I can say अगर कोई ड्रग के बाद हो रहा है, if something is occurring after taking certain drug, then it is not primary. So remember, drug-induced vasculitis are always secondary. This is secondary. Now these are vasculitis, giant cell arteritis, IgA vasculitis. So these are vasculitis. So what these are? These are primary vasculitis. So जो भी हमने जितनी भी vasculitis बाकी जो पढ़ते हो means Takayasu, temporal, Wegener's, Henoch-Schönlein purpura. Then what we have, IgA nephropathy. Then what else we have? We have other conditions like microscopic polyangiitis, Churg-Strauss syndrome, Kawasaki disease. All these are primary. बाकी सब primary होती हैं. Drug induced will be secondary. Clear? It will be secondary. So answer is D. Okay, moving to next one. बताओ. Which of the following investigational finding is hallmark in a patient with kidney disease that begins primarily with glomerular dysfunction? Okay, so understand this thing. Like I know some of you have marked the answer all of the above because ये अच्छा लगता है, मन करता है इसको mark करने का, all of the above mark कर दो. So can you see? Do you think it is all of the above? When they are mentioning, question में mention है, तो the following investigation finding is a hallmark. So it means there should be one finding. There should be not be many findings, right? In a patient with kidney disease that begins primarily with glomerular dysfunction. बताओ. Jack Sparrow, Om, Tabassum, come on, try to answer. All of the above तुमने जो mark किया वो answer नहीं है. Understand this thing. Any patient who is having a disorder of dilution or concentration of urine, it means problem कहाँ पर है? It's a sign of tubular damage. Means tubules में problem है. When there is tubular damage, then ultimately electrolyte absorption will also occur in tubules. So this is electrolyte disorder will also be a feature of tubular damage. So electrolyte imbalance कब होगा? यूरिन में concentration dilution का problem कब होगा? जब tubules में damage होगा, glomerular का damage होगा, तो albuminuria होगा, proteinuria होगा, right? So that's very very important. Hematuria होगा. Am I clear? So just remember, glomerular dysfunction means patient will have proteinuria. Proteinuria means there will be albuminuria. Then you can notice अगर glomerular dysfunction है, then there may hematuria. And because of hematuria, you will see RBC cast. And last thing I can say, you can see acanthocyte. So if these things are occurring, then these are suggestive of glomerular dysfunction. Very very important. Yes. आगे चले. So this is like an expected question. कभी आया नहीं but आगे पूछ सकते हैं. Okay, moving to next one. Come on. ये तो easy question है. Which type of sensation is affected on same side? Again, repeat question. कई बार पूछते हैं. Same side of the lesion in Brown-Sequard syndrome. So same side, what will happen? Same side you will see loss of proprioception. Touch, pain, temperature will be lost on. So same opposite side. So same side क्या होगा? Loss of proprioception. Easy one. Brown-Sequard syndrome. Okay, this is a good question. अच्छा question है. Try to answer. 38-year-old man arrives at the emergency department with symptom of fever, nausea, vomiting. This can occur in any disease. So fever, nausea, vomiting, they are not considered like a cardinal symptom. He described experiencing intense and sharp abdominal pain. तेज हो रहा है, abdominal pain, sharp abdominal pain. So whenever I read a question, something should be coming into my brain. So now see, it's not about solving an MCQ. Whenever you are seeing a patient, also these DD should be in your brain. आपके दिमाग में DD होने चाहिए. So you can see, patient is having fever, nausea, vomiting, abdominal pain. So first of all, I will think it may be a case of acute abdomen. While lying flat on the bed, he shows reluctance to move and exhibit shallow breathing. Means he is having that pain that he is having difficulty even on lying flat. So again, it may be suggestive. Maybe there is an intestinal obstruction. So maybe मेरे दिमाग में क्या क्या चल रहा है मैं आपको बता रहा हूँ. While reading a question, it may be intestinal obstruction. Patient posture and behavior are most likely associated with the following. Do you think it is meningitis? There is no neck rigidity. There is no Kernick sign, no Buczynski sign, so that is not. It is renal colic? No. So pain is in the abdomen and is showing reluctance to move. So maybe it's the case, it could be a case of pancreatitis? No. There is no pain radiation towards back. Renal colic? No. So it's a case of peritonitis. Acute peritonitis can cause acute abdomen, right? And maybe it can occur after intestinal obstruction. So it's a case of acute peritonitis. Like two more things they can give you in MCQ. Like patient sometime will have gorging. So this question was made by me. So again, but in exam you will get some more hints. So what are the more hint you can get? You can get an exam. Patient is showing gorging, or there is rebound tenderness. This rebound tenderness, what we call this Blumberg sign. So these are like rigidity, guarding. These are the features suggestive of acute peritonitis. Clear? Okay. So the following is not typically seen in individual with Cone syndrome. बताओ इसका आंसर क्या होगा? What will be the answer? Jack Sparrow, rigidity is not present, but you can see other option. बाकी option देखो. Patient is having fever, nausea, vomiting, right? Intense pain, intense and sharp abdominal pain. So this is first hint. First hint is intense and sharp abdominal pain. When lying flat on bed, he shows reluctance to move. So this is second hint. He is having so much pain that he can't even move. Is it clear? Shallow breathing. Shallow breathing means there is a gas under diaphragm. That's why there is a difficulty problem. So what I am telling you, maybe in exam you will get, आपका examiner थोड़ा सा अच्छा होगा, सीधा होगा, वो आपको ज़्यादा hint देगा. मैंने hint कम दिए. Acute epigastric pain can be in pancreatitis, but pancreatitis pain will not have this feature, which I am highlighting now in front of you. Right? Shallow breathing is not seen. So this is more suggestive of peritonitis, right? So Jack Sparrow, you can be right in one condition when pancreatitis have converted into peritonitis. तब ऐसा होगा. Clear? आपका आंसर भी ठीक है. Your answer is also correct, but maybe a case who is having pancreatitis converting into peritonitis, right? समझ आया? Okay, moving to next one. Following findings is not typically seen in individual with Cone syndrome. बताओ. पहले आंसर बताओ. Okay, first tell me what is Cone syndrome. What you can see, what is Cone syndrome? Cone syndrome is primary hyperaldosteronism, right? So here I can say there is more level of aldosterone. Cone syndrome is primary hyperaldosteronism. When aldosterone is more, so understand what is job of aldosterone. Aldosterone का job क्या होता है? Its job is sodium and water retention in exchange of potassium and H positive ion loss. इसका loss कराएगा. समझ आया? Sodium और water का retention, potassium and H positive ion loss. So understand this. Suppose you are having a person who is having more aldosterone. More aldosterone means more sodium retention. So sodium बढ़ जाएगा. More water retention means body will have more water. There is more loss of potassium. Potassium गया, ज़्यादा बाहर जाएगा, means patient will have hypokalemia. And more H positive ion loss. H positive ion का loss means patient will develop alkalosis. So not seen. Alkalosis तो होगी. Clear? तो A is not the answer. Now understand muscle cramp होगा. Hypokalemia अगर patient को होगा, whenever patient is having hypokalemia, there can be muscle cramp. So muscle cramp can occur in hypokalemia, it can occur due to any electrolyte imbalance, but mainly because of potassium. Hyper and hypo दोनों में muscle cramp होगा. Now understand. Now B and D, hyperkalemia होगा इसमें. Hyperkalemia is not seen. Normal serum sodium. Can you say this? अब देखो दोनों both are correct. So answer B and D both are correct. So दोनों correct हैं. हाइपरकैलेमिया नहीं मिलेगा और सीरम सोडियम भी नॉर्मल नहीं मिलेगा, लेकिन सीरम सोडियम लेट्स से नॉर्मल मिल सकता है. तो बोथ आर करेक्ट स्टेटमेंट, बट यू हैव टू चूज वन. एक चूज करना है, तो क्या चूज करोगे? व्हाट यू विल चूज? डोपामिन आपके कहने का मतलब है कि ऑप्शन में मैं हाइपो कर दूं, राइट? अगर ऑप्शन में हाइपोकैलेमिया होता, इज इट क्लियर? तो देखो अल्कलोसिस तो होती है, तो आंसर नॉर्मल. अगर हाइपोकैलेमिया होता तो आंसर में नॉर्मल सोडियम कर देता, लेकिन अगर दोनों ऑप्शन में तो रिमेंबर बोथ आर करेक्ट इफ यू हैव टू चूज वन. ओके, दिस इज लाइक अ प्रिंटिंग मिस्टेक इन द एमसीक्यू, डोंट वरी. अगर आपने डी भी लगाया तो आपका सही है, बट अगर मुझे चूज करना पड़े एक, यस जैक स्पैरो, if you have to choose one, then I will choose B, slightly better answer than D. right? Because there is a, you can see there is sometime this because of nitriuresis sodium can become normal. Is clear? So answer B is more correct according to me. तो ये क्वेश्चन में मिस प्रिंटिंग है, तो ये मार्क आपको बोनस मिला है, डोंट वरी. तो यहाँ पर हाइपो होता तो आंसर वो हो जाता. इज क्लियर? और अगर यहाँ सोडियम को मैं अगर इंक्रीज कर देता देन आंसर विल बिकम हाइपर. सिंपल. तो डोंट कंफ्यूज, वॉट एवर योर कंसेप्ट आर दे आर गुड. डन. आगे चलते हैं. इन सेप्सिस पेशेंट मेन मोडालिटीज ऑफ ट्रीटमेंट आर ऑल एक्सेप्ट. बताओ सेप्सिस में क्या क्या नहीं दोगे? बताओ तब तक पानी पी रहा हूं मैं. वॉट यू विल नॉट डू, वॉट यू विल नॉट डू इन सेप्सिस. सेप्सिस पेशेंट, अंडरस्टैंड, सेप्सिस का पेशेंट है, आईवी फ्लूइड देते हैं, आईवी फ्लूइड देते हैं. बच्चे डरो मत, ऐसे डरना नहीं है. बताओ IV fluid do we give patient sepsis में? So understand, patient is in sepsis, maybe this sepsis might have transformed into septic shock. So next step will be septic shock. So shock means patient BP will be low. So when BP is low, you have to give IV fluid. Simple. So IV fluid to do. When patient is having sepsis, sepsis means you need to give antibiotics. Antibiotics to दोगे. और जब बीपी लो हो जाएगा तो वेसोप्रेसर मीन्स आइनोट्रॉप्स भी देंगे. देन ऑल्सो वी गिव वेसोप्रेसर. तो स्टीरॉइड का कोई रोल नहीं होता. तो स्टीरॉइड्स दे आर नॉट मेन मोडालिटी अनलेस इट इज अ कोविड इंड्यूस सेप्सिस. अगर कोविड इंड्यूस सेप्सिस नहीं है तो आप इसको, कोविड में हम सेप्सिस में देते हैं स्टीरॉइड. सिंपल, इजी वन. हर जगह स्टीरॉइड नहीं घुसाना आंसर. ओके, मूविंग टू नेक्स्ट वन. Following a marker of inflammatory disease which helps to rule out irritable bowel syndrome. Fecal fat. Fecal fat, what we can test? Fecal fat is a test for a fat malabsorption के लिए आप fecal fat कराओगे. Fecal chymotrypsin do we do for protein malabsorption. Fecal trypsin हम कराते ही नहीं है. So answer will be fecal lactoferrin. So remember fecal lactoferrin and one more calprotectin. Calprotectin, these are two markers which are increased in IBD and these are normal in IBS. तो देखो IBS का कोई मार्कर नहीं होता. There are no marker for IBS. IBS means irritable bowel syndrome. It is a diagnosis of exclusion. What you have to remember, IBS का diagnosis बाकी सब चीज़ों को rule out करने के बाद बनाते हैं. Simple. IBS is diagnosis of exclusion. So fecal lactoferrin and calprotectin, these are increased in IBD. IBD means ulcerative colitis and Crohn's disease. Simple. Expected question, second expected question in this attempt. Important. Okay, moving to next one. Following symptom is not typically observed in patient with malabsorption syndrome. Now just try to understand this. माल का मतलब क्या होता है? माल means less. माल का मतलब less ही होता है, कुछ और नहीं होता है. तो माल means less. Less absorption. So whenever there is less absorption, अगर absorption कम होगा, so whenever there is less absorption, so remember there is a gut rule. If gut is not absorbing something, gut will throw it away. फिर gut इसको बाहर फेंक देगी. अब बाहर फेंकने का तरीका क्या होता है? What are the way to remove it out? So either they can throw in the form of diarrhea, or they can throw this in the form of vomiting. Some of this will be going where? Some of this will be going where? Some of this will be going to a liver, so patient can develop fatty stool. There can be steatoria. So there can be diarrhea, vomiting, steatoria. Clear? और क्या होगा? और क्या होगा malabsorption में? Why we need food? We need some food for nutrients. So there will be nutrient deficiency. There will be nutrient deficiency. And common nutrient deficiency जो आपको याद रखना है, there can be deficiency of iron, there can be deficiency of folate, there can be deficiency of B12, there can be deficiency of calcium. So these are common nutrition deficiency. And when things are not absorbed, there will be abdominal pains. So ये आपको याद रखने हैं, these are common symptom of any malabsorption syndrome. ये किसी भी malabsorption syndrome के common symptom है. So excessive fat in the stool. Excessive fat in the stool means steatoria. So it's a typical symptom, yes. Anemia is seen, yes. Anemia means it can be folate deficiency and deficiency. Abdominal pain is a feature, yes. Difficulty with bowel movement, no. Difficulty with bowel movement, that is a feature where we see, ये feature कहाँ होगा? That's a feature of IBS, irritable bowel syndrome. So answer is B. थोड़ा सा क्वेश्चन को ट्विस्ट किया गया है. Is it clear? Okay. What is the most common cause of renal failure in patient with multiple myeloma? So understand, multiple myeloma patient can develop renal failure due to many reasons. Light chain deposition can it cause failure? Answer is yes. ये भी कराएगा, but it is not the common one. Amyloidosis in multiple myeloma is AL type of amyloidosis. It is a reason for renal failure. Answer is yes, but it is again not a common cause. Light chain cast nephropathy can it cause? Answer is yes, again not a common one. So remember, multiple myeloma patient can have renal failure due to many reasons, due to more than I can say 12 reasons. Like it can be due to light chains, it can be due to Benz-Jones proteins, it can be due to amyloid, it can be due to calcium, it can be due to NSAIDs, it can be due to like osteolytic lesions. So there are many cases, but remember, most common reason for I can say renal failure is hypercalcemia. Very, very important. So answer will be hypercalcemia. आगे चले. Okay, then a 45-year-old obese, hypertensive patient present with symptom of ataxia and incoordination. So patient is having ataxia. The likely cause of this symptom is involvement of which artery among the option provided. So आपके पास जो question है, so what you can see in this case, it's a case of ataxia. So अगर किसी patient को ataxia हो रहा है, so basically it is cerebellar ataxia. So this cerebellar ataxia, remember which artery occlusion will occur? It is occurring due to superior cerebellar artery. Answer will be D. Superior cerebellar artery. Clear? Okay, so final question in front of you. 55-year-old male, chronic alcoholic on thiazide diuretic. Male है thiazide पे for hypertension, present to emergency department with complaint of right great toe swelling and pain for 1 day. An examination, he had redness and tenderness over the right first MTP. So basically it's the case of gout. So आपके पास जो case है, that's the gout case. So they are asking you all are correct statement except, right? So 90% of cases are caused by overproduction of uric acid. मुझे तो यही गलत लग रहा है. So 90% cases are due to under excretion, not overproduction. So ये आंसर हो गया. और ऑप्शन पढ़ लेते हैं. Uric acid level may be normal at the time of acute attack. Now understand, सारा का सारा यूरिक एसिड कहाँ जा रहा है? वो आपके जोड़ों में जा रहा है, जॉइंट में जा रहा है. सो इट मे बी नॉर्मल इन ब्लड, इट मे डिक्रीज इन ब्लड. सो इट्स द करेक्ट स्टेटमेंट. सो इट्स द ट्रू स्टेटमेंट, हेंस नॉट द आंसर. Men are more commonly affected than women. Yes, gout is mainly affecting males. So it's a true statement, so not the answer. Synovial fluid aspiration is needed. Yes, investigation of choice will be synovial fluid aspiration. So remember, 90% cases of gout is not due to overproduction, it is due to under excretion. The most common cause is under excretion. Excretion ठीक से नहीं हो पा रहा. So I think this was the questions like we have discussed in detail. I hope you enjoyed this. Keep working hard, keep shining, keep rocking. Just remember, 12 more days, 10 hours daily. It's total 120 hours. That's it. And always remember, you can, you will. Be confident. सब होगा, अच्छे से होगा, घबराना नहीं है. Just keep the game on. All the best. Bye-bye.
Ladies and gentlemen, welcome to the CBoT ophthalmology and guiding through these questions. Again, your friendly neighborhood ophthalmologist, yours truly, Shashwat Ray, guiding to you. So let's start this before your exams hit you on 20th Jan, and I hope you all do very well in the exam and in the CBoT too. So let's look at that. Slightly more difficult questions maybe sometimes. Compared with plasma, aqueous humor is an increased concentration of which one of these components? Very good. That's a very good question, I think. Is it protein? Incorrect. Is it ascorbate? Is it glucose? Incorrect. And carbon dioxide? Incorrect. The answer, gentlemen, as I hope all of you got this, is ascorbate. Remember, essentially, the aqueous humor is formed from the blood plasma. It's filtered like that. So the blood plasma passes through the ciliary epithelium from the pars plicator, and it gets filtered, and it is a ultra filtered kind of a thing. And so remember, the aqueous humor and the blood almost have similar constitution, except for 2-3 minor differences. What is that? Remember, blood is richer in two components. One is glucose and the second is proteins. And the aqueous humor is richer in two components. One is ascorbate, which is vitamin C, other is lactate. Okay, the lactate is understandable because remember, the lens, what is a lens? It is a primarily undergoes metabolism through the anaerobic metabolism. And when you have anaerobic metabolism, it produces a lot of lactate. All this lactate is dumped in the aqueous humor. But why ascorbate is higher in aqueous humor compared? And it's quite high, almost 15 to 30 times higher than serum. Okay, we have no idea actually. We do not know. But the fact remains, ladies and gentlemen, you have to remember this, that both ascorbate and lactate, these are the only components that are higher in the aqueous humor as compared to blood. Blood is richer in glucose and proteins. I hope you got all this. Ascorbate is. Next question, gentlemen, is a 41-year-old patient with a history of chronic anti-uveitis. Chronic anti-uveitis, remember, presents with complaints of progressively decreased vision and glare. On slit lamp examination, a breadcrumb appearance visible. And ladies and gentlemen, here you have the main clue. A breadcrumb appearance is the main clue here. Which type of category is most likely responsible for these symptoms? Let's look at the choice B. Diabetes mellitus, incorrect. Poor vision cataract, incorrect. And congenital cataract, of course not. The answer, as you can all make out, is complicated cataract, ladies and gentlemen, because you see, is uveitis causing cataract. Okay, and whenever you have any disease of the eye, any ophthalmic disease causing a cataract, we call it as a complicated cataract. So, and complicated has these three important questions which you must really remember. One is that it is usually posterior subcapsular. Second is characteristic breadcrumb. Look at the breadcrumb appearance here, the breadcrumb appearance. And third is the famous polychromatic luster. It shines like a rainbow. So the answer here, everybody should have got it, is a complicated cataract because of anti-uveitis. Okay, I hope you all got this correct. The next question is, which drug is used during general anesthesia, which is associated with an increase in intraocular pressure? Now, this is a question which we sometimes have to ask in PG entrance, remember, but we need to have some slightly tougher questions sometimes. And is it halothane, is it ketamine, is it Valium, or is it phenobarbital? Please remember something. Amongst all the inhalational agents and all the general anesthetic agents, all of them, almost all of them, lower the intraocular pressure. All of them reduce the intraocular pressure, except one. And that is, you have to remember, it is ketamine. Please remember. So I've written this down here. All inductional agents reduce intraocular pressure except ketamine. All inhalational anesthetic agents also reduce intraocular pressure except ketamine. The other one that sometimes is intraocular pressure is succinylcholine, but that is induction agent which we rarely ask. So can you remember K for ketamine and K causes raised intraocular pressure. K causes raised intraocular pressure. So the rest of them all reduce intraocular pressure. So this is a very important question which you should remember. A 7-year-old child presents to the ophthalmology clinic with a raised lesion located at the limbus of the right eye. You can see that here. This is a raised lesion of the limbus. This is a characteristic lesion. This lesion appears to be well circumscribed and is a yellowish color as shown in the image below. You can see that here. The child's parents report that they noticed the lesion a few months ago but did not observe any changes in size since then. So that's good because it is rapidly growing. It becomes more dangerous. The child's field acuity is 20 by 20 in both eyes. Remember, the vision is not affected. 20 by 20, if you all remember, is 6 by 6 in both eyes. And no other ocular abnormalities are noted upon examination. Okay, so this is the only finding that you have there. Which of the following is fit with the condition shown in the figure? And remember, first you have to diagnose the condition. What is this? This is a dermoid cyst. Can you remember? It's called dermoid cyst. And because it's present at the periphery of the cornea, we call it a limbal dermoid. This is not a very common finding, but it's not very uncommon either. So let's look at that. What does the limbal dermoid do and what does it not do? I mean, again, remember the question is, what is the following is associated? So we need a correct statement. The first choice, adjacent corneal meridian, is typically the steepest relation to this lesion is incorrect. Remember, it's usually flat. Okay. Whenever we have a lesion like that, the adjacent meridian always flattens because of the weight of the dermoid. Second, these lesions are benign and do not have any malignant potential is correct, because remember, it is clearly said that do not grow. They do not grow in a few months that have been observed. They tend to exhibit rapid growth, incorrect, because if they were showing rapid growth, then the question says that there is no growth at all. And some patients may also have congenital cardiac defect. That's also incorrect. So this is a, remember, question. That answer is B. Lesions are benign and do not have any malignant potential. As I mentioned here, look at that, another limbal dermoid. Kindly look at this picture and recognize this. So this is a kind of a dermoid cyst, which is a protuberance. And because it's at the limbus of the eye, cornea and the scleral junction, we call this limbal dermoid. It's a benign lesion. Often kindly remember, if you want to remember something extra from this CBoT, limbal dermoid is often seen in association with the condition which we get to see fairly commonly, not very common, uncommon, not very common. This is called as golden hour syndrome. Okay, it's called as golden hour syndrome. So this has got many things here. Limbal dermoid is done. Then you have some preauricular tags. Okay, then you have a palate. This is a slightly high arched palate, things like that. But basically, the limbal dermoids can be seen with golden hour syndrome. Remember, it appears golden brown in color, so it can be golden hour syndrome. Okay. A 57-year-old patient presents for an eye examination. During the examination, the ophthalmologist observes the patient's optic disc, remember, and notes certain findings. Based on the optic disc findings, which option is the most suggestive of glaucoma? Okay, so remember, we need to find out about glaucoma. Can you have optic disc edema? Incorrect. You do not have optic disc edema in glaucoma. That you see in optic neuritis, in papilledema, AION, and many other conditions, but not glaucoma. Reddish orange color optic disc, incorrect, because that is the normal color of the optic disc is reddish orange. So that is not glaucoma. In glaucoma, it becomes pale. If you have a pale disc, you would think of it as glaucoma as one of the differential diagnoses of glaucoma. AV nicking, arteriovenous nicking means the artery and the veins appear to be cut. Incorrect, because this is seen in hypertensive retinopathy, So the answer is choice B, a cup disc ratio which is greater than 0.8. Is not. So please remember, the cup disc ratio normally is between 0.3 to 0.6. It depends on patient to patient, but within 0.6, it's supposed to be normal. Okay. For instance, my personal cup ratio is about 0.6. So I'm on the edge, an edge in more ways than one actually. And 0.3 and 0.6, 0.3, 0.4, 0.5, 0.6, they are all normal. Many of you have 0.3, many have 0.4, 0.5, 0.6. But if it goes beyond 0.6, it becomes suspicious for glaucoma. And at 0.8, you definitely should suspect glaucoma. Remember, it is suggestive glaucoma. You have not proven yet because you have to check the intraocular pressure and the visual fields, but this option is more suggestive of glaucoma. Okay, and you can see that. Look at that. This is the optic ratio. This huge cup. You can clearly see that the NR has been destroyed by raised intraocular pressure, and the cup size increased. And this kind of a cupping, remember, this increased cup ratio is also called cupping. And remember, this word cupping is the same as increased cup disc ratio is only seen in glaucoma. You have no other condition in ophthalmology which can show cupping. So when you get this word cupping or increased cup disc ratio, you have to think of glaucoma. And you can see this very clearly here. So answer, gentlemen, is going to be B here. And I think all of you are getting this right. A 25-year-old male suffered trauma to his right eye with a fist 6 months back in a brawl. Do you all notice, my friends, that how it's always the guys who get trauma? You never see a lady suffering trauma, is it not? That's surprising to me. He developed a gradual diminution of vision for distance and near over the next 3 months. So post-trauma, you have loss of vision. What could it be? What is the image given below depict? And you can see the star-shaped figure here, the stellate figure, or like a flower-shaped, is also flower-shaped. Is the Vossius ring? Incorrect. Because Vossius ring is a ring of pigment on the lens capsule. Also a sign of trauma, but not this figure here. It's not a Vossius ring. A sunflower cataract, incorrect. A sunflower cataract, it is not. And sunflower cataract is seen in Wilson's disease. Christmas tree cataract, incorrect. Because that is in myotonic dystrophy. The answer is, gentlemen, you've all got this. Look at the star-shaped, the flower-shaped petals of a wonderful flower which is bloomed in the patient's eye after he got hit in the eye. So this rose blooming in your lens after a trauma is characteristically the rosette cataract. The word rosette cataract means like the flowers or like the petals of a rose, and it's seen classically after trauma. Okay, remember it is never overnight, takes a lot of time to develop, which is why 6 months have been given to you, because this is the time it requires for the development of a cataract. Very good. And you can see again, you can see the, remember the shape is very, very typical. Okay, this kind of shape which you've got here is not that typical. The shape that I have shown you here, look at that, just like the petals of a rose. This is more characteristic of a rosette cataract, post-traumatic rosette cataract. Remember, these are always mostly post, these are usually cortical, posterior cortical cataracts. Okay, in the cortical, they're part of the cortical, not nuclear, not postsubcapsular. A 76-year-old male present with a sudden onset of blurring of vision in his left eye since morning. The visual acuity in his eye is 1 by 60. That's very, very poor. You can barely see 1 meter. He is a known hypertensive under treatment. So that gives us another clue. The fundus picture is shown below. What anterior segment finding expected in this case? Remember, the fundus finding is very typical, very famous. What do you see here? You see the cherry red spot. Surrounding the macula, it's this whitish area. And from the fovea, the bright red glow is coming out. There's a famous cherry red spot. This cherry red spot is, so the diagnosis becomes CRAO, central retinal arterial occlusion, which seems to fit the diagnosis because vision is very poor, and he's an old gentleman, and he is hypertensive. So all the clues fit in, it is in CR. So what finding we expect in the anterior segment? Remember, what is anterior segment? Anterior segment, remember, simply anterior segment is the area of the eye, any structure in front of the lens, including the lens, is the anterior segment. Okay, so remember, anything behind the lens belongs to the posterior segment. Anything in front of the lens, including the lens, is a part of the anterior segment. So if you have a cornea, iris, anterior chamber, ciliary body, pupil, lens, ciliary body, all these are parts of the anterior segment. But the vitreous, the retina, the choroid, the sclera, all the parts of the posterior segment. So let's look at the findings. A posterior subcapsular cataract, incorrect. You do not get a cataract in CRAO. Corneal edema, again incorrect. Corneal edema, you do not get, you get raised intraocular pressure, but do not have it in CRAO. Optic edema, again incorrect, because optic edema is not posterior segment at all. What is the correct answer is C, which is RAPD, relative afferent pupillary defect, is not. So remember, the only anti-segment finding. So there will be no finding in the cornea, nothing in the aqueous, nothing in the iris, only the pupil will exhibit RAPD, also called the Marcus gun pupil. And what is that? And that's exactly the answer. So look at that. When we flash a torch to the eye, what happens to the light? What happens to the pupil? Pupil immediately constricts, no? So this is constricts and this also constricts, is not? So this is called the direct and this is called the consensual. In RAPD, what happens is as you flash a light, instead of constricting, it dilates. Now that is highly abnormal. And this dilates. Why it dilates? Because the light impulse is not conducted by the optic nerve. So remember, RAPD or Marcus gun pupil, which is the same thing, is seen in lesions of optic nerve, anytime in the optic nerve. But remember, they have to be unilateral, or at least if they're bilateral, they have to be asymmetric. Unilateral means that if you have both optic nerve damage in both eyes, then you do not have an RAPD. That's why it's called RAPD, relative afferent pupillary defect. It has to be one eye. Or if it's bilateral, they have to be asymmetric. Asymmetric means that the damage to both the eyes should be unequal. Okay, so if this is one is less damaged, the other is more damaged, then you have RAPD in this eye. Okay, so they cannot have equal damage. If you have equal damage in both eyes and both nerves, then you do not have an RAPD. So that's why it's called relative. So either you have optic nerve damage to one eye, or you have a major area of the retina, major areas of retina damaged. These are the two conditions where you have RAPD. So either you have the optic nerve damage or major areas of retina means that you have a large retinal detachment. You have CRAO, which is a huge area. Remember, it's retinal arterial occlusion. So you see, remember, it's a central retinal arterial occlusion. So that the entire retina is deprived of oxygen. So this is again a major area. We have an ischemic CRVO, again a major area of retinal damage. See, these minor damages in the macula, minor areas of damage in the retina, they cannot cause RAPD. You have to have a large extensive area of retinal damage or a optic nerve damage, either mostly unilateral, or if it's bilateral, then asymmetric, then you have RAPD. And as you can see here, that this is a huge area of the retina which is damaged. The entire central retinal artery is blocked, so there is no blood coming to the anterior 2/3 layer of the retina. It's a huge area of damage, lead to RAPD. The answer is RAPD. A 24-year-old student presents with a sudden onset of scotoma and metamorphopsia in the right eye for the last 3 days. Okay, he's a known smoker, anxious, and high strung. Okay, so remember he's high strung. Like many of you, very 24 also fits your age. Smokers, anxious, and very high strung, particularly as the exam progresses nearby. The anti-segment exam is normal. The right fundus picture is present below. What is the most likely? Now, if you look at the picture, if you see this, look at the area. What do you see? If you look very carefully, you'll see it's a slight bleb there, or like a blister. It's a location of fluid that's collected over the macula. And so this sudden local cause of a kind of a macular edema, in fact, kind of a macular edema, but not really, occurs in a student who's anxious and a smoker and high strung. Sudden loss of vision. And that is why he did this scotoma, which is the area of loss of vision surrounded by normal vision, and he has metamorphopsis, distortion, because it's the macula. So what could be? Is this cystoid macular edema? Incorrect. This is not cystoid macular edema, because this is not how CME appears. No, CME, remember, is fluid over the macula. Is that correct? But remember, the difference is that it is fluid between the in the outer plexiform layer only. Okay, so remember, that is the thing, outer plexiform layer of fluid, which is a part of the neurosensory layer. This is not how CME looks like. Is retinoschisis? Retinoschisis is splitting of the retina, of the neurosensory layers of the retina. No, this is not retinoschisis. It doesn't look like that. Is the macular hole? Incorrect. Macular hole does not look like this. You would get a lamellar or you will get a complete full thickness hole or lamellar hole, and you'll be able to make out that there's a hole there. And of course, you will have the famous Watzke-Allen sign, which is missing from here. The answer, ladies and gentlemen, is CSR, central serous retinopathy. Okay, what is that? Remember, CSR is also fluid over the macula. So, what is the difference between CME and CSR? Kindly remember, you must know the difference because they are similar, and they are similar in the sense that they are both fluids over the macula. But that is the only similarity. Remember, there are fluids over the macula, but there's a difference of the layers. Remember, if this is the neurosensory layer, there are 9 layers, and this is the 10th layer, this is the RP, is not. And this is the macula. This is the macula. So if you have fluid, remember here, fluid here, this is cystoid macular edema. This is layer of the outer plexiform layer, one of the 9 layers of the neurosensory layer. This is would be CME. But if you have fluid here, see, this is still the macula, but this is called CSR. The level of the fluid of CSR is between the neurosensory layer and the RP. So actually, CSR is a kind of localized exudative retinal detachment. Remember, exudative retinal detachment is always also a separate neurosensory RP, but it is localized in the sense in CSR is only over the macula. Okay, so kindly remember, CME and CSR are similar, but the difference in the level of fluid. CME is on the outer plexiform layer of the neurosensory layer. CSR is between neurosensory layer and the RPE. Okay, and let's look at the CSR quickly. Let us see the most important key points, the salient points. Sensory retinopathy, CSR, swelling of the macula, as I said, between neurosensory and RP, and you can see the bleb here, clear cut. You can see the bleb here. It comes up like a blister or a collection of fluid, which can be very clear. See, we call it the central halo reflex. It occurs like a halo. What is the cause of this? Remember, the most important is stress. Stress. You are stressed out. Remember, all of them under stress. A lot of you under stress because you have to watch me, CBoT here. And stress. So remember, stress occurs to us, all of us, in the eyes. Remember, stress occurs to us. If you have to think of one condition where the stress precipitates in the eyes, it is CSR. Okay, and these are often young males. The young ladies also is possible, but males are much more common. And type A personalities. This is a typical personality which is high strung. That is why you see a young male student and the known smoker, anxious and high strung. So these type A's are extremely anxious. You remember the type A personality, a sort of a mnemonic could be A. You have 3 A's in type A. 1, they are anxious. They are very anxious. Okay. 2nd, they are often very aggressive. Okay. They are often very aggressive. And 3rd is the ambition. They are extremely ambitious people, like many of you are, is it not? But this combination of anxiety, ambition, and aggressiveness is not very good for your eyes. Will end up with CSR. So one of the most important drugs causing CSR is steroids. If you are particularly on systemic steroids, if you are steroid on this thing, then you have CSR possible. So unlike cystoid macular edema, which improves with systemic steroids, CSR it worsens with systemic steroids. You have to stop the steroids immediately. So, the three main causes of systemic steroids for whatever reason, facial palsy, rheumatoid arthritis, whatever it is, okay, may cause CSR. Type A personalities and stress, three important factors. What is the combination of blurring of vision naturally? Metamorphopsia, because it's macula. So, every straight line appears distorted like this. This is the metamorphopsia. And a scotoma, which patient complains of a dark black area in front of the eye, which is blocking his vision. And on examination, typical halo reflex, which I mentioned here, and I'm tracing it out here, like a blister or bleb on the macula. And remember, most of them go by itself. It's reassurance, the placebos, anxiolytics. You have to tell them. These are very highly strung and they're very, very anxious, as I said, maybe because we're approaching exams, because of some other pressure. Remember, they're ambitious. So, you have to reassure them that it'll become fine or automatic resolves. Placebo, you can give them placebo, some vitamins, give them some anxiolytics. We're highly anxious, okay? So, and usually within 2 to 3 months, it usually settles down itself. The fluid gets absorbed and it automatically subsides itself. So, the treatment is reassurance and placebos, okay? So, this is a typical CSR. You must remember how it presents, okay? Very well. All are true about true membranous conjunctivitis. So, we have this true membranous and pseudomembranous conjunctivitis, which you should distinguish between. True membranes, let's look at that. What all of them are true except. Is it caused by streptococci? Yes, it can be caused by streptococci. It can be caused by a multitude of organisms. Streptococcus is one of the most common. Staphylococcus can produce it. Many other organisms can cause true membranes. May lead to cicatrization, scarring of the conjunctiva. Yes, true membranes can cause cicatrization, may scarring, and they characterized by fibrinous membrane formation adherent to the conjunctiva. That is also correct. True membranes are adhering to the conjunctiva. It's a fibrinous membrane made of fibrin. What is not correct, remember, we need to know all are true except is they do not bleed when being peeled off. Now, this is a blatant untruth. This is the hallmark of a true MEMS conjunctivitis, that when you peel it off, it is so adherent, so tightly adherent to the conjunctiva starts bleeding. And that is the sign of a true membrane. A pseudomembranous, we have something called a pseudomembranous conjunctivitis, which may look like that, but the difference is that it does not bleed when we peel it off. And so, remember, true membranes, you can see the membrane here. See, this is the conjunctival membrane. This is whitish area which you see over under the tarsal conjunctiva, upper tarsal conjunctiva. This whitish, thickish fibrinous exudate is a true membrane, and when you take it out with a forceps, it bleeds. That is the trick. So, the rest of them is correct, but true membranes do bleed, pseudomembranes do not bleed. That is the one distinction between true membranous and pseudomembranous conjunctivitis. Very well. So, some new facts coming to us, my friends. All this is important for exams, which is going to make contact with you on 20th Jan. All of the following features help to differentiate between megalocornea and ophthalmos. Remember, that's an interesting question. Megalocornea is a condition where the cornea is bigger. Usually at birth, it should not be more than 12.5. If it is more than 12.5 millimeter in diameter at birth, it's supposed to be megalocornea. Okay. And ophthalmos, raised intraocular pressure due to primary congenital glaucoma appearing. The eye also appears enlarged because raised intraocular pressure, it increases the size of the eyeball. So they look alike. So how do we distinguish between the two? Look at that. They look alike, isn't it? See, this is typical ophthalmos. Look at the large enlarged eye. And this also, because the cornea is enlarged, so this also looks similar. So let's look at the differentiating features and the one which does not differentiate. Let's look at intraocular pressure. Intraocular pressure does differentiate. Remember, all of them except, is it not? So why? Because in ophthalmos, pressure will be high. In megalocornea, pressure will be normal. So it does distinguish. So we want that feature which does not distinguish, is it not? Second, axial length is incorrect because axial length also differentiates. Remember, ophthalmos, because raised intraocular pressure, the eyeball size is very large. But megalocornea is just megalocornea. The eyeball size is normal. The size of the eyeball is not normal. So this also does distinguish. So this is also not the answer. Corneal clarity is incorrect because this is another factor to distinguish between megalocornea and why? Because remember, ophthalmos will have a hazy cornea. Raised intraocular pressure is corneal edema, so you have cornea will be hazy. But megalocornea will be clear cornea. Okay. So all these three does distinguish. They do distinguish between the ophthalmos and the megalocornea. So which we want one which does not distinguish, except, is it not? which is corneal diameter, because corneal diameter is bigger in both, and the answer is right. So A, the corneal diameter you can see here is the one that does not distinguish, because both of them have a large enlarged cornea. However, you can see in this we have a enlarged eyeball in both thalamus. One that. Second, the cornea is hazy. Here the size of the eyeball is normal, the cornea is not hazy. And third, the pressure is high, the pressure is normal. So the answer here we're looking for, ladies and gentlemen, is the corneal diameter does not distinguish between the thalamus and the megalocornea. So that is not a bad question at all, and I hope you all got this, you worked it out. A 30-year-old patient presents with acute anti-uveitis. The ophthalmologist suspects an underlying systemic condition and discusses the different etiologies of uveitis with the patient. Which of the following conditions is typically associated with non-granulomatous uveitis? Remember, so we can see the KPs stuck to the inferior triangle called the arch triangle, and is typically associated with non-granulomatous uveitis. Tuberculosis is incorrect, because tuberculosis is a granulomatous uveitis. You know, it produces granulomas. Sarcoidosis is incorrect, because sarcoidosis again produces a lot of granulomatous uveitis. Remember, we need to know about non-granulomatous. Lyme disease is incorrect. Again, Lyme disease causes granulomatous disease and granulomatous uveitis. So the answer, ladies and gentlemen, we've all got this correct, I hope, is HLA-B27 associated uveitis, which is definitely non-granulomatous. All the four, which means under HLA-B27 we have these four things. See, typically you see the hypopyon, the congestion of anti-uveitis. What are the four causes of HLA-B27? Number one, and the most common cause, is ankylosing spondylitis, isn't it? So those of you guys, young guys with low back pain, watch out. It could be ankylosing spondylitis. It may cause uveitis. Second, you could have inflammatory bowel disorder, seen mostly in females, and which can be either ulcerative colitis or it could be Crohn's disease. This can also lead to uveitis. Third, it could be the psoriatic arthritis, not very common, but psoriatic arthritis does cause uveitis also. And fourth is Reiter syndrome, also called as reactive arthritis nowadays. Reactive arthritis. Remember the classic triad CUR: conjunctivitis, urethritis, and arthritis. Okay, so conjunctivitis, urethritis, and arthritis is reactive. All of these four fall under HLA-B27, and all of them are non-granulomatous cause of uveitis. So the answer is HLA-B27. Okay. And then KPs are precipitate. Another question, uveitis. So you can see how important it is. The keratic precipitates are in which layer of the cornea? Corneal epithelium, incorrect. Epithelium, it is not. Descemet's, incorrect. It is not. Bowman's membrane, incorrect. It is present in the endothelium of the cornea, and you can see here, you can see again the KPs that we saw here in this one. So we have the KPs associated with. So KPs are basic neutrophils and lymphocytes attached to the corneal endothelium, which is the innermost layer of the cornea. And this is how you can see all the KPs studded onto the back of the cornea, which is the endothelium, the innermost layer, and that is the exact location. Here you can see diffuse KPs, but normally you see KPs in inferior triangle of the cornea, which is called the Arl's triangle, isn't it? Arl's triangle, the inferior part of the cornea. And with that, ladies and gentlemen, thank you very much for a very patient hearing. I hope you got all your questions correct. And with that, it is my privilege and my honor to wish you the best of luck for the encroaching exam. Thank you very much and all the best. May God bless all of you.
Hello friends, so now we'll be discussing the radiology questions of today's CBoT. So the first question is an easy one. All of the following, all features shown in the images are true about this condition except. So first tell me the condition, what are we referring to? So direct question, we know that there is an hand x-ray, wrist x-ray, a knee x-ray, and there is some deformity that we see in the child. Okay, so it's a child x-ray, we see some deformity. So whenever a child x-ray and some hand x-ray is given, first thing that should come to our mind is rickets, and we can see the typical findings of rickets, that there is widening of growth plate, there is widening of metaphysis which is known as splaying, there is cupping of metaphysis, and there is some irregularity at the margins, which is known as fraying. So everything is happening at the metaphysis. So yes, there is playing of metaphysis, correct. There is cupping of diaphysis, no, not diaphysis, metaphysis. There is fraying of metaphysis, yes, and there is bowing of legs, yes, we can see the bowing of legs. So cupping of metaphysis happens, not diaphysis. So the answer here is simple B option. It is not a correct option. Now let's come to the second question. In cancer therapy, which type of particle beam produced by cyclotron is commonly utilized for precise and targeted treatment to deep tissues with minimal damage to healthy cells? So we are using a type of particle beam which is used for precise and targeted treatment to deep tissues, and it is produced by cyclotrons. Now remember what beam is produced by cyclotron? So it is proton beam. And why do we use a proton beam for deep targeting of tissues with minimum surrounding damage? Because it shows a phenomena of Bragg peak effect. Okay, so the answer here is proton beam. So I'll tell you what Bragg peak effect is. So if you see a normal X-rays, and X-rays are most commonly used for radiotherapy. They are the most common agent used in radiotherapy. So if you look at X-rays, their intensity sharply increases, and then as the distance from the source of X-rays increases, their intensity rapidly falls. Okay? So if you are targeting a deeper tissues, the intensity of X-rays in the deeper tissues will be less because they are farther away from the source of X-rays, and the maximum effect or the burning from the X-ray will be on the surface, right? So the side effects will be more, the surrounding tissues will be damaged more. So if we want to target a deeper tissue, we want the energy of that beam to be maximum after a particular point from the source of X-rays. So in protons, their intensity, so if there is relative radiation dose plotted on the y-axis, the dose delivered is maximum at a particular distance from the source, not just adjacent to the source. This is known as a Bragg peak effect, which is shown by protons. Okay, now gamma rays, electron beam, and X-rays. So remember, X-rays are produced by LINAC, linear accelerator, again electron beam produced by linear accelerator, and gamma rays are produced by disintegration. You know, disintegration of radioisotopes. So cyclotrons में क्या produce होते हैं? Proton beam. ठीक है? So let's move on to the next question. Which tumor is commonly associated with Codman's triangle and sunburst appearance on X-rays? So typical straight one-liner question. Codman's triangle and sunburst appearance on X-rays is typical of osteosarcoma. So here, what is the Codman's triangle? This is the Codman's triangle. We can see the uplifting of periosteum. What is Codman's triangle? There is uplifting of periosteum like this, and that tells you that yes, there is an aggressive pathology which is uplifting the periosteum. So it is a marker of an aggressive bony pathology. So not necessarily osteosarcoma, other sarcomas can also show Codman's triangle, and in fact osteomyelitis can sometimes also show Codman's triangle. But sunburst appearance, so there is this peripheral periosteal reaction radiating from the cortex of the bone. This sunburst type of periosteal reaction is very typical of osteosarcoma. Okay. Now let's move see other pathologies which are asked in the question. So how does a giant cell tumor, osteochondroma, and intraosseous lipoma look like? So first of all, we know that all of them are benign lesions. ठीक है, सो ये तो वैसे भी आंसर नहीं होगा सनबर्स्ट का एंड कॉडमन्स ट्रायंगल का, राइट? So Codman's triangle plus sunburst reaction is marker of an aggressive pathology. So option B, C, and D are automatically ruled out. So you can answer even if you don't know the exact answer, right? Now, how does a GCT looks like? So GCT के लिए two keywords that we'll remember. First is skeletal maturity, that is the growth plates are fused. We do not see any growth plate here. Second, it is an epiphyseal lesion, epiphysis का lesion है. And third point, it reaches the articular cartilage, articular surface. That is till the joint surface it reaches. ठीक है. Second part is, second image is that of an osteochondroma or an exostosis. So first of all, it is a sclerotic lesion, and इसके हम 2 point याद करेंगे, that it happens at metaphysis of long bones, and there is cortical plus medullary continuity. There is cortical plus medullary continuity with the main bone. So we see that the cortex is continuing, and so is the medulla. So these are hallmark of osteochondroma. Now the third image is a direct spotter. It is that of an intraosseous lipoma. So third is that of an intraosseous lipoma. इसमें आपको हमेशा ऑलमोस्ट ऑलवेज आपको कैल्केनियम ही दिया हुआ होगा क्वेश्चन में. ठीक है. एंड यू सी ए लिटिक लीजन with this central sclerotic dot. This is how an intraosseous lipoma looks like. Now we move on to the next question. Which type of MR sequence is shown in the below radiological image? I think this was an easy question. Most of you would have gotten this question right. So tell me, is it a CT or an MRI? Yes, it is an MRI. Why? Because the bone is black. The peripheral, this bright structure, this is the scalp fat. This is not the bone. ठीक है. बोन उसके अंदर है. That is black, so it's an MRI. Now second thing that we see, what do we see? We see the CSF. So CSF is bright. ठीक है. And we know World War II water is white on T2 weighted image. CSF is type of water, so it will be a T2 weighted MR image. T1 क्यों नहीं है? T1 में CSF black होगा. तो फ्लेयर क्यों नहीं है? फ्लेयर में भी तो CSF black होता है. उसमें भी CSF ब्लैक होगा. तो T1 और फ्लेयर को कैसे डिफरेंशिएट करेंगे? वी लुक एट द ग्रे मैटर एंड वाइट मैटर. सो इन T2 weighted image we remember two things, that water is white on T2 World War II, and second we remember gray matter white matter relation, gray matter white matter differentiation. So on T2 weighted image, gray matter is bright and white matter is dark. So इसमें हमें दिख रहा है कि जो white matter है that is dark, and the gray matter, ये gray cortex है, this is bright. So this is a T2 weighted image, and this is also there in flare. But in flare we know that water is suppressed. So in flare we'll see that CSF is black. ठीक है. Now T1 weighted image की क्या कैरेक्टरिस्टिक होंगी? उसमें भी CSF black दिखता है, डार्क दिखता है, बट उसमें ग्रे मैटर वाइट मैटर डिफरेंशिएशन एनाटमी जैसा होता है. T1 इज एन एनाटमिकल इमेज. एनाटमी में ग्रे मैटर ग्रे था, वाइट मैटर वाइट था. सो इसमें भी ग्रे मैटर डार्कर होगा एंड वाइट मैटर हमारा ब्राइट होगा. ठीक है. सो कैसा दिखता है? यू सी दिस इज अ T1 weighted image. द CSF इज डार्क, द white matter is white, and the gray matter is gray. So this is an anatomical image. That's why T1 image is known as an anatomical image. T2 में क्या होगा? CSF आपका white है and आपका white matter dark है. And flare में क्या होगा? CSF आपका black है but white matter आपका dark है. ठीक है. Now third जो एक ऑप्शन दे रखा था क्वेश्चन में, stir. First option was stir. So first of all, remember where is stir imaging used? It is used in musculoskeletal imaging. ठीक है. So whenever we want to image joints, we want to image muscles, so dermatomyositis, joints में MRI knee, MRI hip, MRI wrist, MRI shoulder, या फिर हमें spine को image करना है. ठीक है. Here we want to suppress the subcutaneous fat ताकि हमें बोन एडीमा बेटर दिखे. Then we use stir image. So stir के बारे में हम पढ़ेंगे. This is how a stir image looks like. Stir में stands for short. Stir stands for short tau inversion recovery, and it is a type of a fat saturated sequence. So this is the subcutaneous fat which is suppressed. ठीक है. Now where is it used? It is used in musculoskeletal imaging to see bone marrow edema. ठीक है. That's why you remember in ankylosing spondylitis I told you in SI joint pathologies when we want to see bone edema, the investigation of choice then becomes an MRI, and in MRI stir is the sequence of choice. ठीक है. So this was about imaging sequences. Now let's move on to the last question. All other features associated with the condition shown below except. So first let's see what the condition is. So direct X-ray has been given. There is no history which has been given to us in the question, but it is a direct spotter. So what kind of appearance is this on X-ray? Yes, this is a simple boot-shaped heart. And we are talking about, yes, tetralogy of Fallot. So tetralogy of Fallot में क्या क्या होता है? Overriding aorta होता है? Yes होता है. VFD होता है? Yes होता है. Right ventricular hypertrophy होता है? Yes होता है. Box shape heart होता है क्या नहीं? No. Boot shape heart होता है. Box नहीं होता. So box shape heart is the odd one out here. But ये मिलता किस में है फिर? Box shaped heart किस में होता है? It is seen in Epstein's anomaly. ठीक है. This is seen in Epstein's anomaly. अच्छा, चौथा कंपोनेंट क्या होता है टॉफ का? So चौथा कंपोनेंट इज RVOTO और राइट वेंट्रिकुलर outflow tract obstruction. राइट वेंट्रिकल का आउटफ्लो क्या होता है? पल्मोनरी आर्टरी, मतलब पल्मोनरी स्टेनोसिस है. इन सिंपल वर्ड्स इट इज पल्मोनरी stenosis. But what type of pulmonary stenosis? Which part of the pulmonary artery is involved? So the part of the pulmonary artery below the pulmonary wall, we call it infundibulum. So it is infundibular pulmonary stenosis. Okay, so what are the four features of TOF? Four anomalies in TOF. So start with pulmonary stenosis. If there is pulmonary stenosis, there will be RVH, right ventricular hypertrophy. And if there is pulmonary stenosis, there will be a VFT. Okay, to shunt the blood to the left side of the heart. So there is mixing of right and left side. That's why there is cyanosis in TOF. And the fourth pathology is overriding of aorta. Okay. So this was about boot-shaped heart. Let's just quickly revise other shapes of heart quickly. So this is how a box-shaped heart appears. Box-shaped heart किस में मिलता है? Epstein's anomaly. Second बताओ क्या है? This is an egg on string appearance. किस में मिलती है? TGA. Egg on string का क्या मतलब हुआ? छोटा पेडिकल होगा, vascular pedicle, and बड़ा heart होगा, like a egg on a string, seen in TGA. And third image क्या है बताओ? It is a figure of 8 appearance. Figure of 8 appearance या फिर snowman's heart भी बोलते हैं. किस में मिलता है हमें snowman's heart? TAPVC. कौन सा टाइप ऑफ TAPVC? सुप्रा कार्डियक TAPVC. ठीक है. So this was about today's discussion of radiology in this CBoT. Thank you.
Hello everyone, welcome to the CBoT session. Hope the session went well and you have enjoyed it thoroughly.
Starting with the first question in orthopedic segment, a 27-year-old patient arrived at casualty with the injuries to the left elbow and the forearm. Now, what are the injuries which are provided to you in the question? As you can very clearly see it over here. First of all, let's identify the injury itself. That here there is a fracture of the proximal ulna. As you can see that there is a fracture in the ulnar bone, proximal ulna, and this radio-ulnar joint is dislocated. That means there is a dislocation of the elbow. So if you combine both of them, you know what you are getting is the fracture of the proximal ulna with radio-ulnar joint dislocation, the proximal radio-ulnar joint dislocation, or you can say the elbow dislocation. So what is the answer for this question? What that means, what is the fracture dislocation? It is Monteggia fracture dislocation. All right. So combining it, we are getting a Monteggia fracture dislocation. Okay. So one of the segment of the question is already solved. That what is a fracture. Now, on further examination, his hand sensations and the radial pulse were intact. That means there is no sensory loss, but he was not able to extend the fingers. Now, all of you are very clearly aware of the fact that in case of radial nerve injury, there is a loss of the sensations over the first dorsal web space of hand. But in case there is an injury to its pure motor branch, that is posterior interosseous nerve, there will be inability to extend the metacarpophalangeal joint, but the sensations will remain intact because it is a pure motor nerve. It is a pure motor branch of the radial nerve. And the name of the nerve which is most commonly found to be injured with Monteggia fracture dislocation is posterior interosseous nerve. So obviously the name of the nerve injury over here is the posterior interosseous nerve injury. So if you come on to the options, that means before reading the options out, you are ready with the answer. Answer for this question is Monteggia fracture dislocation with posterior interosseous nerve injury. So let's read out the option first. Is it the Galeazzi fracture? No. Is it the Monteggia fracture with posterior interosseous nerve injury? Yes. The other options, Isaac-Lopresti fracture dislocation with the posterior interosseous? No. What is Isaac-Lopresti fracture dislocation? It is the fracture of the radial head with distal radio-ulnar joint subluxation, right? Is it Monteggia fracture with common radial nerve injury? No, because in case of common radial nerve injury, there has to be a loss of sensation in the first dorsal web space of hand. So the answer for this question is very much obvious. And what is the answer for this particular one is a Monteggia fracture dislocation with posterior interosseous nerve injury. All right. So hopefully you find it very easy, means a spot diagnostic answer for this particular question. All right. Next, which of the following is the structure which is more likely to be damaged in the given image? Now, this is a question which was asked in the FMGE examination summer session. You know, back related images, the differential diagnosis of the back images. There are three questions. One is winging of scapula. मीन्स ऐसा क्वेश्चन जिसमें कि बैक की इमेज को देने के बाद द एग्जामिनर विल आस्क यू अ क्वेश्चन. वो तीन डिफरेंशियल्स हैं. वन इज विंगिंग ऑफ स्कैपुला, द अदर वन इज स्प्रेंगल शोल्डर, SPRENGEL, that is Sprengel shoulder. The third one is scoliosis. And the fourth one obviously over here, because these are the three common ones, and the fourth one is the spinal accessory nerve injury. Now, how will you identify these? The first one, winging of scapula. Winging of scapula को identify करने के लिए there has to be a mechanism. That means imagine a person is pushing a wall, so he will be having his hand placed against the wall and the picture would be clipped from the posterior aspect where the medial border of the scapula will be over prominent on the affected side. So this is how you will identify a winging of scapula. The Sprengel shoulder would be identified as the asymmetry of the scapulae. Like left scapula, the right scapula, the right will be relatively higher or the left will be relatively higher. So that is the asymmetry at the level of the scapulae. It is a high riding scapula. It is incomplete descent of the scapula. That is Sprengel shoulder. Then scoliotic abnormality is very easily identified as a curvature in the vertebrae or in the back region. And the final one is spinal accessory nerve injury. You know, spinal accessory nerve is responsible for supplying the trapezius and the sternocleidomastoid muscle. Now, these shrugs of the shoulder over here, they are trapezius muscle. And if there is a spinal accessory nerve injury, then the trapezius would be atrophied, as a result of which these elevations of the shoulder would be depressed on the affected side. Now, if you look at this image in particular, if you look at over here, now both the scapulae seems to be at the same level. That means there is no asymmetry of the scapulae. Then So it is not a spangled shoulder. Then the patient is not pushing a wall. He is not exerting any sort of the pressure on the wall, and there is no over prominence of any of the scapular medial border. That means it is not winging of scapula. But if you look at the shrugs of the shoulder over here, there is a depression which is very clearly observed, and hence the answer for this question is the spinal accessory nerve injury. All right. So this is how the question was framed. It is very simple. It is very obvious. The answers for the questions are relatively obvious, and this is the approach that you have to go through. All right. So hopefully this question was also not very difficult for you to identify and marking the answer of. Then the third one is a clear-cut image which has been asked hundreds or thousands of the times, and you shouldn't be having any problem in answering these kind of the questions. You know, mediolateral deviation from the normal with the extended joint could be categorized into varus or valgus. Now imagine if this is a trunk of the individual, this is the arm, this is the forearm, this is the hand of the individual. As you very clearly understand that the axis of the arm, axis of the forearm normally is creating a certain degree of angle. So this is normal. But if the axis of the arm and axis of the forearm are excessively angled, that means the apex is pointing too much towards the body, then it is valgus. While if the axis of the arm, if this is the trunk of the individual, this is the axis of the arm, and the axis of the forearm is reversed, where the apex is pointing away from the midline of the body, then this is varus. So when it is happening at the level of the elbow, cubitus. The prefix is cubitus. So cubitus valgus or cubitus varus. Now, if you look at this image, here it is representing as the right, and this one is left. Now, this is the axis of the arm, axis of the forearm, and here the axis of the arm and axis of the forearm. As it is very clearly evident that on the left side, this axis or the angle is beyond normal. And this apical angulation, which is excessively pointing towards the midline of the body, is representing the cubitus valgus abnormality that the patient could be having. So the correct answer for this particular question is cubitus valgus. Means no, not at all different from the purpose of identifying this particular condition. All right. So this is how you will identify this image. One more thing that obviously it is not that important at this stage, but certainly it's going to have a significant value in your knowledge in future. As I told you, mediolateral deviations from normal of any joint, when is kept in extension, if the elbow is flexed and there is a certain deviation, it is not varus or valgus. It has to be extended, then only any abnormality would be appreciated. So there is a prerequisite. And even in this image, if you will very clearly see that the elbow is not flexed, elbow is kept extended, and then only you can say that whether it is valgus or varus. Imagine if the patient is having some deviations, mediolateral deviation, but there is an angular deformity also. That means the patient is having a fixed flexion deformity also. Then you cannot jump to the conclusion. You will simply say to the examiner, sir, I cannot say whether it is in valgus or varus. I cannot comment on valgus or varus abnormality because the elbow is in flexion deformity. The elbow is having a certain amount of fixed flexion deformity. So I cannot say clearly there is, I am not commenting on the varus or the valgus abnormality. All right. So there is a prerequisite. It is mandatory that the joint has to be kept in extension. Similarly, in case of knee joint, valgus or varus, genu valgum, genu varum. But if the knee is flexed, no, you cannot say whether it is varus or valgus. If the knee is extended, yes, you can say whether it is in valgus or varus. All right. In future, means for your future, for consolidation of the the concepts, this is required in your future. All right. Next question is, a 5-year-old child was brought to the OPD with the complaints of weakness and walking difficulty. Prominences were observed over the costochondral junctions on the chest. Now, once you see the word costochondral junctions, so possibly you will get an image of rickets because there is an over-prominence of the costochondral junction which is appearing as a ricketic rosary. But there is another condition, another metabolic abnormality, that is scurvy, where there is a costochondral junction abnormality. In case of rickets, it is smooth, it is non-tender. In case of scurvy, it is tender, it is pointed. But costochondral junction abnormalities are appearing these two conditions as far as metabolic abnormalities of the bones are concerned. So that means by reading this information, you are jumping onto the conclusion that the question might be asked in context to either rickets or scurvy. All right. Now, further, X-ray of the bilateral knee AP view is shown below. Now, one thing is that had it been a question related to rickets, then the X-ray of the wrist would have been provided to you. But this question is provided with the curve and means wrist X-rays would be provided if the question was asked in context in relation to the rickets. But here, the X-ray is that of a knee joint provided. So possibly they are not asking about ricket. They are asking about scurvy. So you are getting inclined towards scurvy now. All you have to do is identify what are the features provided to you in the X-ray, which further consolidates your presumption or alignment towards scurvy as a diagnosis. So what is the most likely diagnosis? So when you see it on the X-rays, when you get the X-rays done, what do you see on the X-rays? That here there is an increased density at the end of the metaphysis. And you know, the increased density at the end of the metaphysis is actually because of the increased calcification of the zone of provisional calcification. And this increased density of zone of provisional calcification is known as white line of Frankel. And this white line of Frankel is very clearly observed over here. So this is the answer for this question, particularly is scurvy. The second finding is that there is a prominence of the end of the metaphysis, and this is known as Pelkan's spur. So this is another finding which is very clearly observed over here. The third finding over here is that there is an increase in the density of the end of the epiphysis in comparison to its core. And this is known as ring sign of Wimberger. All right. So this is how you'll be having your approaches in order to identify these kind of the questions. And the answer for this question is straightforward, scurvy. All right. So costochondral junction, rickets or scurvy. X-ray of the knee given, possibly scurvy. Confirming it with the findings, answer for that question is scurvy. All right. Coming on to the next one, that what is the name of the angle shown in the below? Now, it is very clear cut. First of all, you have to diagnose the condition. Don't look at the angle. The condition is that the vertebral column is deviated laterally. There is a lateral deviation of the vertebral column. The moment you realize it to be a lateral deviation of the vertebral column, the diagnosis of this condition is scoliosis. And all of you know that scoliosis is quantified by the name of the angle which is responsible for the measurement of this scoliotic deformity is Cobb's angle. It is Cobb's angle. The name of the angle is Cobb angle. And how the Cobb angle is created? It is, you know, the tangent is drawn from the upper border of the upper end vertebrae and the lower border of the lower end vertebrae, and then a perpendicular is dropped to both these two vertebrae. The angle which is created in between is known as Cobb angle, and Cobb angle is responsible for the measurement of the scoliotic deformity. So instead of identifying the angle, identify the deformity. The moment you identify the deformity, you already are ready. What is the name of the angle you are identifying on the X-rays? All right. Now, as far as kite angle is concerned, kite angle is for CTEV. It is for talocalcaneal abnormality. Bowler angle is for the calcaneal fractures. All right. It is for the calcaneal fracture. Bowman angle is for the valgus or the varus deformity at the level of the elbow. All right. This is for the abnormalities at the level of the elbow. So hopefully you have understood every question related to this particular session. Hopefully you have enjoyed the session, because you have to work hard and you have to have a great sense of fun while working hard. All the best for your future examinations. Thank you very much.
Hello students, welcome. I am your dermatology faculty Dr. Manish Soni, and today we will be discussing these questions from dermatology. First one is that here you can see they are asking what is the likely diagnosis in the image shown below, and in the image what you can see, there is one area of complete hair loss. There are few broken and small hair follicles which are present, but otherwise the area looks clean. The skin don't have any lesions, any swelling or any papules or any pustules. The skin is clean. The only complaint of the patient is hair loss, and such area of hair loss is seen in, yes, alopecia areata. So here the answer is alopecia areata. Why this is not tinea capitis? Because tinea capitis commonly presents in the form of carrion where there is swelling, or favors where there is crusting, black dot where small black dots are seen, or scaling, that is grey patch type. All these are absent, so that's why this is not tinea capitis. Telogen effluvium have diffuse hair loss. So there is not one particular area from where the hair loss occurs. So that's why it is not telogen effluvium. And androgenetic alopecia have pattern of hair loss which is absent here, so that's why it is not androgenetic alopecia. So that's why the answer is alopecia areata. In the second question, they are saying which of the following statement is not true, so false, about the image given below. In the image, what you can see that there are unilateral lesions, they are along a particular nerve segment, and they are vesicular. And all of you know that in which condition unilateral grouped vesicular lesions are seen which are very painful. Yes, it is a case of herpes zoster or shingles. So they are asking what is false about shingles. Let us read. The lesions are infectious to seronegative individual. So if the patient is not exposed to this virus and there is infection to that seronegative individual, the patient can develop what? Because this is varicella zoster virus, so patient will develop chicken pox if the patient is not predisposed to this virus. So this is a true statement. Can be associated with meningoencephalitis. Yes, so this is one of the complications which can occur with herpes. So this is also true. Bilaterally symmetrical dermatomal vesicular eruptions. So they are not bilateral, they are generally unilateral. So unilateral, they are non-symmetrical, they are dermatomal. This is correct, but they are not symmetrical, they are not bilateral. So this becomes the false statement. And geniculate ganglion is involved in Ramsay-Hunt syndrome. So all of you might have read in ENT Ramsay-Hunt syndrome, where what happens that these vesicles start developing around the ear or in the external auditory canal. So there is pain in the ear. So otalgia along with geniculate ganglion involvement or the facial nerve involvement is seen. So unilateral facial nerve involvement, so facial paralysis can be seen along with these vesicles around the ear. So this is the triad which is seen in Ramsay-Hunt syndrome, that is there is pain in the ear, there are vesicles in the ear, and there is ipsilateral or unilateral facial paralysis. So yes, this can also occur with this herpes zoster. So all the statements are true except that it is not bilateral. Then a woman arrives complaining of blue lesions. So these are blue lesions over left eye and forehead. They are unilateral. So they are blue and they are only on the left side. As observed below, the left superior conjunctiva has an uneven, so conjunctiva, eye involvement is also there. So not only unilateral skin involvement, but eye involvement with in the similar manner, that is bluish lesions. What is the diagnosis? Yes, so this is a case of cerulloderma, that is blue skin, and it is involving one side of the eye as well as the skin, that is along the ophthalmic and the maxillary division of the trigeminal nerve. When blue lesions occur, that condition is known as, yes, nevus of Otta. So this is a case of nevus of Otta. It is not Becker's nevus because Becker's nevus is generally brownish with lot of hair growth and not bluish. It is not nevus of Ito because Ito occurs along acromioclavicular nerve, so it involves the neck and the shoulder area. And it is not Mongolian spot because Mongolian spots are generally seen in infants, usually over lower back. So this is what this is, unilateral bluish discoloration of the maxillary area and the eye. This is a case of nevus of Otta. Now 24-year-old lady with asymptomatic pearly dome-shaped small nodules or papules on forehead for 2 months as shown in the picture. So they are asymptomatic, no itching, no pain. They are pearly, they are dome-shaped. So they are something like this. And if you see these lesions, in all these dome-shaped lesions, there is a central umbilication. So there is a central depression. Her 3-year-old daughter also have similar lesions. Why? Because this is a viral condition and virus can get transmitted from one person to another, and that's why, because the children are in close contact with the mother, the child is also developing. What is the causative organism? Yes, this is a case of molluscum contagiosum caused by pox virus. So this is the virus which can cause molluscum contagiosum, and these are the lesions which are suggestive of this condition. Now skin biopsy demonstrate on immunofluorescence such pattern as shown in the image, what you can see there is one linear pattern. So there is one linear pattern, and you know linear pattern on direct immunofluorescence DIF is seen in which condition? Yes, so if this is epidermis and if this is dermis, what is in between? Yes, basement membrane zone. And in basement membrane zone, what is present? BPAG2 and BPAG1. It is present where? In basement membrane zone, and the antibodies are formed against BPAG1 and BPAG2 in bullous pemphigoid, and that's why in bullous pemphigoid such linear pattern is seen, and that's why the answer is pemphigoid. Then this is also pemphigus, this is also pemphigus, and I told you in pemphigus. So in pemphigus, which is intraepidermal disorder, so it is intraepidermal disorder, pemphigus, and that's why, because in pemphigus normally desmoglin is involved, and desmoglin is present in desmosomes in between the keratinocytes. So the antibodies are also present here, that is over the surface of these keratinocytes. So that's why they look something like this or something like this. So all the pattern is within epidermis, and it is something like this, resembling fish net. So fish net like pattern is seen in pemphigus, while linear pattern is seen in pemphigoid. So the answer is bullous pemphigoid. So thank you very much. All the very best.
Hello everyone and welcome to the discussion of our CBoT forensic medicine questions. Let's take up our question number 1. Our first question is regarding a concept called as grievous hurt. The question says, grievous hurt is defined under which IPC? It's a very straightforward and a very simple question. हमें इस क्वेश्चन में सिर्फ क्या बताना है कि कौन से आईपीसी के सेक्शन में ग्रीवियस हर्ट की डेफिनेशन है. इट इज डिफाइंड अंडर, राइट, एंड द आंसर इज सेक्शन 320 आईपीसी. ओके, तो हमें क्या याद रखना है वेरी इंपॉर्टेंटली? सेक्शन 320 आईपीसी defines grievous hurt, and then section 323 to section 326 has punishments for various hurt scenarios. ठीक है? So there could be two kind of hurt: simple hurt, grievous hurt, right? Grievous hurt की definition 320 IPC में है. सिंपल हर्ट, जिसको हम सिंपल हर्ट नहीं सिर्फ हर्ट भी कहते हैं, उसकी डेफिनेशन 319 आईपीसी में है. एंड देन पनिशमेंट 323, 324, 325 एंड 326 में है. 323 and 324 are punishing for simple hurts, and 325 and 326 punishes for grievous hurt, right? So we'll remember this simple nomenclature. Let's move to our next question. Next question is, identify the fingerprint pattern shown in the image below. Now many of you आपने ये चीज़ याद कर ली होगी, ये चीज़ रिहर्स कर ली होगी कि डिफरेंट फिंगरप्रिंट के पैटर्न्स किस तरीके से दिखाई देते हैं. बट आइए इसको एक थोड़े से सिंपल और लॉजिकल वे से देखते हैं. ओके, तो 3 फिंगरप्रिंट पैटर्न याद रखने की हम कोशिश करेंगे. द फर्स्ट वन इज अ वर्ल पैटर्न. ठीक है, पहला जो है वो है क्या है? WHORL, वर्ल पैटर्न. वर्ल पैटर्न कैसे होता है? गोल गोल घुमावदार, जैसे वर्लपूल होता है ना, वर्ल बनता है पानी में, वैसा. तो वर्ल कैसा दिखाई देगा? वर्ल हमको इस तरीके से दिखाई देगा, गोल गोल, right? So wherever you find a fingerprint pattern which is गोल गोल in the form of a whirl, that is a whirl pattern, right? अब इसी whirl को थोड़ा सा अगर हम ओपन कर दें, थोड़ा सा, ज्यादा नहीं, तो किस तरीके का बन जाएगा? ये कुछ इस तरीके का बन जाएगा. It will become like this. It will become like this. हमने whirl को थोड़ा सा खोल दिया, ज्यादा नहीं, थोड़ा सा खोल दिया. ओके, नाउ इट लुक्स लाइक अ लूप. जैसे हम किसी रस्सी का लूप बनाते हैं, ठीक है, तो गोल नहीं है, बट वो एक थोड़ा सा ओपन्ड वर्ल है. और अगर हम इसी को और थोड़ा सा खोल दें, इट माइट बिकम लाइक दिस. अगर हम इसी को और खोल दें, तो ये और भी एक टेंट की तरह खुल जाएंगे, जिनको हम बोलते हैं आर्चेस. ओके, जिनको हम बोलते हैं आर्चेस. तो सबसे पहला क्या है? वर्ल, जो कि एक गोलदार घुमावदार पैटर्न है. दूसरा, अगर हमने वर्ल को ओपन किया तो वो लूप बन गया. अगर हमने वर्ल को और खींच के ओपन कर दिया तो वो बन गया आर्च, राइट? तो अब अगर आप फोटोग्राफ में देखो तो आपको किस तरीके का पैटर्न दिखाई दे रहा है? आपको बीच वाला पैटर्न दिखाई दे रहा है, यानी कि वर्ल को हमने थोड़ा सा खोला है. दिस इज अ लूप पैटर्न, which is also the most common pattern seen worldwide. 65% population tends to show loop pattern of fingerprints, which is most common. और लीस्ट कॉमन कौन सा होता है? लीस्ट कॉमन होता है कॉम्पोजिट. तो कॉम्पोजिट को कैसे पहचाने? अगर आप वर्ल नहीं देख पा रहे हैं, अगर आप लूप नहीं देख पा रहे हैं, अगर आप आर्चेस नहीं देख पा रहे हैं, और इन सभी का एक मिक्सचर सा लग रहा है, दैट इज कॉम्पोजिट, लीस्ट कॉमन पैटर्न. तो इस तरीके से हम फिंगरप्रिंट की रीडिंग को याद रखेंगे. लेट्स सी द नेक्स्ट वन. ड्यूरिंग अ वाइवा in college, the examiner asked the student about dimercaprol. It is used as an antidote for which of the following poisoning? Very simple, again a very straightforward question. हमारे FMG एग्जामिनेशन में कई बार आता है इस तरीके के सिंपल क्वेश्चन कि किस तरीके की पॉइजनिंग का कौन सा एंटीडोट होता है, एंड उसमें किलेटिंग एजेंट्स भी एक ऑप्शन रहते हैं. तो डाइमरकैप्रोल, which is also known as British anti-levisite, is an antidote for arsenic poisoning. Is an antidote for arsenic poisoning. बहुत ही इंपॉर्टेंट क्वेश्चन है, ये याद रखना है. इट इज टू बी गिवन डीप IM इंजेक्शन. ओरली नहीं देख सकते, दे सकते हैं हम इसे डीप IM इंजेक्शन लगता है. रादर देन डाइमरकैप्रोल, इज देयर एनी बेटर चॉइस? फॉर आर्सेनिक पॉइजनिंग, हाँ, बेटर चॉइस है DMSA. DMSA इज अ बेटर चॉइस. क्यों? बिकॉज DMSA आप ओरल दे सकते हो. इट कैन बी गिवन orally, and that's why it is a better choice for arsenic poisoning. But remember, dimercaprol, which is an age-old compound, has been the first line of drug in treatment of arsenic poisoning. Next question. Wearing clothing from the opposite sex is a form of perversion known as. इसमें एग्जामिनर क्या पूछ रहा है आपको? एक सेक्स दूसरे यानी ऑपोजिट सेक्स के क्लोथिंग को प्रेफर करता है, इस तरीके की परवर्जन को क्या कहते हैं? तो सबसे पहले देखते हैं व्हाट एग्जैक्टली आर परवर्जन्स. Perversions are phenomena where a person attains sexual gratification by indulging in the perversive act. नॉर्मली सेक्सुअल ग्रेटिफिकेशन लोगों को सेक्सुअल इंटरकोर्स से मिलता है, सम काइंड ऑफ सेक्सुअल इंटरकोर्स वेदर नेचुरल और अननेचुरल. बट हम परवर्जन्स किसको कहते हैं? परवर्जन्स आर फिनोमेना वेयर पीपल अटेन सेक्सुअल ग्रेटिफिकेशन बाय इंडल्जिंग इन द परवर्सिव एक्ट एंड दैट एक्ट डज नॉट इन्वॉल्व एनी एक्चुअल सेक्सुअल इंटरकोर्स. ओके, सो इस तरीके के परवर्जन को क्या बोलते हैं? जहां पर एक सेक्स का व्यक्ति दूसरे सेक्स के कपड़ों को प्रेफर करता है. इट इज कॉल्ड एज ट्रांसवेस्टिज्म, ऑल्सो कॉल्ड एज फेटिचिस्टिक ट्रांसवेस्टिज्म. सो करेक्ट आंसर हियर इज फेटिचिस्टिक transvestism, also called as it is also called as eonism. It is also called as eonism. Okay, Frotteurism क्या होता है? Frotteurism is pushing onto female's body by self genitalia in public places, right? Frotteurism ये भी काफी बार एग्जाम में पूछा हुआ है. और ऑप्शन डी विच इज एग्जिबिशनिज्म ये भी काफी बार एग्जाम में पूछा हुआ है. दिस इज डिस्प्लेइंग सेल्फ न्यूडिटी to public. Displaying self nudity to public is exhibitionism, punishable under section 294 IPC. So if somebody goes nude into the public, if somebody walks out nude, that's a punishable offense under 294 IPC. That's exhibitionism. Next देखते हैं. In an instance of reported sexual assault involving a female of 18 years of age, Barbario's test was performed on the victim's clothing stains in order to detect semen. Okay, so simple question क्या कह रहा है कि सेक्सुअल असॉल्ट का एक केस है, फीमेल की एज 18 है, उसके अंडरगारमेंट्स पे कुछ अलेज्ड स्टेन है, दे कुड बी सेमिनल स्टेन. उन स्टेन्स पे बारबेरियोस टेस्ट किया गया है. ऑफ द फॉलोइंग विच इज डिटेक्टेड बाय दिस टेस्ट. तो क्वेश्चन बड़ा सिंपली पूछ रहा है कि बारबेरियोस टेस्ट में हम क्या देखते हैं. ओके, तो सबसे पहले देखते हैं बारबेरियोस टेस्ट किस तरीके से परफॉर्म किया जाता है. तो इफ आई से बारबेरियोस टेस्ट, basically what do? We take stain, we add picric acid to the stain. तो स्टेन का हमें स्मीयर बनाना होता है स्लाइड पे, क्योंकि बारबेरियोस टेस्ट जो है वो एक माइक्रोस्कोपिक टेस्ट है. तो स्टेन का हमने स्मीयर बनाया, स्मीयर पे हमने पिक्रिक एसिड डाला एंड देन वी वॉच द स्मीयर अंडर माइक्रोस्कोप. तो जब हम माइक्रोस्कोपिक व्यू में देखते हैं तो हमें क्या दिखाई देता है? हमें माइक्रोस्कोपिक व्यू में दिखाई देता है इस तरीके से क्रिस्टल्स, राइट? क्रिस्टल्स दिखाई देते हैं इस तरीके से, राइट? इन क्रिस्टल्स की जो शेप है और कलर है वो क्या होता है? दीज क्रिस्टल्स आर येलो इन कलर and they are needle shaped. They are needle shaped crystals, yellow in color. If these kind of crystals are seen, they are crystals of spermine picrate, right? And if these crystals generate, we say that the Barberio's test is positive, which means the alleged sample was a seminal sample. तो हमने बारबेरियोस टेस्ट करके कौन से क्रिस्टल ढूंढे? हमने बारबेरियोस टेस्ट करके स्पर्मीन क्रिस्टल्स ढूंढे, जो कि हमारे क्वेश्चन का करेक्ट सिंपल आंसर है। ओके, आगे चलते हैं। नेक्स्ट क्वेश्चन, ऑल द फीचर्स ऑफ कैडेवरिक स्पाज्म एक्सेप्ट। कैडेवरिक स्पाज्म के सारे फीचर्स हैं कौन सा? तो कैडेवरिक स्पाज्म अगर हम देखें तो वो क्या कंडीशन होती है? कैडेवरिक स्पाज्म इज अ कंडीशन वेयर द मसल of the body goes into a strong contraction just before death, and it remains like that after death also. तो नॉर्मली अगर हम देखें डेथ के बाद बॉडी के मसल्स में क्या चेंजेस आते हैं? नॉर्मली आफ्टर डेथ सबसे पहले जो मसल्स हैं बॉडी की वो जाती हैं इनटू अ फेज कॉल्ड एज प्राइमरी रिलैक्सेशन फेज। उसके बाद में वो मसल्स जाती हैं इनटू अ फेज कॉल्ड एज रिजिडिटी का फेज, जिसको हम बोलते हैं राइगर मोर्टिस। और राइगर मोर्टिस जब बॉडी से पास ऑफ हो जाता है तो मसल्स जाती हैं सेकेंडरी रिलैक्सेशन के फेज में, क्योंकि वो दोबारा से रिलैक्स्ड हो जाती हैं। बट कैडेवरिक स्पाज्म में हम क्या देख रहे हैं? डेथ के जस्ट पहले सम मसल ऑफ द बॉडी, नॉट ऑल द मसल्स, सम मसल ऑफ द बॉडी में गो इनटू अ फेज ऑफ सडन कॉन्ट्रैक्शन, और वो डेथ के बाद भी वैसी ही रिजिड फेज में ही दिखती हैं। यानी कि प्राइमरी रिलैक्सेशन का फेज उन मसल्स में से बाईपास हो गया है, वो डेथ के बाद दिखाई नहीं देता। सम मसल ऑफ द बॉडी रिमेन्स रिजिड राइट आफ्टर डेथ। इसका मतलब कैडेवरिक स्पाज्म इंस्टेंटेनियस हुआ, ये एक ट्रू स्टेटमेंट है। ये राइगर मोर्टिस की तरह धीरे धीरे डेवलप नहीं करेगा। इट्स एन इंस्टेंट फिनोमेना दैट इज सीन इन डेड बॉडी, राइट। अगर हम ऑप्शन नंबर सी देखें, सीन ओनली इन स्पेसिफिक मसल ग्रुप, ये भी एक ट्रू स्टेटमेंट है। So this is true because cadaveric spasm will only be seen in those muscles which may undergo that instant contraction or instant rigidity. Generally वो होते हैं hands. So most common muscle involvements are hands, and there is marked muscle stiffening. Even this is true कि muscle stiffening बहुत marked होती है cadaveric spasm में। तो हमारे पास में एक्सक्लूजन से कौन सा ऑप्शन रह गया? दैट इट इंडिकेट्स टाइम सिंस डेथ। कैडेवरिक स्पाज्म देख के हम टाइम सिंस डेथ नहीं बता सकते, बिकॉज कैडेवरिक स्पाज्म इज प्रेजेंट इंस्टेंटली आफ्टर डेथ। किसी डेड बॉडी को आपने मरने के तुरंत कुछ मिनट्स के बाद देखा है तो भी कैडेवरिक स्पाज्म मिलेगा, और अगर उसी डेड बॉडी को आपने कुछ घंटे के बाद देखा है, 1 या 2 घंटे, तब भी उसमें कैडेवरिक स्पाज्म मिलेगा। ओके, राइगर मोर्टिस के कंपैरिजन में कैडेवरिक स्पाज्म का डिफरेंस क्या होता है? कैडेवरिक स्पाज्म इंस्टेंटली दिखाई देता है डेथ के बाद, राइगर मोर्टिस ग्रेजुअली डेवलप करता है। कैडेवरिक स्पाज्म किसी एक स्पेसिफिक मसल ग्रुप में मिलेगा, मोस्ट कॉमनली हैंड्स में। राइगर मोर्टिस पूरी बॉडी के मसल्स को धीरे धीरे इन्वॉल्व करेगा, राइट। राइगर मोर्टिस टॉप टू बॉटम प्रोग्रेस करता है और टॉप टू बॉटम ही जाता है। कैडेवरिक स्पाज्म टॉप टू बॉटम फिनोमेना फॉलो नहीं करेगा, जिस मसल में है सिर्फ उसी मसल तक लिमिटेड रहेगा, बाकी मसल्स बॉडी की नॉर्मल राइगर मोर्टिस साइकिल डेवलप करेंगी। ओके, so our correct answer is cadaveric spasm doesn't help in determination of time since death. Let's see the next question. A patient with the features of depicted in the image below. तो एक पेशेंट है, वो कौन से फीचर लेके आया है जो नीचे इमेज में दिखाए गए हैं? सो दिस इज द इमेज यू कैन सी, और इसमें किस तरीके का फीचर दिखाया हुआ है? ही इज हैविंग diplopia, difficulty in opening the eye, that you can see, is brought to the emergency room due to a history of snake bite. Okay, the patient passed away during the course of treatment. As seen in the picture, the relatives snapped up the alleged snake. In this case, what will be the cause of death? ओके, तो हमें दो चीजें दी हुई हैं पिक्चर में। एक कि स्नेक बाइट हुई है, तो उसकी वजह से क्या सिम्टम डेवलप किया उस पेशेंट ने। वी कैन सी द सिम्टम विच इज डेवलपिंग इज अनएबिलिटी टू ओपन अप द आईज, डिप्लोपिया हो रहा है। ओके, और दूसरा, उसी के रिलेटिव्स ने उसकी स्नेक की फोटोग्राफ्स खींच करके हमारे को दिखाई हैं। और फोटोग्राफ देख करके हमें क्या दिखाई दे रहा है, विच काइंड ऑफ स्नेक इज दिस इज बैंडेड क्रेट। यू कैन सी किस तरीके से बैंड्स बने हैं स्नेक की बॉडी पे। दिस इज एन एग्जांपल ऑफ बैंडेड क्रेट। ओके, और क्रेट किस फैमिली का स्नेक है? केक क्रेट जो है वो एक न्यूरोटॉक्सिक फैमिली का स्नेक है। दिस इज अ न्यूरोटॉक्सिक फैमिली स्नेक, राइट। और न्यूरोटॉक्सिसिटी की वजह से कॉज ऑफ डेथ क्या रहेगा उसका? रेस्पिरेटरी पैरालिसिस। दैट वुड बी दी cause of death, respiratory paralysis. So correct answer is respiratory paralysis. Let's move on to our next question. Rotten egg odor is associated with, very commonly associated question in forensic medicine. बॉडी के डिफरेंट डिफरेंट टाइप के कौन से ओडर्स हमें डेड बॉडी में कई बार मिलते हैं। रॉटन एग ओडर इज एसोसिएटेड विद हाइड्रोजन सल्फाइड। Hydrogen sulfide is gas of organic decomposition. गैस ऑफ ऑर्गेनिक डीकम्पोजिशन। एल्यूमिनियम फॉस्फाइड से हमें कैसी मिलती है ओडर? फिशी। अगर एल्यूमिनियम फॉस्फाइड से पॉइजनिंग हुई है तो डेड बॉडी से हमें फिशी ओडर मिल सकता है। हाइड्रोजन सल्फाइड के केस में रॉटन एग ओडर मिलता है। आर्सेनिक एंड फॉस्फोरस दे गिव garlicky odor. They give garlicky odor. Very commonly asked these three odors. Fishy odor किसका होता है, rotten egg किसका होता है, garlicky किसका होता है, वो हमने इस क्वेश्चन में देखा। Right, with that we come to the end of discussion of this CBOT. I'll see you in the next one. तब तक जम के पढ़ाई करते रहिए।
Alright, hi guys. So let's discuss the pharmacology question that was asked in our computer-based offline test. Now I saw there were around 20 plus questions from pharmacology, and most of the questions were pretty easy and some were directly from previous year topics as well. And I'm pretty sure that most of you have got it correct. Majority of you have got most of the questions correct. Now let us see what are the area where you could have avoided the silly mistakes, and what are the things that you should be aware in the upcoming examination. Now this CBOT or the grand test discussion that we're going to do is going to be important with respect to the things that we will be discussing after the other options, right? About the other option, whatever we discuss, please take care of that as well. The very first question that we got here was about a patient who got under treatment for colorectal carcinoma. And for the colorectal carcinoma, remember the drug of choice for colorectal carcinoma that we know is a 5-fluorouracil. Okay, so this is one information given already. He is now experiencing diarrhea. See, nausea, vomiting, diarrhea is always seen. And here actually the question is, examiner is asking the question that if there is a patient with the chemo-induced diarrhea. Now earlier they were asking questions like chemo-induced nausea and vomiting, but this time there is chemo-induced diarrhea. which of the following is the most appropriate drug? So chemo-induced diarrhea के लिए opioid like loperamide is the most appropriate drug. As a matter of fact, loperamide is considered the drug of choice for this scenario. Correct answer for this one is going to be B. Now another question the examiner which can frame or examiner has asked already, that if there is a patient coming to you with the chemotherapy induced nausea and vomiting, and this answer to this question is pretty simple, that is going to be your 5-HT3 antagonist by the name of your ondansetron. 5-HT3 antagonist by the name of ondansetron. All right, so this was your first question. Now atropine has no utilization here. Alone atropine will not be effective. Or nidazole, it's again from the gram negative, and ciprofloxacin is one of the fluoroquinolone that can again be utilized in GI infection, but again for the chemo-induced diarrhea we'll be using loperamide as a drug of choice. Your 62-year-old female had a past history of acute episode of chest pain and tightness with ST depression, okay, and changes on ECG on few occasions. She is now prescribed medication for prophylaxis of her condition. Okay, so she presented to the OPD with headache and constipation. All right, so simply examiner is asking which of the following drug will be causing headache, constipation for the past month. Which of these could be the drug that was prescribed to her causing these symptoms? Now constipation is something, see nausea, vomiting, ये होता रहता है, diarrhea भी होता रहता है, but whenever it comes to constipation is something which is mainly associated with your calcium channel blocker by the name of your diltiazem, your DHPs, dihydropyridines, or your DHPs or non-DHPs, they both are actually associated with your constipation because they both can cause relaxation of the smooth muscle, right? Especially with respect to intestine, and they are very common. I mean, if you are going to compare constipation with any other drug in the antihypertensive drug, diltiazem and DHPs में कौन आएगा? DHPs में all the dipines, they will always top the list. Others can be associated with your diarrhea or other GI symptom, but again constipation is not very common. And propranolol is the beta blocker. Nicorandil, now nicorandil is something that you should know. What is nicorandil actually? Nicorandil, it's one of the drug that is the next best alternative to nitrates. It is one of the drug that is utilized in a patient with the angina. It is utilized in a patient with the angina. It's a source of nitric oxide, nicorandil. In addition to it being a source of nitric oxide, remember it's also one of the potassium channel opener. It's also one of the potassium channel opener, mainly utilized in a patient with the angina. Isosorbide dinitrate can also be utilized in angina. They can be associated with headache, but not commonly your constipation is a side effect. 67-year-old male presented with complaints of difficulty in urination, back pain, okay, difficulty in urination, back pain, elevated PSA, prostate specific antigen, and X-ray revealed two radiolucent lesion on in the bony pelvis. Okay, so radiolucent lesion in the bony pelvis, high level of PSA, they are actually suggestive of a prostatic carcinoma that is possibly already has started metastasis. MRI revealed large lymph node. Okay, so there is lymphatic evidence as well in the lower abdomen. Which of the following drug can most likely be used? So in a condition like this, we will be using the drugs like your goserelin. What are they? They are actually the drug that is known as your GnRH analog. They are actually your GnRH analog. So whenever we are going to give this one GnRH analog on the continuous dosing, it will be acting as an antagonist. Continuous dosing will be acting as an antagonist. Other agent that can be utilized for this condition, other agent or other drug that can be utilized will be your digarelix. They are the antagonists. Digarelix, cetrorelix, they are the antagonists. Last में X word आ रहा है, that is cross. They are the antagonists of the GnRH. Okay. Other agents actually, some of them like let's say anastrozole and all can be utilized, but again, whenever you have to choose one, goserelin, it will be the preferred over other agent that is given here. A 73-year-old man presented with a shortness of breath, wheezing. He has a 50-pack year smoking history. On examination, vitals are normal except for the blood pressure, which is 168. Okay, so BP is high. On previous visit, BP was this, so BP is still high. What they're trying to say, grade 2 already. Another examination finding is given below. So if you can see here, the image, this is possibly a case of your peripheral vascular disease, possibly a case of let's say Raynaud's syndrome, Raynaud's phenomena, right? Where there is fingers are turning quite dark, or I would say blackish, Now, which of the following antihypertensive agent is contraindicated in this one? Now, lisinopril. What is lisinopril, guys? Lisinopril is one of the ACE inhibitor. There is no such a contraindication of ACE inhibitor in a patient with the peripheral vascular disease. Nadolol. What is nadolol? Nadolol is a non-selective beta blocker. Non-selective beta blocker. Prazosin is one of the alpha-1 blocker. All the zosine are alpha-1 blocker. Now, one more thing that I would like to highlight here. In a patient with a peripheral vascular disease like Raynaud's syndrome, the most preferred agent that we are going to use is always going to be calcium channel blocker. Dipines like amlodipine, nifedipine, they are the most preferred. In addition to that, we can utilize other, like let's say others like nitrate we can utilize. We can also utilize prazosin, terazosin, that is alpha-1 blocker can also be utilized, right? Alpha-1 blocker can also be utilized. All these agents can be utilized. Now, bisoprolol. Bisoprolol is one of the cardioselective beta blocker. It is one of the cardioselective beta blocker. Can we use cardioselective beta blocker? The answer is yes. Now, if you are going to see alpha-1 blocker, they are definitely going to be utilized, right? Can we use nadolol? The answer is no. Why not? Because nadolol is something that can aggravate. Actually, in a patient with a peripheral vascular disease, we give beta blocker with much precaution. Reason being that when we talk about a selective or non-selective beta blocker, the non-selective beta blocker, like let's say nadolol as a drug, they are going to block beta 1 and they are also going to block beta 2. You see, if they are going to block beta 1, definitely the heart rate will decrease. We are okay with it because we have to reduce the blood pressure. But if they are going to block beta 2 normally causes vasodilation. Beta 2 normally causes vasodilation, and whenever beta 2 is associated with vasodilation, but if you block beta 2, now there will be apparent vasoconstriction because alpha tone will be high. There will be apparent vasoconstriction, and therefore it can always and always precipitate a condition like peripheral vascular disease. Therefore, it is always and always said that the non-selective beta blocker are going to be contraindicated in following condition. Non-selective beta blocker are going to be contraindicated in patient with the bronchial asthma, in patient with the peripheral vascular disease, right? In patient with your diabetes also. In diabetes, non-selective beta blocker can actually cause masking of the hypoglycemic symptom. They can cause masking of the hypoglycemic symptom, right? Let me just put it a little more up. So these are the areas in which non-selective beta blockers are actually contraindicated. So do remember this one. BPD is a very, very simple mnemonic. BPD bronchial asthma mein nahi denge, peripheral vascular disease mein nahi denge, and also in diabetes mellitus also we are not going to give. BPD is a very, very simple mnemonic where we are not going to give. Which of the following drug does not require any renal, or I would say any dose modification in patient with the chronic kidney disease? Glyburide, ripaglinide, saxagliptin, lina. Now, this was a straightforward question, has been repeated many a number of times. The answer to this question is linagliptin. Gliptin, all the gliptins actually coming from the DPP-4 inhibitor. DPP-4 inhibitor, they are all excreted renally. They are all excreted renally except all the DPP-4 inhibitor excreted renally except your linagliptin. So लीना को कैसे याद करने के लिए बोलता हूँ? लीना को मैं बोलता हूँ कि लीना लिवर से एक्सक्रीट होता है. लीना is getting excreted via the hepatic route, and that is why it is said that linagliptin, it is a safest one in a patient with the renal failure, or dose adjustment is not required in renal failure. Another important question that can be framed, that they are going to be contraindicated in hepatic failure patient. They are going to be contraindicated in hepatic failure patient, or dose adjustment may require in hepatic failure patient. Which of the following anti-dyslipidemic drug is the drug of choice in pregnancy? Anti-dyslipidemic drug of choice in pregnancy. Bezafibrate, rosuvastatin, cholestyramine. Now, anti-dyslipidemic drug of choice in pregnancy is always your bile acid sequestrants, and a bile acid sequestrant, which we also call them as a resins, right? They are going to be drugs like your cholestyramine, drugs like your cholestyramine, cholesevelam, cholesevelam. Now, all these drugs that we have, cholesevelam, cholestyramine, they are bile acid sequestrant. They are the bile acid chelator in the intestine. The site of action of these drugs is actually in the intestine. They are not working at the circulation level or working at the intestine level. That is why they are considered the safest or most preferred in a pregnant female and also in the pediatric population. Pregnancy and pediatrics, right? So cholestyramine is the one. Now let's quickly rule out other option. Azatimib is an easy peasy drug. It is going to inhibit the cholesterol absorption from the intestine. Cholesterol absorption from the intestine by inhibiting a transporter known as your NPC1L1, right? Niemann-Pick like one transporter. Rosuvastatin is one of the statins, right? It's one of the statins that is one of the HMG CoA reductase. आपके एग्जाम में एक बार क्वेश्चन आया था, उसमें आया था HMG CoA synthase. No, ऑप्शन में synthase भी था, reductase भी था. It is one of the HMG CoA reductase inhibitor. Bezafibrate, they are all fibrates. Bezafibrate, clofibrate, fenofibrate, they are the PPAR fibrate, PPAR alpha agonist. They act by nuclear receptor and increase the level of an enzyme called lipoprotein lipase. That lipoprotein lipase will be causing breakdown of the triglycerides. Okay, so this was your quick summary of important anti-dyslipidemic drug. All right, next one. Which of the following DMR require regular monitoring of the visual acuity and fundus? This is one of the previous year NEET PG question, and the answer to this question is straightforward: hydroxychloroquine, because it's actually associated with your bull's eye maculopathy. This bull's eye maculopathy is actually an irreversible phenomena. Bull's eye maculopathy, it's an irreversible phenomena. Okay, methotrexate, as a matter of fact, remember guys, it's one of the dihydrofolate reductase inhibitor. They are actually associated with your megaloblastic anemia. Methotrexate associated with your megaloblastic anemia. Methotrexate can be also associated with other side effects. There are many other side effects, like let's say hepatotoxicity, crystalluria, and sulfasalazine. It's one of the sulfa compound, not having any visual related side effect. Neither does leflunomide. So correct answer for this one is going to be hydroxychloroquine. A 29-year-old woman who has been consistently taking oral contraceptive pill for the past 6 months experiences an unintended pregnancy. Okay, so oral contraceptive pill and she conceived. That means there is a contraceptive failure. And always remember, I used to tell you that there is something called enzyme inducer. Let me write the complete word: enzyme inducer. And there is something called enzyme inhibitor. मेरी कहानी अगर आपको याद है, if you remember my story, I used to tell you nearby, whenever the examination is near, whenever you are easily getting induced, the risk of failure will be high. Enzyme inducer will always be associated with your treatment failure. Now this is going to be, earlier they used to ask you which is enzyme inducer, which is inhibitor, but now instead of asking that, they said that okay, now this student is aware about this already, let's ask the clinical application of this one. You should be aware about this as well, that what will be the outcome of enzyme inducer and what will be the outcome of inhibitor. So inducer, if you are getting induced around the examination, there will be high risk of failure. Getting inhibited, if there is too much inhibition, and I remember I used to tell you a story that a type of toxicity will develop inside you, and there will be sudden outburst. So again, there will be increase in the risk of toxicity. Inhibitor will have increase in the risk of toxicity. Now see here, contraceptive failure, again possibly due to associated with your enzyme inducer. Examiner is asking, while on OCP is least likely to occur with which of the following? Okay, contraceptive failure is least likely to occur with which of the following? Now, phenobarbital is a barbiturate, which is one of the enzyme inducer. They can be associated with your contraceptive failure. Phenytoin is an enzyme inducer. Valproate, the only anti-epileptic drug that is not having inducing property, or rather it is having inhibiting properties, valproate. And remember my mnemonic, peacock wala aayega, inhibit karke jayega, where P stands for protease inhibitor, erythromycin. Then next is your amiodarone, and next is your cimetidine, omeprazole, ciprofloxacin, ketoconazole, and VALA will be valproate. Peacock, VALA, I just narrated the drugs that are example of the enzyme inhibitor. So VALA is valproate. It's one of the very, very potent enzyme inhibitor, and all the enzyme inhibitor will have increased the risk of toxicity rather than treatment failure or drug failure. Rifampicin is a very potent enzyme inducer. Okay. A 67-year-old male patient presented with the acute onset of palpitation, chest discomfort, and tachycardia. With a variable heart rate within a short period of time, the cardiologist posted in the ER at the time diagnosed a supraventricular tachycardia, supraventricular arrhythmia in the patient based on ECG and other suggestive finding. Which of these drugs act primarily by blocking sodium channel? Okay, so there is a case of supraventricular tachycardia, or I would say arrhythmia, and examiner is asking which of the following is acting primarily by sodium channel. So sodium channel blocker, if you are going to see, it is drugs like your class 1, 2, 3 and 4, all these are antiarrhythmic drug 1 2 3 4. Out of this 1 2 3 4, 1 is mainly your sodium channel blocker, 2 is the beta blocker, 3 is the potassium channel blocker, 4 is the calcium channel blocker, 1 2 3 4. Out of them class 1 is sodium channel blocker, but 1 के further 3 part होते हैं ना, 1 is further subdivided into 3 important area, that is 1A, 1B and 1C. 1A stand for your, they all are having sodium channel blocker with a potassium channel blocking property. 1B stand for your sodium channel blocker with a potassium channel opening property. And 1C is the only sodium channel blocker. They have no property on the potassium. I mean, very less action on the potassium. So we consider it as a negligible action at the potassium. Only sodium channel blocker. Okay. Now 1A में A grade people. Now in my story, if you remember, A grade people, I used to tell you a story that there is a kingdom having A grade, B grade, and C grade people. A grade people are going to be your people like your queen, so quinidine. Then there is gonna be procainamide, queen prince, and then there is gonna be your disopyramide. So queen prince and dasi. That is A grade people. This is going to be all A grade people. Then B grade people, they are the brave people. Brave people, those who are always bragging about their power, that I'm so brave that they all like to phone me. I'm so brave that they all like to phone me. ये निमोनिक हो गया. Like to phone me, lidocaine, tocainide, phone me is actually phenytoin, me is maxilitine. राइट, नेमोनिक लिख लीजिएगा शायद अगर आप लिख रहे हैं, या अगर आपको याद ही होगा तो लाइक टू फोन मी, आई एम सो ब्रेव दैट दे ऑल लाइक टू फोन मी. 1C, they are doing all the C grade वाला वर्क, that is floor per mopping etc. That is going to be your flecainide, propafenone, moricizine and encainide. So ये जो भी मैंने निमोनिक आपको बताया बड़ा ही सिंपल तरीके से, and you can remember it very very easily about a kingdom which I was talking, that is having A grade people like queen prince and dasi. B grade, they are all brave people, those who are protecting the kingdom, and they say I'm so brave that they all like to phone me. एंड सी ग्रेड वाला काम करते हैं उस किंगडम में, फ्लोर पर मॉपिंग एक्सेट्रा, ये सी ग्रेड वाला काम मान लीजिए उस किंगडम का हो गया. तो फ्लिकेनाइड, प्रोपाफिनोन, मोरिसिन, एनकेनाइड. सो ओनली वन दैट इज हैविंग, ऑल थ्री आर हैविंग सोडियम चैनल ब्लॉकर, बट C is having only sodium channel blocking property. Now what is verapamil? It is one of the class 4 antiarrhythmic drug. It's a calcium channel blocker. Propranolol is a class 2 antiarrhythmic drug. It's a beta blocker. Magnesium is one of the miscellaneous group of antiarrhythmic drug. Flecainide, floor per mopping etc. is the correct answer. They are class 1C antiarrhythmic drug. Flecainide, class 1C antiarrhythmic drug. Remember, they are also considered the drug of choice in a patient with the WPW syndrome, Wolff-Parkinson-White syndrome. Next that we are having, about a 16-year-old boy comes to the OPD with a right knee swelling, but can wear weight and has no great abnormality. Over the last few months, he has had fatigue and pain occurring in variable joint across the body, and characteristic rash. If you are going to see and involving the joint, and remember we call it as a target lesion. Okay, what is correct regarding the first line drug? Target lesion and involvement of the joint. What could be the possible diagnosis? No gait abnormality, fatigue bhi hai, some non-specific symptom we are having. So possibly this target lesion is associated mainly in a condition called your Lyme disease. And Lyme disease के लिए जो drug of choice होता है, the drug of choice for Lyme disease that we know is your doxycycline. Doxycycline is a drug of choice. This doxycycline being a drug of choice, it is one of the 30S inhibitor. So correct answer for this question is going to be your tetracycline is 30S ribosomal unit पे काम करने वाला drug है ना. They are the protein synthase inhibitor. Doxycycline is one of the protein synthase inhibitor targeting your 30S ribosome. 30S protein को target करके काम करते हैं, right? So I hope it is pretty clear to all of you guys. Next question is going to be about a 42-year-old lady presenting the emergency with severe breathlessness while running on the treadmill. The patient has had similar milder symptom while running or when she had a cold. Chest examination revealed polyphonic wheezes bilaterally as a nasal polyp. Okay. nasal polyp, severe breathlessness, emergency. Again, could be possibly a case of bronchial asthma, right? Nasal polyp. Which of the following has the greatest chance of precipitating similar attack? So bronchial asthma patient, asthmatic patient, we always remember whenever we give any of the COX inhibitor, there will be less prostaglandin formation. Apart from that, COX inhibitor will always and always lead to increase, because जो भी हमारा cyclooxygenase pathway था वो तो block हो गया. What we know here, that we are having phospholipid which is actually converted with the help of phospholipase A2 to arachidonic acid. Now over arachidonic acid 2 enzyme is going to work. COX enzyme will be causing prostaglandin formation, and 5-lipoxygenase enzyme is going to cause leukotriene formation. Leukotriene, whenever they are going to act at the bronchial smooth muscle, they will be causing bronchoconstriction. At any point of time, if you are going to give your patient COX inhibitor, what will happen? This entire arachidonic acid cycle, arachidonic acid pathway will now be shifted towards more and more leukotriene, and more leukotriene will always and always lead to precipitation of the problem. So examiner is asking which of the following drug has the greatest risk of precipitating similar attack in this patient. The answer to this question is aspirin. So this is an aspirin sensitive patient actually, and if you are going to see, there is a nasal polyp as well. There is a nasal polyp, there is a bronchial asthma, there is a bronchial asthma, right? Aspirin sensitivity, and polyp. This BAP, this BAP that we have, bronchial asthma, aspirin sensitivity, and nasal polyp, they are also given the name in ENT. You must have read about it. In ENT, you must have read about it. This one, we call this one as a Samter's triad. ठीक है, in a patient with aspirin sensitivity or nasal polyp is seen, and there will be high risk of precipitation of the bronchial asthma. So again, there are two reasons why I have told you that aspirin will be the correct answer. Not steroid. Steroid will provide relief. Theophylline is a phosphodiesterase inhibitor. They will have no such action like polyp, or like same goes for your captopril. A 25-year-old female with overdosage of a drug. The physician looked at the bottle and planned for forced diuresis by causing alkalinization of the urine. Forced alkaline diuresis. Simply examiner is asking forced alkaline diuresis. If you have to change the urine pH to more alkaline, this will be mainly done in the acidic drug poisoning. It will be mainly done in the acidic drug poisoning. What are the example of the acidic drug poisoning, guys? The example of the acidic drug poisoning is going to be aspirin. Other example can be your barbiturate, aspirin, barbiturate. Other drugs are also there, like chloropropamide. They are all example of the acidic drug. Acidic drug poisoning, जहाँ कहीं भी antidote available नहीं होता है, we can do forced alkaline diuresis. Now always and always remember that a drug is never a strong acid or a strong base. They are always going to be your a weak acid. So weak acidic poisoning में alkalinization of the urine will be required. ठीक है, a drug that is having high volume distribution, उसमें will be needing chelators. Chelators or antidotes will be required. Because अगर high volume distribution है, that means that drug has mostly gone to the tissues. Forced alkaline diuresis, remember, in acidic drug poisoning, and no drug is strong acid or strong base. इसी का एक counterpart होता है forced acidic diuresis. तो forced acidic diuresis किस में करते हैं? Forced acidic diuresis, it is done mainly in a patient with the basic drug poisoning. In a basic drug poison, जहां कहीं भी एंटीडोट अवेलेबल नहीं होता है, जैसे कि एट्रोपिन. नाउ एट्रोपिन का एंटीडोट यूजुअली होता है फाइसोस्टिगमिन. इफ फाइसोस्टिगमिन इज नॉट देयर, वी कैन यूटिलाइज फोर्स्ड एसिडिक डायuresis स्टेप, राइट? स्ट्राइचिनिन, you can easily identify the basic drug is going to be strychnine, amphetamine, ठीक है, all of them they are ending with the ene, ठीक है, atropine, strychnine, and quinine, all of them are example of your basic drug that will be requiring your forced acidic diuresis. This will be requiring forced alkaline diuresis. Okay, no drug is strong acid or strong base. Now There is a 61-year-old man reported with fever, night sweat, and productive cough, occasional hemoptysis. So they have given an X-ray already, possibly a case of TB, because hemoptysis, night sweat, productive cough. Empirical treatment is initiated based on this symptom. In follow-up visit, several months later, the patient complains of difficulty in reading newspaper. Okay, so anti-tubercular drug has been given. Now he is having difficulty reading newspaper in the morning and has been observed wearing unconventional color combination at work. Okay, because again there is a color blindness ki taraf they are trying to put your attention. What is the most probable cause of the recent symptom? Again, ocular side effect from the anti-tubercular drug is caused mainly by ethambutol. Ethambutol is mainly EMB is ethambutol. It is actually associated with your optic neuritis. Associated with what? Optic neuritis. This ethambutol that is associated with your optic neuritis, they can actually cause your red-green color blindness. They will cause what? Red-green color blindness. So again, which anti-tubercular drug causing ocular side effect? The answer is in front of you. That is your ethambutol. Rifampicin can produce multiple other side effects. Like rifampicin can cause hepatotoxicity. Rifampicin can cause hepatotoxicity, flu-like symptom, red-orange urine. ये rifampicin के लिए. Isoniazid can also produce hepatotoxicity, peripheral neuropathy. Pyrazinamide, most hepatotoxic. प्यार सबसे toxic होता है. Most hepatotoxic, I used to tell you. Most hepatotoxic, and they can also increase the level of uric acid. Uric acid, that means it can precipitate gout as well. Okay. G protein coupled receptor that does not act through opening of the potassium channel. Now, opening of the potassium channel is mainly associated with your GI. GI जो होता है ये दो तरह से काम करते हैं. One is they act by inhibiting your adenylate cyclase, and therefore there will be less conversion of your ATP to cyclic AMP. Lesser ATP will be broken down to cyclic AMP. So cyclic AMP will always be lesser. Another way is that they are also going to open the acetylcholine sensitive potassium channel. And this potassium channel, when they open the potassium channel, they will be causing potassium ka efflux. That will be causing hyperpolarization of the membrane. Okay. So all of the following, or examiner is asking which of the following does not act through opening of the potassium. So all of the following acting through GI except. So GI के through जो example का होते हैं, मैंने example आपको दिया है ADOMS, ADOMSH, ADOMS. That is going to be your alpha 2, dopamine 2, opioid, M2, M4, 5-HT1, histamine 3 or 4. Right, histamine 3 and 4. So dopamine 2, 5-HT1, M2 is सारे के सारे आ गए. Angiotensin 1, AT1 receptor. AT1 receptor, remember guys, they are mainly going to act via GQ, which is acting through your IP3 and DAG pathway. Do remember a very important thing, that this is one of the previous year AIMS question. Not previous year, I mean 2 years ago. AIMS IRICT में ये question आया होता है around 2020 में, if I'm not wrong. The last AIMS before this, it was merged to IRICT. This question was there. ठीक है, this is going to act via GQ वाले जो होते हैं, मैं आपको एक सिंपल सा निमोनिक बताया होगा कि maths is always questionable. Maths is questionable. Maths, MAATHS, maths is questionable. So this maths stand for your M stand for your receptors like your M1, 3, 5, odd number M1, 3, 5, alpha 1, AT1, angiotensin 1, है ना, your TSH, maths, right, your histamine, histamine का H1, 1 is the very favorite word here, and serotonin का 5-HT2. ठीक, so this is your GQ mediated receptors. Which specific medication in the antiretroviral therapy regimen is most likely to cause hypertriglyceridemia? Hypertriglyceridemia is maximally associated with your protease inhibitor, and all the protease inhibitor, they are all going to end with your navir. So that is going to be your nelfinavir. They will be associated with hypertriglyceridemia. Now tenofovir, again, which type of drug is this? One of the nucleotide reverse transcriptase inhibitor. Tenofovir, anti-RTI, nucleotide reverse transcriptase inhibitor. Dolutegravir, it's one of the integrase inhibitor, and nevirapine, it is one of the NNRTI, non-nucleoside reverse transcriptase inhibitor. This is mainly associated with rash. They are mainly associated with your hepatotoxicity, rash and hepatotoxicity. Okay. A manic patient on lithium therapy developed hypertension. He was started on thiazide diuretics for hypertension. After a few days, he developed abdominal pain, vomiting, along with coarse tremor. Which of the following could be the likely mechanism? Okay, so manic patient, he's taking lithium already, and he was started on thiazide diuretics. Always and always remember, guys, that whenever you start a patient on thiazide diuretics, any thiazides, will they cause loss of sodium? They will be causing loss of sodium, right? We call them as a natriuresis. Because of natriuresis, what will happen? There is decrease in the serum sodium. Body में sodium की level की कमी होगी. As a compensatory mechanism, there will be increase in the sodium reabsorption from the tubules. Sodium reabsorption tubule से बढ़ जाएगा. And always remember, inside the body, because sodium, lithium, they belong to the same family in the periodic table. Always remember, inside of the body, your lithium and sodium is not differentiated. Body cannot differentiate whether it's lithium or sodium. So lithium also utilizes the same channel for getting transported, same as your lithium. So what will happen as a compensatory sodium reabsorption from the tubules along with the lithium. So lithium भी उसके साथ ही चला गया, right? Lithium. So lithium चला गया, उसकी जगह कई बार सोडियम जगह पे lithium चला जाएगा, है ना? And that can increase the risk of toxicity. It can increase the risk of lithium का toxicity. So lithium mediated toxicity is mainly because of excessive reabsorption. As a compensatory sodium reabsorption की वजह से lithium भी body में आ जाता है. Now, which of the following could be the likely mechanism for this interaction? What could be the possible mechanism? Metabolism of the lithium inhibits the thiazide. They are not enzyme inducer or inhibitor. Thiazide act as an add-on drug. Again, dummy choice. Thiazide decrease the tubular reabsorption. Now, is the thiazide decreasing the tubular reabsorption or increasing? If thiazide would decrease the reabsorption, toxicity to hoga hi nahi. There will be no toxicity, right? So thiazide actually increases the tubular reabsorption of lithium. How it is increasing? As a compensatory sodium reabsorption के through lithium भी आ रहा है body में, ठीक है? Which of the following column and mark is correct option? Okay, you have to match it. It's like match the following, है ना? So देखिए इसमें there can be multiple correct one, but if you have to choose one single one, you will be able to correct it. फर्स्ट एंड फॉरमोस्ट, अगर आपको कुछ नहीं आता है, एटलीस्ट आपको इतना पता है पाइलोकार्पिन क्या है. पाइलोकार्पिन प्यूपिल पे काम करने वाला ड्रग है. बिथानिकॉल ब्लाडर पे काम करने वाला ड्रग है. कोलिनर्जिक. वेरेनिक्लिन ये निकोटीन को क्लीन कर देता है. सो व्हाट वी नो अबाउट वेरेनिक्लिन, इट्स वन ऑफ द एंटी स्मोकिंग ड्रग. सो 4 का व्हाट वी नो ए, इतना तो पता है वेरेनिक्लिन. नाउ 4 का ए इज प्रेजेंट इन हाउ मेनी ऑप्शन? स्मोकिंग सेसेशन के लिए. बाकी कोई भी स्मोकिंग सेसेशन के लिए नहीं यूज करेंगे. See, in xerostomia, you can use bethanicol, pilocarpine, cevimeline. तीनों use कर सकते हैं because they are all M3 agonist. But varenicline is the only one. Varenicline is the only one that is utilized for the smoking cessation. So 4 का A is available only in 2 options. Option number A, option number C, जहाँ पे मैंने dot दे दिया. Option number A and C. Now, let's read other option. Pilocarpine is a drug among all of them. It's a very specific in a patient with the angle closure glaucoma, है ना? तो pilocarpine is used for the glaucoma. तो 2 का हो गया C. 2 का हो गया C. So I am also teaching you how to approach this kind of question if they are asked in the examination. 2 का C. So 2 का C is present in how many options? 2 का C is present only in one option. That is option number C. And there you go. You have your answer already. अब कहीं देखना ही नहीं आप कहीं देखना नहीं. बाकी definitely automatically wrong होगा. देख लेते हैं कैसे. Bithanicol mainly urine retention may we can utilize. As I told you that cevimeline, pilocarpine, bithanicol, they all can be used in xerostomia. But the drug of choice for xerostomia is always going to be cevimeline. So you have to choose one best drug, cevimeline. So 1 ka B is available in option C. 2 ka C, there is pilocarpine used for the glaucoma. 3D, bithanicol is used for retention because bithanicol is M3 agonist. And 4 का मैं आपको बता चुका हूँ. Vasomotor reversal of Dale is seen in. Vasomotor reversal of Dale, whenever in presence of alpha blocker we give high dose of epinephrine, there will be only fall in the blood pressure. Only fall in the blood pressure. So fall in blood pressure with epinephrine in presence of alpha blocker. This is the correct one. है ना? इसको बोलते हैं डेल्स रिवर्सल फिनोमेना मेनली, है ना। कभी भी अगर अल्फा ब्लॉकर दे दिया इन प्रेजेंस ऑफ एपिनेफ्रिन, there will be only fall in the blood pressure. That is uniphasic response. Normal person में, in a normal epinephrine, normal person में epinephrine will have biphasic response. They will first, let's say there is a normal blood pressure here. Whenever epinephrine will be introduced, let's say there is a BP of 120. When epinephrine is introduced, the BP will increase because alpha 1 mediated receptor BP will increase. So this can go to, let's say, 160. But when the level of epinephrine comes down, there is someone called sensitive receptor, that is beta 2. So alpha is a strong receptor because they are more in number, and beta 2 is a sensitive receptor. That means they will respond at a very, very lesser dose. So at the lesser plasma concentration of epinephrine, beta 2 will be stimulated, and because of beta 2 mediated activity, the BP will further fall down. Let's say going to 90 or 100. Once the drug is totally washed out, it will go back again to its normal, that is, let's say, 120. So normal person में epinephrine will have biphasic response. First increase, then decrease. First increase, then decrease. But if you are going to give epinephrine in presence of alpha blocker, then epinephrine to BP ko it won't be able to affect, won't be able to increase. Only there is a fall in the blood pressure. This concept of vasomotor reversal of Dale or Dale's reversal phenomenon we utilize mainly in presence with your pheochromocytoma, where we always try to treat a patient of the pheochromocytoma as a drug of choice. Drug of choice का होता है phenoxybenzamine. Phenoxybenzamine. We never give phenoxybenzamine alone. We never give phenoxybenzamine alone. Along with this, we always add beta blocker, and order always remains the same. Order always remains the same. Order remains the same. That is going to be your alpha blocker followed by beta blocker. है ना. So अगर आप सिर्फ अल्फा ब्लॉकर दे देते हैं, तो there are high chances बीटा mediated BP fall will be there. In a patient with pheochromocytoma, कभी भी एक ड्रग नहीं यूज करते हैं. We always use phenoxybenzamine with the beta blocker. Order always goes alpha blocker then beta blocker. Okay. A 68-year-old male diagnosed with the infiltrating astrocytoma receiving palliative care develops cerebral edema. IV mannitol therapy is started to relieve the symptom. Which of the following is the incorrect statement? So mannitol is one of the osmotic diuretic. Definitely it's a correct statement. It can also be used in some case of the drug overdosages. Okay, let's read other option. It expands the intravascular fluid compartment. Definitely it increases. It can be used to alleviate symptom of the acute pulmonary edema. Now whenever you have to do forced diuresis, है ना, कई बार किसी ड्रग में forced diuresis जब करना होता है, तो वहां पे we can actually utilize in forced diuresis वाले सिनेरियो में we can actually utilize our diuretic like osmotic diuresis, है ना, तो वहां तो यूज कर सकते हैं. Now in acute pulmonary edema, they can always see intravascular volume is already very high, and if you are going to give a drug जो कि in a patient with already pulmonary edema, वो further deteriorate करेगा, it will worsen. So it will not alleviate, rather it will worsen. So it will also worsen. It also worsens. Mannitol also worsens congestive heart failure patient का condition. CHF में भी नहीं देंगे. So they are actually contraindicated. Mannitol as a drug which is osmotic diuretic, it's contraindicated in congestive heart failure. Mannitol is contraindicated in patient with the acute pulmonary edema. Mannitol as a drug, it's a active cerebral bleed. Active cerebral bleed. उसमें भी नहीं देंगे because again they are osmotic diuretic, और जहां भी जाएंगे they will pull the water towards themselves. They will worsen the cerebral edema in that case scenario. A mother brings her 10-year-old son to the clinic for multiple episodes of bedwetting every night for the past 2 months. The patient was prescribed desmopressin. Desmopressin is one of the synthetic vasopressin. It's one of the V2 analog, synthetic vasopressin. The drug belongs to the class of vasopressin. Okay, so they have given this information as well. Which of the following is not another indication for the use of this class of drug? Which of the following is not another indication? Von Willebrand disease, esophageal varices, central diabetes insipidus का तो drug of choice है. Acute pulmonary edema में नहीं use करते ना. We do not have any use of acute pulmonary edema V2 analog का. Von Willebrand disease में we can utilize, and also in esophageal varices में we can utilize. है ना. They are having V2 receptor analog है, but they also have V1 analog property that will be causing vasoconstriction. That is why esophageal varices we can utilize. Last question, which of the following is false about the clinical trial? Which is false about the clinical trial? Now, clinical trial, remember guys, phase 0 pharmacokinetic analysis को microdosing बोलते हैं. Yes, they are phase 0 is a microdosing analysis. So, उसमें pharmacokinetic analysis होता है. Remember, it's a non-mandatory trial. It's a non-mandatory trial, and this non-mandatory trial, it is mainly done on normal healthy volunteers. It is mainly done on the normal healthy volunteers. It is not done on the animal. Phase 4 is post-marketing surveillance. Yes, that's also correct. You have to find out a false statement. Phase 3 may around 3000 patients are there, है ना? So sample size, if you are going to see sample size की basis, if you are going to see 1 2 3 4, तो 1 में around 25 से 125 to 100, around 100. 2 में early part और late part, तो somewhere around 200 to 400, so 200 watt आ गया. 3 में 1000 to 5000, I used to say on an average around 3000 आपको याद करना है. 3 में 3000, and 4 में there is no limitation on the sample size. ठीक है. So 5 to 10 patients are taken. No, 5 to 10 patients तो नहीं होते, उससे ज्यादा patient होते हैं. This is a very straightforward question. Phase 2 blinding is done. Yes. Phase 2 और phase 3 अगर study design देखना है तो this is one of the open label study. Phase 1 is one of the open label study. Phase 4 is also an open label. Open label का मतलब everyone is aware who is taking what kind of drug, what is the possibility here. 2 and 3, they are the one that will be requiring randomization, and for that remember blinding will be done. So initial condition there will be single blinding, double blinding, and later on the phase 2 phase 3 may will we have double blinding crossover. So again blinding will be required in both the scenario. Actually 2 और 3 जो है दोनों ही blinding होता है. 2 and 3 they are almost same. It's just that 3 will be requiring more number of patients, and in majority of the condition 3 is a multi-centric trial. Okay. So this will be everything in our today's TND. As I told you, and it's not a TND but again CBoT discussion. The clinical trial का एक question था. I hope all of you guys have got this one. Pulmonary edema, desmopressin का there is no role, है ना? And pulmonary edema में again mannitol has no role. Acute pulmonary edema में in fact it can worsen the scenario. Then vasomotor reversal of Dale का एक question था, तो total 21 question हो गए, है ना? Then different cholinergic drug के different uses, as I have told you already. Here thiazide, it is going to actually increase the tubular absorption of lithium as a compensating mechanism. Nelfinavir hypertriglyceridemia के साथ maximum होगा among all the antiretroviral drugs. AT1 receptor is mainly mediated by GQ, rather all others in this option is GI mediated. TB में which of the following will cause optic neuritis? That is going to be ethambutol. Weak acid, we always have either weak acid or weak base. We don't have weak strong acid or strong base. Weak acid में we will be causing forced alkaline diuresis. Aspirin can always precipitate bronchial asthma, and Samter's triad is a triad of bronchial asthma, aspirin, satiety, and polyp. So aspirin always precipitate bronchial asthma. Remember, Lyme disease में doxycycline being the drug of choice. It is a protein synthesis inhibitor targeting 30S ribosomal subunit. Flecainide is class 1C anti-inhibitor, mainly a sodium channel blocker. Valproate, remember, it's a potent enzyme inhibitor. All other anti-epileptic drugs are mainly your enzyme inducer. Valproate is an enzyme inhibitor. Hydroxychloroquine associated with your bullseye maculopathy. Cholestyramine, antidyslipidemia drug that is preferred in pediatrics and pregnancy. Linagliptin, it's a gliptin that is mainly safer in a patient with your renal failure. And non-selective beta blocker is contraindicated in BPD वाला scenario मैंने आपको बताया था, bronchial asthma, peripheral vascular disease, and diabetes mellitus. Goserelin, GnRH analog, can be utilized in your prostatic carcinoma. Diltiazem can be causing constipation, you know. Loperamide, preferred drug in chemo-induced diarrhea, right? So this was your 21 question that was asked in our today's session. I hope that you guys got maximal correct. Wherever you made the mistake, wherever you think that the mistake has happened, try to reduce those silly mistakes, because the most common cause of mistake in your examination is not your mistake per se or your lack of awareness about the question. The most common problem is the silly mistake. That is what we have to reduce, and that is why this computer-based offline test is continuously pushing you to reduce your silly mistake. I'll see you in upcoming class. Thank you very much.
Hi everyone. So let's start with the biochemistry section. So question number 1, which of the following vitamin is teratogenic in large doses? So guys, teratogenic vitamin is only one, and that is vitamin A. right? So no confusion in that. Direct question. Okay, so we must remember the teratogenic vitamin which are not safe in the pregnancy, and that is vitamin A. Should not be given after 1 month of conception. Okay, that can be toxic to the developing embryo and can cause various complications, especially the neurological. You know, the most of the complications are CNS complications. Okay, so what are the CNS complications it can cause? It can cause, like, you know, for example, spina bifida. Okay, one of the complications that it can cause. Then there are various other complications like, you know, absence of thymus gland, right? It can also cause that. Fine. So vitamin A is our answer. See guys, most of the fat soluble vitamins are toxic. Water soluble vitamins are non-toxic except vitamin niacin and B6. So B6 and niacin, these are the only two toxic vitamins, while in the fat soluble vitamin, most of the vitamins are toxic. Fatty acids used as a therapy in the management of hypertriglyceridemia. So guys, which fatty acid decreases the TG levels? The only one fatty acid which decreases TG level, that is omega-3. Okay, so just remember, like 3, omega-3 and TG. It has no effect on cholesterol or minor effect on cholesterol. So we must remember that omega-3 causes the decline or decrease in the TG, and that's why it is used in the management of hypertriglyceridemia. Okay, so remember this. Okay, omega-6, you know, has effect on the this cholesterol. It decreases the LDL and total cholesterol also. Olive oil is monounsaturated fatty acid. Guys, this is the only, you know, I would say, just to remember this, MUFA. So MUFA is found in both the mustard and olive oil, and MUFA has a very nice effect, that is, it can increase the HDL. So this is the only type of fat that is called as MUFA which can increase the HDL levels, good cholesterol levels, and the only fatty acid which decreases the TG level, that is omega-3. So these are unique in these terms, right? All of the following are true regarding the structure. So structure is of cholesterol, and guys, cholesterol is a structural component of membranes. Yes. Nerve conduction, so that is part of the myelin sheath. Kidney plays a role. No. So that is the answer, except they have asked. It is one of the component of plasma lipoproteins for sure. Which lipoprotein has a maximum cholesterol? That is LDL. LDL has the maximum cholesterol levels. Clear? If the content of adenine is 15%, what is the amount of the G in the DNA according to the Chargaff's rule? So guys, DNA is a double-stranded molecule. So A is given as 15%. So T is also 15% now. A binds with the T, and then G bind with the C. So 15, 15, 30. So remaining is 35 and 35, 70. Right? So the answer will be 35%. Got it? So I have to make it 100%. So 15, 15, 35, 35. So that's the answer. Very simple. Guys, remember, RNA don't follow the Chargaff's rule because most of the time RNA is single-stranded. Right? So RNA, if A is 15, that it's not necessary T will also be 15. So RNA is a single-stranded molecule in general. Though some viruses may have the double-stranded RNA, but you know, that is a case which will be mentioned in the MCQ. So if they mention this, that there is a double-stranded RNA, then you can apply this rule. But there will be uracil, not the thymine. A binds with U in the RNA, not the T. Which of the following prosthetic group or the coenzyme, you know, so will be involved in the reaction highlighted. So this is the highlighted reaction, succinyl-CoA plus glycine. So guys, this is making ALA. So the name of enzyme is ALA synthase. That is a rate limiting enzyme of heme synthesis. कौन सा? Heme synthesis. तो इसमें होता है B6. Vitamin B6 is the correct answer. Okay. So guys, vitamin B6 is required for heme synthesis, and that is why vitamin B6 deficiency can lead to microcytic anemia. Got it? Microcytic anemia. जो iron deficiency type of anemia होता है वैसा. Long chain fatty acid is transported into the inner mitochondrial membrane by. So the answer for this question is acyl carnitine. Guys, acyl carnitine is something which is required for the transport of fatty acids to the mitochondria. Okay, transport of fatty acids to the mitochondria. And guys, carnitine is a dipeptide, right? It is dipeptide made of lysine plus the methionine. Okay, lysine plus methionine. Okay, so that is called as carnitine. match the physical finding with the corresponding lipid profile. Options are being hidden because of some problem here, right? So don't worry. So the question is showing us the orange tonsils, right? As you can see, these are orange tonsils. So guys, orange tonsils occurs in which disease? What's the name of the disease? Tanger's disease. Okay, so name of the disease is definitely, we know, the Tanger's disease. And in the Tanger's disease, the HDL levels are low, that is less than 10. So the answer will be HDL low, right? This will be the answer, not, it's hidden here, but you know the options already. Okay guys, so that is your Tanger's disease. Also, in this case guys, this is a LCAT deficiency and the fish eye disease. As you can see, right, there is a, what I can say, the periphery is being, you know, blurred, right? What I can say, clouded. So that is fish eye disease, and that is because of LCAT enzyme deficiency. Again, the HDL will be low. Clear? So guys, this is a question in which the point that we can understand here is that distinct acetone order from her breath. Okay. So the patient was admitted in the emergency and has an acetone order from the breath. So that is a case of diabetic ketoacidosis probably. So what they are asking is, already the sugar is high, so it's a case of diabetes for sure. Which of the following test is employed to detect the ketone bodies in the urine? So guys, for the urine, we have Rothera's test, right? Rothera's test identifies acetone and acetoacetate, but not the beta hydroxybutyrate. Okay, so this is not for beta hydroxybutyrate. So beta hydroxybutyrate is not identified by Rothera's. So for that, you have to check for the blood BHB. So if they ask you that what is the best test, it's not Rothera's. In a case of diabetic ketoacidosis, what is the best test? So I will answer any test jahan pe option hoga. So I will answer blood BHB levels. Okay, blood BHB levels. Fine. So that will be the answer. Okay, HMP shunt is the only source of. So guys, the word only is important here. So don't mark NADPH, because for NADPH I have three sources. One is HMP shunt, then second is the malic enzyme, okay, malic enzyme, and third is cytosolic isocitrate dehydrogenase. That is cytoplasmic, not in the mitochondria of Krebs cycle. So isocitrate dehydrogenase, वो cytoplasm वाला, वो जो not part of Krebs cycle है. Malic enzyme, right? So ये HMP तो है ही है, तो तीन source हो गए हमारे पास. तो guys, answer is ribose 5-phosphate, because we don't have any source of pantose sugars apart from this HMP shunt. So that's why this question is not that direct. It is tricky, and don't jump to the answer कि भाई NADPH है, right? Okay. Which of the following amino acid is non-toxic transport form of ammonia from brain to the liver? So guys, the question is repeated, non-toxic transport form of ammonia, very common question, and the answer is glutamine, right? Just remember, glutamine is carrier of ammonia in the blood. Carrier of ammonia in the blood कौन सा है? Glutamine. Okay, fine, right guys? ऐसे याद रखो कि the ammonia has been glued, right, in the glutamine. So glutamine is, the bound form of ammonia, right? Free form तो toxic होता है ना, that is a bound form of ammonia. 65-year-old man complains of the chest pain, and so it's a case of like heart attack, right? Myocardial infarction. Which of the following isoenzymes? So guys, answer isoenzyme specific to the heart or myocardium is CKMB. Guys, normally CKMB levels are very low. They are just 3 to 5% of CK total. तो एक हमारे पास वर्ड होता है CK total. टोटल में ये दोनों आता है, ऑप्शन ए और बी, इनको बोलते हैं हम टोटल. तो CK total जो होता है उसमें सिर्फ 3% ऑफ CKMB होता है, तो दैट इज नॉर्मल. ओके, तो जब हम टेस्ट करते हैं तो हमें टोटल वैल्यू लेनी होती है. तो अगर टोटल का CKMB का जो वैल्यू है वो 3% ही है ना, मान लो 100 था टोटल और ये 3 आया, तो MI नहीं है. बट अगर मान लो ये 100 था और अगर मैं उसको बोल दूं 15 to 30% करीब करीब, राइट, तो एवरेज चलता है मान लो 25%, ऐसे याद रखो 25%. तो अगर इसकी वैल्यू 25 आ गई है ना CKMB की, तो MI है. ये एग्जांपल दे रहा हूं सिर्फ आपको ना, वैल्यू विल बी डिफरेंट ऑब्वियसली इन द लैब. 100% का 25% बस. तो 25% के करीब आ रहा है, तो दैट इज अ केस ऑफ मायोकार्डियल इन्फार्क्शन. ओके. A 3-day-old infant was brought to the emergency room by the mother. So guys, ये question है जो बहुत simple है, because there is a smell, right, which is detected to be the burnt sugar odor from the baby's diaper, right? So it's a case of maple syrup urine disease. है ना, बस क्लिक होना चाहिए आंसर शुड बी क्लिक्ड कि यार ये ऑर्डर तो ये आंसर है ना, हमें फालतू चीजें पढ़नी ही नहीं है, हमें डिस्ट्रैक्ट होना ही नहीं है, बस बर्न शुगर ऑर्डर मतलब ओनली चांसेस मेपल सिरप यूरिन डिजीज. व्हाट इज द नेम ऑफ एंजाइम इन द मेपल सिरप यूरिन डिजीज? अल्फा ब्रांच चेन अमाइनो एसिड अल्फा केजी dehydrogenase, alpha keto dehydrogenase, right? Okay, so branch chain amino acid alpha keto dehydrogenase enzyme, and this enzyme is dependent on thiamine. Guys, I told you that PDH जैसा ही enzyme होता है ये, PDH भी thiamine पे dependent होता है ना, pyruvate dehydrogenase, same is like this. So BCAA alpha kg dehydrogenase. So answer is vitamin B1. Okay. So question is, in this clinical scenario, which of the following is required cofactor of the deficient enzyme? तो indirect question है, clinical बना के, thiamine is a simple answer. ठीक है. तो guys, enzyme देखो, विटामिन का हमें clinical पता होना चाहिए, but we should also know that इस विटामिन का actual cofactor role क्या है, वो भी पता होना चाहिए मुझे, right? Identify the transporter A. तो guys, ये फ्रक्टोज को अंदर लेके जा रहा है in the intestinal cell. ये एंटेरोसाइट है, ये ब्लड है ना, ये ल्यूमन है. तो गाइज ये तो GLUT5 हो गया फॉर श्योर. और देखो, अगर वो पूछता आपसे कि भाई ये C कौन सा हो सकता है, तो ये हो सकता है GLUT2, क्योंकि सारी शुगर GLUT2 के थ्रू ब्लड में जाती है ना. ये आपसे कोई पूछे B क्या हो सकता है, तो गाइज B बोल सकते हैं SGLT हो सकता है ये. ओके, सो दैट्स ऑल. सो फ्रक्टोज ट्रांसपोर्टर कौन सा है? नंबर 5, दैट इज GLUT5. विच ऑफ द फॉलोइंग इज अ फंक्शनल प्लाज्मा एंजाइम? तो गाइस देखो, जो एंजाइम्स होते हैं वो ब्लड में, एंजाइम्स व्हिच आर प्रेजेंट इन द ब्लड, दे हैव अ सबस्ट्रेट इन द ब्लड. यू गेटिंग अ पॉइंट? फंक्शनल प्लाज्मा एंजाइम मींस द सबस्ट्रेट इज फाउंड इन द ब्लड. ओके, so that is called as a functional plasma enzyme. So out of all the option, guys, the only enzyme which has a substrate in the blood is prothrombin. Guys, prothrombin is just not a protein. कि आप सोचो कि यार ये तो कोएगुलेशन फैक्टर है, तो इट्स ए प्रोटीन, इट्स एंजाइम, राइट? सीरीन प्रोटीज ग्रुप का एंजाइम है ये, है ना. तो जो ब्लड कोएगुलेशन फैक्टर्स होते हैं, दे बिलोंग टू ए ग्रुप ऑफ एंजाइम दैट इज कॉल्ड एज सीरीन प्रोटीएज. ओके, सीरीन प्रोटीएज इज द name. You got my point? So that is called as a prothrombin. So guys, blood coagulation factors. Then what else? Others are, guys, बाकी सारे हैं जो ये, these are non-functional plasma enzymes. So these are used in some diagnostics. जैसे CK is used in muscle disease. जैसे अभी हमने पिछले क्वेश्चन में देखा CKMB, heart disease. Lipase is for like pancreatitis. So ये pancreas में होता है, not in the blood. ये है functional in the blood. That is functional plasma enzyme. What are the examples? जैसे कि एक और example हमें याद रखना है. What is that example? That example is very important name that is called as lipoprotein lipase. Okay, that is very important name. Okay, not the hormone sensitive lipase, lipoprotein lipase. Okay, so that's the name that we should know. During prolonged starvation, the brain depends on, simple, that is answer is ketone bodies. So option number C. Okay, prolonged starvation, guys, especially remember that after 72 hours, okay, the brain is able to, so when equal to 72 hours ho jayenge, 3 days, so the brain is able to use the ketone bodies. Okay, fine. 15-year-old male presented with the complaints of pain during urination and decreased urination. He also complained of pain in the lumbar region. X-ray, KUB, renal stones are seen. Okay, amino acid expected excreted in the urine, right? So guys, this is the image shown, which is a hexagon, right? As we can see, hexagonal crystals are found in cystine urea. They are made up of cystine. Again, I'm repeating, cysteine is different. Cysteine is a amino acid. Cystine is the two cysteine together. When I take two cysteine and bound them with the sulfur, that is two sulfur actually, disulfide bond, so that is called as cystine. Okay, so cystine urea it is, not cysteine urea. So cysteine will be there, ornithine will be there, arginine will be there, all of the above actually. So which of the following amino acid expected to be excreted? Okay, my answer will be changed now. All of the above, because COLA appears in the urine: cysteine, ornithine, lysine and arginine. Right? Cysteine, ornithine, lysine and arginine. So these are the 4 amino acids which will appear in the urine. You got my point? Okay, fine. So guys, that's it. These are the questions. So I wish you all the best again. Keep revising, do your best, make it your last chance to, pass the exams, right? Be motivated and disciplined, most importantly. Make a discipline, keep your, study hours of minimum of 10 to 12 hours per day, right? Without any distraction. It's like last few days remaining. Bye-bye guys. All the best.
Hi students, I hope you had a good CBoT. So let us see what are the questions which were asked from anesthesia, very expected question right from the app if you have done the app properly. So the first question, which of the following best describes grade 3 Mallampati score in assessment of airway visibility? So it's a question on Mallampati scoring. Okay, now Mallampati scoring, one of the most common topic which are being asked in exam, right? So options are soft and hard palate and base of uvula is visible. Tonsillar pillars, uvula, soft, hard palate visible. Uvula, soft, hard palate visible. And D is soft palate non visible at all. So grade 3 Mallampati is what we need to know, what corresponds to grade 3 Mallampati. So what is Mallampati? Now Mallampati score is pre-anesthetic scoring system to assess difficulty in intubation. So it's a pre-anesthetic score to assess difficulty in intubation, right? Okay. So we have 4 grades of Mallampati, 1, 2, 3 and 4. See, 1, 2, 3 was originally given by Sheshnagri Mallampati. Grade 4 was later on introduced by Samson and Young. So it's called modified Mallampati scoring. So 4 grades are modified Mallampati scoring. How do we do Mallampati scoring? We ask the patient to open his mouth, take the tongue out, and do not vocalize. And then we see the structures of oral cavity. By seeing the structures of oral cavity, we are assessing the size of tongue. If tongue would be big, it would obscure the or structures of oral cavity and we'll get an idea the tongue is big, and during laryngoscopy it may not go out of our way and give us a clear visualization of epiglottis and glottic opening. So it will make our intubation difficult. So grade 1, 2, 3, 4 and grade 1, that's in grade 1 most of the oral structure is seen easily. So it's hard palate or soft palate or your base of uvula, your uvula or your tonsillar pillars or your fauces. Everything is visible. Grade 2, now most of the things are visible. One, fauces may be not visible or tonsillar pillars may not be visible. Grade 3, hard palate and soft palate visible and the base of uvula, but not the tip of uvula is visible. And grade 3, 4, only hard palate. Only hard palate is visible. So what does corresponds to it? Soft and hard palate visible and base of uvula is visible. Well, this corresponds to grade 3. Tonsillar pillars, uvula, soft palate, hard palate is visible. This corresponds to grade 1 or 2. Uvula, soft and hard palate only visible. Uvula, hard palate, soft palate, these 3 are visible. Uvula, hard palate, soft palate, right, are visible. So this could be grade 2. Okay. Soft palate not visible at all. Then this would be grade 4. So grade 3 is soft and hard palate and base of uvula visible. Okay. Grade 1 or 2, why I have written this? Because they have not mentioned fauces. If tonsillar pillar and fauces both are visible, it would be definitely grade 1. If any of the structure is missing, it will be grade 2. Or maybe in grade 2, these 3 structures are clearly visible. Okay. Okay. Now coming on the next question. A 57-year-old patient undergoing surgery administered neuromuscular blocking agent to facilitate endotracheal intubation and muscle relaxation. Which of the following neuromuscular blocker is primarily eliminated by Hoffman degradation? So this is a question on the metabolism of neuromuscular blocker. I told you the rule. Then most of the neuromuscular blocker metabolized by liver and kidney, right? Only some of the benzyl isoquinolines, atracurium, cisatracurium, atra and cisatracurium. These are metabolized by Hoffman degradation, which is non-enzymatic, time-dependent self-degradation of drug. And mevacurium of this group only, benzyl, it is metabolized by pseudocholinesterase. So these two have a unique metabolism, right? Especially your atra and cisatracurium, which has non-organ elimination. So this is very, very advantageous for us in patient with pre-existing liver and kidney dysfunction. Okay, so answer is your atracurium. If atra was not in the option, cisatra would have been the answer if it would have been in the option. Okay, so both atracurium, cisatracurium metabolized by Hoffman degradation, right? So remember about atracurium and cisatracurium. Both undergo organ independent metabolism. So they are agent of choice in renal and hepatic dysfunction, right? And they are agent of choice in children because their liver and kidney is immature. And they are agent of choice in old patients since their liver and kidney is deranged. Okay, so this is about atra and cisatracurium. Now, third question. A 5-year-old child is scheduled for surgery requiring anesthetic induction. Considering child's age and advantage of smooth and rapid onset, which anesthetic would be preferred for pediatric inhalation and induction? So, we are asking a simple question. Inhalational induction agent of choice with minimal respiratory irritation, I would write no respiratory irritation. Induction agent, I told you, if you see this word for inhalational, what should be the answer? Sevoflurane, nothing else. Sevoflurane. So answer has to be sevoflurane. This is the best inhalational for induction. Best for induction. Now, the second best for induction after sevo, halothane. This is also sweet smell and good for induction, can be used. But what is best for induction? Sevoflurane. This is best for induction. Desflurane not used for induction, isoflurane not used for induction. And sometimes we even intubate the child under inhalational anesthetic agent, right? We just deepen the child and put the tube also when we don't want to give neuromuscular blocker in case of any suspicion of difficult airway. Okay, so answer has to be sevoflurane. Okay, now next question. A 32-year-old patient presents with severe uncontrolled asthma and a recent history of stroke. Despite the patient's young age, the medical condition significantly impact his daily activities. What would be the right ASA classification for this patient? Well, significantly impact his daily activity. Severe uncontrolled asthma, recent history of stroke, all put him in the criteria of ASA grade 4, right? Well, ASA grade 1, no comorbidity. ASA grade 2, mild to moderate comorbidity, which is affecting the strenuous activity. I mean, which is to very little affecting the strenuous activity, but the person can perform. ASA grade 3, moderate to severe comorbidity, right? Moderate to severe comorbidity. But the patient can perform his normal day-to-day activity, right? On strenuous activity, the person becomes symptomatic. And ASA grade 4 is the comorbidity with a significant risk on the life, and patient cannot perform his daily activity. Here there is a significant impact on his daily activity. Answer has to be ASA grade 4. And what is ASA grade 5? ASA grade 5 is surgery is only option for survival. Okay, so 5 is surgery is only option for survival, and 6 is the brain dead patient. So we have to be very familiar with ASA grading, very important from exam point of view. Needle shown in the image is used for. So this is image based question, and question is, what is this needle used for? I told you when I discussed in my clinical video on the needles, that spinal needle there will be no marking on it. Epidural needle, there would be 1 centimeter marking on it. So this is an epidural needle. There is marking on it, 1 centimeter marking on it, because we need to identify the distance of the epidural space from the skin, because we have to put a catheter. So this is a 2-His needle. 2-His needle, most commonly used for epidural anesthesia. Okay. Now coming on the last question. A 63-year-old patient with COPD presents with mild hypoxia. Mild hypoxia. Which of the following oxygen delivery device is most suitable to provide low flow supplemental oxygen? So low flow supplemental oxygen, well, low flow. But the question is, the patient is COPD and has mild hypoxia. We don't want to give over oxygen to COPD patient. We need to give controlled oxygenation. So though low flow is required in this patient, we will go for the Venturi mask with low flow setting. Venturi mask, we have different color coding in which we have to keep different flow. So even we can give low flow through it, and even we can give high flow. Though it is a fixed high flow, fixed FiO2 delivering device, green one gives highest flow of 60 liter up to 60 liter, but the white one, the yellow one, they give the less flow, and we can fix the FiO2 with it. So for COPD patient, always I would prefer Venturi mask. So I would always prefer this. Question was just an intent to little confuse you that if I am given low flow, then can never answer Venturi mask? Yes, we can. Venturi mask has options. It has color coding Venturi barrels in which we can vary the flow, right? We can give a fixed flow, right? And fixed FiO2. So Venturi mask. For COPD, always remember that we need to give oxygen supplementation by Venturi mask. Okay. The number of students may have got confused that we should use nasal cannula. Well, we can use nasal cannula also, but the issue with nasal cannula is that the FiO2 can vary, and maybe if a high FiO2 will be delivered, the respiratory drive in the COPD patient will be affected. So in COPD patient particularly, we go for Venturi mask. That's the best device for COPD patient. Okay. So these were the questions which were asked. I hope you have answered the question well. Thank you so much.
हेलो फ्रेंड्स, कैसा रहा आज का एग्जाम? I am Dr. Anupama Chaudhary Devgan, आपकी physiology faculty, and I will be discussing the physiology questions. So let's see the first question. Now this says कि what happens when the Golgi tendon organs are activated during the inverse stretch reflex? Now what is the Golgi tendon organ? Golgi tendon organ is a receptor for muscle tension. जब भी मसल में टेंशन बढ़ता है, फॉर एग्जाम्पल व्हेन यू आर ट्राइंग टू लिफ्ट अ वेरी हैवी वेट, the Golgi tendon organ will be stimulated, and what is the reflex response which is set up? The reflex response is a muscle relaxation, right? So Golgi tendon organ is responsible for what is known as the inverse stretch reflex. इसका एक बार let's have a look at what is the pathway of the inverse stretch reflex. Now let's say this is a muscle here. Whenever there is an increase in muscle tension, the receptor which is going to be activated is the Golgi tendon organ, और Golgi tendon organ से जो sensory fiber है वो है 1B, and this enters into the spinal cord. This 1B fiber, this carries impulses into the spinal cord, and this fiber synapses with an inhibitory interneuron. Or ye inhibitory interneuron will now inhibit the A-alpha motor neuron to the same muscle. 1B fiber excites an inhibitory interneuron, or ye inhibitory interneuron will now inhibit the A-alpha motor neuron to the same muscle. तो muscle का response क्या होगा? Muscle relaxation. So let's see this once again. What is the stimulus for the inverse stretch reflex? Stimulus is an increase in muscle tension. What is the receptor for the inverse stretch reflex? This is the Golgi tendon organ. What are the afferent or the sensory fibers of the inverse stretch reflex? This is 1B. What is the center for the inverse stretch reflex? The center is the spinal cord. And what are the efferent or the motor fibers of the inverse stretch reflex? These are A alpha. And what is the response? Response is a muscle relaxation. और कितने synapses हैं इस inverse stretch reflex में? ये एक bisynaptic reflex है. This is a bisynaptic reflex. So ये हो गया आपका inverse stretch reflex. And the answer to this question is muscle relaxation. Let's have a look at the next question. Which of the following conveys information regarding fine, well-localized touch and position sense? This is carried by the dorsal column. Anterior spinothalamic tract will carry crude touch, itch, tickle, sexual sensations, as well as barognosis. Lateral spinothalamic, what is barognosis? Barognosis is detection of pressure. Baro, pressure, gnosis, detection. Lateral spinothalamic tract is meant for pain and temperature. And what is the dorsal column or the posterior column meant for? This carries fine touch, localization, 2-point discrimination, conscious proprioception. Proprioception किसे कहते हैं? Position sense को. Conscious proprioception is carried by the posterior column, unconscious proprioception by spinocerebellar tracts. Then vibration and stereognosis. Stereognosis क्या होता है? Stereognosis is the ability to identify an object from its size and shape. That is known as stereognosis. This is also carried by the posterior column. What about the lateral corticospinal tract? Lateral corticospinal tract is a motor tract, and this is meant for fine skilled movements. So ये हो गए आपके different tracts, and what do they carry? Answer to this question, dorsal column. Let's look at the next question. Which of the following is synthesized by the zona fasciculata of the adrenal cortex? Adrenal cortex has got a zona glomerulosa, and zona glomerulosa synthesizes aldosterone. The largest zone is the zona fasciculata. Zona fasciculata synthesizes mainly glucocorticoids, but also androgens. And the zona reticularis secretes androgens mainly, and also glucocorticoids. So that means, what is the answer to this question? Fasciculata will synthesize which of the following? That is going to be mainly glucocorticoids, or in other words, cortisol. Aldosterone, zona glomerulosa, androstenedione, which is an androgen, will be mainly by the zona reticularis. Let's see the next question. A neurologist performs an EEG in a 33-year-old patient. He observes rhythmic electrical activity of a frequency of 8 to 12 Hz, predominantly in the occipital region when the patient is awake but relaxed with eyes closed. Which of the following is the most likely wave pattern observed in this patient? Patient is awake with eyes closed, relaxed hai or eyes closed hai. So in this situation, the wave which is going to be recorded is the alpha wave, or alpha wave ki jo frequency hai, this is 8 to 12 Hz. When do we record the alpha wave? When the patient or the person is awake, eyes closed, mind wandering. Now, to remember what is the frequency of the different EEG waves, remember D tab. So as you go from delta to beta, there is a decrease in the amplitude and an increase in the frequency. So that means delta is the largest amplitude wave and beta is the smallest amplitude wave. Delta has the least frequency, beta has the maximum frequency. And to remember the frequencies, remember 4 1s are 4, 4 2s are 8, 4 3s are 12, and 4 4s are 30, not 16. Just to remember the frequencies. Now, delta has a frequency of less than 4 hertz, which is 1 to 3 hertz. Theta has a frequency of 4 to 7 hertz. Alpha will have a frequency of 8 to 12 hertz, and beta has a frequency of 13 to 30 hertz. So please understand, when a person is awake, at rest, eyes closed, mind wandering, the EEG wave which is going to be recorded is the alpha. As soon as you ask him to open his eyes, now the alpha will be replaced by beta. And what is the frequency of beta? 13 to 30 hertz. Very low amplitude, high frequency waves. The moment he opens his eyes, alpha waves disappear and the waves which are now going to be recorded are beta. This alpha getting replaced by beta, this is known as arousal or what is known as alpha block. Let's look at the next question. All of the following occur as a result of increased parasympathetic activity except decreased heart rate? Yes. Lacrimal gland secretion? Yes. Gallbladder contraction? Yes. Mydriasis? No. Parasympathetic stimulation causes meiosis, not mydriasis. Dilatation of the pupil. What is mydriasis? This is dilatation of the pupil. Right? This is sympathetic activity. This is seen whenever there is an increased sympathetic discharge. Right? Increased sympathetic discharge will cause dilatation of the pupil or mydriasis. है ना? वो जब कहते हैं कि जैसे आपने, let me try and explain this to you. I don't know if you remember whenever we read comics, है ना? तो उसमें क्या होता था कि whenever a person met someone whom they liked, आंखों में stars बनाते थे, है ना? वो comic book में, or in other words, उनकी आंखें चमकने लगती थी, right? What was that? When he or she meets someone they like, there is increased sympathetic discharge. और sympathetic discharge से pupils dilate कर जाते हैं, तो एक आंखों में चमक आ जाती है. So that mydriasis is a sympathetic function, not a parasympathetic function, right? So answer to this question is B. Let's look at the next question. Match the following with the correct definition. What is autocrine? Now, autocrine is when whatever substance is secreted by the cell, it acts on receptors which are located on the same cell. So that is autocrine. Next is juxtacrine. J in juxtacrine, J in adjacent. Secretion of a cell acts on a receptor which is on a neighboring cell, adjacent cell. So that is juxtacrine. What is paracrine? Paracrine means the substance which is secreted by a cell will act on a target cell which is in the vicinity, nearby. That is known as paracrine. And what is endocrine? Whatever substance is secreted by a cell travels via the blood to act on a target cell which is at a considerable distance from the secreting cell. So that means, what is the answer here? A will be 4, B is Adjacent cell, B is 3, A4, B3, C is 2. It acts on a cell in the vicinity, and D is 1. Endocrine means that the secretion of the cell will travel via the blood to act on a target cell which is at a different site. So, आपका answer हो गया. Substance secreted by a cell acting on the same cell is autocrine. Substance secreted by a cell acting on an adjacent cell, J, juxtacrine. Substance secreted by a cell acting on a cell in the neighborhood, in the vicinity, this is paracrine. Substance secreted by a cell traveling via the blood to act on a target cell which is at a different site, this is known as endocrine. So my answer to this question is C. Let's look at the next question. External pressure affects transmission of nerve impulses in which fiber first? A fibers are the most susceptible to pressure, followed by B, followed by C. And out of the A fibers, it is the A alpha fiber which is most susceptible to pressure. And A alpha fibers we know are the motor fibers, motor neurons. And very commonly, you must have heard of something known as Saturday night palsy. So what happens in Saturday night palsy? Saturday night is usually a night of partying. है ना? ये individual बहुत party करके आता है, probably is drunk, comes home, sleeps with his arm under his head or over a chair, and when he gets up, there is palsy of the affected site. क्योंकि A neurons, A alpha neurons, which are the motor neurons, these are most susceptible to pressure. Let's see the next one. Tight junctions are seen between the intestinal epithelial cells, PCT, and collecting ducts towards the luminal side. Which of the following proteins help in making tight junctions? Occludins, claudins, jams. तीनों ही tight junctions बनाते हैं. So answer to this question is D, all of the above. ये जो tight junctions हैं, they make what is known as the zonula occludens. और zonula occludens कहाँ पर होगा? Towards the luminal side or towards the basal side? This is towards the luminal side. For example, these are two intestinal epithelial cells. They have tight junctions towards the luminal side, and these tight junctions will form the zonula occludens. A 32-year-old man is brought to the hospital emergency after having severed a major artery in a motorcycle accident. He has lost almost 700 ml of blood. His blood pressure is 90/55. Which of the following set of changes will be expected in this patient in response to the hemorrhage? Whenever there is hemorrhage and a hypotension, there is going to be an increase in the sympathetic discharge. Fall in blood pressure, baroreceptor reflex will increase the sympathetic discharge. और अगर sympathetic discharge बढ़ेगा, what will happen to the heart rate? Increases. What will happen to the blood vessels? Blood vessels will constrict. Vasoconstriction होगी, और जब vasoconstriction होगी, उनका diameter कम हो जाएगा, and less the diameter, what will happen to the resistance? Increases. So there will also be an increase in the total peripheral resistance. Isn't it? This is a very common kind of a situation which you come across in the emergency. एक पेशेंट आया है, ब्लड लॉस लेके आया है, जब आप उसकी पल्स फील करते हैं तो पल्स इज लो वॉल्यूम एंड वेरी फास्ट, देयर इज अ टैकीकार्डिया. और अगर आप उसकी एक्सट्रेमिटीज को फील करेंगे, उसके हैंड्स एंड फीट आर कोल्ड. व्हाई? बिकॉज देयर इज अ पेरिफेरल vasoconstriction. There is increase in total peripheral resistance. There is less blood flowing to the extremities. So his extremities will feel cold. Which of the following statements is true regarding electrical changes occurring in the heart in hypokalemia? Tall tented T waves मुझे किस में मिलते हैं? In hyperkalemia. Arrhythmias. Arrhythmias are also seen are more common in hyperkalemia. heart stops in diastole. This also occurs in hyperkalemia, in severe hyperkalemia. Produces a hyperpolarization of the resting membrane potential in myocardial cells of the whole heart. This is true. In hypokalemia, whenever there is a decrease in the ECF potassium, there is now an increase in the concentration gradient for potassium between the inside and outside of the cells. है ना? जैसे आपको पता ही है कि inside potassium बहुत ज़्यादा होता है, 140 millimoles per liter, and outside potassium is less, 3.5 to 5 millimoles or milliequivalents per liter. If the ECF potassium is less than 3.5, so what will happen to the gradient for potassium between inside and outside the cells? Increases. Increase in concentration gradient for potassium means there is an increased tendency of potassium to move out of the cells. Right? Because please remember, the cell membrane at rest is almost freely permeable to potassium. So there is an increased tendency of potassium to move out of the cell. More potassium leaving the cell means what will happen to the inside? Inside becomes more negative. The resting membrane potential now will become more negative. In other words, the cell will be hyperpolarized. और जब cells hyperpolarized होते हैं तो उनकी excitability को क्या होता है? कम हो जाता है. Right? So this is what is going to be seen in hypokalemia. In hyperkalemia, on the other hand, there is increased excitability. Arrhythmias are commonly seen. Tall tented T waves are seen because of abnormal repolarization. But in severe hyperkalemia, there is the heart may stop in diastole. Next question. Which of the following is responsible for tachycardia during right atrial distension? Whenever there is a right atrial distension, this stimulates the atrial stretch receptors. Atrial stretch receptors are responsible for the Bainbridge reflex. And when the atrial stretch receptors are excited, they now cause a tachycardia. And how do they cause a tachycardia? They inhibit the vagal action on the SA node, and that in turn increases the heart rate. So answer to this question is Bainbridge reflex. Now, what happens in the Bijol-de-Jarisch reflex? This is also called the coronary chemo reflex. The Bijol-Jarisch reflex, whenever you inject substances such as serotonin, capsaicin, phenyl biguanides, or veratridine into the coronary arteries. Injection of these substances into the coronary arteries, this now causes a coronary chemo reflex, which is characterized by hypotension and a bradycardia. What happens in the Cushing's reflex? Cushing's reflex is whenever there is a raised ICP, it compresses the cerebral blood vessels. And whenever the cerebral blood vessels are compressed, it now causes what is known as a CNS ischemia. Whenever there is a CNS ischemia, there is now what is known as the CNS ischemic response. And what happens in the CNS ischemic response? There is a massive increase in the sympathetic discharge. If there is an increase in sympathetic discharge, it causes an increase in blood pressure. But now Whenever there is increase in blood pressure, the baroreceptor reflex will be triggered. And what is the response of the baroreceptor reflex? It causes a bradycardia. It causes a decrease in the heart rate, or a bradycardia. Right? So, in the Cushing's response also, what is the feature that you're going to see is a bradycardia. Now, this is also, you should be able to correlate this clinically, right? Whenever there is a patient of head injury, the first thing that you look for is the pulse rate. If there is a bradycardia, that means there is definitely some sort of an intracranial bleed. There must be a raised ICP. Bradycardia would mean a raised ICP. And this is the reflex response. Whenever there is raised ICP, compresses. What is ICP? Intracranial pressure. It compresses the cerebral blood vessels, causes a CNS ischemia. Whenever there is CNS ischemia, there is massive increase in sympathetic discharge, which causes increase in blood pressure. Then the baroreceptor reflex response causes a decrease in heart rate, or a bradycardia. What is the J receptor reflex? J stands for juxtacapillary receptors. In the J receptor reflex, in conditions such as pulmonary congestion, pulmonary embolism, or pulmonary edema, this will stimulate the J receptors. And the J receptors, when they are excited, they will result in a hypotension, bradycardia, and very importantly, they cause a rapid shallow ventilation. This is typically seen in J receptor response. So all these reflexes other than Bainbridge are causing a bradycardia. Bainbridge reflex causes a tachycardia. What is the lung volume at the end of a normal expiration? This is going to be functional residual capacity. Lung volume at the end of a maximum inspiration is total lung capacity. What is residual volume? This is the lung volume at the end of maximum expiration. And what is tidal volume? This is the volume of air inspired or expired during a normal quiet respiration. So the answer is D. Which nerve carries taste sensation from the majority of the tongue? From the anterior 2/3 of the tongue is going to be the 7th nerve. Majority of the tongue, the anterior 2/3 of the tongue is the 7th nerve, and from the posterior 1/3 will be the 9th nerve. So answer to this question is B. All of the following statements are true about stagnant hypoxia, except this is seen in cardiac failure. True. It increases the arteriovenous oxygen difference. This is also true. देखो arteriovenous oxygen difference क्या है? When blood enters into the arterial side of the capillary, the PO2 here is 95 millimeters. Saturation is 97 to 98%, and PCO2 is 40 millimeters of mercury. As blood flows through the capillary, CO2 moves from the tissues into the blood, and oxygen will move from the blood into the tissues. So that on the venous side of the capillary, PCO2 increases to 45 millimeters of mercury, PO2 decreases to 40, and saturation of hemoglobin also reduces to 75. So what is arteriovenous oxygen difference? 95 minus 40. That is your arteriovenous oxygen difference. अब stagnant hypoxia में क्या होगा? Stagnation of blood flow. Blood flow धीरे धीरे हो रहा है through the capillaries. So now there is more time for the oxygen to diffuse from the blood into the tissues. So what will happen to the arteriovenous oxygen difference? Increases. No peripheral chemoreceptors are stimulated. This is an incorrect observation. Peripheral chemoreceptor stimulation is seen in all types of hypoxia except anemic hypoxia. Carbon monoxide causes anemic hypoxia. This is true. So answer to this question becomes C. Peripheral chemoreceptor stimulation will be seen in stagnant hypoxia. It is seen in all types of hypoxia, hypoxic hypoxia, stagnant hypoxia, as well as in histotoxic hypoxia, but not in anemic hypoxia. Which of the following pair is correctly matched? Connexins are responsible for gap junctions. This is true. Claudin for desmosomes? No. Desmosomes are formed by cadherins, desmoglin, and desmocolin. So this is incorrect. Tight junctions are formed by occludins, claudins, and JAMs, junctional adhesion molecules. Adherence junctions are formed by cadherins. Adherence junctions. Cadherins में ही adhere है. So adherence junctions are formed by cadherins. So answer to this question is A. Next, which of the following occurs in Barter's syndrome? Now, Barter's syndrome is a hereditary disorder which affects the thick ascending limb, and there is defective sodium potassium chloride reabsorption in the thick ascending limb. What are the symptoms of Barter's syndrome? Symptoms of Barter's syndrome are similar to Lasix overuse. What is Lasix? It is a diuretic which affects the Na plus K plus Cl minus co-transport in the thick ascending limb. So symptoms of Barter's syndrome are similar to Lasix overuse. Which of the following causes the X descent in the JVP? Bulging of closed tricuspid valve into the right atrium during isovolumetric contraction is responsible for the C wave. Downward pull of the closed tricuspid valve into the right ventricle during ejection is responsible for the X descent. Venous filling of the right atrium just before opening of the tricuspid valve is responsible for the V wave, a positive wave. Flow of blood from the right atrium into the right ventricle during the first rapid filling phase is responsible for a negative wave, which is called the Y descent. Atrial contraction in the second rapid filling phase is responsible for the A wave of JVP. So these were the physiology questions in your CBoT. I'm giving you my email ID. So any questions that you might have related to today's test, please feel free to get in touch with me at dranupamadevgan@gmail.com. Thank you so much and all the best.
Hello dear friends, so let's start up the discussion of this particular CBoT, and obviously the questions are easy itself, and I suppose must have done all of them correct. And today, like, I will give you an insight along with that explanation. I will try to give you some extra information which can come in your exam. Okay, so let's start up without wasting time. What is the most probable diagnosis of this particular picture which comes in your mind? So guys, one thing is for sure, that there is a edema in this particular region, and this particular neck edema happens to be in two things. One is mumps and one is diphtheria. Okay, so neck edema is a complication in the case of diphtheria, and it happens in the mumps also, which presents with unilateral or bilateral parotitis. Okay, mostly bilateral. So obviously this was the repeat question of FMG itself. It already had come in the exam, and the answer is mumps. And if at all that diphtheria option is there in that, then it becomes a problem. But in that particular scenario, they will give you some hints also regarding it. Okay, so they will definitely add upon to the question that like this is having a Chinese letter pattern, this is having Albert staining and all that, green color and all that stuff. Is it fine? So all those particular things will also be there in the question along with this particular stuff. So basically guys, mumps is a favorite question of examiner. They do ask us. Most commonly it presents with bilateral parotitis more than the unilateral, and in the males it associates with unilateral orchitis as a complication, and in the females the oophorytis can happen of. It can happen in both in the childhood or in the young age also. Overall, the most common complication associated with mumps is aseptic meningitis. That also needs to be remembered. Besides that, you need to know that this hand-mouth disease, this is being done by what? Coxsackie virus. Okay, and Coxsackie virus, which one? A16. And yes, Coxsackie virus B also does it. Erythema infectiosum, you already know, that is having a slap cheek appearance, done by what? Parvo B19. Exanthum subitum, it's done by, also termed as Rosella infantum, and it is done by what? Human herpes virus 6 or 7. Okay, so this is termed as 6 disease. Now coming to the next one, a 5-year-old child presents with a slabbed cheek appearance, having a lacy reticular pattern rash on the extremities. See this particular statement, lacy reticular pattern rash on the extremities, and this is being asked that which is the causative agent. So guys, slab cheek appearance itself is a sufficient hint that we are talking about what? We are talking about the parvovirus infection of erythema infectiosum, and that is also termed as 5th disease. And basically it is having this slab cheek appearance, and on the basis of this only we have a mnemonic of ours that after this particular slab, apne ho gaye paraye. So parvovirus does this particular apne, and you know that what is there in the apne? A is aplastic crisis. Okay, A is what? Aplastic crisis. P is what? Pure red cell aplesia. This particular question of pure red cell aplesia was there in the exam twice last time. Along with that, P is polyarthralgia syndrome. Okay, this is polyarthralgia syndrome. And N is NIHF, and E is erythema infectiosum. Erythema infectiosum. Okay, so that is what is slab cheek appearance. So this should be clear that they will not be asking the same question again. They will be asking in and around that. So you should know this particular thing also. So aplastic crisis ought to happen in sickle cell anemic patients, and this is an important one. And parvo, this parvo is a single-stranded DNA virus, and it is non-enveloped. These questions are being asked, and they will be asked again and again. So you should know regarding them. Coming to the next one, multiple asymptomatic scaly patches varying in color from white to tan, brown to pink. On potassium hydroxide wet mount, we observed spaghetti and meatball appearance. So obviously you know that if it is written of spaghetti and meatball appearance, what we are talking about. So answer in this particular question is towards what? A more common causative organism for this disease. So everybody knows that furfur does it and globosa does it, but as per the recent data, this is what is more than this particular furfur. So answer should go in the favor of what? C, that is Malassezia globosa, which is the causative agent of Tinea versicolor or Pityriasis versicolor. And when you take up the scales and you put in 10% KOH, you observe this spaghetti and meatball appearance. Okay, so spaghetti and meatball appearance, everybody knows it, but they can ask you in other fashion also. What that fashion is? That the short hyphae with E cells. That is what is the feature observed of spaghetti and meatball. It looks like this noodles, and within that noodles you have what? These particular meatballs. Fine. So this is what it's termed as spaghetti and meatball appearance, and you culture it on the SDA. We have fried egg appearance, and along with that you observe that particular fluorescence also on this, that is the yellow one. Okay, so these are the important ones which can come in a way in your exam. And we already know that malassezia furfur is also one of the causative agents of it, and this is a super antigen also. And what is a super antigen? Which is non-MSC restricted, and this is non-MSC restricted, and it directly goes and activate the TCR, that is the T cell receptor. It binds on the V beta domain of it and activates more than 20% T lymphocytes. So malassezia furfur do act like that. This is the extra point. Rotatory motility. So you know guys, the motility question is important, and already we have discussed up that TDS falling, this particular mnemonic which is there for the motility, that is T is tumbling motility, D is darting motility, S is swarming motility, and the last one is falling leaf-like motility. The falling leaf-like motility. These are the four important ones which is there. And rotatory they have asked up here. So rotatory, first of all, if we discuss up, the answer is C, that is Balantidium coli, which is a ciliate. Another FMGE question of yours. This is a ciliate, and this is the largest intestinal protozoa. And the other one which can come is, it is having micro and macro nucleus. This is a unique feature of Balantidium coli, and this is the largest intestinal protozoa which you know. And this is having which motility, guys? Rotatory motility. Fine. So tumbling, if somebody asks you, because this is also important, the tumbling is observed in Listeria. Okay. Darting is observed in Vibrio cholerae, and Vibrio cholerae everybody knows, but now they can ask you Campylobacter jejuni. That is also having a darting motility. Swarming is obviously seen in what? Proteus, and the slow form of swarming is termed as in the Clostridium. Okay. And the falling leaf-like is observed in Giardia lamblia. The falling leaf-like is observed in what? Giardia lamblia. Falling, Giradia, Giardia. Fine. So this is also there. Along with that tumbling motility, you should know this thing also, that Listeria is one of the organisms which shows differential motility based on temperature. At 25, it is motile. At 37, it is non-motile. Remember that thing also. And which is the other one? Yersinia enterocolitica. What it mimics? It mimics appendicitis. So that also is important point to be remembered in this particular one. So we have already mentioned up, Vibrio shows what? That is a darting, which looks like a dart. Listeria, tumbling, so tumbles over like a drunkard. Balantidium coli, rotatory motility. Troponium pallidum is having corkscrew motility, and this is due to an endoflagella. This question can also come, that it is not due to the normal flagella, it is due to the endoflagella. This rotatory motility is observed. Fine. Now coming to this particular question, slight bit big one. Let's see. A company held an elaborate holiday dinner party for its employees within 3 to 4 weeks. 3 to 4 weeks. Many of the banquet attendees had complaints of experiencing fatigue. Okay, they had fever, nausea, dark urine, observed to be jaundiced. Fine. So that particular, the bilirubin levels are increased off. The group exhibited no bacterial infections in common. So this they have made clear in the question, that no bacterial infection in common is there. The employees who became ill had all eaten up the raw food at the party. Okay, they had eaten up the raw food at the party. The company doctor assayed a sample of the employees' blood for anti-hepatitis B antibodies, because you want to test upon by doing the ELISA that whether they have hepatitis B or not, because jaundice and all that stuff is there. But all samples, they came out to be negative for the anti-hepatitis B surface antigen immunoglobulins also. Okay. The causative agent consistent with this history most likely is. So obviously in this particular scenario, there is a feco-oral contamination which happened up, feco-oral transmission, and they have already checked upon for the hepatitis B that this is not there. So what likely can be there? That is hepatitis A. So answer is hepatitis A virus. This particular one is like tend to do up in the parties and all, the infection, because of any of the reasons of the like chef and all and anything. So that might be there. So hepatitis A virus answer seems more correct here in this particular question. Okay, and regarding hepatitis A virus, you know that when you want to diagnose it up, you can go for IgM NTHAV for the acute hepatitis A. And obviously you can culture it also, because this is only the hepatitis virus which can be cultured off, and this 3 to 4 weeks, this also goes in the favor of hepatitis A, because if you remember up my class, I told then the incubation period is how much? 15 to 50 days. 15 to 50 days. That is what is the incubation period of hepatitis A. Fine. Now coming to this one, the lady presented with a foul smelling greyish white discharge. So favorite question of yours, whiff test found to be positive. On examination, the following cells were seen as shown in the image given below. Identify the causative organism, drug of choice. So guys, these are the typical Gardnerella vaginalis which you observe, and over it, they are over a epithelial cell, and that is what is termed as clue cells. You tell them as what? You tell them as clue cells. So this is clue cells which is there, which is observed in this picture. And we are talking about which infection, guys? We are talking about Gardnerella vaginalis. That is a bacterial vaginosis, and the drug of choice for that is what? Metronidazole. And a similar one in the pregnancy also, which particular drug is used for bacterial vaginosis? The answer is metronidazole. And which criteria is followed up? Amsel's criteria. Okay. And if you remember up here, other thing also, like which is having a curdy white discharge, so that is Candida, which is having a greenish discharge along with greyish white also, along with the strawberry cervix and vagina, that is trichomoniasis. And for that also we use metronidazole. But that needs to be given to both the partners because that is an STD. Okay. Now coming to this, a 70-year-old male presents with fever, vomiting and neck rigidity. So obviously it features meningitis. The patient blood picture shows monocytosis. Okay, so this is a sufficient hint that they are talking about something, Listeria monocytogenes. Okay, the organism is cultivated from the CSF, gives a positive Anton test. This is a traditional test which you ought to know if you wants to tackle up some questions. So positive Anton test it is. Okay, and positive Anton test is what actually? You take the Listeria culture, you put in the eyes of the rabbit, and rabbit develops what? Keratoconjunctivitis. So that is there. Which the following statement is incorrect regarding that. So it is a cocoid. So it's a cocobacillus. Gram-negative bacillus. This statement itself is wrong because it is a gram-positive. Okay, cocobacillus. The most human infections, they are caused by serovar 2A and 2B. This is extra information which you can add upon. That most of the infections, they are done by what? 2A and 2B. Serovars of Listeria monocytogenes. It shows slow tumbling motility, yes. And the point to be added is, it also shows what? Differential motility based on temperature. So that is also important. It is catalase positive. And what is catalase reaction? It is also true. That is catalase positive, slow tumbling motility. And this statement is also true. What is catalase positivity? When you put 3% H2O2 on a slide and in that you put the Listeria culture, the bubbles come. So that is catalase positivity. Now, the Australian antigen hepatitis B virus, everybody knows the answer is HBsAg, and this is the one which comes at the earliest, and this is one of the markers for what? Acute hepatitis B. Okay, and the better marker for acute hepatitis B, you know, is what? IgM anti-HBc, and anti-HBc is what? That is the core. Against the core antigen, directly what comes? The IgM antibody. Okay, so this also needs to be remembered, that against the core antigen, what directly comes? That is the IgM. Fine. So this doesn't come in the circulation. This comes directly. After that comes in HBeAg, that is the pre-core one. Then against that the antibodies, and later on the IgG anti-HBc can also be determined of. And more than 6 months HBsAg positivity is termed as what? Chronic hepatitis B. So that you already know. Okay. Which of the following does Treeman syndrome? So guys, Treeman syndrome itself is a very important question, and it is being done by what? HPV 5 and 8. Okay, human papillomavirus 5 and 8, and human papillomavirus belongs to Papillomavirinae family, subfamily in fact, and Papovirinae is a family. And this particular human papillomavirus 5 and 8 does this Treeman syndrome, which is also termed as epidermodysplasia verruciformis. Epidermodysplasia verruciformis is the name of the Treeman syndrome, which you should know. Okay, so that is important. Other than that, the important ones are 6 and 11, which does genital warts and laryngeal warts also. 16, 18, 31, 33, they associate with what? Carcinoma cervix. And this carcinoma cervix itself tell you that there are certain regions like E6 and E7 which associates with loss of certain genes. E6 does loss of P53 gene, which is a tumor suppressor gene, and E7 cause loss of RB gene, which is also a tumor suppressor gene, and thereby these regions are responsible to cause cancers in the HPV. Okay, they are the ones because of which the cancer happens here, that is E6 and E7. Okay, because they are the reasons in the HPV which does the loss of these particular tumor suppressor genes, and that's why the tumor happens in these particular cases. One of the things is very clear. Other than that, the next question is by which you produce the vaccine of it. That is the L1, and that is the L1 capsid protein by which the vaccine of this human papillomavirus for the carcinoma cervix like Gardasil and Cervarix, they are being prepared up. Gardasil is a quadrivalent mostly. Now the 9-valent also have come, and Cervarix is bivalent, and that is against the 16 and 18. Fine. So that is also there. Then match the following diseases with their causative agents. That Q fever, you know guys, Q fever is done by Coxiella burnetii, and Coxiella burnetii used to be belonging to what? Rickettsial family. The cat scratch disease, everybody knows, Bartonella-Hansley. Okay, haste, the cat has scratched you, that is Bartonella-Hansley. Rat bite fever is done by Spirillum minus, and the Bill-Jensen disease is done by Rickettsia prowazekii, and this Rickettsia prowazekii does epidemic typhus, and the recrudescent form of epidemic typhus is only termed as what? Bill-Jensen disease. So the Q fever, first is A, okay, second is C. So answer is going in the fashion of B. So answer is first A, second C, third B, and fourth D. Fine. Now match the following E. coli types. The ETEC, that is enterotoxigenic E. coli. This particular one leads to traveler's diarrhea. In fact, the most common cause of that is there. Okay, so we can mix up with that. IEC is enteroinvasive, and this particular test is positive in that is termed as Sereni test. Enterohemorrhagic E. coli associates with hemolytic uremic syndrome, that you know, O157H7, which leads to this HUS in the children mostly. And the question comes like which toxin is there? Virotoxins 1 and 2, and that is the exotoxin of the E. coli. EPEC associates with pediatric diarrhea. So let's see what's the answer. The first one is B, okay, second one is A, third one is D, and fourth one is C. So answer is B, guys. Answer is B. And a definite question is there regarding the entero, like those which does the diarrhea, diarrhegenic E. coli, I should say in that way. Okay. The gram-negative bacilli releasing histamine to cause scombroid fish poisoning, they are all except which one does this scombroid fish poisoning. So one of them is Morgellella, guys. Then E. coli is also responsible. Protease is also responsible. The odd man out is Salmonella. So in this also the sequence is what, guys? The Morgellella, the number 1, which associates with scombroid fish poisoning. Then comes the Protease, and then comes the E. coli. Now you must be thinking that why this scombroid fish poisoning is important. So guys, this is important. Why? Because it releases histamine and serotonin, and because of that what happens? Vasodilatation and bronchoconstriction, and this leads to what? This leads to asthma like conditions, and this constriction can be fatal also. So that's why like anaphylaxis stuff. So that's why this particular fish poisoning needs to be monitored, and that's why it asked also. Okay. The child is presented with abdominal pain and rice watery stool. So obviously, guys, you know rice watery stool is a feature of which fellow? Vibrio cholerae, and the enrichment media for that is alkaline peptone water. So that you know. For the cell type broth, it is for the enrichment media for Salmonella and Shigella. Okay, Salmonella and Shigella, and the RCM. This particular RCM, Robertson cooked meat media. This particular one. You know that if the meat pieces turns pink, so we are talking about what? We are talking about sacrolytic stuff. Okay, that is they like hydrolyze up or they lyse up the saccharides, that is the carbohydrates, and if the meat pieces turns black, then they are utilizing the proteins. So that is termed as proteolytic. Then they are utilizing what? They are utilizing the proteins, then they turns black because of this protein utilization. So how to remember this particular one? Pink sari and black pants. And what does grow in them? So guys, obligate anaerobes, they grow into this, and obligate anaerobe typical example is what, guys? That is the Clostridium. Okay, so Clostridium is important entity which grows up in these particular Robertson cooked meat media, and turns out to be according to the color change, saccharolytic or proteolytic. So that also needs to know. BHI is brain heart infusion 1, and this is being used for what? This is being used for blood culture. Okay, alkaline peptide we already discussed up, that is for the enriched media for the Vibrio cholerae, and selenide broth is for Salmonella and Shigella. Important here is which is the best selective media for Vibrio cholerae, so that is TCBS. Thiosulfate, citrate, bile salt, sucrose. Which color media? Green color media changes to what? Yellow. Okay, why? Because of the sucrose fermentation. Now talking about this, all the following are true about the Bacillus anthracis or anthrax except the plasmid responsible for the toxin production, yes. The cutaneous anthrax generally resolves spontaneously, yes, it's a self-limiting disease. The capsular polypeptide aids in virulence by inhibiting the phagocytosis. That is also true because this is the only capsule which is made up of what? Polypeptide. Otherwise, mostly are what? Polysaccharides. The culture media is what? MIPA. And what is MIPA? Culture media is MIPA. What is MIPA? So that is mannitol deoxide polymyxin agar. This is what is the answer is, because what is being asked, except because this is not the culture media for Bacillus anthracis. This is a culture media for Bacillus cereus. Okay. I already told up also how to remember this. MIPA is a serious fellow. And what about the Bacillus anthracis culture media? That is PLET. Okay. So what is the culture media for Bacillus anthracis if somebody asks you? For the Bacillus anthracis, the answer is PLET. Okay. That's the answer. The answer is PLET. The fever with inguinal lymphadenopathy, that is buboes, after wheat go down visit, and Vasen staining itself is crying and telling that we are talking about Yersinia pestis, and it shows up a bipolar stained appearance or a safety pin appearance, and the organism we are talking about is what? Yersinia pestis. And what is the culture media for this? That is the ghee broth. Which type of growth happens to be there in it? Selectite type of growth. Okay. Along with this presentation, this is which plague? Bubonic plague. What is the drug of choice for this? Streptomycin. Okay, drug of choice is streptomycin. Now, which of the following is not a dimorphic fungi? So, this is very easy because we already have remembered up the various diseases which are dimorphic fungal diseases by this mnemonic HSBC. Please try. HSBC, please try is having what? This is H, that is histoplasmosis. S, that is sporotrichosis. B, that is blastomycosis. Okay. Then C, that is termed as coccidioidomycosis. P is termed as paracoccidioidomycosis, and T is termed as telaromycosis. Okay. So these are the names of the diseases, and the fungus which does them, they are here. The Telaromyces barnefi leads to telaromycosis. Histoplasma capsulatum leads to what? Histoplasmosis, Darling's disease. Blastomyces dermatitis leads to what? Blastomycosis. And Pneumocystis cerevisiae is not a dimorphic fungi. In fact, there is a controversy regarding it, whether it is a fungi or a protozoa, because it exists in the form of cyst and trophozoite. And trophozoite changes which color, guys? Green. And that particular cyst looks like what? This is having a crushed ping pong ball appearance. That also you know. Okay. Now, which of the following species of Candida is interestingly resistant to azoles? Okay. So, for that, you know that Candida krusei, what is being isolated from number of areas, and it's found to be intrinsically resistant to the various azoles. And we remember like this, cruises, they are resistant to holes, that is azoles. So, that's why what you need to use in this, liposomal amphotericin B, Candida krusei. It already had come in the INICET exam, it will come in your FMGE exam also. Fine. So, Candida krusei is intrinsically resistant to the azoles, and here the other important one is beta-1,3-glucan-SA. That is done for the CAP, that you need to know. And along with that, in the CAP, you have invasive candidiasis, invasive aspergillosis, and Pneumocystis cerevisiae. That is for the beta-1,3-glucan-SA. Fine. So, that is also one of the important things to be remembered. Now, talking about the bacteria with the appropriate culture media. The Salmonella typhi selective media, everybody knows that is the Wilson and Blair. Yes. Okay. We already remembered like this now. Like we have a jet black colonies on this, and the black jet is with whom? Black jet is with Salman. Okay. We remember like that. And in jet, that fellow goes to meet whom? Wilson and Blair. So like that we remembered in the class also, and now also you can remember for the exam. Bordetella pertussis, we have B for B, that is bordet ganju media, that is BG media, and having a bisected pearl appearance on this particular one. Okay. Then you have this particular one, chlamydia. Chlamydia does not grow on any culture media, grows on the cell lines, that is McCoy cell lines. And Mycobacterium TB, we know the LG media is there, but beyond LG also some other medias are there that are like Dorset egg media, okay, Pitragnini media, Du Bois media. These are also there. If at all they come, you should know that we are talking about whom medias? We are talking about the mycobacterial TB culture medias. Okay, so that is for the Dorset egg is also used to there. So what should be the answer? The first is B, the first is B, second is A, the third is D, and the fourth is C. The answer is B again in this particular one. So these types of questions, like in a single go, you could able to know 4 to 5 facts at one go. So these are very good type of questions. Fine. Now to this particular one, the growth rate of bacteria during the exponential phase of the growth. So you know now guys, this is the bacterial growth curve. This is the lag phase. A lag phase, what is increased? The size is increased. Log phase, what is increased? The number is increased. Then comes the stationary phase, and stationary phase is same for what? Sporulation, because they are seeing their death in the decline phase. And what is happening in the decline phase? There is a total accumulation of toxic metabolites, and because of that, this particular one dies off. Okay. So basically guys, what you need to know here is in the lag phase, there is an increase in size, in the log number, stationary, we have sporulation, and a decline, everybody dies. Now the question comes, the growth rate of the bacteria during exponential phase is what? Yes, increasing? No, answer is constant, because growth rate is to the power n. That is the exponential. Exponential growth is seen in this particular one. Rate is constant. Number increase, the rate is constant. So this way also the examiner can play with you in the exam. So growth rate is constant, but yes, if it comes in other ones, that the growth number, this increase in this particular one. Is it fine? So this is the way to tackle up the various questions. The topics and the important stuffs, they will remain same today. After 10 years also, they will be the same. Okay. Even if next comes and anything comes, these will be asked in an integrated fashion to you. And they already have started up asking up in the FMGE first exam in the integrated fashion. So you should have that scenario in your mind, and you should catch up some hint in that. And that particular catching of hint should be in your practice, so that you could not able to, like, you don't feel it's a tough question, I could not able to do it. Okay. So very best of luck from my side. And I know that you will fare wonderfully in your exam, and you all will pass. And do tell me up after passing up on my email ID drsp187@gmail.com your views. Okay. So thank you so much, and very best of luck from my side.
So, hello friends, welcome to the session of Obs Gynae FMG CBoT 3. I am Dr. Harmeet Goyal discussing the Obs Gynae questions. Hope you must have done the questions well. Now, question number 1 is, a 32-year-old woman shows up with a positive urine pregnancy test, 18 weeks of amenorrhea, and she has a history of ejecting the results of conception and is complaining of bleeding per vaginum. Fundal height as determined by abdominal examination corresponds to 14 weeks of pregnancy, and open internal os is seen during the vaginal examination. Which of the following describes it as most likely? So whatever may be the language of the question doesn't matter, but you have to get the clues. Okay. So number 1, she is pregnant because urine pregnancy test is positive, and the period of gestation according to the dates, period of gestation is 18 weeks, because it's written in the question 18 weeks amenorrhea, and there is history of bleeding per vaginum, bleeding present, and per abdomen the fundal height is corresponding to 14 weeks. Okay, that means on examination the fundal height is somewhat here. It should be at this level. Okay. So fundal height less than the period of gestation. Number 1, it is wrong dates. Number 2, it can be oligohydramnios or it can be IUGR, but IUGR usually develops in the 3rd trimester. Okay, so whatever may be the possibility, but one thing is, in the finding, you have to read the question carefully. In the findings, the cervical os is open and bleeding is present. Period of gestation is not corresponding with the fundal height. Okay, so period of gestation and the fundal height are not matching. Fundal height is less than the period of gestation. So what type of abortion it will be? Is it a missed abortion, complete abortion, inevitable abortion, or is it incomplete abortion? So how to differentiate between them? So it will be incomplete abortion. Why I am saying so? Because the cervical os is open and the fundal height is less than the period of gestation. That means some of the products must have expelled by the time you have done the examination of the patient. Maybe the period of gestation is given to us is 18 weeks, okay, but the fundal height is not matching with it and the cervical os is open, so it is more likely to be an incomplete abortion. Let us see in this diagram. In this diagram, what I am trying to explain is, suppose if the cervix is closed, no products are being felt and bleeding is present, but the fundal height is equal to period of gestation. In this case, it will be considered as threatened abortion and you have to get an ultrasound done to check for the cardiac activity. If cardiac activity is present, you can save this pregnancy by giving progesterone support. Okay. Number 2, if the cervix is open, products of conception felt but not expelled, bleeding per vaginum is present and size of the uterus is equal to period of gestation. In that case, it will be inevitable abortion, but this pregnancy cannot be saved. So the management will be D and E, dilatation and evacuation. Now let us see the third case. In the third case, the cervix is open, period of gestation, the fundal height is less than the period of gestation. In this case, cervix is open, bleeding is present and products of conception hanging out in vagina. Hanging out in vagina, fundal height is less than period of gestation. This will be incomplete abortion. So in our question, it will be incomplete abortion and the management for incomplete abortion and inevitable abortion is dilatation and evacuation using the ovum, forceps followed by a curettage. In case of complete abortion, the cervix is closed, bleeding may be stopped or it may be scanty and fundal height is less than the period of gestation because all the products have expelled. So we have to go for a conservative management. This is complete abortion and we have to go for a conservative management. Maybe if we feel there are some products or the fetal membranes left inside, then we can get an ultrasound done, and if there are any retained products, we can do DNC. If there are no retained products, we can just send the patient home. So this is threatened abortion where we can save the pregnancy, inevitable where we cannot save, incomplete where we have to do termination in the form of dilatation and evacuation, and complete where conservative management, nothing to be done. Now next is calculate expected date of delivery in a female with last menstrual period 27th of December 2020. Now is it 3rd of October, 3rd of September, 4th of October or 4th of September? So if we are given the last menstrual period of the female, that is 27 December, then we have to add 7 days plus 9 months to the last menstrual period, or we have to add 7 days and subtract 3 months from LMP. This formula is called as Neagley's formula to calculate the expected date of delivery. So expected date, if you add 7 in 27, it will be 4th. Now if you add 9 months, December, January, February, March, April, May, June, July, August, September, October, because it will be 4th of October 2021. Now how many percentage of pregnant ladies deliver on the expected date of delivery you gave? So remember, only 4% of the pregnant ladies deliver on the expected date of delivery that we give. Next, best fetal parameter to find out the period of gestation by ultrasound is crown rump length. In the first trimester also it is crown rump length. In the second trimester it is biparietal diameter. In the third trimester is femur length, abdominal circumference, different parameters. But most accurate will be the earliest ultrasound, and we measure the crown rump length. Now one more thing you remember, if we want to describe macrosomia or IUGR, which fetal parameter is considered the best? Okay, what is your answer? What do you think? It is abdominal circumference, single most answer. The best answer will be, it is the abdominal circumference for that particular period of gestation. Now, Niggles formula is to calculate expected date of delivery from first day of last menstrual period. Hadlock formula is to calculate the expected weight of the fetus on ultrasound. Johnson's formula is to find out expected weight of the fetus clinically. And Granham's classification is, this is by clinical method, and Hadlock formula is by ultrasound. And Granham's classification is for placental grading on ultrasound. So remember, Niggles formula, Hadlock formula, Johnson's formula, and Granham's classification. Next, a pregnant patient with heart problems is on warfarin. At what point will you switch over to heparin as advised? Which point of time you will switch over to heparin? Okay. So what is your answer? At the onset of labor, at 34 weeks, at 36 weeks, or at 40 weeks. So remember students, less than 12 weeks, that means as soon as the pregnancy is being diagnosed or before conception, if she is planning the pregnancy, we should switch over to heparin. That is subcutaneous injection. Okay, 5,000 units of subcutaneous injection, low molecular weight heparin. 12 to 36 weeks you can give warfarin. Why warfarin is contraindicated in first trimester? Because it is causing teratogenic effects. Now from 36 weeks to delivery, again heparin. Okay. Now heparin should be stopped, okay, within 6 hours of normal vaginal delivery and within 24 hours of cesarean section. After the cesarean section or the delivery, the heparin or the warfarin can be resumed. Breastfeeding is not a contraindication. Now why, important question is, why we are giving in the last month of pregnancy the heparin? Because it is seen that if the warfarin is being continued in the last month of pregnancy, the bleeding tendencies in the neonatal brain has been seen to increase. That is why in the last month of pregnancy we have to switch over to heparin. So this is again important. So heparin should be stopped shortly or 6 hours before birth and 24 hours before the cesarean section. Breastfeeding is not contraindicated if the patient is on heparin or warfarin. Now the maneuver shown in the image, you can see in this maneuver, there is a pregnant lady, she is been delivering and you see the head is delivered, okay, and the shoulders are stuck up. So this is a case of shoulder dystocia. That means this was not a booked case. The lady must have come in the active stage of labor, because had it been a macrosomia previously diagnosed or a good sized baby, we will do a planned cesarean section in view of CPD, in view of macrosomia, etc. So such situation occurs when a normal vaginal delivery occurs in an registered or unbooked patient. Okay, so the head of the baby is delivered and the shoulders are stuck up, and you see the nurse is applying a suprapubic pressure. Okay, and the legs of the lady are being flexed and abducted. So this maneuver is called as the Mac-Roberts maneuver. The Rubin's maneuver and the Wood's corkscrew are also done in cases of shoulder dystocia. It is possible to utilize the suprapubic pressure. Yes, this is true. But which pressure is contraindicated is fundal pressure. You must have seen in the labor room, the ward ladies or nurses sometimes apply the fundal pressure to facilitate the delivery of a baby. You can do it in any other case when it is, uneventful pregnancy. That means there was no complications during pregnancy, but never in case of shoulder dystocia, because the neck of the baby has got stuck up, the shoulders are stuck up. So it will cause immediate death if you do a fundal pressure in this case. Now, most likely, which nerve can be damaged in Mac-Roberts maneuver? The answer is lateral cutaneous nerve of thigh. Both these are important AIMS PG questions as well. Okay, so which maneuver or which pressure is not being applied in Mac-Roberts maneuver? Answer is fundal pressure is contraindicated, but you can apply suprapubic pressure. And which is nerve most likely to be injured if Mac-Roberts maneuver is being done? So answer is lateral cutaneous nerve of thigh. Next, what is the complication of this kind of placenta if found in the lower segment of the uterus? You can see the umbilical cord is getting attached. The umbilical cord is getting attached to the fetal membranes. So what happens when the fetal head or the presenting part descends down, okay, or there is compression, or during the process of delivery? What will happen? There will be laceration of these membranes as the blood vessels are not, as the umbilical cord blood vessels are not covered with Wharton's jelly. So what is this condition where it can lead to antepartum hemorrhage? The condition is called as vasa previa. The condition is called as vasa previa, and the type of placenta shown in this image is filamentous insertion of placenta. Filamentous insertion of placenta, and the complication it likely to cause is vasa previa, which is a type of antepartum hemorrhage, and the problem is it is a fetal blood. So in these situations, if the baby is born, in such cases mortality is very high, because baby will be born very pale and baby may die of hypoxia. So these vessels are exposed as they are not covered with Wharton's jelly, and this is filamentous insertion of the umbilical cord. The condition is called as vasa previa. Next question. I hope you have marked all these answers very correctly, because if your basics are very clear, you are applying your clinical knowledge, you are able to get the correct answers in Obs and Gynae. As I have already said, 30 to 35 questions out of 300 is your Obs Gynae paper, and it is highly scoring among all other major clinical subjects. Now, 30-year-old women with primary infertility is being assessed to determine whether or not she ovulates. A transvaginal scan on day 9th and 11th reveals no growing follicle. Which of the following endogenous hormones action seems to be inadequate in this situation? We always know that the ovarian cycle starts with follicular stimulating hormone, which has been released by anterior pituitary, and there is a pulsatile secretion of FSH that is required. So follicular stimulating hormone acts on the ovaries and leads to the maturation of Graafian follicles. So many follicles mature. One follicle reaches a maximum size that is called as dominant follicle, and dominant follicle is the one which is engulfing the ovum. Size of the dominant follicle is 18 to 20 mm on transvaginal scan, and this dominant follicle usually secretes estrogen. Estrogen causes a negative feedback inhibition for suppression of FSH because further growth of the follicles is not required in this cycle, but it causes stimulation of LH surge. So LH acts on this dominant follicle, bring out its rupture. So ovulation, formation of corpus luteum occurs, and corpus luteum secretes progesterone, which causes secretory changes in the endometrium. So which is the hormone that is responsible for initiating the ovarian cycle, for development of the Graafian follicles, for the differentiation and formation of dominant follicle? The correct answer is FSH, follicular stimulating hormone. FSH and LH are called as gonadotropins, which are released by the anterior pituitary. Next question. A 16-year-old girl with normal breast development and pubic hair was brought to OPD by her mother complaining of primary amenorrhea. Okay. So this is a 16-year-old girl and she has presented with primary amenorrhea. The vagina and uterus and cervix were not visible, okay, during the ultrasound examination, and ovaries were present. So in this case, the uterus is not visible on ultrasound and ovaries were present, and there is a case of primary amenorrhea. So what is the finding? We have got it from the question where history and examination is written. In the history and examination, one very important feature in the beginning is breast development is normal and pubic hair are normal. That means the ovarian function is normal. So ovarian function is normal and ovaries are visualized. That means the karyotype is 46XX. So you can differentiate by the karyotype, by the clinical finding and by the ultrasound examination. So let us see what are the options given to us. Is it gonadal dysgenesis, androgen insensitivity syndrome, Mayer-Rokitansky-Kuster-Hauser syndrome, or Turner syndrome? Let us just write down the karyotype and the gonads. In the gonadal dysgenesis, that means it is dysgenetic gonads. So it will be dysgenetic ovaries. Although the karyotype will be 46XX, so dysgenetic ovaries will not secrete hormone, so the breast development will not be seen. So this is not gonadal dysgenesis. Androgen insensitivity syndrome. In androgen insensitivity syndrome, the pubic hair will be absent. But in this question, it is written pubic hair present. And also in androgen insensitivity, the karyotype is 46XY and the gonad is undescended testis on ultrasound, which is again not this case. Now, Turner syndrome. Again in Turner syndrome, uterus will be present because it will be hypoplastic. It will be hypoplastic and ovaries will be streak ovaries. So streak ovaries, breast development will be absent. Breast development will be absent. So it is not Turner syndrome. So it is Mayer-Rokitansky-Kuster-Hauser syndrome, which is, like going with this finding. Uterus is absent because it is a type of Mullerian agenesis. Type of Mullerian agenesis where uterus, cervix are absent and ovaries are present, breast development is normal, and it is a case of primary amenorrhea. So let us see. Dysgenetic gonads. Gonadal dysgenesis, I have already explained, dysgenetic gonads which are not functioning. So breast development will be absent in that case and uterus will be hypoplastic. So this is not with this case. Androgen insensitivity syndrome, uterus, fallopian tube, ovary will be absent. But ovaries written in this question is present. Breast development will be normal and the gonads will be undescended testis. Karyotype will be 46XY. MRKH syndrome, it will be uterus absent and ovaries present, breast development will be normal and pubic hair and axillary hair is normal. So karyotype will be 46XX, which is given in this question. Turner syndrome, uterus will be present but it will be hypoplastic and there is streak ovaries. Breast development will be absent and karyotype will be 45XO. So that is Turner syndrome. So our answer is MRKH syndrome where ovaries are functioning. Next, regarding postpartum hemorrhage, all of the following statements are true with the exception of, means which is a false statement. So this is a question of postpartum hemorrhage, which is very commonly asked question. Now, what is not true in this question? Uterus is not palpable in atonic PPH. Yes, because uterus becomes flabby and uterus is relaxed. So this is true. Secondary PPH is after 24 hours within 12 weeks of delivery. Yes, that is also true statement. Medical management with uterine massage is tried for 30 minutes. This is also true. Devascularization of the blood vessels is done if the patient is hemodynamically stable. If the patient is hemodynamically stable, why do we have to ligate the uterine arteries or ovarian artery ligation? So this is a wrong answer. Devascularization is not being tried in a stable patient. If the patient, in spite of the medical management and after trying the uterine tamponade, still the bleeding is continuing and no success rate and the patient's condition is unstable, then we go for systemic devascularization by ligating the uterine arteries and ovarian arteries. So this is a wrong statement. Next question, 75-year-old women presented to our outpatient department with large bilateral adnexal masses. So there is a history of large bilateral adnexal masses and the mammography findings are typical. The patient had no prior history of unusual bleeding, but more testing revealed that potentially malignant stomach tumor. So there is a history given. There is a malignant stomach carcinoma and there is bilateral adnexal masses. So stomach cancer and bilateral adnexal masses, it is most likely to be adenoma, Krukenberg tumor, Brenner's tumor or struma ovarii. If there are bilateral masses, this is likely to be a Krukenberg tumor. So the primary sites, because Krukenberg tumor is a metastatic ovarian tumor. Metastatic ovarian tumor, like you see secondaries in the liver, there has to be primary somewhere in the gallbladder, in the genital tract, anywhere. Okay. Similarly, here the primary sites of tumor can be a stomach cancer, breast cancer or colon cancer. So in this case, stomach cancer is already written. So it is likely to be a Krukenberg tumor. Next, an adolescent girl was brought by her mother to the clinic with complaints of oligomenorrhea and hirsutism. So there's a history of young girl being brought by her mother with a history of oligomenorrhea, that means a menstrual disturbance with hirsutism. So before you read the question completely, young girl, menstrual disturbance, hirsutism, the most probable diagnosis that strikes your mind is polycystic ovarian disease. Ultrasound finding reveals multiple follicles in the left ovary, 8 to 10 mm in size and left ovarian volume is 18 cc. That means the ovarian volume is more than 10 cc. Plus, there is history of menstrual disturbance plus hirsutism and it is a young girl. So, these findings are clearly directing towards the Rotterdam criteria, and Rotterdam criteria we use for polycystic ovarian disease. Let us see, it is not likely to be endometriosis because endometriosis, number one, it can present in young patient, I am not saying, but endometriosis, why there will be hirsutism and why there will be ovarian volume like 18 cc So these findings are not matching. Androgen secreting ovarian tumor. Androgen secreting ovarian tumor, there will be features of virilization, and usually it occurs in around 40 or 50-year-old female. It is not with theca lutein cyst, because for the theca lutein cyst there has to be a history of a molar pregnancy or an infertility patient where we have given the human menopausal gonadotropin injections, triggering that we are giving a HCG injection to trigger the ovulation, which is again not matching with this history and findings. So it is polycystic ovarian syndrome. So Rotterdam criteria. Rotterdam criteria says there is hyperandrogenism lab or clinical finding. There is menstrual disturbance like oligomenorrhea or secondary amenorrhea, and ultrasound showing polycystic ovaries. The follicles are arranged in the periphery. Okay, so that is what is a Rotterdam criteria, and this is what is a necklace pattern of ovaries. Next, a 25-year-old female arrived complaining of greenish fluid coming out of the vagina, and there is a strawberry vagina seen. Now, which of the following describes the course of the treatment? So, what is your diagnosis? Strawberry cervix or strawberry vagina and a greenish vaginal discharge is consistent with trichomoniasis, which is caused by Trichomonas vaginalis, which is a flagellated protozoa. So, drug of choice for trichomoniasis is not doxycycline, not amoxicillin, not fluconazole. It is metronidazole, and we are supposed to treat the partner as well. Now, greenish color vaginal discharge, itching present, and strawberry vagina. This is trichomoniasis, and the drug of choice is metronidazole. Thick curdy white cottage cheesy discharge, thick curdy white cottage cheesy vaginal discharge, itching present, that is candidiasis. Dirty vaginal discharge, fishy smell and no itching, that is bacterial vaginosis. The drug of choice for candida is fluconazole oral and a clotrimazole vaginal pessary. For bacterial vaginosis, again drug of choice is metronidazole, but since it is not STD, so there is no need to treat the partner. Next, the following are associated with tubercular salpingitis with the exception of, which is a wrong statement. Tubes are enlarged, ruffling, and there is a presence of grayish tubercles. This is true. Ampullary part of the tube appears dilated with fimbria and open and pouting. This is again true. Microscopically, granulomas and chronic inflammatory infiltrate hyperplasia may be mistaken for carcinoma. That's again true. Fimbria are commonly involved. That is a false statement. Fimbria are rarely involved. Okay. So, the findings of the tuberculosis can be a beaded appearance of the fallopian tube, or it is a tobacco pouch appearance, or it is lead pipe appearance or cobblestone appearance. These are the varieties of genital tuberculosis. So, let us see in the HSG images. There are some HSG images which I have added, because if such questions are being asked, you should be able to answer. So, there is a lead pipe appearance of fallopian tube. There is hydrosalpinx bilateral. So, there is tubo-ovarian masses, and there is fimbrial end usually is free, but there are tubo-ovarian masses. There is beaded appearance of the fallopian tube, as you can see in this image. Then there can be tobacco pouch appearance, you can see, and cobblestone appearance. This is all genital tuberculosis, which is a very important cause of infertility. Now, in severe cases, there are bilateral tubular masses where there is a tobacco pouch appearance and fimbria are usually spared. Next, 3 months after challenging prolonged obstructed labor. So there is a history of obstructed labor. A woman presents in the OPD and now complains of dysuria and frequent urine leaks. What fits into the diagnosis? There is a history of obstructed labor, dysuria and frequent urine leaks. That means there is incontinence of urine. Obstructed labor leading to incontinence of urine. According to me, it is vesico-vaginal fistula, because obstructed labor, in that case, the presenting part applies pressure downwards and it is not able to deliver. So it tries to apply pressure anteriorly. Anterior to the uterus is bladder. So there is pressure necrosis of the bladder and sloughing of the bladder mucosa. So after 7 days or 10 days, after a week or 10 days, the female complains of continuous dribbling of urine from vagina. So this is involuntary passage of urine. So this is most likely, according to me, will be vesico-vaginal fistula. Now, we can go for a methylene blue dye test, and many times the question is being asked. So there is an uppermost swab, middlemost swab and a lowermost swab. If the uppermost swab is as it is when we are infiltrating the methylene blue dye into the bladder, and we have kept 3 swabs in the vagina. If the middle swab is stained blue, this is vesico-vaginal fistula. If the lowermost swab is stained blue, this is urethro-vaginal fistula, which may be a case of criminal abortion. And if the uppermost swab is wet and smell of urine, that means it is uretro-vaginal fistula. That means it is uretro-vaginal fistula. Now, what is the best investigation for vesico-vaginal fistula? So the answer is cystoscopy, because we can see the site size and number of the fistula. Next, a 25-year infertile male underwent semen analysis and the sperm concentration is 15 million per ml, pH is 7.5, volume is 2 ml, no agglutination, morphology is 60% and 60% are motile. So this is normospermia. This is a normal finding. Now, what is the WHO cutoff limit for semen analysis? The amount is 1.5 ml. Cutoff values I am telling. Count is less than 15 million per ml and motility is 40%, less than 40%, and morphology is less than 4%. Progressive motility is 32%. So that is the WHO cutoff findings for the semen analysis. Most important fertility indicator in semen analysis when you are working up an infertility couples is the morphology of the sperms should be normal, and next is the motility, and third one is the count. Next, identify the test shown in this given image, and you can see the electrodes being applied onto the abdomen of the pregnant lady. This is non-stress test. From the image, you can have an idea. This is not amniocentesis, this is not Doppler. So this is a non-stress test where a belt is tied to the mother's abdomen and it is attached to a NST machine, and there's a graph paper running. You can take the recording of the fetal heart rate, and mother is instructed to press the button on the belt whenever she feels a kick movement. So we are assessing the relationship of fetal heart rate to fetal movement, and normal fetal heart rate is 110 to 160 beats per minute. So what parameters we see in the NST? We can see the baseline fetal heart rate, beat to beat variability, presence of acceleration, and there is no deceleration. So this is a reactive NST. You can see this is the fetal movements and this is the fetal heart rate. You can see the basal level is nearly about 130. There is beat to beat variability, and you can see the acceleration in response to the fetal movement. So this is a reactive NST. NST can be done at weekly intervals or bi-weekly intervals depending upon the situation. So it is usually done in cases of pregnancy-induced hypertension, preeclampsia, in IUGR, chronic hypertension, diabetic patients, etc. Now this is non-reactive NST. You can see a straight line. Now next question. A 26-year-old female worked up for primary infertility on HSG, hysterosalpingography. There are bilateral cornual block. What is your next step in management? So here in this case, the cornua are blocked. Are you going to plan a tuboplasty, hydrotubation, IVF? I am not going to plan any of these. I am going to plan a hysteroscopy and laparoscopic guided surgery, because the most common cause for a bilateral cornual spasm is a physiological spasm. So I am going to do a hysteroscopy and hysteroscopic guided cannulation, tubal cannulation. Okay, and with this tubal cannulation, I can achieve the cornual dilatation, and I can put in a laparoscope and check the tubal patency by doing a methylene blue dye, injecting the methylene blue dye from below and seeing that there is a blue liquid from the fimbrial end. So tubal patency can be checked. So I can opt for a hysteroscopy and laparoscopic guided surgery. And if there is hysteroscopically I am not able to cannulate the fallopian tubes, the next step would be the IVF. Next, all of the following statements given below are not correct about the umbilical cord. Which of the following is a true statement? Umbilical vein carries deoxygenated blood from placenta to fetus. We have always studied that the umbilical vein carries oxygenated blood from placenta to fetus. So this was a wrong statement. Umbilical cord has a Wharton's jelly. This is a true statement. Umbilical artery carries oxygenated blood. This is again false. Umbilical artery carries deoxygenated blood from fetus to placenta. Umbilical cord has 2 veins and 1 artery. Wrong. Umbilical cord has 2 arteries and 1 vein. What happens to the right umbilical vein? It disappears in the 4th month of pregnancy, and left umbilical vein persists as ligamentum teres, and the umbilical artery persists as medial umbilical ligament. All these are important questions. Please revise. Next, a woman had vaginal hysterectomy to treat her cervical cancer. Why these questions are being given lengthy? Because we want to prepare you for a lengthy clinical questions as well. If you get the exam in the single liner form or more image based question, it's going to be a beneficial for you. It's going to be a bonus for you. But if you get a lengthy clinical questions, as it's going to be a next pattern, so then you should be prepared for that. That is what an idea of giving you this CBoT practice tests. So women had vaginal hysterectomy to treat her cervical cancer, and she complained of urinary incontinence after urethral catheter was removed after surgery. Upon examination, she showed signs of continuous incontinence and normal voiding. That means there is involuntary passage plus voluntary passage of urine. Both are present. And her urethra was injected with methylene blue dye into the bladder, and oral phenenzopyridine dye was put. When her pads was examined, after some time there is a yellowish staining of the top cotton pad, but neither of the middle and the bottom were yellow stains. So uppermost was stained wet and yellow because that is a color of this dye. So this is most likely to be ureterovaginal fistula which has developed, because in the cancer cervix we are removing the lymph nodes, and when you're removing the lymph nodes, and suppose you're removing the pelvic lymph nodes or para-aortic lymph nodes for sampling, most likely that you can cause injury. But there is also a chance when you are applying clamps while doing the hysterectomy, you are applying clamps. Here is the ureter which is posterolateral to the uterine vessels. If you are not very careful, you can cause damage or injury to the ureter, which must has happened in this case. Or there may be a cervical cancer which has been eroding the ureter, something or the other cause for this. Or there can be post surgery, there might be given a radiotherapy, and like some complication must have occurred. So it is more likely to be ureterovaginal fistula with the history. Voluntary plus involuntary passage of urine after a surgery for cancer cervix. So it is most likely to be a ureterovaginal fistula. Next, a G2P1L1 lady underwent cesarean section in previous pregnancy. Okay. So the previous pregnancy, the cesarean section was done for a fetal distress. Now this time she has underwent a vaginal birth, that is VBAC, vaginal birth after a cesarean section, but placenta could not be removed completely. The cord snapped on traction and the placenta did not deliver. So patient is bleeding profusely. So that means it was a scarred uterus and they have tried to deliver the placenta. But placenta could not be delivered and the patient has started bleeding profusely. Placenta is still attached. So what is the likely cause? So that means there's a history that she has been a case of previous LSCS and vaginal birth after cesarean has been conducted. But placenta could not be delivered and she started bleeding profusely. Most likely after a cesarean section, if you are not able to deliver the placenta, it is likely to be an adherent placenta. And what is that condition called as adherent placenta? This is called as placenta accreta. It is not uterine inversion, it is not succensurita lobe, it is not placenta previa. So it is placenta accreta. Because had it been any type of a placenta previa, they would have done a planned cesarean section, but they have attempted which would have come. The placenta previa diagnosis must have come in the ultrasound finding, which they must have got it done during the pregnancy itself. So that means it was not a placenta previa. And when the placenta did not come out, it is not succensurita lobe. And when the uterus is still intact inside in its anatomical position, so it is not acute inversion of uterus. So this is adherent placenta, which is placenta accreta. So in this case, most likely since it is a multiparous lady, they might have to proceed with the hysterectomy. So this is placenta accreta, where like Nitterbuck's membrane, that is a membrane that separates or that prevents the invasion of the trophoblast into the myometrium. So in this case, placenta accreta or adherent placenta, the Nitterbuck's membrane is absent. So the chorionic villi invade the superficial layers of myometrium, that is placenta accreta, full thickness of myometrium, that is increta, and up to the serosa layer, that is percreta. For these situations, I recommend it is hysterectomy. Now during the dilator test, a woman who has had 2 abortions before and easily you are able to pass number 8 Hager's dilator. Hager's dilator number 8 easily, and there is history of previous 2 abortions. So this is most likely to be a case of incompetent cervical os, and another way to diagnose this, it can be done by HSG or it can be done by ultrasound. In ultrasound, you get a finding of shortening of cervical length to less than 2.5 centimeters. Okay. HSG, what do you find? You find funneling of cervix. So management in this case will be a, like for incompetent os, we go for a cervical encerclage operation. So this is Hager's dilator. Next question. A 24-year-old lady with 8 weeks history of amenorrhea, positive urine pregnancy test. So she is 8 weeks amenorrhea. 8 weeks amenorrhea. Urine pregnancy test is positive. but vaginal examination and a vaginal examination reveals an empty uterus and adnexal mass, transvaginal finding also shows that uterus is normal size and there is adnexal mass. Okay, which of the following test will sum up with her next evaluation further? Is it immediate emergency laparotomy? No way. Laparoscopy? No way. Estimation of serum beta HCG or 3 doses of methotrexate? We never give 3 doses. First of all, we always give first dose. But first of all, I would like to confirm that it is a case of ectopic pregnancy. So the best investigation has been done, transvaginal scan, which shows there is an empty uterus and there is an adnexal mass. But they have not written about the gestation sac and the cardiac activity in this adnexal mass. So next, I would like to confirm my diagnosis. I would like to go for an estimation of serum beta HCG to arrive at a diagnosis. Okay. Next, identify the given instrument. So this is not Carmen's cannula, this is not MVA syringe, that is manual vacuum aspiration, that is done for MTP. It is not Spexman's cannula, this is a Rubin cannula. Rubin cannula was used for the air insufflation test for tubal patency. Air insufflation test for tubal patency in cases of infertility. But this is very obsolete test because in this test, Rubin's cannula was inserted and air was injected into the uterus. Air will enter into the uterus and strike the diaphragm, and lady is supposed to tell the doctor that she is feeling a shoulder tip pain. So this is most obsolete test now, and we use the Leash-Wilkinson cannula. So this is Carmen's cannula. Carmen's cannula is usually used for suction evacuation method, or we can use it for doing the endometrial sampling as well. This is MVA syringe, that is again used for MTP. Next question. A pregnant lady with 10 weeks period of gestation presents with spotting on ultrasound. There is a gestation sac seen but no fetal pool. What is the likely diagnosis? At 10 weeks, you are just seeing a gestation sac but no fetal pole. So that means it is most likely to be a case of missed abortion. Inevitable, incomplete and threatened, I have already discussed in the first question itself. Next. An investigation was conducted on a woman who had an abdominal lump. She had smooth surface ovarian tumors on both sides during the surgery, and there's a signet ring mucin secreting cells. What type of likely diagnosis? So since it is a mucinous secreting signet ring cell we see in the Krukenberg's tumor, which is bilateral, and the surface of the ovary is smooth and the capsule is intact. So this is signet ring cells, Krukenberg's tumor. Next, a 29-year-old woman who is nulliparous with infertility, uterus reveals that it is retroverted, fixed. Uterus is retroverted, fixed, and there is tenderness in the pouch of Douglas. Tenderness in pouch of Douglas, that means it is endometriotic spots in the pouch of Douglas. Uterus is retroverted and fixed, that means there are adhesions. Retroverted fixed, that is adhesions. Tenderness in the pouch of Douglas, so it goes with endometriosis, because endometriosis is occurring in a young female reproductive age group, and if this patient is married, so might be there is infertility. That is written, so it is a married patient, nulliparous infertility with a normal sized fixed retroverted uterus with tenderness in pouch of Douglas, that is endometriosis. What is the gold standard investigation in endometriosis? Answer is laparoscopy. What is the most common site for endometriosis? Answer is ovary, that is chocolate cyst of ovary. And if there is moderate to severe endometriosis on laparoscopy, what is your management? In moderate to severe endometriosis, when there is so much of additions that you cannot treat by surgery. So in that case, you can go for IVF. Endometriosis means presence of endometrial tissue outside the uterine cavity. Most common site is the ovary. Other sites can be pouch of Douglas, rectovaginal septum, appendix, sigmoid colon, etc. Now, 25-year-old lady arrives with a history of bleeding after sexual activity. Examining the specimen revealed the following appearance. What is the diagnosis? Looking at this with a, polypoidal mass coming out from the cervical os, it is unlikely to be a CA cervix because number one, it is occurring in very young female and bleeding occurs, that is a history of postcoital bleeding. So postcoital bleeding can occur in cancer cervix and cervical polyp as well as, okay. So looking at the history, which is little bit incomplete appears to me, 25-year, very unlikely that it is a presentation of a cancer cervix in such a young patient. So it is most likely appears to me a cervical polyp. Nabothian follicles do not present like this as the image is given, and cervical fibroid is on the cervix, lip of the cervix. Okay, it's not like this. Next question, which of the following requirements must be met in order for a registered medical practitioner to be authorized to perform MTP under the updated MTP Act regulations? House training for 12 months, wrong. House job for 6 months. 6 months house job in Obs Gynae can entitle for an MTP. Should have assisted 16 MTPs in authorized centers. No. It is 25 MTPs in government approved authorized centers. Certified for 6 months in laparoscopic surgery. No. It has to be some qualification in Obs and Gynae. So having a degree or diploma in Obs Gynae. So the correct answer is A. That is 3. So in the new MTP Amendment Act 2020 or 2021, you should know the upper limit for MTP is 24 weeks. MTP is legal when done up to 24 weeks and till 20 weeks. Opinion of one doctor is enough. From 20 to 24 weeks, opinion of 2 doctors needed. In the special cases like rape, unmarried girls, etc., if the pregnancy has gone beyond 24 weeks, can MTP done? Yes, that case goes to a medical board and they decide. Medical board consists of a gynecologist, pediatrician, radiologist and a gusted officer appointed by government of the state or the union territory. And if they say, okay, you can go ahead with MTP, then MTP can be done beyond 24 weeks as well as. Then who can perform MTP? A registered medical practitioner who has assisted 25 MTPs in a government approved authorized center, a doctor who has done 6 months of house job in Obs and Gynae, a doctor who has done MD, MS, DGO or DNB in Obs and Gynae can perform MTPs. So also pay attention to the indications of MTP and complications of MTP as well. Next, a lady who is parous observes a swelling at the vulva that becomes less as she lies down. Okay, so swelling gets reduced when she lies down and she also has a trouble starting with micturition process. So that means there is history of difficulty in urination and there is a swelling which reduces on lying down and appears on standing. So these findings are not in favor of cervical fibroid, not for uterine prolapse, not congenital elongation of cervix. This is cystocele, that is bladder prolapsing in the vagina. And what is the surgery for cystocele is anterior colporrhaphy. Anterior colporrhaphy, remember this. And number 2, what is most common type of genital prolapse? Most common type of genital prolapse is cystocele. Most common type of genital prolapse is cystocele. Next, a woman presented to our OPD with primary infertility. On examination, it is found to have nulliparous prolapse of the uterus. Nulliparous prolapse means only the cervix is cervix is prolapsing. It is not cystocele, rectocele. What would be the most appropriate management in this case? Ring pessary? No. Ring pessary is done when the patient is having genital prolapse and she is pregnant, or she is in the purpurium, or she is elderly unfit for surgery. Fothergill operation is done in a multiparous lady, but she is young, having genital prolapse with cystocele, rectocele. Then Fothergill operation is tried. Cervical amputation alone is not done. So here for the nulliparous prolapse, we go for a sling operation. Sling operations are done for a nulliparous prolapse where there is only cervical descent, there is no cystocele, rectocele, and the type of surgeries can be the Purandra's sling surgery, Khanna sling operation, etc. or Shirodkar sling operation, and there are modifications also available. Next, in cases of gestational diabetes, which of the following problems is not seen? Preeclampsia is associated with diabetes. This is true. Abortion is associated with diabetes. Yes, because in gestational or pre-gestational diabetes and the lady is pregnant. So pre-gestational diabetes, if the blood sugars are not being controlled, then there is likely to get abortions, because the diabetes leads to congenital malformation and congenitally malformed fetuses are likely to get aborted. And there is always a risk of infection, but oligohydramnios is not associated with diabetes, rather polyhydramnios is seen. So with this, I end up my session. Hope you have seen or you have checked the answers with my discussion, and hope this session is useful to you. So this was a very final revision. Be prepared for the clinical questions, image-based questions, previous year questions, and the single liners. So all the best and thank you.
Okay, so welcome to this session on anatomy. I'm Dr. Ankit, Faculty of Anatomy. Let's see the first question. A 48-year-old came to the surgery OPD with the chief complaints of facial flushing and sweating while eating after parotid surgery, which was performed on him a few days back. Which of the following nerve cross connections can lead to these clinical manifestations? Here, if you look at the facial flushing and sweating while eating, it refers to our Frey syndrome, right? And also known as the gustatory sweating. Gustatory sweating. So this happens when after there's a cut over the region of the parotid region. Okay, so it could be post surgery or it could be any penetrating trauma. So there's some cross connections of the nerves over here. What happens is the nerves which cross connect, one of the nerves should be going to the parotid gland for more salivary secretion. So what is that post ganglionic nerve that goes to the parotid gland? It comes from motor ganglion. It is the auriculotemporal nerve. right? It is a, you can say, the secretomotor nerve for the parotid gland. Other should be the cutaneous nerve over here, so that for facial flushing and sweating, and that is a great auricular nerve. Okay, it is a great auricular nerve. It is coming from C to C3, and this auriculotemporal nerve is a branch of mandibular nerve. So these two nerves, they actually cross communicate after any of the surgery or trauma, and that leads to this Frey syndrome or the gustatory sweating. So these two nerves, if you look in the options, we have option number A over here. So remember, in this option number A, this great auricular is for the skin over here, and this auriculotemporal is going into the parotid gland, and they cross communicate, and that is how it leads to Frey syndrome. Next one, which is not properly matched with its main action. So lateral rectus, it abducts the eyeball. Yes, it is the only abductor of the eyeball, the main abductor. Superior rectus, it mainly elevates the eyeball. The main action of the superior rectus is that it elevates, right? Inferior rectus, now rectus are straight muscles, so inferior rectus will depress the eyeball. Correct, correct. So obviously we are left with option number D, and that should be the answer, but let us see. So what is the main action of superior oblique? See, superior oblique is a oblique. Oblique means at an angle. The main action of the oblique muscles are either intorsion or extorsion. Intorsion means rotating inside of the left eye, if I give you an example. Extorsion means rotating outside. So superior and inferior oblique, they are mainly either intortus or extortus. Superior oblique is mainly intorsion. It mainly causes intorsion or rotating the eyeball medially, not laterally. So it has to be medially. So this main action is wrong. Therefore, answer is option number D. If you look at this image, here they are showing us all the actions of the main 6 extraocular muscles. So medial rectus adduction, lateral rectus abduction, superior rectus inferior oblique, inferior rectus. So superior oblique does this. Superior rectus elevates, inferior rectus depresses. The superior oblique does mainly intorsion, and the inferior oblique does mainly extorsion, mainly main action. Okay, superior oblique supplied by the fourth or the trochlear nerve. A man, 67-year-old, presents with the shingles on his left forehead, upper eyelid, and a bridge of the nose, as shown in the figure. What sensory ganglion is most likely affected? So we all know that shingles over here, the herpes zoster, is it's a dormant virus, herpes, that is inside the sensory ganglion. This region of the body, if you see the forehead and the upper eyelid, this region is the ophthalmic or the trigeminal nerve branch ophthalmic division, V1. Shingles are over there, very painful condition. They asking you which sensory ganglion. Has to be the trigeminal ganglion, right? Has to be the trigeminal ganglion. Now, if you look at the options, otic ganglion, B is the answer. Now, if you look at the other options, otic ganglion is parasympathetic, supracervical is sympathetic, ciliary is again parasympathetic. So here you have trigeminal, that is the sensory ganglion. Okay, S is over here sympathetic, right? So answer is option number B. Remember shingles, herpes zoster. 21-year-old suffers a traumatic injury and dies after a motor vehicle accident. Autopsy reveals abnormally increased mobility at the neck. A section of the spinal cord at the C6 level is processed into sites. Which of the following features will be seen at this spinal cord level? So at C6, that is cervical part or spinal cord, what special feature will we see? Prominent lateral horns, option number A. The lateral horns are mainly found in the thoracic region. It is for the sympathetic outflow. Least amount of white matter. Now, cervical region has a maximum amount of gray and white matter. So, least amount will be seen in the lower part, mainly sacral part. Absence of gray matter. Again, there will be abundant gray and white matter in the cervical region. What's the upper part of the spinal cord? Presence of fasciculus cuneus. Yes, so fasciculus cuneatus and gracilis, these are the two parts of the dorsal column, and they are separated only in the cervical region. Why? Because see, cuneatus coming from the upper part of the body and gracilis coming from the lower part of the body. So if you look at the thoracic region or the lumbar region, there mainly you will have only one part in the dorsal column, but in the cervical region you have two parts. Let me show you. Here look at the cervical part of the spinal cord. What do you see? Abundant white and abundant gray matter, and this is the fasciculus gracilis and fasciculus cuneatus. This is what they actually ask in the question. If you look at the thoracic part of the spinal cord, what do you see over here? L is for the lateral gray horn, because T1 to L2 means entire thoracic and the upper lumbar part, they are sympathetic outflow. If you look at the lumbar region over here, okay, you see again a lot of gray and a white matter, because gray matter more because of the lumbar plexus. But there is no different fasciculus cuneatus gracilis, there is no different lateral horn. If you see at the sacral part, you see a very less amount of white matter, gray matter. You see a lot of cauda equina over here. Okay, this is how you can differentiate the parts of the spine cord. MBBS student, while studying histological sections, observed the following cartilage. The given cartilage is present in all of the following except, always remember except. So there are two ways to answer this question. Either you recognize this cartilage having a lot of elastic fibers, you know, okay, it is an elastic cartilage. Or you look at the option, they are saying given cartilage is present in all of the following except. So you know they are elastic cartilage, fibro and hyaline cartilage. So if out of 4 options, there is a odd man out over here, that has to be the answer. Think about it logically. Out of 4 options, there is one odd man out, that could be the answer. Very high probability. So if you look at eustachian tube, it is elastic cartilage. Earlobe, elastic cartilage. Epiglottis, elastic cartilage. We know that, okay, this is the odd man out. So this should be the answer. Yeah, it is the answer also, because epiphyseal cartilage, that is at the end of the long bones, we have mainly the hyaline. Hyaline means where you don't see the elastic fibers in between. It's a completely, there's a transparent sort of cartilage. I will show you the image over here. Look at the image. This over here is the hyaline cartilage. The fibers are there, but they are not visible. This over here is the elastic cartilage. A lot of elastic fibers. And where you see a row of chondrocytes, this is the fibrocartilage. Okay, so there are 2 ways to answer that question, but hopefully the ideal way or the good way or the better way is you look at the image, identify the cartilage. That is the best part. While examining muscle function at the metacarpophalangeal, PIP and DIP, metacarpophalangeal, PIP and DIP, what findings do you expect in the presence of a radial nerve palsy? Good question. Inability to abduct, adduct, okay, fine. So this is a metacarpophalangeal, that is PIP joint, this is DIP joint. So radial nerve, if there is injury to the radial nerve, which movement will be lost or which will be weakened over here? See, when you say radial nerve injury, there is wrist drop and there is also finger drop. Finger drop means you can't extend the fingers. There is finger drop. Now you can't extend the fingers. This extension of finger is occurring at which joint? MP joint. So MP joint, decrease extension occurs. That leads to finger drop. Which muscle over here? The muscle over here is extensor digitorum, supplied by posterior interosseous nerve, branch of radial only. So fine. But if you look at the PIP and DIP, what occurs over here? You can extend and you can flex. So which muscles causing flexion at these joints? Obviously the FDS and FDP. But they are supplied by the median nerve. The extension at the PIP and DIP is mainly done by which muscles? It is mainly done by the lumbricals and interossei. So PIP, DIP, if you look, the extension over here is mainly done by the lumbricals and the interossei. Remember, this is the action of the lumbricals, and interossei you also know pad and dab, adduction, abduction, but they also do extension at the PIP and DIP. Now, lumbricals are supplied by innervator which nerve? Mainly the median or the ulnar, interossei mainly by the ulnar nerve. Therefore, radial nerve injury will mainly act on the MP joint, not at the PIP, DIP. Because PIP, DIP, as I told you, again I'm telling you, the flexion will be done by FDS or FDPs. They are not supplied by the radial nerve. So, effect of radial nerve at the joint of fingers is mainly at the MP joint, and what at the MP joint? Basically inability to extend the MP joint. Now, if you look at the options, inability to abduct the digits, no. Abducting the digits mainly done by the interossei, the dorsal interossei. Inability to adduct, no. Adduct again by palmar interossei. Now, those interossei supplied by ulnar nerve. Inability to extend MP joint only, yes. This is the answer. The very beautiful question. You should know this basics of this radial nerve. And then they are saying inability to extend the PIP, DIP, no. That is done by the, again, lumbricals and interossei. Answer over here will be option number C. Go through this question, very important conceptual question. Which correctly describes the development of the lungs in order. Okay. PCTA, just remember this at least. Pseudoglandular, canalicular, terminal sac and alveolar stage. This terminal sac over here is where the viability starts, or the child or the fetus might be viable for birth. That occurs when at the beginning of the 7th month. So we say that if the child is being born at 6th month, it is very difficult for it to survive, because the lungs and the brain, they have not yet developed completely. But from 7th month starting, the terminal sac period, there's there's a communication between the blood and the alveoli, the capillary barrier, okay, where the exchange of gases can take place in the alveoli. That starts. Surfactant, more important. So remember, PCTA, pseudoglandular canalicular terminal sac in alveolar stage. If you look at the options over here, answer is option number A. Now, what is this PCTA in detail? You can have a look at from this particular table. At which time zones also? Pseudoglandular at 5 to 16 week. Okay, what happens over here? The lungs appear like glands. Then you have a canalicular period which is from 16 to 26 weeks. That is till 6 months, up to 6 months. Each terminal bronchioles divide into 2 or more respiratory bronchioles, which in turn into alveolar ducts. So there is a branching and sub-branching and sub-branching, but the connection between the capillaries and the air in the alveoli, that has not yet been established. This is the important one, the terminal sac period, right? From 26 weeks to birth. From 26 weeks is the end of 6th month. So the beginning of 7th month. Their terminal sacs form and capillary establish close contact. That is important for the viability. Remember, alveolar stage occurs from birth till up till 7 or 8 years of age, when the number of alveoli, they keep on increasing. So more alveoli are being formed. So remember PCTA, and that is the correct sequence. And time period also. In the question they didn't ask the time period, but remember this time period, very, very important. Next question, all the following are derivatives of neural crest cells except. So in embryology, always remember the derivatives. And neural crest cells are regarded as the 4th germ layer. They migrate a lot. They give rise to the adrenal medulla. They give rise to the ganglias, all the ganglias. They give rise to a lot of structures. In the in the septums of the heart. Okay, they give rise to your odontoblasm, all those things. So let us see. Septum of the heart, yes, they form. Schwann cells, yes. In this, do remember that Schwann cells, they do myelination in the peripheral nervous system, outside the CNS. So they are coming from neural crest. If instead of Schwann they would have given you oligodendrocytes, then no, oligodendrocytes, they don't come from the neural crest, they come from the neuroectoderm. So oligodendrocyte, not from neural crest cell, cross NCC. Odontoblasts, yes, are given. Ameloblasts are not coming from the neural crest cells. Now here's a table, go through it number of times. Here all the derivatives of the neural crest cells are given. This is a complete table. So which is important? All are important. To be honest, all are important over here. Connective tissues of the bones of face and skull, the pharyngeal arches, ganglia, thyroid glands, septum of the heart. These were the options, right? These 3 were the options in the question. But remember, all are important over here. Go through them number of times. Try to understand. As part of the examination to evaluate the lower limb, a physician asks a patient to stand on his tiptoes. What nerve is the doctor testing? This question we have done earlier also, but remember, when you stand on the tiptoes, if I ask you what is the movement which is occurring at the ankle joint, which is a hinge variety, movement can occur only in one axis. Here, what is occurring is plantar flexion. Plantar flexion, simply flexion. So plantar flexion will be done by which compartment of leg muscles? The posterior compartment of leg muscle, that is the calf muscles. Supplied by which nerve? The tibial nerve supplies. And even if you look at the image over here, focus onto this calf muscles. You can see the contractions. And if you do this on your own, you stand on your tiptoes, you stand on your toes, you'll realize the tightening of the calf muscles. The posterior leg muscle supplied by the tibial nerve. Now, what are they asking you? What nerve is the doctor testing? Obviously, it has to be the tibial nerve, and therefore option number A is the answer. If you look at the other option, the deep fibular nerve, it is supplying the anterior leg compartment. So that will do the dorsiflexion. If that is injured, what will happen? There will be foot drop. The applied of it is foot drop, like the wrist drop. The superficial fibular nerve, it supplies the lateral leg muscles. And if this is injured, there will be loss of eversion. Eversion of foot will be lost or will be hampered severely. Sural nerve is a cutaneous nerve. It's a cutaneous nerve spreading on the lateral aspect of the leg and the lateral border of the foot. Okay, the answer over here is option number A, the tibial nerve. 34-year-old suffered a superior gluteal nerve injury in a motorcycle crash in which his right lower limb, so it's a superior gluteal nerve injury, right lower limb was caught. Later, he exhibits a waddling gait and a positive trend sign, which is most likely physical finding. Everything is given over here. Superior gluteal nerve, they supply actually the gluteus medius and the gluteus minimus. Okay, and they are mainly the abductors of the hip joint, and when they are damaged, there is going to be the Wedling gate. But they, on which side they are damaged? Right side. So where does the Wedling occur? On the normal side. So the left pelvis starts to drop down. If you look at the options over here, option number B, the left side of pelvis drops a size when he attempts to stand. Yes, option number B, this is the answer over here. Option number B is the answer. Let us understand how. If you look at this image, this is a normal person, okay, and that is this abnormality over here. What is abnormality? Let me tell you. In the normal person, to start with, the person is standing on the right foot. The right gluteus medius minimus contracts, and what they do is they tilt the pelvis to the right side. So the person can lift the left foot off the ground, and any normal person can walk easily. That is fine. Now what happens when on this right hand side image, when the gluteus medius minimus and when this muscle is paralyzed? So when the person stands on the right foot and he takes the left foot off the ground, this muscle is not working. So the pelvis is not being pulled to the right side, pelvis is dropped down on the left side. So left side of pelvis drops down. So it's a normal side of pelvis that drops down. Understand this. Okay. So answer over here in this question is option number B. Right. Let's see the next one. A 57-year-old was admitted to the hospital with severe abdominal pain. Gastroscopy and CT reveals a perforating ulcer in a posterior wall of the stomach. Where would peritonitis most likely develop initially? So they are saying that there's ulceration, there's perforation in the posterior part of the stomach. So what is the space that is present behind the stomach? That is the basic question. It is our lesser sac, but lesser sac, if you look at the option, not in the option, what to do now? What is the other name of lesser sac? It is omental bursa. Is that in the option? Yes, that is in the option. So it is simply straightforward option number B. C, sorry, omental bursa. Other options over here, if you look carefully, the right subhepatic space. It's basically the Morrison pouch, the space between the liver and the right kidney. Okay, so it is what they are referring to, Morrison pouch, same as option number B. Greater sac is the general peritoneal cavity in front of the stomach. So first of, they are asking where would peritonitis most likely develop initially. So initially, to begin with, it start with the omental bursa. Then from here it might go to these places via epiploic foramen or the foramen of Winslow. But initially it will develop over here. If you look at this image, here's the anterior part, here's the posterior part, and if you look over here behind the stomach, if I make this dots, this area is the lesser sac, and the perforation must have been coming from here, the posterior aspect of the stomach, and through the epiploic foramen over here. When this has been completely being filled, when this has completely been filled by this contents of the stomach, then from here it might come out into the greater sac or might go to the liver or the Morrison pouch. But first, initially goes into the lesser sac. Okay, you are at a surgery and are about to mobilize the second portion of duodenum, okay, and the head of pancreas, right? So we all know that your first part duodenum, second, third, and the fourth part duodenum, and between you have this P for pancreas. You note an artery and a vein passing anterior to the uncinate process of pancreas. Okay, now you start to see that there is an artery which is running in front of uncinate process and a vein which is running in front of uncinate process. Okay, and the third portion, why? Fine. What vessels are these? It's a very famous question. We should all be crystal clear that these are the superior mesenteric vessels, which run in front of the third part of duodenum, which run in front of the uncinate process of pancreas. Okay, do remember. And the superior mesenteric artery, if we talk about, it also runs in front of the left renal vein, leading to that nutcracker syndrome. So answer over here is undoubtedly, it is very simple, straightforward, is superior mesenteric vessels. And if you look at this image, you will realize that here you have this, what we can say, the head of pancreas, and the neck of pancreas. This is the whole, if we change the color, this is the whole body of pancreas, that is a T for tail of pancreas, that is the neck of pancreas. And this is what they exactly asked over here. What are these vessels? Artery and vein running in front of the uncinate process of pancreas. Where is uncinate process of pancreas? This is the uncinate process, the uncinate process of pancreas. Okay, fine. A 48-year-old lady had been scheduled for cholecystectomy. During the operation, the scissors accidentally entered the tissues immediately posterior to the epiploic foramen. So we are now coming again to the this epiploic foramen boundaries. The surgical field was filled immediately by blood. What vessel? So they are saying that the scissors entered posterior to the epiploic foramen and there is a lot of bleeding. So in boundaries of the epiploic foramen, what is structure lying behind posterior to it? That has to be a vessel. And there is a very important vessel over here is our inferior vena cava. Is there any vessel in front of it? Yes. What are those vessels? In front you have a vessel known as portal vein. You have another vessel also known as hepatic artery, and even in fact you have a bile duct also. But they are lying where? They are lying anteriorly. Okay. So anteriorly you have this portal triad. Anteriorly what you have? The portal triad. Posteriorly what you have? The IVC. Okay, what lies above it? We'll see. If suppose this is the epiploic foramen, what lies superior to it is the liver, and what lies below the epiploic foramen is the first part of duodenum. Okay, so if you come to the question again, posteriorly which vessel might have been cut? The answer is definitely going to be the IVC. Let me show you this image as well. Here, just if you look at carefully, this is the anterior aspect, that is the posterior aspect, the same thing. This is the epiploic foramen over here, also known as Winslow. Posterior is IVC, anteriorly you have these three structures, portal triad. Okay, so this is important. The foramen of Winslow or the epiploic foramen boundaries should know. 58-year-old is admitted with a chronic angina. The coronary angio reveals nearly total blockage of the circumflex artery near its origin from the LCA. When this artery is exposed to perform the bypass, what vein? Okay, so which vein is associated with circumflex artery? Remember over here, with LCA, left coronary and left circumflex artery, which vein is there? With posterior interventricular artery, which vein is there? And with the right coronary artery also, which vein is there? This should be clear. We'll see in the images as well. With LCA and LCX, there is great cardiac vein, and that is the answer for this question. If we look at the options, this is the answer. With the posterior interventricular artery, that is normally the dominant circulation artery, it is a middle cardiac vein, right? The RCA, normally the small cardiac vein. Small cardiac vein normally runs along with the RCA or the right marginal artery. RCA, or you can say the right marginal artery. Basically, it is the small cardiac vein. Let us see an image over here. This is the anterior view of the heart. Here you have the RCA. This is the anterior interventricular artery, and that is the circumflex artery. So the vein that must be running over here is the great cardiac vein. Here you have the small cardiac vein, and behind with this artery you have the middle cardiac vein. Let us see in this image. So this was the great cardiac vein that they asked in the question. That is running along with the LAD and the left circumflex. That is a small cardiac vein, and behind is a middle cardiac vein with the PIVA, posterior interventricular artery. This with LAD or LCX. Here it's better to write, instead of LCA, let us write LAD, left anterior descending artery. Okay, that is a better word for it, though both are branches from L6 only. And that is a coronary sinus present posteriorly, where all these veins ultimately drain, and this coronary sinus drains into the right atrium, right? Okay, let's see one more. With respect to the openings in the diaphragm, which statement is incorrect? What is wrong over here? So we all know that the three main openings, I 8, 10 eggs at 12. This was one of the mnemonic which we have discussed already. I8 over here is the IVC is located at T8 level. Esophagus opening is at T10 level, and aortic opening is at T12 level. What passes along with IVC is also important. It's a right phrenic nerve that passes along with IVC. What passes along with the esophagus are the vagus nerve and some of the vessels. What passes along with the aorta is the thoracic duct and the azygous vein. They pass along with the aorta. Basic idea. This is normal. Now let us see what is incorrect. Aortic opening passes at T12. That's correct. Left phrenic passes through IVC. Oh, it is the right phrenic, not the left phrenic. This does not look correct over here. This can be the answer, or this should be the answer. Not can, but should. Aortic opening passes, yes. It passes behind median arcuate ligament, correct. Esophageal at T10 level, yes. If you look at the image also over here, you can see the esophageal opening over here at a T10, the IVC opening over here at a T8, and the aortic opening at a T12 around. Okay, so these are the three major openings. There are many other openings, but you should know at least minimum, this is minimum basic, three major openings. As a surgeon exploring the thorax, you will be able to identify the right pulmonary artery in which of the following locations. Okay, interesting. Let us see over here. If this is the heart over here, they're asking us the right pulmonary artery. We all know that this runs the arch of aorta from front to behind. And this is the SVC that is coming from above. And apart from all of this, what else we have? We also have the pulmonary trunk coming out from the right ventricle, and that gives rise to this left and the right pulmonary artery. What they're asking us in this question is about the right pulmonary artery. Right pulmonary artery. Now, this right pulmonary artery, will it go in front of aorta or behind? It goes behind aorta. And then see, SVC is coming where? SVC is coming into the right atrium. So it is more anterior. Therefore, the right pulmonary artery will also go behind the SVC, and then it will go into the hilum of the right lung. Hilum of the right lung. Understood? So basically, the right pulmonary artery is running behind the aorta and the SVC. If you look at the options, anterior to the ascending, no, it is not anterior, it is behind the aorta. Anterior to the ascending, no, again, posterior to the descending aorta and SVC. Yes, it is posterior to the descending aorta, but here if they are asking us descending aorta, again that will be a problem. Why? Because the descending aorta is present behind, posteriorly, descending thoracic aorta. And right now this artery is running behind the ascending aorta or the arch of aorta. So again, that would not be completely correct over here. Posterior to ascending aorta, yes, this one is the answer. See, just one small word might confuse us, descending or ascending aorta. It is posterior to the ascending aorta, and SVC is the location of the right pulmonary artery. Understand this. If you look at an image also over here, this is the pulmonary trunk. This is the pulmonary trunk, but here they are not showing us the pulmonary artery. Right one will go like this and then enter into the hilum. The left one will go obviously into the left side, hilum of the left lung. Okay. Okay, one more, probably the last question. During the removal of a neurogenic tumor in the posterior mediastinum, the indicated structure is right over here, was damaged. What type of nerve fibers were affected by this iatrogenic injury? Okay, this question is important and not an easy question if you don't know this idea of this. So looking at the image, we all know that we are seeing the spinal cord and we are seeing the DRG. So this is the posterior, that is the anterior. These are the ventral roots, that is the dorsal root. That much is clear. Then both the roots, they meet and they form this spinal nerve over here. And here you can imagine, if you are more just cautious about the image, you have a more visual memory, you will remember that this is the sympathetic ganglia. You have a sympathetic chain of ganglia, right? And ganglia always, remember, have a afferent and an efferent, and in between you have a ganglia. Okay. So what happens is you are seeing these two roots. So one is obviously the afferent, one is the efferent. And afferent, efferent here. The afferent one, the one that is coming inside, is known as the white rami communicans, and the efferent one, the one that is going out, is known as gray rami. Why? Because the white is myelinated and this is gray is non-myelinated. Fair enough. Now if you look at the image, you will realize, okay, if they are showing the question, arrow is at this point, that appears like a preganglionic or a white rami, right? Or afferent one for that ganglion. So it appears like a preganglionic sympathetic. Fine. If you look at the options, preganglionic sympathetic, you will say, okay, option number A. That appears like fine. But the trick over here is, the detailed knowledge over here is that this white rami or the preganglionic is the one that is distal over here. This is the preganglionic. That is the thing. And that one more proximally, this over here is the postganglionic or the gray rami. This is what you need to remember. Slightly twisting over here. Therefore, this marked over here is the postganglionic sympathetic axons, option number C, not A over here. Answer is option number C. And this is also known as what? It is a gray rami communicans, non-myelinated. And this is white rami communicans, myelinated. So even in fact, you know everything, but that a small thing, that the one that is more closer to the spinal cord, that is the one that is postganglionic, the gray. And the one that is a bit farther away is the preganglionic or the white rami. Just remember this. And both are sympathetic. Why? Because it is a sympathetic ganglia that is running. Clear? Okay, so that was all. I hope you enjoyed. Thank you. All the best.
Okay, guys, let's start with the pathology questions. First question. रेडियोपैथो का कोरिलेशन है 28-year-old female with weakness, dysphagia, thoracic pain and aspiration. The barium swallow study is shown below. The patient also crave for non-food stuff such as clay. Peripheral blood smear shows small size RBCs. This type of anemia is suffering from. Come on, कितना कुछ दे दिया. The patient has the clearly. सबसे पहले तो देखो रेडियो और पैथो का कोरिलेशन. ईसोफेज में मेम्ब्रेन्स बने हुए हैं. स्मॉल बेरियम स्टडी पे ईसोफेगस में बने हुए हैं. यू हैव ईसोफेजियल वेब्स. So how beautifully they have correlated the radiology with pathology. Esophagus में you have small membranes from esophageal webs. फिर उसने क्या लिखा है? The patient crave for non-food stuff such as clay. I hope all of you remember this feature is called as pica. So pica is seen here, boss. So इतना कुछ क्या बताऊं. फिर microcytic RBC भी दिख रहे हैं. The clear-cut case of IDA. Esophageal dysphagia with pica ka symptom with small size RBC. That is clear-cut case of IDA, and I'm sure all of you remember Plummer-Vinson syndrome. Why esophageal webs? I'm sure all of you remember same genes are involved. So Plummer-Vinson syndrome. I hope you remember Plummer-Vinson syndrome. Triad क्या होता है? Triad is IDA only. इन पेशेंट को आयरन डेफिशिएंसी एनीमिया होता है तो आईडीए से आपको याद आएगा. इनमें आयरन डेफिशिएंसी एनीमिया होता है इन प्लमर-विंसन सिंड्रोम. डी से आपको याद होगा डिस्फेजिया. This patient present with dysphagia because of esophageal webs. Because of esophageal webs. And A से याद करो angular stomatitis and ciliitis भी होता है. Angular stomatitis, ciliitis is also seen in the patient of Plummer-Vinson syndrome. So this is a clear-cut case of Plummer-Vinson syndrome, which have iron deficiency anemia, dysphagia, esophageal webs, and also the patient can have angular stomatitis or ciliitis. Right? Next question. 28-year-old female with recurrent UTI and frothy urine. Physical examination में you have edema and the lab test shows serum creatinine levels and proteinuria. तो एक चीज तो पता लग गया, edema है and 3+ proteinuria है. तो it is nephritic or nephrotic syndrome. Sir, yes, it is a case of nephrotic syndrome. Then renal biopsy ली गई है and an image is given. Sir, दिल मत तोड़ना, क्या दिख रहा है अपने को? Look here, क्या दिख रहा है अपने को? सर मुझे दो बेसमेंट मेम्ब्रेन दिख रही हैं सर. मुझे हर जगह आई सी दिस दो बेसमेंट मेम्ब्रेन. लुक हेयर सर, मुझे बिल्कुल जहां भी देखूं मुझे दो बेसमेंट मेम्ब्रेन दिख रही हैं. इससे ज्यादा मैं क्या बताऊं सर. दिस इज अ क्लियर कट इमेज ऑफ ट्रैम ट्रैक अपीयरेंस. दिस इज अ क्लियर कट इमेज ऑफ ट्रैम ट्रैक अपीयरेंस. सर बता दो सर. अब तो ट्रैम ट्रैक अपीयरेंस, दो बेसमेंट मेम्ब्रेन दिखना, मेरे दो बेसमेंट मेम्ब्रेन दिख जाए तो दिस इज कॉल्ड एज द ट्रैम ट्रैक अपीयरेंस. अब बता दो ट्रैम ट्रैक अपीयरेंस इज सीन इन, कम ऑन गाइस, MPGN. मैंने आपको बताया था ट्रैम ट्रैक यानी दो बेसमेंट मेम्ब्रेन यानी मेम्ब्रेन प्रोलिफरेट हो गई है. आई एम श्योर ऑल ऑफ यू रिमेंबर MPGN स्टैंड्स फॉर मेम्ब्रेनो प्रोलिफरेटिव. नाम से पता लग रहा है, फ्रॉम द नेम ओनली यू कैन रिमेंबर मेम्ब्रेन प्रोलिफरेटिंग. प्रोलिफरेशन मींस द नेम इज इंक्रीजिंग. प्रोलिफरेशन फ्रॉम 1 to 2 basement membrane. This is called as tram track appearance. So very important image, tram track appearance seen in membranoproliferative. 3 appearance आपको याद रखनी है in renal pathology. Tram track, MPGN. Next, spike and dome appearance. Spike and dome appearance. Please tell me spike and dome appearance. Membranous glomerulopathy. Membranous glomerulopathy. And last में सबसे important basket weave appearance. Just remember these 3 terms. Basket weave appearance, it is seen in Alport syndrome. It is seen in Alport syndrome. So remember these 3 appearance from renal pathology. Tram track, spike and dome. मैंने आपको पढ़ा था spike and dome Y से याद रखना है. It is membranous glomerulopathy, basket weave appearance. Airport पे जगह baskets. Alport basket weave appearance. Right. Third question. 6-year-old boy, life-threatening bleeding है. Hemarthrosis is seen, sir. Hemarthrosis, पहला feature. Enough for diagnosis. Then PTT prolonged, PT normal. हीमार्थ्रोसिस का पीटी नॉर्मल है और एपीटीटी बढ़ा हुआ है, इंक्रीज। द फैमिली इनहेरिटेंस शोज एक्स लिंक रिसेसिव पैटर्न, और कितना कुछ बोले साहब। द पीटीके वर कैरेक्टरिस्टिकली एब्सेंट इन दिस पेशेंट। पीटीके किस में होते हैं? कम ऑन, पीटीके कहां मिलते हैं? ब्लीडिंग डिसऑर्डर में। कहां पे? प्लेटलेट डिसऑर्डर्स में। एक चाचा पता लग गया सर, पीटीके परपुरिया नहीं है मतलब प्लेटलेट डिसऑर्डर तो नहीं है, इट इज क्लॉटिंग डिसऑर्डर। एंड विच कंपोनेंट इज लाइकली टू बी मिसिंग इन दिस पेशेंट? सर क्लियर कट बता दो। हीमार्थ्रोसिस का लौंडा है, एक्सलिम्स यानी बॉयज में मिल रहा है, और एपीटीटी बढ़ा हुआ है। इट्स अ क्लियर कट केस ऑफ हीमोफीलिया ए। मैंने आपको बहुत अच्छे से पढ़ाया था। एक बॉय आए आपके पास, वाई बॉय? बिकॉज इट इज एक्सलिंक्ड रिसेसिव। 8 से 10 साल का बॉय विद हीमार्थ्रोसिस, इंक्रीज एपीटीटी, हीमोफीलिया ए। तो आंसर क्या होगा? फैक्टर नंबर 8। फैक्टर नंबर 8। आई एम श्योर ऑल ऑफ यू रिमेंबर एपीटीटी इंक्रीज। पढ़ना ही कहां था अपन ने? एपीटीटी इंक्रीज है तो या तो हिपैरिन याद रखना है या एच से हीमोफीलिया याद रखना है। सिंपल रूल भी सिखाया था आपको, इफ एपीटीटी इज इंक्रीज इधर गो विद हिपैरिन और इधर गो विद हीमोफीलिया। यहाँ पे हिपैरिन का कोई हिस्ट्री नहीं है तो इट इज हीमोफीलिया का क्लियर कट केस। सर ये VWF क्यों नहीं है? ये वॉन विलीब्रेंट डिसीज क्यों नहीं है? अगर वॉन विलीब्रेंट डिसीज होता तो यस उसमें भी एपीटीटी बढ़ता, उसमें भी एपीटीटी बढ़ता, बट साथ में क्या बढ़ता? ब्लीडिंग टाइम बढ़ता, साथ में ब्लीडिंग टाइम बढ़ता। यहाँ पे ब्लीडिंग टाइम इज नॉर्मल, ब्लीडिंग टाइम इज नॉर्मल बिकॉज परपीटीकिया नहीं है, दैट मींस देयर इज नो platelet disorder involved. Von Willebrand disease, very important image. BT plus APTT is increased. So very, very, very important question, right? Clear cut. Okay, next question पे आते हैं. 2-month-old infant, recurrent bacterial infections with delayed separation of umbilical cord stump. Guys, umbilical cord stump से more than 30 days हो गए हैं, umbilical cord stump delay separate नहीं हो रही है. Blood test shows no neutrophil count, low neutrophil count, and there is deficiency in expression of CD18 molecule. No CD8 molecule on leukocytes. Which the following is most likely diagnosis? Come on, CGD पागल है क्या? LAD2 पागल है क्या? Shadyake syndrome पागल है क्या? The answer is LAD1. Everybody, LAD1. I am sure all of you remember. जब मैंने आपको LAD पढ़ाया था, there are 2 type of LAD, LAD1 and LAD2. I am sure all of you remember. LAD1 is due to deficiency of integrins. Integrins जो ICAM, VCAM बाइंड करते थे, so CD11 और CD18, just another name for ICAM and VCAM. So please remember, LAD1 occurs due to deficiency of integrins or CD11 or CD18, whereas LAD2 occurs due to deficiency of sialyl X on surface of WBCs. So 11 due to deficiency of integrins, which is also called as the molecules, the adhesion molecules are also called as CD11, CD18. जैसे यहाँ पे देर का एग्जाम में there is deficiency of CD18, so that is LAD1. यहाँ पे sialyl X लिखा होता तो आंसर would have been LAD2. Then I'm sure मैंने को बताया था आपको इन दोनों में कॉमन क्या है, दोनों में प्रॉब्लम क्या है? चाहे यहाँ पे एडहेशन नहीं हो रही बिकॉज ऑफ लॉस ऑफ इंटीग्रिन्स, देयर इज नो एडहेशन, sialyl की वजह से यहाँ पे रोलिंग नहीं हो रही. इंपॉर्टेंट क्या है? बोथ रोलिंग एंड एडहेशन आर पार्ट ऑफ इन्फ्लामेशन. सो इन्फ्लामेशन नहीं होगी तो ऑफ कोर्स न्यूट्रोफिल्स बाहर नहीं जाएंगे. तो इन दोनों कंडीशन में यू विल हैव न्यूट्रोफिलिया बिकॉज न्यूट्रोफिल्स का इन्फ्लामेशन का मतलब क्या हुआ? टू टेक द WBCs टू द एक्स्ट्रावेस्कुलर स्पेस. ये दोनों नहीं है, एडहेशन नहीं होगी तो WBCs निकल के बाहर नहीं जाएंगे तो ब्लड में उनका लेवल बढ़ जाएगा. यू हैव न्यूट्रोफिलिया और दोनों में रिकरेंट इंफेक्शंस आएंगे. So LAD1 or LAD2 both will have the same clinical feature. So sir, how will we differentiate in the exam? Remember LAD1 और LAD2 का जो main differentiating feature है, LAD1 में याद रख लेना delayed separation of umbilical cord. There is delayed separation of umbilical cord as this was given in this question. This is the correct, very important image of LAD1. जबकि LAD2 का patient will have Bombay blood group. Will have Bombay blood group. Please make sure you know this. LAD1 delayed separation of umbilical cord, LAD2 Bombay blood group. ध्यान से क्वेश्चन को पढ़ना. ब्लीडिंग फ्रॉम अम्बिलिकल कॉर्ड स्टंप लिखा हुआ है तो ब्लीडिंग फ्रॉम अम्बिलिकल कॉर्ड स्टंप लिखा है तो हमें ग्लैंसमैन थ्रोम्बोस्थेनिया के बारे में सोचना है. लास्ट CBoT आपने दिया था, आई एम श्योर यू रिमेंबर. वहां पे डिलेड, वहां पे देयर वाज ब्लीडिंग फ्रॉम द अम्बिलिकल कॉर्ड स्टंप. जब अम्बिलिकल काटा वहां से ब्लीडिंग आ रही है तो ब्लीडिंग फ्रॉम अम्बिलिकल कॉर्ड, थिंक अबाउट Glanzmann syndrome. Delayed separation of umbilical cord, go with LAD1. Bleeding from umbilical cord. आई होप दैट हेल्प्स। क्वेश्चन को ध्यान से पढ़ लेना, राइट। तो डिलेड सेपरेशन ऑफ अम्बिलिकल कॉर्ड, इट इज LED1। ब्लीडिंग फ्रॉम अम्बिलिकल कॉर्ड लिखा हुआ है, गो विद ग्लैंसमैन सिंड्रोम। ग्लैंसमैन सिंड्रोम। सर CGD क्यों नहीं है? याद करो CGD के बारे में, कौन सा एंजाइम डेफिशिएंट था? NADPH ऑक्सीडेज, रेस्पिरेटरी बस डेफिशिएंट था। आई होप यू रिमेंबर। और CGD मैंने एक टेस्ट बताया था, मोस्ट कॉमन इन्फेक्शन कौन सी थी? स्टैफ ऑरियस। सिर्फ कैटलेस पॉजिटिव इन्फेक्शन, स्टैफ ऑरियस। और CGD का टेस्ट का नाम बता दो, मेरी आत्मा खुश हो जाएगी सर। यस, CGD के टेस्ट का नाम था नाइट्रोब्ल्यू टेट्राजोलियम डाई टेस्ट। यू हैव नाइट्रोब्ल्यू टेट्राजोलियम डाई टेस्ट, दैट इज NBT वाला टेस्ट, इज फॉर क्रॉनिक CGD। ना शेडी-किगाशी क्यों नहीं है? ये भी हमने पढ़ा था सर। इन शेडी-किगाशी सिंड्रोम हमने पढ़ा था। जीन कौन सी है? लिस्ट जीन। लिस्ट जीन। पेशेंट सिम्टम्स क्या क्या लेके आएगा? न्यूट्रोफिल्स नहीं है तो इन्फेक्शन तो होंगी। लिस्ट जीन्स नहीं है, लाइसोसोमल ट्रैफिकिंग नहीं होगी तो इन्फेक्शन होंगी। उसके अलावा याद करो, मैंने कहा था 3 सेल्स आर अफेक्टेड इन शेडी-किगाशी सिंड्रोम। PSM वाले सेल्स, सो प्लेटलेट्स विल बी अफेक्टेड, Schwann cells will be affected in शेडी-किगाशी syndrome, and M से you have, yes, come on, melanin will be affected. You have melanin will be affected. So फटाफट मैं नहीं बोलूंगा, you will tell me guys. If platelets will not function, the patient will have bleeding. Schwann cells नहीं होंगे तो न्यूरोपैथी, the patient will have neuropathy, and melanin नहीं होगा तो albinism. Right? So remember, the शेडी-किगाशी syndrome will have PSM cells affected, platelets, Schwann cells, and the melanin. So we'll have bleeding disorders, gray white hairs because albinism, and neuropathy. इसलिए यहाँ पे answer is not शेडी-किगाशी syndrome. Right? Done. Move to the next question. Time waste नहीं करेंगे सर. Stellate granuloma. Stellate granuloma, cat scratch disease. बोलते चलेंगे. I told you the last CBoT also. My intent is clear. जो इंपॉर्टेंट क्वेश्चंस है उनको बार बार पढ़ना, रेदर देन नया बनाने के चक्कर में कुछ भी मुश्किल में डाल दूं। तो सार्कोइडोसिस कौन सा ग्रेनुलोमा? नॉन केजिएटिंग। ट्यूबरकुलोसिस कौन सा ग्रेनुलोमा? केजिएटिंग ग्रेनुलोमा। सिफिलिस में भी अगेन केजिएटिंग ग्रेनुलोमास। कैन यू टेल मी द व्हाट यू कॉल द ग्रेनुलोमास ऑफ सिफिलिस? इट्स कॉल्ड एज गम्मास। So syphilis में you will have again a caseating granulomas which is gammas, tuberculosis में caseating और sarcoidosis में non-caseating granulomas will be seen. Moving to the next question. एग्जाम की डेट पास है तो टाइम वेस्ट ज्यादा नहीं करेंगे। बर्किट्स लिम्फोमा का पेशेंट है, इंक्रीज फटीगनेस है, डिक्रीज यूरिन आउटपुट है। द डायग्नोसिस ऑफ ट्यूमर लाइसिस सिंड्रोम वाज मेड। विच ऑफ द फॉलोइंग इज द फीचर ऑफ ट्यूमर लाइसिस सिंड्रोम? पूछा क्या? विच ऑफ द फॉलोइंग इज फीचर ऑफ ट्यूमर लाइसिस सिंड्रोम? हाइपोकैलिमिया, पागल है क्या? हाइपरयूरेसीमिया, यस। लैक्टिक एल्कलोसिस, पागल है क्या? लैक्टिक एसिडोसिस होता है सर, लैक्टिक एसिडोसिस होता है। हाइपरकैल्सीमिया, पागल है क्या? हाइपोकैलीमिया होता है। आई एम श्योर यू रिमेंबर, जब ट्यूमर लाइसिस सिंड्रोम पढ़ते हैं, सेल के अंदर 3 चीजें तो मिलती हैं। पोटेशियम मिलता है, उसके प्यूरिन में यूरिक एसिड होता है, और इंटरसेलुलरली फॉस्फेट मिलता है। और ट्यूमर लाइसिस सिंड्रोम का मतलब ट्यूमर सेल्स टूट गए, ट्यूमर सेल्स हैव बीन लाइस्ड, और ट्यूमर सेल्स की लाइसिस हो जाएगी तो ऑल दिस 3 थिंग्स विल इंक्रीज इन द ब्लड। सो पोटेशियम विल इंक्रीज, यूरिक एसिड विल इंक्रीज, एंड फॉस्फेट विल इंक्रीज। एंड फॉस्फेट इंक्रीज होगा तो ऑफ कोर्स कैल्शियम लेवल्स विल डिक्रीज। सो प्लीज रिमेंबर, यहां से 2 क्वेश्चन, हाइपरकैलीमिया, हाइपरयूरेसीमिया, हाइपरफॉस्फेटीमिया एंड हाइपोकैल्सीमिया इज सीन इन ट्यूमर लाइसिस सिंड्रोम। एंड देन एक क्वेश्चन और क्या पढ़ लिया अपन ने? ट्यूमर लाइसिस सिंड्रोम इज मैक्सिमम सीन इन बर्किट्स लिम्फोमा। वाई बर्किट्स लिम्फोमा? आपको याद आ रहा होगा, बर्किट्स लिम्फोमा हैज 100% सेल इन माइटोसिस। तो रैपिडली प्रोलिफरेटिंग सेल्स हैं, बिकॉज सेल्स आर रैपिडली प्रोलिफरेटिंग, मोर यू गिव कीमोथेरेपी, मोर देयर बी लाइसिस ऑफ सेल्स। वी ऑल नो कीमोथेरेपी अटैक्स रैपिडली प्रोलिफरेटिंग सेल्स। कीमोथेरेपी दोगे, सेल्स टूटेंगे, देयर इज मैक्सिमम चांसेस ऑफ ट्यूमर लाइसिस सिंड्रोम। So tumor lysis syndrome, that is TLS, maximum chances is with Burkitt's lymphoma. Move to the next question. Alpha fetoprotein is increased in all except SCC में yes, germ cell tumor में yes, prostate carcinoma में पागल है क्या? The hepatoblastoma में yes. So prostate cancer में कौन सा बढ़ता है सर? PSA बढ़ता है सर। There is no alpha fetoprotein increase. Everybody, alpha fetoprotein के बारे में 2 बातें मुझे बता देना सर। सबसे पहले तो कहाँ बढ़ता है? नॉर्मली भी बढ़ सकता है, प्रेगनेंसी में बढ़ सकता है। फिर कहाँ बढ़ता है? हेपेटोसेलुलर कार्सिनोमा में। ऑल्सो इंक्रीज इन हिपेटोब्लास्टोमा। आई एम श्योर आप मुझे बता दोगे। मोस्ट कॉमन लीवर कैंसर, मैलिग्नेंट लीवर कैंसर इन एडल्ट्स, it is hepatocellular carcinoma. Malignant of adults, primary I'm talking about is HCC. Malignant liver cancer of children, it is hepatoblastoma. Hepatoblastoma, कोई भी ब्लास्टोमा चिल्ड्रन में कॉमन है. एवरीबडी, मोस्ट कॉमन रीनल ट्यूमर ऑफ चिल्ड्रन विल्म्स ट्यूमर. विल्म्स ट्यूमर का दूसरा नाम नेफ्रोब्लास्टोमा. ब्रेन में मेड्यूलोब्लास्टोमा. तो ब्लास्टोमा ब्रेन में मेड्यूलोब्लास्टोमा, इधर नेफ्रोब्लास्टोमा. तो लिवर में बच्चों में क्या होगा? हिपेटोब्लास्टोमा. सो रिमेंबर, मैलिग्नेंट ऑफ चिल्ड्रन मोस्ट कॉमन आई एम टॉकिंग अबाउट. इधर भी मोस्ट कॉमन प्राइमरी मैलिग्नेंट ऑफ एडल्ट्स, ग्लायोकार्सिनोमा. ऑफ चिल्ड्रन इट इज हिपेटोब्लास्टोमा. इंपॉर्टेंट, दोनों में ही अल्फा फिटोप्रोटीन इज इंक्रीज्ड. दोनों में अल्फा फिटोप्रोटीन इज इंक्रीज. इसके अलावा सर कहां मिलता है अल्फा फिटोप्रोटीन? नॉन सेमिनोमैटस जर्म सेल ट्यूमर. नॉन सेमिनोमैटस जर्म सेल ट्यूमर में जो लिखा हुआ है टेस्टिस के अंदर, नॉन सेमिनोमैटस जर्म सेल ट्यूमर, उनमें सबसे इंपॉर्टेंट अपने कोई यॉर्क सैक ट्यूमर तो याद रखना ही रखना है सर. तो दैट इज करेक्ट स्टेटमेंट. जर्म सेल ट्यूमर में भी यू हैव अल्फा फिटोप्रोटीन. प्रोस्टेट कैंसर में नहीं होता, यू हैव PSA इन्वॉल्व देयर, राइट. मूव टू द नेक्स्ट क्वेश्चन, राइट. A medical professional is collecting a blood sample and they select a commonly used blood collection tube. What is typically present in this container? कौन से कलर की वैक्यूम कंटेनर है बॉस? वाइल कौन से कलर का है? रेड कलर का. तो आंसर सोडियम EDTA हो सकता है क्या? पागल है क्या? EDTA होता तो लेवेंडर कलर, पर्पल कलर होता. ट्राई सोडियम सिट्रेट हो सकता है क्या? सिट्रेट, पागल है क्या? सिट्रेट होता तो ब्लू कलर की वाइल होती. हिपैरिन हो सकता है क्या? पागल है क्या? हिपैरिन होता तो ग्रीन कलर की वाइल होती. तो आंसर इज इट इज क्लोट एक्टिवेटर. रिमेंबर, रेड कलर वैक्यूम कंटेनर हैज द क्लोट एक्टिवेटर. क्लोट एक्टिवेटर का मतलब इसके अंदर कोई एंटी कोएगुलेंट नहीं होता. नो एंटी कोएगुलेंट इज सीन इन द रेड वैक्यूम. वेरी वेरी इंपॉर्टेंट, नो एंटी कोएगुलेंट इज सीन, इसलिए इसको प्लेन ट्यूब्स भी बोलते हैं. यू डोंट हैव एनी एंटी कोएगुलेंट इन रेड कलर वैक्यूम कंटेनर. कहां यूज करते हैं सर? रेड का मतलब खून, तो इसको हम ब्लड बैंक या किसी सीरोलॉजिकल एग्जामिनेशन में यूज करते हैं. रेड का मतलब खून, खून का मतलब ब्लड, तो यू यूज इन ब्लड बैंक पोटेंशियल. लेवेंडर पर्पल कलर, ये तो सबको पता है, CBC और ESR के लिए लेवेंडर पर्पल कलर. ब्लू, मैंने आपको कहा था सर, ब्लू वाले में क्या है? सिट्रेट, और C से सिट्रेट, C से इट इज यूज फॉर कोएगुलेशन स्टडी. ब्लू वाला इज फॉर सिट्रेट. ब्लू में एंटीकोएगुलेंट क्या है? सिट्रेट. इसमें क्या है? लेवेंडर वाले कलर में EDTA क्या था? EDTA, ये लिख लिया अपन, EDTA वाला इस लेवेंडर कलर. ब्लू वाले में सिट्रेट एंटीकोएगुलेंट है, उसको कोएगुलेशन स्टडी, PT, APTT. ग्रीन, कम ऑन, ग्रीन को हिंदी में क्या कहते हैं? हरा. और H से हरा, H से हिपैरिन. तो सब में एंटीकोएगुलेंट है एक्सेप्ट इन रेड वाला. देयर इज अ प्लेन ट्यूब, नो एक्टिवेटर, नो एंटीकोएगुलेंट इज प्रेजेंट, इट्स कॉल्ड एज क्लोट एक्टिवेटर. तो ग्रीन वाला कहां यूज होता है बॉस? याद कर लो सर, दो सबसे इंपॉर्टेंट चीज है, चाहे फ्लो साइटोमेट्री आ जाए, फ्लो साइटोमेट्री के लिए भी यूज ग्रीन वाला, एंड ऑल्सो फॉर ऑस्मोटिक फ्रेजिलिटी टेस्ट. ऑस्मोटिक फ्रेजिलिटी टेस्ट, अगेन अदर रीनल एग्जामिनेशन में वी कैन यूज इट, बट इंपॉर्टेंट एग्जाम पॉइंट ऑफ व्यू से फ्लो साइटोमेट्री एंड ऑस्मोटिक फ्रेजिलिटी टेस्ट यूज अ ग्रीन कंटेनर कंटेनिंग हेपरिन. H फॉर हरा, H फॉर हिपैरिन, राइट. ब्लू वाले के बारे में 2 C, सिट्रेट होता है और कोएगुलेशन. रेड वाला, रेड ब्लड बैंक में यूज होता है, राइट. नेक्स्ट क्वेश्चन, अमाइलोइडोसिस आता था, आता रहेगा. डायबिटिक पेशेंट है विद क्रॉनिक रीनल फेलियर अंडरगोइंग हीमोडायलिसिस. आई विल नॉट वेस्ट योर टाइम हियर. हीमोडायलिसिस में A-beta-2, आई विल नॉट वेस्ट योर टाइम. A टाइप कहां मिलेगा? सेकेंडरी अमाइलोइडोसिस में. सर A-beta कहां मिलेगा? अल्जाइमर्स डिसीज में. A-cal कहां मिलेगा? मेडुलरी कार्सिनोमा थायराइड में. तो नो पॉइंट वेस्टिंग टाइम ऑन दिस. यू नो दिस, यू नीड टू नो दिस, राइट. चलिए नेक्स्ट क्वेश्चन. विच ऑफ द फॉलोइंग ट्यूमर मार्कर्स, लंग कैंसर पे क्वेश्चन आए ऐसा हो ही नहीं सकता. विच ऑफ द फॉलोइंग ट्यूमर मार्कर्स विल नॉट बी एलिवेटेड इन एडिनोकार्सिनोमा लंग्स. नैप्सिन है? यस है. CA हो सकता है सर. TTF है? बिल्कुल हो सकता है. NSC सर मुझे CA के बारे में याद नहीं था, बट NSC हो सकता है. पागल है क्या? NSC is used in small cell lung carcinoma. If you remember the last CBoT, मैंने वहीं पढ़ाया था सर. एनी न्यूरोएंडोक्राइन ट्यूमर जिसका निमोनिक हब स्टडी, स्मॉल CM लार्ज PM. इफ यू रिमेंबर दिस, अगर आपने वो वीडियो देखी है, स्मॉल CM लार्ज PM, सबके अंदर NSC इज पॉजिटिव. NSC इज सीन इन स्मॉल सेल कार्सिनोमा या किसी भी न्यूरोएंडोक्राइन ट्यूमर में. यस, किसी भी न्यूरोएंडोक्राइन ट्यूमर में. इट इज नॉट सीन इन एडिनोकार्सिनोमा. आई होप यू रिमेंबर. एडिनो के बारे में क्या याद रखना है? टैन. मैंने आपको कहा था एडिनोकार्सिनोमा में टैन याद आता है. TTF1 इज पॉजिटिव. एडिनो इज TTF1 पॉजिटिव. TTF1 ALK positive and napsin A positive. And napsin A positive. So remember, lung cancers, again I see very important, TTF napsin हो गया. Small IC बता दो squamous की. Yes, you remember P40, P63. स्मॉल की अगर आपको याद हो, मैंने बताया था सर स्मॉल की. स्मॉल पीपल डू BSc बॉम्बेसिन, साइनेप्टोफाइसिन and chromogranin. These are the main one. Synaptophysin, chromogranin and bombesin. इसके अलावा किसी भी, because I am sure all of you remember small cell एक neuroendocrine tumor है, and if you have gone through my last video, कोई भी neuroendocrine tumors are also positive for NSC and CD56. NSC and CD56, because in this question NSC was given. NSC is not seen in adenocarcinoma. The non-specific annulus is seen in neuron-specific annulus is seen in, yes, adenocarcinoma में कभी भी नहीं. It is seen in small cell carcinoma. Small cell carcinoma. Next question. 59-year-old with progressive exertional dyspnea. Examination पे आज दिखा है nodular densities in bilateral lung and calcification of hilar lymph nodes. Calcification of hilar lymph nodes. ट्रांसब्रोंकियल बायोप्सी पे कैल्सिफाइड नोड है विच वाज बाइरिफ्रिंजेंट पार्टिकल साहब. और क्या छाती निकाल के क्या निकाल के रख दो तुम्हारे सामने. ऑन केयरफुल हिस्ट्री, chronic exposure to what substance is likely to be seen? Guys, calcification of hilar lymph nodes. दिल मत तोड़ना. Whenever you read about axial calcification of hilar lymph nodes, या सिंपली calcification of hilar lymph nodes, तुम्हारे दिमाग में दो ही तो बीमारी आनी चाहिए. Axial calcification of hilar lymph nodes, either it is seen in sarcoidosis or it is seen in SA silicosis. यहाँ पे axial calcification of the hilar lymph nodes, sarcoidosis, silicosis. बट अब इसको डिफरेंशिएट कैसे करना है? कोई नॉन कैजिएटिंग ग्रैन्युलोमा लिखा होता है एग्जाम में, अगर उसने नॉन कैजिएटिंग लिखा होता तो मैं सार्कोइडोसिस पे चला जाता. बट हेयर देयर इज नो रिटर्न ऑफ नॉन कैजिएटिंग ग्रैन्युलोमास. उसने सिलिकोसिस में क्या लिख दिया? पॉजिटिव birefringent. Please remember, silica is the only particle which is positive birefringent. वो चमकती है साहब using polarized microscopy. Please remember, silica out of coal, asbestos and silica is the only one which will show positive birefringence. Right? Everybody, come on. Apple green birefringence कहाँ याद रखना है? Amyloid के लिए. Very good. Apple green is for amyloid. वैसे silica, remember, silica is also positive birefringent on polarized microscopy. So here the best answer is silica. Best answer is silica. Very important question. जब भी मैं silica पढ़ूंगा मुझे दो बातें तो कभी भूलनी नहीं है सिलिकोसिस के बारे में. पहला तो ट्यूबरकुलोसिस के चांसेस बढ़ जाते हैं. दूसरा, सिलिकोसिस इज ऑल्सो कॉल्ड एज ग्राइंडर्स डिसीज. स्टोन माइनिंग मिलेगा तो ग्राइंडर डिसीज. सर सिलिकोसिस के बारे में एक्सेल कैल्सिफिकेशन नहीं भूलनी, एक्सेल कैल्सिफिकेशन नहीं भूलनी. और सिलिकोसिस में इट इज द ओनली वन विच इज पॉजिटिव बायरेफ्रिंजेंट, और कोई नहीं होता. तो हियर द बेस्ट आंसर इज सिलिकोसिस. राइट? एस्बेस्टोसिस नहीं है, एस्बेस्टोस पॉजिटिव रेफ्रिजरेंट नहीं होता. कोल डस्ट भी हमेशा पॉजिटिव रेफ्रिजरेंट नहीं होता. और नेक्स्ट क्वेश्चन, बेरिलियम. अगेन बेरिलियम के बारे में इंपॉर्टेंट क्या है? बेरिलियम में भी नॉन कैजिएटिंग ग्रैन्युलोमास मिल सकते हैं लाइक सार्कोइडोसिस. ये नीट पीजी में क्वेश्चन आया था, कैन डेफिनेटली बी रिपीटेड सर. नॉन कैजिएटिंग ग्रैन्युलोमास लाइक सार्कोइडोसिस. बट तो हिस्ट्री क्या देखी होगी? बेरिलियम हिस्ट्री एरोस्पेस इंडस्ट्री या एयरक्राफ्ट इंडस्ट्री. तो एक पेशेंट जो एयरक्राफ्ट इंडस्ट्री में जॉब कर रहा है, काम कर रहा है, उसके लंग्स में इफ यू सी नॉन कैजिएटिंग ग्रैन्युलोमास, गो विद बेरिलियोसिस. Like sarcoidosis, again you can have. So please, just looking at non-कैजिएटिंग granulomas, don't rush to the answer. It can be sarcoidosis or it can be berylliosis also. But berylliosis will always have a person who's working in aerospace or aircraft industry. Right? Move to the next question. Again, stains without toluidine, masti tolke, that is mast cells. Prussian blue, Russian, hemocytin, iron. Alcian blue, mucus. Bone कोसा, कैल्शियम. टाइम वेस्ट नहीं करना सर. A is 3, B is 1, A is 3, B is 1, C is 2. So I think C is the best answer. Yes, we have the C is the best answer. So remember, ये स्टेन मत भूलना. स्टेन आती थी. टोल्यूडिन ब्लू is for mast cells, iron, hemocytin, Prussian blue, calcium, bone कोसा and alizarin red. बच गया क्या? म्यूकस. बैरेट्स इसोफेगस में म्यूकस कौन सी डिसीज दे रखी होगी? बैरेट्स इसोफेगस, व्हिच वी वेयर यू यूज अल्शियन ब्लू स्टेन. नेक्स्ट क्वेश्चन. 30-year-old मैन, फैटीग लास्ट 6 months से, पॉलीगोनल रैश है ऑन द लेफ्ट फोर आर्म, स्पाइडर एच, कमन कमन कमन, वायरल हेपेटाइटिस, HCV दिख गया साहब, HCV RNA, लीवर बायोप्सीज ऑर्डर्ड फॉर सीवीआरटी, जहां पे हमें मिली एक एसिडोफिलिक बॉडी. Which of the following underlying pathology is responsible for this acidophilic bodies in the liver of the patient? Everybody, I hope आपने इतनी बड़ी, उसने तो हिंट दे दी. सबसे पहले तो उसने क्या हिंट दिया आपको? HCV पॉजिटिव है, दे दिया. और HCV में फिर ये इमेज दे रखी है, सर दिल मत तोड़ना सर, इतनी बड़ी इमेज दे दी. कौन सी बॉडीज दिख रही है अपने को? सर सिंगल सेल है विद डार्क रेड साइटोप्लाज्म और इओसिनोफिलिक साइटोप्लाज्म. HCV का पेशेंट है, हेपेटाइटिस सी का पेशेंट है, सिंगल सेल दे रखा है विच इज डार्क रेड, अलग से एक डार्क रेड कलर बॉडी दिख रही है. अब तो बता दो सर ये कौन सी बॉडी है? सिंगल सेल विद इओसिनोफिलिक साइटोप्लाज्म. सर दिस इज काउंसिलमैन बॉडीज, दिस इज काउंसिलमैन बॉडीज. और इतना तो अगर आपको याद आ गया, HCV का पेशेंट है, C फॉर सी हमने पढ़ा था, C में यू हैव काउंसिलमैन बॉडीज, तो आपको ये भी जानना चाहिए सर ये हेपेटाइटिस सी में मिलता है. एंड काउंसिलमैन बॉडीज आर नथिंग बट apoptotic bodies. They are nothing but apoptotic bodies. तो आंसर क्या है? apoptosis. इतने लंबे क्वेश्चन में कंसेप्ट रिमेन द सेम. हेपेटाइटिस सी के पेशेंट में C फॉर सी काउंसिलमैन बॉडीज मिलती हैं एंड काउंसिलमैन बॉडीज आर नथिंग बट apoptotic bodies. apoptotic bodies. इसमें कुछ ऐड करना हो तो मैं ऐड करूंगा. एग्रीगेशन ऑफ इंटरमीडिएट फिलामेंट प्रोटीन्स, एग्रीगेशन ऑफ इंटरमीडिएट फिलामेंट प्रोटीन्स, एग्जांपल इज साइटोकैरेटिन 8 and 18. किसी को याद आ रहा है? एक स्पेशल बॉडीज in the liver, I repeat, which is made up of cytokeratin 8 and 18. Come on, बता दो, you got it right. It is Mallory-Dank bodies, sir. Mallory-Dank bodies. Please exam में confuse मत हो जाना. Councilman bodies are apoptotic bodies, whereas Mallory-Dank bodies are made up of intermediate filament, that is cytokeratin. ये ना भी याद रहे to at least remember the Mallory-Dank bodies are made up of cytokeratin 8 and 18. Cytokeratin 8 and 18. 8 and 18. माल 18. Remember guys, है ना? 18 के बाद ही अपन माल उठा सकते हैं ठेके से. So माल is 18. 8 and 18 is Mallory-Dank bodies. फिब्रिनोइड नेक्रोसिस कहाँ मिलती है? जाते जाते ये भी बता दो मुझे. यस कम ऑन. फिब्रिनोइड नेक्रोसिस MRP वाली कंडीशन में. M फॉर मैलिग्नेंट हाइपरटेंशन, R फॉर रूमेटिक हार्ट डिसीज एंड P फॉर पैन. So remember councilman bodies, hepatitis C, Mallory-Dank bodies made up of cytokeratin 8 and 18. 8 and 18. Next, ट्रांसलोकेशन पे 2-3 क्वेश्चन आने हैं. वी हैव टू मेक इट राइट. ट्रांसलोकेशन फॉलिकुलर कार्सिनोमा, फॉलिकुलर यार, फॉलिकुलर फूल, और अपन लौंडा का फूल अपना कटता है 14 तारीख को. सो 14 and 18 इज फॉलिकुलर कार्सिनोमा. फटाफट बता दो सर. 11-18 मार्जिनल जोन लिम्फोमा, या जिसको हम माल्टोमा भी कहते हैं. 11-18 इज मार्जिनल जोन लिम्फोमा. 11-14 सर मेंटल सेल लिम्फोमा. 922 is for CML. 920 is for CML, right? So follicular is 14 and 18 translocation. Next question. 48-year-old, consciousness चली गई, rhythmic movements and limbs में, headache है. Women है with headache and progressively increased severity. Intracranial mass दिया गया है and biopsy is given. अरे यार बता दो सर. पिंक गोल और पिंक गोल दिखा तो मुझे सामोमा बॉडीज दिखी. और ब्रेन के अंदर एक औरत को हेडेक हो रहा है और सामोमा बॉडीज दे रखी हैं. मुझे आगे नहीं पढ़ना साहब. मेनिंजियोमा, मैंने आपको पहले कहा था, मेनिंजियोमा में मेन है और नॉर्मली औरतों का काम होता है मर्दों को सिर दर्द देना, सारा दिन चैं करके सिर दर्द देना. पर मेनिंजियोमा में दुनिया के सारे मेन इकट्ठे हो गए औरत को सिर दर्द देने के लिए, अपना बदला लेने के लिए. तो मेनिंजियोमा वो ट्यूमर है जिसमें सारे मेन इकट्ठे होकर फीमेल्स को क्या देते हैं? हेडेक. तो मेनिंजियोमा का मोस्ट कॉमन सिम्टम इज हेडेक. ग्लायोब्लास्टोमा होता तो इसमें हमने पढ़ लिया कई बार, हमें सरपेंटाइन नेक्रोसिस मिलती. सरपेंटाइन नेक्रोसिस. और ग्लायोब्लास्टोमा में कौन सी पहली दिखती? सूडोपेलिसेडिन दिखती. अब इसमें सूडोपेलिसेडिन दिखती. एपेंडाइमा में PE है, एपेंडाइमा PE से इसमें पेरिवेस्कुलर रोजेट्स मिलते. एपेंडाइमा में PE है, पेरिवेस्कुलर रोजेट्स मिलते. पेरिवेस्कुलर श्वानोमा होता तो हमें ट्रू पेलिसेडिंग मिलता. लास्ट CBoT हमने दिया है, यू हैव ट्रू पेलिसेडिंग विद द नेम ऑफ वेरुके बॉडीज. मुझे वेरुके बॉडीज दी गई होती तो मैं श्वानोमा पे टिक करके आता. मुझे वेरुके बॉडीज नहीं, मुझे सामोमा बॉडीज दे रखी हैं तो मेरा आंसर होगा meningioma. Next, thyroid cancer पे क्वेश्चन आना ही आना है. 45-year-old male, painless neck mass, firm fixed mass, FNAC दे रखा है. Which of the following is most likely diagnosis? अरे बना दो भैया, इस अनाथ औरत की मम्मी पहचान लो. ऑर्फन एनीआई न्यूक्लियाई, ऑर्फन एनीआई न्यूक्लियाई हो. पहले तो आपको प्रश्न आना चाहिए. ऑर्फन एनीआई न्यूक्लियर का मतलब क्या हुआ? ऑर्फेनी का मतलब यस, यू हैव एन ऑप्टिकली क्लियर क्रोमैटिन. ऑप्टिकली क्लियर क्रोमैटिन इमेज पहचानी आनी चाहिए. ऑप्टिकली क्लियर क्रोमैटिन का मतलब नॉर्मली हम किस सेल के न्यूक्लियस को देखते हैं? द न्यूक्लियस इज ऑल ब्लू इन कलर. द न्यूक्लियस इज ब्लू इन कलर. दिस इज अ नॉर्मल न्यूक्लियस. बट यहाँ पे व्हाट यू सी इज द पेशेंट हैज द कंप्लीट वाइट न्यूक्लियाई. ऑप्टिकली ऑर्फन एनी की आंखों की तरह. So when you have this orphan NEI nuclei, the answer should be papillary carcinoma thyroid. The answer should be papillary thyroid cancer. Very very important. कुछ क्वेश्चंस बार बार आते रहेंगे. papillary carcinoma lymphatic spread से होता है. इसमें हमें P से सामोमा बॉडीज दिखती हैं. इसमें P से ये पोस्ट रेडिएशन होता है. इट अकर्स पोस्ट रेडिएशन. और P से तुम्हें ये भी याद आएगा सर, कमन P से कमन, यस, कौन सी बॉडीज? P से इसमें पैपिले बनेंगे. तो राइट, ऑल दीज आर पी वाला फीचर इज फॉर पैपिलरी कार्सिनोमा. फॉलिकुलर एडिनोमा के बारे में याद रख लेना. फॉलिकुलर एफएन कार्सिनोमा एडिनोमा हो, एफएनएसी से डायग्नोसिस नहीं होती. एफएनएसी नॉट डायग्नोसिस. मेडुलरी कार्सिनोमा थायराइड होता तो अमाइलॉइड जमा होती. यू विल हैव अमाइलॉइड. एंड एनाप्लास्टिक होता तो पेशेंट डिस्पनिया और डिस्फेजिया के साथ आता. डिस्पनिया एंड डिस्फेजिया के साथ आता. तो आउट ऑफ ऑल दिस, क्योंकि मुझे न्यूक्लियस बिल्कुल ब्लू कलर के दिख रहे हैं, दिस इज ऑर्फन एनीआई न्यूक्लियाई. द आंसर शुड बी पैपिलरी थायराइड कार्सिनोमा. नेक्स्ट, विच ऑफ द फॉलोइंग इज नॉट अ कंपोनेंट ऑफ वेरिकोस्ट्राइड? आई एम श्योर आपने गलत किया होगा. आंसर इज कम ऑन हाइपर विस्कोसिटी. नॉट पूछा है, नॉट. मुझे पता तुमने गलती कर दी होगी. हाइपर विस्कोसिटी लिखा है, हाइपर कोएगुबिलिटी नहीं लिखा सर. coagulability नहीं लिखा हुआ बॉस. There is hyperviscosity symptom. Yes, hyperviscosity also increases chances of thrombosis, but that is not a part of varicose-triad. तो varicose-triad में hyperviscosity नहीं होता, hypercoagulability होता है. I am sure all of you remember varicose-triad. तो varicose को अपन VIR से ही याद रखना है सर. V से तुम्हें याद आएगा, it has a very coagulable state. Very coagulable state is varicose. I से आपको याद आएगा injury. It occurs because of injury to endothelium. And R से आपको याद आएगा retention of blood flow. और retention of blood flow को ही अपन stasis बोल देते हैं. और जब भी stasis होता है वहां पे turbulent blood flow तो होगा ही होगा. जहां पे stasis होगा वहां पे turbulent blood flow तो होगा. stasis का मतलब क्या होता है? जब blood के अंदर you have all the RBCs packed together. जब सारे cells एक दूसरे से packed up हो जाएंगे, then you have the stasis. So this is same thing. Stasis here and turbulent blood flow is same thing here, boss. The best answer is hyperviscosity. Hypercoagulability is a feature of varicose-triad, not hyperviscosity. Yes, आपने पढ़ा है सर hyperviscosity जो polycythemia vera में पढ़ते हैं. Yes, polycythemia vera में there is hyperviscosity that can lead to again chances of thrombosis. But remember, this is not a part of varicose-triad. Varicose-triad में इंजरी होती है, you have very coagulable यानी hypercoagulable state होता है, इंजरी होती है, and stasis और turbulent blood flow होता है. There is no hyperviscosity. एग्जाम में जल्दबाजी मत करना. Hyperviscosity is not a part. Hypercoagulability is a part of varicose-triad. Now, deposition of PRPSC. Come on, PRPSC पता लग गया सर मुझे. It's a misfolded protein which is seen in Prions disease. PRPSC is a Prions disease, abnormal type of amyloid which is seen in Prions disease, seen in Creutzfeldt-Jakob disease. Creutzfeldt-Jakob disease में you have PRPSC deposition. सर रेबीज होता तो कौन सी बॉडीज होती? रेबीज होता तो नेग्री बॉडीज होती. पार्किंसन डिजीज होता तो कौन सी बॉडीज होती? अल्फा साइन न्यूक्लिन वाली, यस, अल्फा साइन न्यूक्लिन वाली लुई बॉडीज होती. और एल्जाइमर्स होती तो हमें पता ही है सर, हिरानो बॉडीज होती. न्यूरोफिब्रिलरी टैंगल्स होता, न्यूरोफिब्रिलरी टैंगल्स होता. एंड आई एम श्योर ऑल ऑफ यू कैन नो, रिमेंबर, न्यूरोफिब्रिलरी टैंगल्स किससे बने हैं? हाइपर ताऊ से. ताऊ जो गुस्सा होके हीरो बन रहा था, हाइपर फॉस्फोराइलेटेड ताऊ प्रोटीन. हाइपर फॉस्फोराइलेटेड ताऊ प्रोटीन that only form neurofibrillary tangles, right? So Hirano bodies, neurofibrillary tangles ये मिलती हैं अल्जाइमर डिसीज के अंदर. पार्किंसन में have Lewy bodies and rabies में Negri bodies. whereas PRP-SC containing bodies is seen in Creutzfeldt-Jakob disease. Right? Done. Next question. Mode of inheritance of patient of color blindness. Color blindness. Color blindness. Answer is, come on, color blind answer is X-linked recessive. X-linked recessive. Sir, class में तो I have told you with an examples of autosomal dominant. Mnemonic के साथ we have studied autosomal dominant, autosomal recessive, X-linked recessive. यहाँ पे mnemonic का टाइम नहीं है. X-linked recessive के बारे में प्लीज कुछ एग्जाम्पल है जो आपको कभी नहीं बोलने, जो एग्जाम में पूछे जाते हैं. पहले तो हीमोफीलिया ए हो या बी हो. हीमोफीलिया ए इज X-linked recessive. G6PD deficiency. I have told you the mnemonic. यहाँ पे mnemonic ने मेन में रखना. और तीसरा इज कलर ब्लाइंडनेस. ये तीन तो कभी नहीं पूछना, which have been favorite for FMGs. Hemophilia, GCP deficiency anemia, and color blindness. All these three are X-linked recessive disorders which are commonly seen in boys. तो boys में hemophilias, GCP deficiency and color blindness को star mark कर लेना. Other than we have CGD also, we have so many other diseases, but remember hemophilias, color blindness and GCP deficiency anemia is example of X-linked recessive disorder. Next, caspase independent program cell death. Program cell death तो है, but caspase independent. Sir, necroptosis is the right answer. Necroptosis is the right answer. Caspase independent. Caspases की बात चलिए तो मुझे बता दो, necrosis में caspase इन्वॉल्व नहीं होते, पर necrosis तो program cell death भी नहीं है. Apoptosis के caspase फटाफट मुझे बता दो, intrinsic pathway में, intrinsic के बता दो, extrinsic के बता दो एंड एक्सिक्यूशन के बता दो. आई एम श्योर आपको रटा पड़ा है. इंट्रिंसिक में कैस्पेस नंबर 9 है, एक्सट्रिंसिक में 8 एंड 10 है, एक्सिक्यूशन में 3, 6 एंड 7. 3 पे स्टार मार्क कर लेना. 3 इज द मोस्ट इंपॉर्टेंट वन फॉर एक्सिक्यूशन. फिर इतना बता दीजिए तो पायरोप्टोसिस के कैस्पेसिस बता दो मुझे, 1 एंड 11. 1, 4, 7, 11. 1 एंड 11 जो मेन है वो याद रखो अभी के लिए. पायरोप्टोसिस के कैस्पेसिस 1 एंड 11. नेक्रोप्टोसिस डज नॉट इन्वॉल्व एनी कैस्पेसिस. राइट, डन. That will bring us to the last question. Receptor. This is very, very important MCQ. Receptor for Epstein-Barr virus. Epstein-Barr virus. Answer 19. पागल है क्या? 19 के बारे में मुझे एक क्वेश्चन याद रखना है. It is pan B cell marker. Pan B cell marker. 21. Absolutely correct statement. Absolutely correct statement, sir. Sir, CD21 याद रख लेना. Epstein-Barr virus binds to CD21 of the B cells. Also called as CR2, complement receptor 2, but CR2 भूल जाना, but ये मत भूलना सर. Epstein-Barr virus will have CD21 of the B cells. Remember, all are B cell marker. 19, 20, 23 all are B cell marker, but 21 is the one जहाँ पे Epstein-Barr virus find करता है. Epstein-Barr virus के बारे में दो बातें बात कर लेते हैं. सबसे पहले तो ये infectious mononucleosis नाम की डिसीज करता है. It causes infectious mononucleosis, जिसमें हमें अच्छे से याद है सर, डाउनी सेल्स मिलते हैं सर. Where we see downy cells, जिसके लिए अपन मोनोस्पॉट टेस्ट भी यूज करते हैं. मोनोस्पॉट टेस्ट भी यूज करते हैं. और जिसमें which is also called as kissing disease. Kissing disease तो जो आपत्तिजनक अत्यधिक चुंबन की प्रतिक्रिया से बीमारी फैले, that is infectious mononucleosis. Kissing disease. फिर इसके बाद it can cause cancers. Infectious mononucleosis we all know can cause cancer. Can you tell me the most common cancer virus के cancers? Come on, Epstein-Barr virus cause bingo cancers. I hope you remember. Epstein-Barr virus cause Burkitt lymphoma. It cause immunoblastic B cell lymphoma. Immunoblastic B cell lymphoma. It causes nasopharyngeal carcinoma. Nasopharyngeal. It causes gastric cancer, especially the diffuse gastric cancer. And O for Hodgkin's. O for Hodgkin's lymphoma. So these are the 5 cancers caused by Epstein-Barr virus: Hodgkin's lymphoma, gastric lymphoma, nasopharyngeal, and we have Burkitt's. Out of this, remember, most common cancer caused by Epstein-Barr virus is diffuse gastric carcinoma. Most common is diffuse gastric carcinoma, but 100% associated is nasopharyngeal carcinoma. So Epstein-Barr virus very, very important for exams, right? Done guys. So that is all from pathology. पेपर के डेट आने वाली है, फाड़ के आएंगे, सच्चे में फाड़ के आएंगे. स्टे द मोरल अप, कीप द कॉन्फिडेंस वेरी अप. क्वेश्चंस नहीं आएंगे बाहर से, ट्रस्ट मी ऑन दिस. कीप रिवाइजिंग योर नोट्स. 3 अलग अलग जगह मुंह मारने से अच्छा जो तुम्हारी है परमानेंट उसी पे मुंह मारो बार बार. बी लॉयल टू योर नोट्स, बी लॉयल टू टीचर. कीप स्टडिंग दिस नोट्स. आएगा, बाहर नहीं आएगा. ट्रस्ट मी. कीप स्टडिंग वेल गाइस. टेक केयर. गॉड ब्लेस यू गाइस.